Hello everyone. So welcome for today's INI-CET marathon series, and in this series we are going to learn about orthopedics first. Sorry for the shuffling of orthopedics and pharmacology. So Siraj sir is going to take in the next session. So this session in the morning time we are going to learn about ortho. Right? So let's get started. Before that, can you please confirm whether the audio and video is clear? Hi. So is the audio and video clear? Jay Jadav, hi. Yes, thank you for that. So let's get started. So in this, no, we are not going to learn anything new or anything, fancy. But what we are going to learn is only about what are the important things. So what is one brush or one, go through to the entire subject of ortho. Ortho, so maybe it may be a short subject, but it is sometimes very, very easy for you to score. Right? So we are not going to leave that. So first we are going to always start with our very interesting trauma, right? So trauma is very, very interesting and very, very important. Hi Narayani Agrawat. Okay, so fracture, we are going to start with what is an important of or what is the important topics of the fracture. So anytime you start about the fracture, the first question which hits your mind is whether this fracture is an open fracture or a closed fracture. So that is what you should start with. So that is very, very important, and the questions also should be framed, or the answer, while you read the question you have to always think that whether this is an open fracture or a closed fracture, because based on that the treatment changes, right? Good morning, Sudan, Shrujana, Shruranjan. Okay. So when it comes to open fracture, so open fracture play a very, very important role. Why they play a very important role? What is the most important complication we have to take care in case of open? That is, we have to take care about the infection. So infections are the one, very important criteria which we have to take care when we deal with the open fractures. When it comes to closed fractures, what is that you take care about? You take care about the fracture patterns, you take care about whether it is a fracture or a fracture dislocation or the displacements. So all these things we talk about. So when it comes to open fractures, so open fractures you should start directly from the what is the type of open fracture. So let's name the classification which helps us in the open fracture. Yes. Yes, good morning Omkar. What is the classification name for open fractures? Let's be quick in answering. So this is called the Gustilo-Anderson's classification. Yes? Yes, very important, your Gustilo-Anderson's classification, right? So what does it tell you? What does it teach you? So this is the image of your Gustilo-Anderson's classification, where it tells you that there are three types. So you have 3, 1, 2 and 3, right? So yes, very good, Gustilo-Anderson. So what about 1? So when we talk about 1, it is just a mild importance, like there is only a small opening which is less than 1 centimeter. So you see it is less than 1 centimeter wound. So we usually call this as puncture wound. Then if you talk about 2, so this is about 1 to 10 centimeters wound, and most importantly type 3, when you talk, it is more than 10 centimeters wound. So this is the major criteria which you have to remember, and this Gustilo-Anderson classification is mainly based upon your size of the wound. It will decide based upon your size of the wound, and also it takes other components also into consideration, but most importantly it is based upon size of the wound. So what usually we tell is whenever the wound size is more, so usually it is because of high velocity, and because of high velocity again there will be a lot of soft tissue damage, the fracture will be communicated. So all this will fall based upon your size of the wound. right? So now let's go to the classification here. So this is the table you have to remember in the classification. So it depends upon the first thing what I've told you is the wound size. So this depends mainly on the wound size. So wound size is less than 1 centimeter or more than 1 centimeter or more than 10 centimeters. Okay, then comes the soft tissue injury. So soft tissue injury, usually I've told you, right, if it is 10 centimeters, we usually think it is a high velocity injury, right? So more energy is required. And similarly, the fracture pattern, if it is 3C, you already know that it would be a severe or a complex comminuted fracture because of the high velocity injury, right? So what is most important in 3? So when it comes to 3, again you have A, B and C. So A, B and C in case of 3. So what do you think is the difference? So first important thing is the easy thing we have to remember. So 3C is whenever there is an involvement of vascular injury. So whenever there is a vascular injury, you directly put this into 3C. Right. Now, what is the difference between A and B? So, B is severe soft tissue, So, how do you quantify the severity? And that means you're taking a help of a plastic surgeon. So, if a plastic surgery is required to close the wound, so high amount of, flaps or skin grafting, which is, complex type are required, then it is B. If it is a simple soft tissue injury, that means which could be done by us, the orthopedic surgeons, a soft tissue injury is minimal, but minimal matlab it is not, very, very minimal. Compared to type 3B, it is lesser compared to 3B. Okay, so this is the difference between A, B and C. A, if you see soft tissue coverage is okay, that you can manage. 3B is where your soft tissue coverage requires a procedure like the wounds or flaps or your skin grafting, and type 3C is when there is a vascular injury or a nerve injury. Okay, so this is how you quantify and divide your open fractures into Gustilo-Anderson type 1, type 2 and type 3, and again in 3 you have A, B and C. Now there are various controversies around your Gustilo-Anderson classification which will not tell you whether you have to salvage the limb or amputate the limb. So when it comes to limb, the most important thing whenever you see your assume that you're in a casualty and you got an open fracture with severely comminuted injury, a lot of soft tissue damage has been done and you can feel still the pulse but not very, it is not very high voluminous pulse. So then they will ask you, what is the one question they will ask you? They will ask you whether are you going to salvage the limb or amputate the limb. So this is the one question which you have to answer in every casualty at at a very wrong time, maybe that where the casualty is fully flooded with the patients, or you're dealing with one more interesting or very important case, then this case arrives. So in that time, to help you decide whether you're going to salvage this limb or amputate this limb, we have a very important score which is called as Mangled Extremity Severity Score. So this is called as MESS, Mangled Extremity Severity Score. And in this score, what is the most important thing is you are going to take some components and you're going to score the system, and if it is more than 7, the score comes more than 7, you tell that this limb is going to amputation, right? If it is less than 7, you are going to try to salvage the limb. Okay, now let us see what are those components. So in this critical case dealing, you have to always think about the God, right? So Almighty or the Lord is the one which helps us. So Shiva is the creator of the universe, right? So you're going to ask him only to tell us whether you're going to salvage the limb or amputate the limb. So how Lord Shiva is going to help us? So he is going to help us while asking you some questions. So he will ask you what is the state of the patient. So he will ask you about the shock. How is the patient, whether it is in severe shock or what is it? Okay, based on that you have to tell him whether the shock condition is 0, 1 or 2. So then you can see 0 is the systolic BP if it is more than 90, and 1 is hypotensive, where the patient is hypotensive, and then you can with help of some fluids you can increase, and then persistently if the patient is hypotensive, then it is 2. Okay, and once you have answered that question, then again he will ask you what is the injury type, whether it is a high injury, he'll ask you about the ischemic, limb ischemia. So after the shock, then he's concerned about the ischemia. So limb ischemia. If the limb ischemia, you have to ask whether this person has been brought to the casualty before 6 hours. So 6 hours is considered as the arbitrary time for the perfusion. So based upon that, you will tell whether there is a pulse present or pulse is absent, or you say it is more than 6 hours and the limb is completely numb. Okay, so then you're going to answer about the shock, then he will ask you about ischemia, which you're going to answer, then velocity. Then he'll ask you what is the mechanism of the injury. So mechanism of the injury is it a high velocity, is it a low velocity? So what are the injury, what is the energies required for this patient? So then again you have 1, 2, 3, 4 where you say it is a low, medium, high or very high, right? And finally he will ask you the age. So what is the age of the patient? If he is less than 30, young patient, you can, sometimes you can try considering salvage. If he is more than 50, then he's go for amputation. Based on that, you will tell 0, 1, 2. So after discussing 0, 1, 2, after your calculations, if the score is more than 7, you go for amputation. If it is less than 7, you will try to salvage the limb. Okay, salvaging the limb has multiple, things to consider, but mainly, once the patient arrives in the casualty, this is the most important classification which will take care about your questions and the patient's questions, right? So, is that clear? So, that is about the mangled extremity severity score. But now, it is very important for us to acknowledge our talent. So, when you go back and see, the most important scoring system available today is the Ganga Hospital scoring system. So Ganga Hospital, thank you Omkar. So Ganga Hospital scoring system. So this is this is very close to my heart because Ganga Hospitals is in Coimbatore, is in Tamil Nadu, Coimbatore, and this has been designed by our own orthopedic surgeons, Dr. S. Rajashekaran. So he is the chief of Ganga Hospitals, and his brother, he is a plastic surgeon. So these two people have done a lot of research on open fractures, especially in our country, and have come out with a very important scoring system which is called as the Ganga Hospital scoring system for the open fractures. Why it has gained so much of importance? Because they have used everything possible. So right from skin, right from fascia, right from tendons, right from muscles. So all this has been taken into consideration along with the comorbidities, right? All this has been taken into the consideration, and then they have come up with this Ganga scoring system. And in that, if the patient score is less than 14, you go for salvage. And if it is more than 16, okay, more than 16, that is more than 17 and above, you go for amputation. This is very, very clear. And this has gained international recognition, so we have to learn it, we have to apply it. So this has not been still asked in the exams, but I hope this time they will put a question on this, okay, so that you will be aware of the Ganga Hospital scoring system. Right. So what are actually the advantages I have given in that blog? Because why specifically we are, adapting Ganga Hospital scoring system? Because there is a lot of scope for, giving importance to every structure, like right from the skin, fascia, ligaments, tendons, muscles, comorbidities, bone, energy. So all that are taken into consideration. So this one thing I want you all to remember. The next important is your Ganga Hospital scoring system, right? Just remember the scoring, that is more than 15, less than 14 is for salvage, more than 17 is for amputation. So anywhere, if it is between 14 and 17 is always the gray zone, okay? You have to decide based upon the patient condition and doctor's ability, okay? So that is the next scoring system. Now, jumping into our trauma. Okay, so now let us start with the upper limb trauma. The most important trauma which we encounter usually in our OPD is the shoulder dislocation. So that is why this has become common in exams also. So this is the advantage of people who attend postings in the internship, because most of the questions are around the most common scenarios we see in the casualty. So this is the most common dislocation. So which is the most common dislocation in the body? It is your shoulder dislocation. This is the most common. And in the shoulder dislocation also, again we have types of shoulder dislocations like anterior, posterior, inferior. So again, what is the most common type? It is the anterior shoulder dislocation. Very important question. And then one more important question. What is the most common nerve which gets damaged? So axillary nerve. So this has been asked in the exam. So what is the nerve which is most commonly injured in anterior shoulder dislocation? It is the axillary nerve. Okay, so Mayur wants us to add something. Very good, Mayur. When it comes to anterior, again there are types, and in that the subcoracoid is supposed to be the most common. Very good. So let's add this also. The most common again here, the subcoracoid. Okay. Yes, and now let us see what is the mechanism of the injury in case of your anterior shoulder dislocation. So mechanism of the injury is, so what happens, why actually this gets dislocated? So whenever the patient puts his hand in abduction and external rotation, so he is going abduction and external rotation. So all these type of maneuvers will result in pushing of this humeral head outside. So this is anteriorly. Okay, just imagine somebody is, twisting your hand like this, abduction, and trying to, do external rotation like this. So the humeral head. So what actually is the thing? The thing is here, the glenoid is not a cup-like structure. It is somewhat flat like this. So the humeral head gets attached like this. So it is not completely enclosed. It is somewhat like this. But the complete enclosure is by the labrum, right? So when you give enough force for this humeral head to dislocate, so in the external rotation it comes outside anteriorly. So similarly apply this to the posterior dislocation. So somebody is twisting to adduction and internal rotation, so there is high chance of this head going back. That is posterior dislocation. And what is inferior? Inferior is the head has to go down, so the limb is hyperabducted. So hyperabduction, so this particular head will go down. So that is your inferior dislocation. Yeah, maybe. Yes, if somebody is playing throw ball, they can assess well. Okay, done. And now, so that is the mechanism of the injury in case of your shoulder dislocation. So now they will ask you what is the most common type of nerve which is involved, and we have answered that, that is the axillary. And then they will ask you what is the reduction maneuver. So how do you reduce it? So reduction is mainly by what? You give a traction, then again you do abduction, right, and then you do external rotation, and then you do internal rotation and adduction. Okay, so why actually we have to do abduction and external rotation? So always remember, so whenever you want to reduce a fracture or whenever you want to reduce the dislocation, the most important thing what you have to do is you have to exaggerate the deformity. So this is the base, exaggerate. So exaggerate the deformity. That means initially it was what? Abduction and external rotation. So why it has been dislocated? Because of the abduction and external rotation, and it has been locked in that position. So that is why it is not coming back to the normal position. So now what you do? You slightly abduct, external rotate, so that now it disengages, and then you do adduction and internal rotation, so it falls in its position. Okay, so anytime, yeah, team, the traction, external rotation, adduction and internal, all medial rotation. So let's take help of Mayur again. So Mayur has been helped us with a mnemonic, that is team. But I want you all to remember the concept. So first always exaggeration, that is disengaging it, and then you convert it into a normal. So here the normal is adduction and internal rotation. So opposite of that, exaggeration. Okay. So we are going to remember it with traction, external rotation, adduction and medial or internal rotation, right? So yes, so this is the reduction maneuver of your anterior dislocation of the shoulder. And then one more thing I want you to remember is the posterior dislocation. So in case of posterior dislocation, what happens? Okay, so posterior dislocation, where do you usually see in posterior dislocation? We usually see, yeah, distract first and then locate. Yes, maybe correct. See, the terminologies are very important. See, I said you have to disengage it. It is little bit of a academically correct. So distracted is like maybe for the people who can understand it better. Okay, then for the posterior dislocation, what we are going to remember, it is commonly seen in condition where the patient come with convulsions and electric shock. So these are the two important conditions. If the patient tells you the history of these two, like in the convulsions or electric shock, you can just always think about your posterior dislocation. Okay, and what is the important sign which you have to remember here? The empty glenoid sign or the electric bulb sign. So empty glenoid sign and the electric bulb sign, right? Yes. So these two are very important. And then coming to the inferior dislocation, in case of inferior dislocation, it is also called luxatio erecta. It is also called luxatio erecta. So why I am putting this terminology is because sometimes they can just ask you what is luxatio erecta. So this is nothing but inferior dislocation of the shoulder. Okay? Yes, these are the shoulder dislocation. And then let's move on to the next one. So what is this here? The next image, what is it showing? Very important again. So next image is showing you the humerus shaft fracture. And remember, if it is a proximal humerus, so if it is a proximal humerus fracture, also the most common nerve which is involved is again your axillary nerve. This is also very important. Okay, and then what is the humerus shaft fracture? That's not correct. Omkar, any dislocations are painful. Why posterior is painless? So here what I am very concerned about is the position of the fracture. So whenever you see a humerus shaft fracture, you have to be very careful whether this is in the proximal or middle or distal. So that is very important. So when it is in a junction, of middle and distal 1/3, right, middle and distal 1/3, then it is very, very important because here you are going to encounter what? The most important structure, the radial nerve. Very good. So the radial nerve gets involved here, and what it results in? It results in the wrist drop. So whenever the radial nerve is involved, it results in the wrist drop. And what is this called? So what is this called? This is called as the Holstein-Lewis fracture. Very, very important, asked in the exam. So what is a Holstein-Lewis fracture? Humerus shaft fracture whenever associated with your wrist drop is your Holstein-Lewis fracture. And why so is the radial nerve involved? The radial nerve is involved because it is tethered tightly to the lateral intermuscular septum. So INICET is always about the concepts. You have to remember concepts if you want to crack the exam. So why the radial nerve is involved? Because of its strong connection with the intermuscular septum. So sometimes always in the human body, if they are not mobile, for example your medial meniscus, the medial meniscus is tightly attached to your medial collateral ligament, so that is why it cannot escape the injuries and hence it is commonly injured. Similarly the radial nerve. The radial nerve, when it is nicely coming on the posterior aspect to the lateral side, it wants to come to the lateral side, and as it is transitioning, it is tightly adhered to the intermuscular septum. So because of that tightness, whenever there is a fracture at that area, this radial nerve gets crushed because it is tightly attached and it cannot escape. So because of this crushing of the radial nerve, it results in wrist drop. So the patient will come to your OPD directly with the fracture plus wrist drop. But what is the most fortunate thing here? The fortunate thing here is this radial nerve which is injured is a neuropraxia. So what is a neuropraxia? So this is a type of nerve injury. If you remember, there are three types: neuropraxia, axonotemesis and neurotemesis. So neuropraxia is supposed to be the mild form where just the nerve is irritated. So there is no pathological loss of any layers of the nerve, and only there is a loss of axoplasm flow. So the flow gets stopped. It is like your concussion of the head or your bowel. So here, because of that loss of your axoplasm, the nerve is damaged. Okay, so this is a neuropraxia. So now why you want to know whether it is a neuropraxia or not? Because reassurance, treatment. So you're going to tell the patients that this is a neuropraxia injury to the nerve and hence the recovery is 100%. right? So again, you have to remember whether this is an open fracture or a closed fracture. If it is an open fracture, you have to check and explore the nerve to see whether there is any structural damage to the nerve. But if it is a closed fracture, then it is 100% neuropraxia, and it is 100%, the nerve is going to recover back. So that is about the Holstein-Lewis fracture. Very important, they will ask you. Then comes the third one. So what is this? The third one is called the terrible triad. It is called the terrible triad of elbow. Yeah, yes, you can check for the Tinel sign. So how are you going to reassure the patient that it is, recovering? So then you're going to check for the Tinel sign. So you're going to check for the Tinel sign. So what is a Tinel sign? Tinel sign is nothing but whenever there is a recovery, the nerve is now recovering, you can feel certain sensations in that part of the hand. So for example, I will explain the Tinel sign also here, as Omkar has raised that. So this is the median nerve. So you all know the distribution of the median nerve, right? So it is in the carpal tunnel at the center of your palm, like this, and now radial nerve is on the lateral aspect, so it goes like this on the lateral aspect. So for the first, you have to know the surface anatomy of the nerves, and then for example, for carpal tunnel, if you're thinking, so now what you do, the Tinel sign is, so now the nerve is completely damaged at this end. So let us assume the nerve is damaged at the wrist point. So near my strap, near my watch strap, it is damaged, right? So what happens here, the recovery starts from here to, it goes like this. So recovery is from proximal to distal, right? Now what you have to do, the Tinel sign is, you're going to check whether the nerve is recovering or not. So now what you do, you come from distal to proximal. Okay, from distal to proximal. So you're going to tap somewhere around here because the thenar eminence is supplied by the nerve, right? So you're going to tap on the thenar eminence, and then you come over to the wrist, and then come over to the area where it is damaged. And somewhere around, if you feel there is a shock-like sensation, that means the nerve is recovering. So for example, I have come tapping like this, and now I see somewhere just 2 centimeters above my strap, I found there is a shock-like sensation. That means the injury which was over here has been recovered up to that point. So now you're going to tell the patient, now it takes time for it to recover whole of this hand, maybe some 2 weeks, 3 weeks time. If there is no sensations present, that means recovery has not yet begun. So that is what is Tinel sign. So this is for your knowing whether the recovery has started or where it is in the present of the nerve. So where it is still it is going to recover little, or it has been completely recovered, or what. So that is the Tinel sign. Okay. So now let us learn about the terrible triad. So what is a terrible triad of the elbow? So elbow dislocation is the next most common after shoulder dislocation. So whenever you see a elbow dislocation, it could be a simple dislocation or it could be a fracture dislocation. So when I talk about fracture dislocation, the most important thing you have to remember is the terrible triad. So in the terrible triad, what you see is there are 3 important components in the terrible triad. So first is the elbow dislocation. So there is always a elbow dislocation which is associated with the fracture of the radial head, right? Radial head and fracture of the coronoid, So what is a coronoid? Coronoid is this particular area. So this is your this anterior aspect of the ulna is the coronoid process. So when that is very important for the stability. So when this is also fractured, this becomes very unstable. So what is the importance of knowing that this is a terrible triad? That means it is a very unstable injury, very high velocity injury. That means all the ligaments which were present, that your radiocollateral ligament, ulnar collateral ligaments, all the ligaments which are present on the elbow joint has been damaged. So this is how you come to a conclusion to counsel the patient. So whenever you see such a terrible triad, you have to counsel them. So this is a very bad injury. Most of the ligaments would get injured. So you're going to take a CT scan, you're going to take a MRI scan, and then you're going to tell the patient that so and so fracture has happened, so and so ligaments has been damaged, and what is the prognosis, right? So that is very important. So whenever you see a terrible triad, so 3 important things will be noted. One is the dislocation elbow, radial head fracture, then your coronoid fracture. Okay. And then what is this? What is the image which is next to the terrible triad? So this image will tell you that there is a rupture of the intermembranous ligament rupture, that is interosseous membrane. So here if you see, there is a radial head fracture, okay, and then you see which is associated with the distal radio-ulnar joint dislocation or disruption. Okay, so this is the beauty that you have to appreciate in orthopedics. Whenever we say that you have to examine a joint above and joint below, one joint above and one joint below has to be examined. For example, now we are dealing with the terrible triad of elbow. So now what you have to do, you have to examine what is the status of the shoulder joint, what is the status of the wrist joint as well. So sometimes whenever you see a radial head fracture, simple radial head fractures also, you have to examine for the wrist joint. Why? Because there are chances that this radial head injury, whatever has happened, will travel, this injury velocity will travel through the interosseous membrane and will damage your wrist joint. That is the yes, that is your 𝐒𝐿-Lopresetti injury. Very good. So that is your 𝐒𝐿-Lopresetti injury. Okay. So that is why very careful whenever you're dealing with trauma, you have to carry in mind one joint above and one joint below. X-ray also, one joint above X-ray, one joint below X-ray should be included to overcome all these other minor injuries which we can miss. So can you tell me what is the similar pattern which we see in the lower limb? In the upper limb, I am telling you that there is an injury to the radial head, and this particular injury along with your interosseous membrane, it is also damaging your distal radio-ulnar joint, right? And this is nothing but your 𝐒𝐿-Lopresetti. This is what we have learnt, right? So that is why one joint above, one joint below. And can you tell me the same which we can see in the lower limb, the name of the fracture? Very good, Mayur. Meso-Nevis fracture. So the name is your Meso-Nevis fracture. So what do you mean by Meso-Nevis fracture? So here what you see is the ankle joint. So you will see there is an ankle joint fracture. And now similarly when you take a knee X-ray, one joint above, you will see there is a fracture of the fibular head also. Okay, ankle joint fracture associated with the fibular head fracture is again similar to your 𝐒𝐿-Lopresetti, which is called as the Meso-Nevis fracture. Meso-Nevi, N has to come. Okay, Meso-Nevis fracture. Very good. Okay, so that is about the various fractures which we have learned, and now let's move on to the complication of your shoulder dislocation. So whenever you see a recurrent shoulder dislocation or a habitual shoulder dislocation, so this is usually seen in the patients. So these two terminologies can result in an important complication, which is again important for us in the MCQ point of view, is two important things. So one is called the Bankert's lesion. So one is called the Bankert's lesion, and the second one is called as your Hill-Sachs defect. So Hill-Sachs defect. So what is a Bankert's lesion? So Bankert's lesion, if you see, this is all about your labrum. So I've already told you that the shoulder joint is not as deep. So the glenoid is not so deep to incorporate your shoulder humeral head. So what happens, it is little bit shallow like this, but this becomes deep because of the presence of the labrum around it. So this is the labrum, the fibrous structure which is present, right? So this labrum makes it more deep so that the head sits nicely inside. Okay, so because of the recurrent dislocation, so for example, in anterior dislocation, so what is happening? This labrum is being rubbed. So whenever the head is coming out, you are going to rupture the labrum and go. So that is why this glenoid labrum is disturbed, especially in the anterior and the inferior area. So the anterior inferior area, you see a injury in the labrum. This is known as Bankert's lesion. And similarly, whenever the head is coming out, so which part of the head is hitching the bone? So it is the posterolateral area. So this is the posterolateral part of the humeral head. So you see a posterolateral defect in the head. This is your Hill-Sachs. Okay, this is your Hill-Sachs. So remember, H for H. Hill-Sachs is for humeral head. That is what you have to remember. So H for head, 𝐒𝐿-CET is for your humeral head, and the second one is your 𝐌𝐞𝐝. 𝐌𝐞𝐝 is for your glenoid labrum. So glenoid labrum, so what usually they ask in the INI-CET, I told you concept oriented. So they will ask you which part of the labrum is injured. Then the answer would be anterior and inferior part of the labrum. And which part of the defect is called as 𝐒𝐿-CET? Posterolateral part of the humeral head. Nothing to by heart, just remember the head is coming out. So the labrum, it is disturbing in the anterior part, right? And anterior and inferior part. So usually you remember the most common type is subcoracoid. So coracoid is down, right? So the anterior inferior. So exactly opposite to that, the head is hitching on the posterior side. So posterior lateral side. Okay, posterior lateral side is called the 𝐒𝐿-CET, and anterior and inferior is your 𝐴. And now they can ask you, how do you treat them? So we treat them arthroscopically. So we use arthroscopic shoulder repair, arthroscopic shoulder repair. And sometimes for the recurrent dislocation, what they treat is they put the subscapularies as double breasting. So they take the subscapularies and they prepare and they make it as double breasting technique. That means they put this muscle over anterior aspect so that it is not dislocated frequently. This is by your habitual dislocation. So people with habitual dislocation, we can do this subscapularis muscle, which is used as a double breasting technique. So this will be not asked, but maybe they will ask now. Okay, so this is about the complication of your shoulder dislocations. Now coming to the forearm. Forearm, you all very know quickly we are going to complete the forearm because very easy. Two important things you have to remember. One is your Monteggia and the second one is, yes, Monteggia, the second one is, okay, till you answer, I am not going to write what is Monteggia. So till then I'll explain what is Monteggia. So Monteggia is what? Fracture of the ulna with the proximal radio-ulnar or radial head dislocation. I think this is very easy for you all to remember. So whenever we talk about Monteggia, very good, it is Galeazzi fracture. The second one what you're going to talk about is your Galeazzi fracture. So now what you're going to identify. So this is an IBQ. It is an image based question. So they will just put an IBQ, that is image X-ray, and they will ask you name the fracture. So you're going to name it based upon your presence of the fracture. So whenever you see a ulnar fracture, M for medial side is ulna. Okay, so M is on ulna, that is whenever you see a ulnar fracture, it is associated with the radial head dislocation. Then, so this is the radial head. So radial head is dislocated. So this radial head dislocation with ulnar fracture is Monteggia. And what is the next opposite to it? So Galeazzi. So Galeazzi, you all know it is nothing but again the fracture of the radius. So radius has been fractured, but with the presence of distal radio-ulnar joint disruption. So remember, proximal is ulna, Monteggia is ulna with the proximal, and Galeazzi is, yes, what I remember is like, you can remember this as murg also. Murg is chicken, no? So M for ulna, Monteggia ulna, Galeazzi is radius. Okay, radius for Galeazzi. Okay, so people who are fans of chicken can take the help of Murg and remember what is Monteggia and Galeazzi, just not to confuse in the exam. So whatever mnemonic you want you put, but please don't get confused in the exam. Okay. Yeah, grimace also you can take. And why, if the ulna is always associated with the radius head dislocation, so that is Monteggia. And why we are very concerned about Monteggia and Galeazzi when there are so many fractures which we can learn in forearm? Why we are most concerned? The concern is the treatment always. The concern is the prognosis always. So these are supposed to be the fractures of necessity. That means they always require open reduction and internal fixation. That is important. So this will be asked in the INI-CET. What they will ask, what is the treatment of Monteggia? Because he knows that everybody will learn what is Monteggia, but only few people will come up with the treatment. Now tell me, what is the treatment of Monteggia? Yes, the Monteggia treatment is open reduction and internal fixation. So now what you are going to fix it? Are you going to reduce the radial head or you are going to treat the ulnar fracture? So obviously with the common sense you will answer me that you are going to fix the ulnar fracture. But what about the radial head? Are you going to touch the radial head? Yes, I want you all to answer this quickly. Yes, Mayur. That is okay. Pin injury we will learn, Mayur. But I am asking you what is the treatment of the Monteggia? You are going to fix the ulnar fracture. And then what about the radial head? You are going to fix it, you are going to reduce the radial head. Omkar, Mayur and Sudhan, Narayani, Jai. Yes. So the thing here, the catch here is you're not going to touch the radial head. Once you reduce the ulnar fracture properly, so there is an absolute reduction of the ulnar fracture, the radial head will fall by itself into its place. So these we are not going to depend on injury, can excise or replace. No. No excision, no replacement. There is no radial head fracture. Omkar, there is no radial head fracture. The radial head has dislocated. Okay, so whenever there is a dislocation of the radial head, especially with the ulnar fracture, what we do is we fix the ulnar fracture. We are not going to touch the radial head. Once you fix it properly, the radial head will come and sit in its place. Okay, this is what you have to remember. But with the Monteggia, but with the Galeazzi, whenever you fix the radius fracture, you have to test for DRUJ, because DRUJ sometimes requires fixation. Sometimes it requires fixation. Okay, but for Monteggia, again there are types of Monteggia. So there are types of Monteggia ka matlab, again you have to tell me what is the classification of Monteggia. So classification of Monteggia is Bedo classification, right? So if it is a simple Monteggia fracture, you're just going to fix the ulnar fracture, the radial head will fall on by itself, nothing to do. If it is a complex, if it is a communicated, if it is an open type of fracture, then you have to do something for the radial head. And for the Galeazzi, radius fracture, usually because it is a disruption of the ligaments. So this is not a dislocation or something, it is a disruption of the ligaments. So you will going to check what is the status of the DRUJ. This is called as the piano sign. So this is called as the piano sign. So you are going to play with the radius and ulnar like the piano. You are going to push each thing like this and you see, and if it is very unstable, you just going to put a wire through it. So that is the fixation. Okay, and now let's take Mayur's thing also into consideration and write the important nerve which is damaged, that is your pin nerve. So what is the difference between a wrist drop and what is the difference between a radial nerve palsy and a pin nerve palsy? So radial nerve, you are going to see the wrist drop, whereas pin nerve, the output is your what? Finger drop. Okay, this is what you have to remember. So that is the wrist drop, radial nerve. Pin is nothing but it is a branch of the radial nerve. So if this nerve is damaged during your Monteggia fracture or during your reduction, there will be a finger drop. So yes, it is a purely motor, right? It's a purely motor. Yes, this is about your Monteggia and Galeazzi. Hope you have completed in detail. So moving on to the next one. So next one, yes, can you identify, these are the fracture of the first metacarpal, that is your thumb, and especially the base of the thumb. So there are two important fractures which you have to remember when I speak about the base of the thumb. There are two. One is called the Bennett's, the second one is called the Rolando. Now, can you identify which one is Bennett, which one is Rolando? I have marked A and B. So, what is A, what is B? So, this has been asked in the INI-CET as a match the following. So, three fractures. So, all these three has been given. Right? What are the three here? So, one is your Bennett's, Rolando, and the third one is, this is what? C. So, all these three has been given. Yes, I want to know what is Bennett's, what is Rolando, and what is the C. Faster, faster. Yes, Mayur, the first one is the Bennett's, where you see there is a two-part fracture. So, the fracture fragments are divided only into two. So, this is your Bennett's. Where you see Rolando, Rolando is three parts, that is a T-shaped or a Y-shaped. It is nothing but a comminuted fracture. So, this is a comminuted fracture of base of the thumb. You can see this is a Y-shaped fracture like this. Okay, and then what is the C, the third one? The third one is the boxer's fracture. Can you see on the, Yes, C is Boxer's fracture, where you see there is a fracture of the metacarpal. Which metacarpal? Fifth metacarpal neck. And what is the most common type of fracture? Fist. You make a fist and then you hit somebody with the anger. So that anger is required than the fist. Why anger is required? Because the velocity has to be more. So anger is very important than making a fist to have your fifth metacarpal fracture neck. Okay. So fifth metacarpal fracture neck fracture is what? Boxers. B for bi. So whenever you say Bennett's, it is bi. Bi means 2. So 2 means 2 parts. It is divided into 2 parts. First part and second part. And if you see the larger part, you have to be very, very careful. There are 2 parts. This is the larger part, that is the small part. And here the Bennett's is very important for us. Why it is important? Because it is intra-articular and you have to fix it. So both of these fractures are intra-articular fractures. Both Bennett's and Rolando are intra-articular fractures. But I am very concerned about the Bennett's because why? Yes, Mayur, you have to tell me why Bennett's requires surgery. I'm very impressed that you have come up with telling me that Bennett's is surgery, Rolando is conservative. But why Bennett's requires surgery? Yes, quickly. So I have given you a clue there. I have drawn something on the larger segment or larger fragment. So because there is a pull of the tendon, there is one tendon which is constantly pulling the fragment of this particular area. Can you name the tendon? And this will be asked in the exam. So what is the tendon? I am pretty sure you all know the name of the tendon. So this tendon constantly keeps pulling the fragment and it will not allow to heal. So because it is an intra-articular fracture, so whenever the fracture is into the joint, they have to be fixed because the joint movement is very important. So this is the base of the thumb, right? So you have to do a lot of things with the thumb. So you need to fix that fracture. So because you need to fix that fracture, first you have to know what is the mechanism which is happening inside, right? So there is a fragment which is a bigger fragment and it is constantly pulling. Yes, it is the abductor pollicis longus. Very good. APL, EPB. You know APL and EPB, these are the tendons of the first compartment, right? So these are the tendons of the first compartment, APL, EPB, and this APL, abductor pollicis longus, keep pulling the fragment and it will not allow it to heal. Hence we have to fix it, counteracting the pull of the tendon. Very good. That is important. And coming to Ronaldo also requires fixation. It is not always conservative, but if it is severely, 3-4 fragments, we can't fix it. So we will leave it to unite. So that is why we take Ronaldo as conservative and this as a absolute fixation, because there are only 2 fragments and you can fix it properly. And now coming to the boxers also you can fix it with the K wire at least, or you can go for a conservative treatment, right? So these are the 3 important fractures and this has been asked in the table form A, B, C and they have given the names of it. Yes, we are done with it. And now let's coming to the complications. So very important, you have 2 important complications in case of your fractures. So the first one is the non-union. In case of complications, you have to remember there are many, but what are the important points of each thing? Complication of fractures is again a very important topic. So we'll start right away with the non-union. So whenever you see a fracture, so example, this is a fracture and this is supposed to heal. And the beauty of orthopedics is this heals very neatly, which is called as remodeling, and it will be same like the original one. So if you think this is the original bone, it has fractured and it is healing again because of the process of remodeling. It looks exactly similar like the normal one, but it takes time over a period, maybe up to 2 years. After 2 years, if you take the x-ray, it looks similar. But sometimes these fractures don't heal. Why they don't heal? Because there are certain problems to it. So what are those problems? And this not healing of the fractures is called as non-union. And this non-union can be of 2 types, which could be called as an atrophic non-union. The second one is called as an hypertrophic hypertrophic non-union. Now let us understand why it is called as atrophic and hypertrophic. So I told you the bone has to heal, right? So bone has to heal. Why it is not healing and what is actually required to it to heal? Can somebody tell me one important thing what it requires to heal? The broad one important thing. So the first thing what it requires is nutrition, right? So it requires vascularity. So the bone has to be viable. It is to be filled with bone, filled with blood, with growth factors, and the nutrition all is required, right? Second one is mechanical stability. So the bone has to be fixed properly, stabilized. That is why whenever there is a fracture, whenever there is a sprain in the ligament, whenever there is any orthopedic problem, the first thing what we give rest and immobilization, because whenever we immobilize, that means we are giving stability to the part to heal. So this stability it depends upon the bones. It depends upon types of the bones. If it is a femur, you just can't make it sit like that and heal. It requires some amount of stability, more stability. So we give a femur nail as its stability. And for smaller bones, like for example Box's fracture, it is just a metacarpal. So metacarpal, anyways, you don't put a lot of weight, and if you ask the patient to stay back from his regular activity, a simple cast would help him. So in this cast, what we are doing, we are providing immobilization. That means we are giving stability to the part, rest to the part, so that it heals. So if this stability is not given properly, the bones will not heal. And if the vascularity is also not proper, the bones will not heal. So now, depending upon the vascularity, which is very, very important, they have divided into two parts. So if the vascularity is absent, it is atrophic. If the vascularity is present, that is hypertrophic. Now you should ask me, even though the vascularity is present, why it is not healing? Because there is no stability. Right? Now you understood what is a hypertrophic non-union. It is vascular enough, but there is no stability. Hence, it goes into hypertrophic non-union. Clear? Any doubts? So now, how can you identify a hypertrophic non-union? So always a non-union, whenever you see on the X-ray, you will see some amount of gap. And remember, these non-unions are painless. Okay? And if you see, there is a callus formation, then it is hypertrophic. So in the hypertrophic, what you do, you see there is lot of callus formation. Why callus has been formed? Because there is vascularity, because the blood is going there, because it is being filled with growth factors and everything is there. But there is lack of stability for it to heal. And what is atrophic? Atrophy. Atrophy means there is no vascularity. Even though the stability might be or not there, but we are first involved to know whether it is vascular or not. If there is no vascularity, even if you give a lot of stability also, it will not heal. Is that clear? No confusion, no stability, vascularity? Yes, I want you to give some, heads up. Okay, not okay, too much. So I'm just concerned whether they will ask a question based upon your hypertrophy and atrophy. So just you have to identify the image. If you see there is a lot of callus, still the bone is not healing, it is a non-union. And sometimes non-union can be because of one more interesting thing, that is avascular necrosis. So this is important for you. So whenever you deal about avascular necrosis, remember there are three important areas: the scaphoid, the talus, the femur head, right? So these are the areas you have to be very careful. Because of the avascular necrosis, they go into non-union. So these are the three areas. Whenever you see a scaphoid fracture, this is the scaphoid fracture. So scaphoid fracture, where the fracture will occur in scaphoid, it is the waist fracture, and which goes into AVN, the proximal part of the scaphoid. The proximal part of the scaphoid will go into non-union. Similarly, femur head goes into non-union because of fractured neck of the femur. So there is a fractured neck of the femur where the head goes into non-union. And similarly, talar neck also. The talar neck fractures will go, the head, the proximal part, the head of the talus will go into AVN. Okay? Yeah. That is the most important thing you have to remember. for the non-union, especially it is with the avascular necrosis. So avascular necrosis is a separate component where there will be a problem in the blood supply in that particular bone itself. So for example, if it is a fractured neck of the femur, so the blood supply to the head will cut off because of fractured neck. So that is why head goes into non-union. Okay, non-union because of again AVN and non-union. Is that clear? Yes. And here in the talus, what you have to remember is one more important thing in the talus: non-union. Why there is a non-union? Because they might end up with AVN of the talar body. So talar neck fracture will result in talar body. And what is Hawkins sign? This they will ask in the exam. So what is Hawkins sign? Hawkins sign is, what is Hawkins sign? Yes, this is seen in the talar head. So if you see, this is a talus. So usually what happens whenever there is a non-union or AVN, if it has gone into AVN, so there will be sclerosis. What is sclerosis? Sclerosis means increase in the white part or increase in the density of the bone. So usually the bone is white, right? So whenever there is an increase in this white color or there is an increase in the density, that means the bone is dead. Dead means there is no vascularity. No vascularity means AVN. Whenever the bone is dead by itself, it cannot unite, right? So it goes into non-union, right? So this is called as Hawkins sign. So what is Hawkins sign? So whenever you see a sclerosis, or this Hawkins is mainly, you have to see the lucency. Lucency means it is normal. Lucency is normal. Sclerosis means it is dead. So if you see in lucency, that means the bone is viable, that is Hawkins signs positive. Hawkins signs positive is lucency. Okay, so Hawkins is the one who has observed that whenever you see a sclerotic bone, that means the bone is dead, and if you see a lucency, that means there is a nice, dark color structure, that means the bone is viable. So there is no problem with the talus. So that is Hawkins sign. And again you have to remember the classification of the talus fracture is nothing but Hawkins classification. This has been, they have asked this in the NEET PG. So Hawkins classification they have asked in the NEET PG. Okay. Now let's see one more important complication of the fracture, that is the malunion. So now you see the bone has been healed well. If you see there is no gap, non-union I have said that there is a gap in the bone, but here you see the bone healing is good. But do you think this healing will help us? So I told you the bone whenever it heals, it has to look like the normal. So here do you think the bone is looking normal? No, right? So this is loss of alignment. So there is a loss of alignment in this bone, and this loss of alignment is called malunion. So the union is malalignment. So this is called as the malunion. So why malunion is again important? Because this is also a complication of the fracture, and you have to remember there are again three important areas where you see malunion, starting right from your clavicle fracture, then your Colles fracture, then your supracondylar fracture of humerus. Okay, supracondylar fracture humerus. And can you tell me the fourth one, important one, easy one? Yes, can somebody answer? Mayur, Omkar, Sanjay? Yes. Important one, easy one. Fourth one, areas which are important for malunions. So whenever you see these fractures, again you have to counsel the patient. So why it is again important? Again for prognosis. So whenever you see a scaphoid fracture, it is again asked in the exams. Always they ask in the exams, because scaphoid fracture is the one which we usually miss in the exam. Not in the exam, sorry. We usually miss the diagnosis. So scaphoid fracture, where you look for the scaphoid fracture, you look for the anatomical snuff box. So where you look for the scaphoid fracture, you look for the anatomical snuff box. This you have to remember. So anatomical snuff box, if there is a tendency or tenderness, so there is a tenderness in the anatomical snuff box, there you are going to suspect the scaphoid fracture, right? So this, whenever you see the scaphoid fracture, so that is why you have to counsel the patient that, you know, this fracture might land up in AVN. Because of the AVN, it might land up in non-union also. Similarly, femur fracture. Yes, Mayur, very good. Intertrochanteric fracture. It is very, very important. Intertrochanteric fracture femur. Right? And non-union is fracture neck of femur. So, fracture neck of femur is union, intertrochanteric fracture femur is malunion. So, these two we will learn in next slide, don't worry about it. These are the areas. So, whenever there are 3 or 4 options or answers, you have to be very careful because this will be a potential question in the exam. So, what are the areas where you expect malunion? They can ask you clavicle, they can ask you about Colles, they can ask you supracondylar fracture humerus and intertrochanteric fracture femur. So, coming to the malunion. So, what is the treatment of the malunion? So, what happens if there is a malunion? Malunion will always result in deformity. So, whenever there is a malunion, there will be deformities. That means you can visibly see from outside the patient complains of deformity in the malunion, and the treatment will always be a osteotomy. So, treatment will always be osteotomy. So, you have to cut the bone and then you have to align it. So, that is why osteotomy is the answer. And now, one such example for the deformity is your gun stock deformity. Is the gun stock deformity. So, this is the gun stock deformity. So, what is a gun stock deformity, guys? So, whenever you see a supracondylar fracture non-union, you will see this gun stock deformity. So, this is because of supracondylar fracture malunion. You will see this gun stock deformity. And what is this gun stock deformity? You can see the distal fragment has gone inward. So, this is called as the cubitus varus. So, this is called as the cubitus varus. And supracondylar fracture is very, very important. So, what is the important things you have to remember? What is the most common nerve which is damaged? The most common nerve. This was asked in the exam. So, it starts with anterior interosseous nerve, then median nerve, then radial nerve, then ulnar nerve. So, the answer what they have asked you is anterior interosseous nerve. Okay. So, whenever you see, yes, that is a Colles and Smith. So, distal fracture. Yes, Smith fracture is also a malunion. Yes, correct. Colles or Smith. That means distal radius. Yeah, Smith also you can take as malunion. Now, what the most common nerve which is damaged in case of your anterior interosseous nerve, in case of your supracondylar fracture humerus. So, this is also regularly asked, which nerve is damaged in supracondylar fracture humerus. So, this is the supracondylar fracture humerus. So, this is the humerus. And what is the classification? The Gartland classification you have to remember, right? Most common type is the extension type. This you have to remember. So, they can put options, which of the following is right or wrong as sentences. So, the most common type which we see in supracondylar fracture is extension type. And what is the most, what is the classification name? Gartland. The nerve which is damaged, anterior interosseous nerve. If that is not there in the option, you have to go for median nerve. And then you have to remember the OK sign. So, the OK sign is not seen. They might also ask you that OK sign is not seen, then which nerve is involved? So, it is the anterior interosseous nerve. So, if this particular fracture is not reduced properly, it goes into a complication which is called as the malunion, and this results in the gun stock deformity, which is the cubitus varus deformity of the limb. And this deformity, how do you correct it? You correct it with the osteotomy. The name of the osteotomy is the French osteotomy. So, what do? You do the French osteotomy. So, this is all about your supracondylar fracture. And one more important thing you have to always remember with the supracondylar fracture is, again, there will be a damage to the brachial artery as well. So, this also you have to remember, brachial artery. So, brachial artery can also be damaged. Okay, so you can't see it properly. Okay, brachial artery. So, vascular injury possible with supracondylar fracture is the brachial artery. So, vascular injury which is possible is the brachial artery. And what is the outcome of it? So, this might land up in compartment syndrome as well. So, brachial artery, compartment syndrome. So, these are all the complications which you can see in case of your supracondylar fracture. And the nerves, okay, you can't see something at the back of me. So, that is why I am writing anterior interosseous nerve, median nerve, radial nerve and the ulnar nerve. Okay. Yes, so that is about the malunion. We have discussed about non-union and malunion. And what is the one more important thing which you have to read? Important fracture. So this is called as an extra-articular fracture of radius, and this with the dorsal displacement. So this was asked in the exam. They have asked you what is a Colles fracture. It's a very easy question, but what you have to remember is whenever there is an extra-articular fracture, and if they put the next time as intra-articular fracture of distal radius, so that means the answer would be yes, Mayur, Sanjay, Omkar, what is the answer? The intra-articular distal radius fracture? I've told you the extra-articular distal fracture, whenever there is a dorsal displacement, this is called as the Colles fracture. Yes, if it is a dorsal displacement. So when it is a ventral displacement or volar displacement, is a Smith fracture. And now I'm asking you, what is the name for intra-articular? Yes, very good. So that is your Barton's fracture. So intra-articular is Barton's fracture. So now what is the X-ray showing you? X-ray is showing you somewhat it is extra-articular, not involving the joint. And if you see on the lateral view, you have to see for the dorsal displacement. So on the dorsal displacement, lateral view you see, and now this is a reason for a malunion. So usually there is a malunion which is happening, and whenever there is a malunion, there is a deformity. So you have to remember the name of the deformity which you see. This is called as the dinner fork deformity, right? And what is with the Smith fracture, the deformity? Garden spade deformity, right? Again, what you do the treatment, you do the osteotomy. Okay, clear everybody? So Colles fracture, extra-articular, dorsal. Smith, extra-articular, volar displacement. Intra-articular, either it could be a volar displaced or a dorsal displaced, but whenever it is involving the joint, the intra-articular joint, so this is the Barton's fracture. Clear? Yes, moving on to the next. Very, very important again. I'm not going to teach you in detail, just the important points of each thing. So fat embolism. So what is the most important thing? How they will start. So the question always starts with the young male, 25 years. So you will see a person coming to the casualty who is just 25 years, male patient with a long bone fracture, typically the femur fracture, but mind it could be a tibia fracture also, any long bone fracture, right? So he has come with the femur fracture. Assume that was a closed fracture, nothing is there, and then you are very intelligent, so you have checked everything, all the vitals, everything are stable. Then what do? You will shift to what? Shift to ward. Okay, now what is the scenario in the ward? So there it has been 24 hours and 72 hours in between, anywhere between 70 to 24, that is after 2 or 3 days. So if the patient has mild head injury, assume, and then you have posted him for surgery, so there is some financial disturbances in the family, so they are postponing the surgery. So within that, what will happen? The patient in the night, you have handed over to your friend stating that this is a normal case, femur fracture, everything is done, we are waiting for the bill to clear. And the next day your friend calls and tell you that this patient is in ICU. Then you are surprised what made him to sit in ICU. So here what happened is the patient in the night, he suddenly has shortness of breath. And with the shortness of breath, there were certain rashes. There's a _𝐒𝐿 which is present, right? And then suddenly, when we were asking what happened, he's completely confused. So all these three, whenever the patient is not talking, not oriented properly, with slight rashes here and there, especially the retinal hemorrhages, and then when the patient is having SOB, this is nothing but a triad which is telling you there is an involvement of neurology, involvement of respiratory and blood, right? That is your 𝐻𝐿. Okay, all this will tell you that when, and all this in our department, in with the femur fracture, will tells you that there is a problem which has occurred because of the flat globules which has been distributed in the blood, and they have initiated a capillary reaction, inflammation in the lungs, right, in the brain, resulting in damage of those capillaries and the lung. The parts has got damage, and this will result in the SOB and the PTK and the confusion. This is nothing but your fat embolism syndrome. Okay, very, very important. They will ask in the exam and they will tell you that this is the scenario, what is happening to the patient. You have to tell that this is a case of fat embolism. So the fat globules have escaped, but the catch here is you have to remember the time. The time. It is always after 2 to 3 days, after 2 days, after 24 hours, after 72 hours, after 48 hours. So this time gap will be present always to diagnose. And now what you do? We will happily shift it to ICU. So usually they take care of it. But what is our thing here? So sometimes what you do is you can fix the femur with a lot of support from the anesthesia staff and your ICU staff, so that once the fixation has been done, the patient sometimes gets stable. But sometimes the patient is so unstable that you can't shift him to surgery. So you will stabilize the patient first. So usually what we do, we treat it with the heparin, low molecular weight. Okay, so we treat it with the heparin and then we give him a lot of hydration, heparin. Okay, and all these things we do. So here what are we concerned about is only the diagnosis. They will ask you only about diagnosis. You have to remember when there is an involvement of young male patient with femur fracture with the symptoms of shortness of breath, pulmonary confusion, that is neurology is involved, and then what is the criteria, the 𝐒𝐿's criteria. So all these are included in the 𝐒𝐿's criteria, the major and the minor, what we have discussed. So in the minor you will also have fever plus tachycardia. So this is what you have to remember in the minor one. Okay, so this is about the fat embolism. And then coming to the compartment syndrome. So now I'll tell you what will you see in a compartment syndrome. Compartment syndrome, same scenario, there is a fracture. Here the fracture is in the forearm, right? So now what happened, this is a child, assume 12 years old child. Okay, now there is a forearm fracture in the casualty. We have told your resident has told it is a simple forearm fracture, closed fracture. We'll put a slab first. So you both have happily applied slab. You're very happy that you have applied the slab. You have shifted the patient to ward again. So now we have told the sister that this is a slab fracture, so and so. Treatment has been there in the sheet. You will put the treatment and you go away. Because it is the orthopedics, now no OT today, so you are free, you have gone to your room. So now the sister will call you, the patient is having pain. Then you will tell, we have already wrote the treatment, give the treatment, pain will subside, nothing to worry because it is a fracture we have given. So first hour pain, then again the sister will call you after 2 hours. Again she will tell, sir, baby is crying, child is crying, mothers are panic, 2 hours there is no pain reduced. Then you say you can increase the dose because the child is 12 years, maybe a little hefty patient, so you can increase the dose. You will ask the patient increase. Again sister will call after half an hour. Now it is 2.5 hours and then the pain is not reducing. Now the sister will tell, now it is not your hand, ma, I will call to resident, you are not responding properly. Now we will call the resident and tell that, sir, since 2.5 hours sister is disturbing me, even though I increase the analgesic, the pain is not reducing. Then suddenly your resident will tell, let's go to the ward immediately. So you will go to the ward immediately because the resident knows that he is dealing with the compartment syndrome. Why compartment syndrome? Because the pain not responding to analgesia. Okay, not responding to analgesia, the first symptom. Okay, the patient tell the pain is not responding to analgesia. Then what you do? Then your resident will come and tell, I think we are dealing with compartment syndrome. Then you will ask, how did you know, sir? Just pain. You will tell it is compartment syndrome. Then what your resident will do? He will do a passive stretch. So now what is a passive stretch? So it is ortho stories, yeah, our diaries. So now what you do, the patient, if there is a pain in the flexor compartment, so what you do, you slightly stretch it. So you slightly extend it. So with the extension, now the baby, the child cries, he will tell. Then you are like, okay, this is confirmed compartment syndrome. Now what he will do? What he will do? He will do nothing. He will call the consultant. He will tell, sir, we have applied this slab. Now, I think the patient is in compartment syndrome. The patient is having pain, stretch and all. Since 2.5 hours, there is no relief. Then your what you have to do immediately as the consultant arrives, you have to remove all the slab first. So remove all the circumferential things which are present. So remove the slab, slightly elevate the limb. Okay, slightly elevate the limb. You reassure the patient first. So reassurance is very important, telling that we are here to manage it. We know what is happening inside it, nothing to worry. We have cracked the diagnosis. This could be compartment syndrome. Okay, so now your consultant has arrived and he has told nothing to worry, we will wait for some time. So this is called as the impending compartment syndrome. So there will be a lot of pain as your resident is very active. He has removed the slab in time. So there is a chance of this compartment syndrome coming down. But sometimes if the residents are not active, they are not intelligent as your resident, this might land up in a severe compartment syndrome where the treatment would be fasciotomy. So the treatment, they have to immediately shift the patient to the OT and they have to excise the fascia. That is called the fasciotomy. Okay. So now what are the questions they usually ask? They put this scenario asking you what is this? You will tell this is compartment syndrome. They will ask what is the treatment of compartment syndrome? That is fasciotomy. And rest all is theory. Rest all is what is pain, pulselessness, all that is your theory. So they will have pain, pallor, pulselessness, okay, poikilothermia, and what is the other one? Paresthesias. So all this is theory. You don't usually take care of all these things. Surgery call, yes, you have to even involve the plastic surgeon sometimes, you know. And now see, what is the last thing? Here the question for us is, what is the last thing? You don't wait for the pulselessness, you know. Once the resident comes, he will feel the pulse. He will feel the pulse. Pulselessness is the last thing to arrive. That means the compartment syndrome has been gone into severe form. They have stopped the circulation. Okay, so now this is your scenario. You have dealt it very nicely. So who is the hero here? Hero is you. You have alerted the resident in time. So 2.5 hours you have waited, but you have alerted him in time. Okay, so sometimes what happens, even that time is not usually taken and the sister has to alert the consultant immediately. Paresthesias also will occur, and that is after your pain, passive stretch, sometimes paresthesia, sometimes tingling and numbness will happen accordingly. But pulselessness, poikilothermia, going cold is the last symptoms. So what is the pathology? Now after fasciotomy is done, now you are suturing. Now you discuss, right, with your residents. So sir, what could be why compartment syndrome has come? So your resident will take and tell you that compartment syndrome is a condition where there is an increased compartment pressure. So now you both are discussing the pathology. So we are discussing about the compartment pressure. So whenever this pressure goes 30 mm of Hg above, so this will land up in syndrome. So why actually this will occur? So because our muscles and bones are fixed in a compartment. So this is the compartment, this is tibia, this is fibula. And now if you see in the leg, we have 3 compartments. So we have the anterior compartment like this, and then we have the posterior compartment. Okay, posterior compartment completely like this, and then we have the lateral compartment. Okay, anterior, posterior and lateral. So why these compartments has occurred? They have been divided by the very important, what is our important here? The culprit, the fascia. So the fascia is a tight structure. The fascia is a tight structure and it will not allow anything to come and sit in the compartment. So it is very clear. The compartments are clear. It is well defined, the volume is well defined, only those has to sit. If there is some problem, so for example, you and your residents has put the cast, right? So this cast, because of tightness, the compartment is not able to adjust. So there will be increase in the edema, right? So because of the tightness, what is this tightness causing? It is raising the pressure. So what is this pressure dynamics? So what is this pressure dynamics means? In our body, everything flows with the pressure. So what is that? From high pressure to low pressure, the blood flows. So that is very simple, right? If you see waterfalls from high pressure to low pressure, height. So here also the blood flows from high pressure to low pressure. That means if there is a capillary or a blood supply outside. So here is the blood supply and here is the capillary inside the muscles. So now the blood has to flow from here to here, right? So the pressure has to be high here. the pressure has to be low here. In the compartment, there should be low pressure, and the outside the compartment, the pressure has to be high. So that is why all the things will flow, the blood will flow from high to low. But what is happening here, because of the cast, the compartment pressure is increasing. So now the compartment pressure has become high, right? The compartment pressure has become high. High. Now this is also high. So there is no movement of the blood. So hence, because there is no movement of the blood, ischemia. What is ischemia? Absence of the blood. Once there is ischemia, the forearm muscles don't know what is happening. Now there was blood, there was nutrition, now there is no blood. So what they will do? They will call the body defense mechanism. So the inflammation will come. It will release all the substances. So again there will be edema. Because of the edema, again there will be rise in pressure. Again the high. So again there is no gap, so there is no blood flow, again ischemia, again pressure high. So this is the vicious cycle. So how you have to break the cycle? You have to break the cycle first removing the cast, because of that only the pressure has risen. So now we are going to remove this cast. So once you remove the cast, the pressures fall down. So there will be blood supply. So this has to be done in time so that you are going to save the limb. Similarly, if this is not helping, now what you do? You will cut the fascia. So fascia is tight structure which is not allowing you to do all this. So now you are going to incise the fascia. So all the compartments you will release the fascia. So now what? Because of the release of the tightness, the pressures will fall down. So once the pressures have fallen down, there will be supply of the blood and the muscle will recover. So this is the story behind you and your residents has discussed all this, and now you are going to prepare for the exam for the compartment syndrome. Is that clear? Yes, Mayur has given very detailed that edema, inflammation increase, pressure then edema increase, that is a vicious cycle. Yes, very good. Okay, clear? Clear? Yes. Okay, now let us see what is happening in crush syndrome. So what is this crush syndrome? So this crush syndrome is nothing but when this is happening usually in the, for example, you have gone to a concert. Okay, in the concert, everybody are happily smiling, listening, dancing, and suddenly there is some explosion. So with that explosion, everybody are running here and there, and suddenly one of your relative or friend has fallen down and stampede has happened, right? Or sometimes in case of volcano, there will be a high velocity injuries, and this will result in the one important syndrome which is called as the crush syndrome, right? So what is actually this crush syndrome? The crush syndrome can be a combination of these two, the fat embolism and the compartment syndrome. Okay, so the crush syndrome is very important because there will be severe crushing of the muscles in that compartment. So here, because of the heavy load which is fallen onto the limb, it could be buildings, it could be the persons, it could be any heavy vehicles or machines, whatever it is, there is a severe high velocity injury which is causing crushing of the muscles. This is the pathology. So whenever there is a crushing of the muscles happening, so these muscles which are rich in potassium and myoglobin are released into the blood. So this you have to remember. This is the only thing you have to remember. Release of potassium and myoglobin. So this myoglobin will go to the kidney, right? And this will result in damage to the kidney, because excessive of myoglobin will result damage to the proximal tubules of the kidney, right? So this will result in kidney damage. So there will be damage to the kidney, hence the creatinine levels will go high. And there will be hyperkalemia. So this has been the exam. So the question here is, what is the electrolyte abnormality you see in the crush syndrome? So that is your hyperkalemia. And what is the damage occurring? This is a proximal tubule. So the proximal tubules get damaged here in the kidney because of the myoglobin. So sometimes what is the treatment? The treatment you have to go for dialysis sometimes to encounter this loss to the kidney. So treatment should be adequate, dialysis should be given, or the chelators, the potassium chelators has to be given to bring down the potassium levels and the myoglobin. So there will be myoglobinemia, myoglobinuria, hyperkalemia. All this will result in the damage to the patient. So this is called as the crush syndrome. Okay, so now moving on to the next one. So the next one is Volkmann's ischemic contracture. So what is Volkmann's ischemic contracture? So this contracture is mainly because of damage to the vessel. So for example, damage in the vessel in case of brachial artery. So you see there is a damage in the brachial artery, especially in the supracondylar fracture humerus, right? So here this might land up in a severe form of brachial artery injury or the sequelae of your compartment syndrome. So now if you have not treated the compartment syndrome immediately, what will happen? Yes, you can see this in supracondylar fracture. So if you're not treated that, this will go, the muscles will die because of the ischemia, and now the muscles will go into fibrosis. So they won't heal properly and they goes into a fibrous structure which is called as the fibrosis. So this fibrosis will make the fingers, the flexors, especially it is involved in the flexor compartment. So this will be seen in the flexor compartment. Flexor compartment. So because of the fibrosis, what happens? This is the contracture. So this is called as the Volkmann's ischemic contracture. So there will be complete contractures of the fingers like this because all the flexor compartment group of muscles have gone into fibrosis. So there is no expansion, there is no relaxation for the muscles as the tissue has been damaged. So they are completely contracted like this. So this fibrosis will result in contractures. So what is the important thing we have to note in case of the VIC? So VIC, you have to see that there is an important sign which is called as the Volkmann's sign. So what is the Volkmann's sign? So Volkmann's sign is whenever you, what do you do? Whenever you extend the wrist, the fingers will further flex. So wrist extension will result in further flexion of the fingers. This you have to remember. Or whenever you are doing the wrist flexion like this, so wrist flexion will result in release of the contracture, release of the finger flexion. Okay, so this you have to remember. So that is the Volkmann's sign. So Volkmann's sign is there is a absolute contraction of the fingers on wrist extension. So it further aggravates the fibrosis, right? So further it makes tight. So that is why fingers go into flexion like this. So once you relax the wrist, so you are going to flexion of the wrist, there will be spontaneous extension of the finger. So that is your Volkmann's ischemic contracture. Yes, the treatment depends upon the types of it, the severity of it. If it is a mild, you can go for physiotherapy. If it is moderate, again you can go for splinting. The splinting is Volkmann's splint. So it is a Volkmann's splint. And the severe form, what you do is you give Max Page gliding surgery. So you do a Max Page surgery. If it is a severe form, yes, you can remove some of the bones so that it makes the wrist into flexion. So that is the thing. So fibrosis is they have become straight and they are stretched, right? So some amount of the bone will make them flex and you can move the movement. So that is the Max Page sliding operation. Okay. Yes, so that is about the VIC. Next, myositis ossificans. So what is myositis ossificans? So this is usually seen in two different conditions. So one, it is mainly seen in the elbow joint. After that, it is seen in your hip joint. Okay, so these are the two joints where you see this myositis ossificans. Max Page and bone shortening is in severe form. In mild or moderate, you go for your splinting. Okay. Yes. So myositis ossificans is nothing but the name itself suggests that the muscle is ossifying. So there is a muscle which is getting ossified, and this is usually seen in the joints. There are two important joints which are involved. So one is called the elbow joint, which is very common, followed by the hip joint. So what will happen in this? So whenever there is a fracture or whenever there is some problem in the hip joint, because of continuous massage which is done, to the joint, the muscle gets activated. So the osteoprogenitor cells get differentiated and this muscle gets ossified. And now what they do, the problem is they cause restriction of the joints. So you will see the movement, restriction of the movements. So the movements are restricted, so they cannot flex or extend properly because of the bone is present in the joint. So the joint has to be clear for the movements, right? So for the flexion and extension, if there is something which is present in the joint which is limiting your flexion and extension, so that is your bone itself. So that is your myositis ossificans. So this is very commonly seen in the villagers, where they do lot of massage over the joints, and this will stimulate the muscle to form into a bone. So what is the thing you have to do? You will do an X-ray and you will find that there is a bony part which is present in the joint. And how do you come to a conclusion? So usually what will happen in myositis ossificans, both passive and active movements are restricted. So this is important. Either you do or the patient do. Both active and passive movements are restricted. That is when we will see that some bony component is involved. Okay, and you have to see whether this bone is matured enough or not to excise. So it will depend upon the X-ray. You can see that the outer part of the bone is matured, so then you can go for bone excision. So the treatment here is bone excision. So you will remove this particular bone and then you will increase the movement. So this is very treatment is the bone excision. So you will remove the bone in the joint, and then this will result in your flexion and extension movements. So that is the myositis ossificans, right? And the next one is your Sudex osteodystrophy. So here in the Sudex dystrophy, what is happening in the Sudex dystrophy? So this is a condition which we'll usually seen in elderly people, especially with the Colles fracture. So usually we see in the elderly people with the Colles fracture. And how do they present? They present with certain symptoms which are very vague. So it's pain, hyperesthesia. So they will tell that there is some abnormal pain sensitivity has been increased. And what is the most important thing you have to remember, on the X-ray what you see is, on the X-ray you see there is an osteoporosis of the bone. So on the X-ray you see there is an osteoporosis of the bone. Right, on the X-ray you see there is an osteoporosis of the bone. So what is mainly important in the Sudex osteodystrophy? So this is a condition, it is also called as complex regional pain syndrome. So this is also called complex regional pain syndrome, where the patient usually presents with the pain, hyperesthesias, they are not very happy, and then they'll have atrophy of the bone as well. So they will have atrophy of the muscles. So all these are there, and they are not very happy with the functioning of the hand. So they feel that there is a constant pain, there is a constant tingling sensation, there is a constant, not very happy patient, and this is not treatable. Usually they suffer, even the doctor suffers treating it. So now they have come up with two types of complex regional pain syndrome, type 1 and type 2. So whenever there is no problem in the nerve, so there is no problem in the nerve, like for example, there is no evidence of anything is involved. So that is type 1. So when you see there is an evidence, that is median nerve is involved. So that is type 2. Okay. So type 1 is no involvement of anything. Type 2 is median nerve involvement. So there is some nerve which is involved, and this is putting all the symptoms. But type 1 is there is no nerve involvement also, but patient will come with all the symptoms, and this is one of the most painful thing. The patient is very much in pain. The surgeon himself is very much in pain, and usually the symptomatic treatment is given like pain killers and all gabapentins, physiotherapy, everything will be tried, but nothing will help. So finally what you have to do, this is nothing but an autonomous overreactivity. So sympathetic overreactivity. So they will usually try to reduce that by doing sympathectomy. Okay, the surgery sometimes is needed if the patient is very adamant to the treatment, right? So this is about the Sudex osteodystrophy. So all these are little important things you have to remember about the complications, like your fat embolism, compartment syndrome, Sudex osteodystrophy, and then your myositis ossificans. So myositis ossificans, the most important thing what you have to remember is the muscle which is involved. So this is the extensor carpi, brachioradialis is the one which is involvement here. Brachialis is the muscle which is involved. Okay, so this is the muscle which usually goes into your ossification. That is, this is the muscle which goes into the ossification. Right. So now let us see about what are this is another very important classification name. So as we have learned about so many fracture types, so these are some of the important classification names we have. So you have to remember the name. Sometimes they will just ask you the names. So proximal humerus is knees, and you know that knee has divided this into 4-part fractures. So you have 4 parts like the greater tuberosity, lesser tuberosity, shaft, and the proximal humerus head. So this is the 4-part fracture. So based upon that, you will tell whether it's type 1, type 2, type 3, type 4. So that is the 4-part fracture which we see in case of your proximal humerus. Then femoral head. Simple femoral head, whenever it is associated with the dislocation, we use the Pipkin's classification, and whenever it is acetabulum, we use the Letourneur and Judet classification, right? And Monteggia, we have learned it is Bedo, and Supracondylar is Gatland, calcaneum is Essex lopticity, and Sanders in case of your CT classification. So whenever you are going to CT scan, you can use the Sanders classification. And in case of femur neck, you already know there is an anatomical classification, Gardens and Powell's classification. Powell's is an angles. So 0 degrees or 30 degrees or 50 degrees. What is the angle of the fracture neck? Whereas it comes to Gardens, it is based upon the trabeculae. It is based upon the trabeculae. And lateral condylar fracture humerus is Milch. So one more example for lateral condylar fracture humerus, it goes into non-union. Okay. And what is the deformity you see here? The deformity you see here is your cubitus valgus. Okay, this is very important. Cubitus valgus in case of lateral condylar fracture. This is also a humerus. Clear? Yes? Yes, very good. So it is the cubitus valgus, and these are some of the names you are going to learn, and you are going to ask your friends, and both of you are going to learn and then remember in the exam. Now coming to the lower limb. Lower limb is again very important because this has to be treated very meticulously, because these are the weight bearing joints. So all these weight bearing joints are even more important, and critical care has to be taken. So the first important question which comes from the lower limb is, whenever there is a pelvis fracture, so what is the first step of management? So there is a patient who has come to the casualty with a high velocity injury. They have transferred in from a road to the hospital, and you are suspecting a pelvis fracture. So how do you suspect? You will do a pelvic compression test, which is positive sometimes, and sometimes you will see the patient in shock. So you can sometimes diagnose this as a pelvis fracture. And what is the first next management after diagnosing as a pelvis fracture? You are going to put a pelvic belt or a compression around the pelvis with the help of a blanket also. Whatever is available. First, why we have to do it? Because severe hemorrhage occurs. So there will be severe hemorrhage which will occur if you don't do this. And where you should put? This should be done at the level of the GT. So you will identify the greater trochanters at both the sides, and then immediately you will put the belt. If the belts are not available, like in the rural setups, especially in our country, so what we do, we take a bed sheet or a blanket. We take a bed sheet or a blanket, and then when we do a tightening of that bed sheet. So you will tie that bed sheet around the GT. So to 2 GTs you will close it. So this will put a pressure on the pelvic vessels so they don't bleed. Yes, Mayur has told us the tamponing effect. So this is what they have been asked. So this is important question. Remember. So the pelvic classification is tile classification. So the name of pelvic classification. So based upon the tile classification, you can tell which type of pelvis fracture you are dealing with. Done. So next one. So here then they will ask you most important question. Again, this is also a question. So question in various forms. The first form what they will ask you is attitude of the limb. Can you tell me the attitude of the limb in this photo? Yes. What is an attitude of limb? Attitude is nothing but the position of the ease. So what is the attitude here? Yes, quickly. Very good. Flexion, adduction and internal rotation. So you can see in this limb or in this patient, there is a flexion, adduction and internal rotation. So they have asked multiple times. So what is this attitude? So this attitude is one which will lead to posterior dislocation of hip. So there will be a posterior dislocation of the hip. So how will you identify on the X-ray? So in the X-ray you see first the lesser trochanter. So obviously the head will be outside, but the lesser trochanter will be less visible or absent. So that means the limb is in internal rotation. So this is the important point which you have to remember. So the limb is in internal rotation. That means the lesser trochanter is little less visible. So you can see in the X-ray itself. So here you see there is a lesser trochanter like this, but here there is no lesser trochanter. And Shenton's line, again the medial neck to the superior pubic rami, inferior part. So here you see the Shenton's line is broken. So there is a break in the Shenton's line. That means the head is dislocated. It is internally rotated. So there is a flexion, and you can see the limb. Limb is adducted. So it is coming towards it. So this is called the adduction. So there is a farther position which is seen, and they will ask you if the patient has arrived to casualties with so and so attitude. So what could be the diagnosis? Posterior dislocation of the hip. They'll put this X-ray IBQ. What is the position of the limb? Flexion, adduction, internal rotation. Which nerve is damaged? So sciatic nerve injury. And they can ask you what is the consequence. Then you will examine the foot, and then they will tell that there is a foot drop. Then what is foot drop? They can ask you what is a foot drop. They will ask you, so loss of dorsiflexion. Loss of dorsiflexion of the foot is called your foot drop. Then where is the sensation which is lost? Sensation is usually in the first web space, which is lost because of the involvement of the common peroneal nerve. So peroneal nerve is the one which is responsible for the foot drop, the CPN. So this will result in loss of dorsiflexion of the foot. The patient will have foot drop. So now the patient can't move. If the patient moves, what is the type of gait which we see in the foot drop? It is called as the high stepping gait. Okay, you can't see. It is called as the type of gait. What you see, it is called as the high stepping gait which we see in case of the foot drop. But in this traumatic condition, patient will not walk, right? So they will not ask the high stepping gait, but sometimes they can ask you what is the gait. This is the high stepping gait which we see in the foot drop. So what is foot drop? Foot drop is nothing but there is a loss of dorsiflexion of the foot. So there is a loss of dorsiflexion. So this is your posterior dislocation of the hip. And then the treatment. The treatment is very important. So immediately you will reduce, immediate reduction. So immediate reduction, especially under anesthesia, you have to reduce it. Okay, so otherwise what is the complication? It might go in avascular necrosis. So the head will get damaged, it will result in avascular necrosis. So that is the posterior dislocation of the hip. And then this is very important, and if you have not understood anything till now and you've gone sleeping till now or not listened to the class, this one question will help you. So what is this question? So what is this diagram? So the treatment part. So what is the diagnosis? What is the treatment? Very, very important. So we are dealing with the proximal fracture femur. So proximal femur fractures, there are two types. One is called the intracapsular fracture of the neck of femur. So this is also neck of femur, but this is called as the intertrochanteric fracture. Can you see and identify the difference between intracapsular and intertrochanteric? Yes, you can see that the capsule, the fracture is extending somewhere here. So this is the intracapsular fracture. So there is a neck which is involved, and if you see the two trochanters, greater trochanter, lesser trochanter, and there is a fracture between the two trochanters. So this is very important. First you have to identify what type of fracture it is, whether the fracture is in the neck of the femur. So if I say this is the greater trochanter and this is your head, this is your lesser trochanter. So when I say the fracture is in this neck, fracture neck, this is intracapsular. And similarly, if I say there is a greater trochanter neck, this. So here the fracture extends here between the GT and the LT. So that is the difference. So the first difference you have to identify that this is an intracapsular and this is an extracapsular, that is outside the capsule. So what is the of deformity you see here, the deformity mostly we see here is external rotation. So here what we see is the external rotation. So why externally rotated? Because there is fracture and the external rotators are stronger, so hence there is external rotation of the limb. So here what happens? Here you see there is an external rotation plus shortening. That is very important. And there is an exaggerated external rotation. So how much is the externally rotated? That means the limb which has to be like this, now it is touching the couch. Okay, so this is the amount of external rotation. So the limb which has to be straight, externally rotated like this, will almost touch the couch. Okay, so here it is slightly, the limb which is like this will slightly go like this, but here the limb which is like this will completely go and touch the couch. So this is the amount of external rotation we'll see, and the shortening also very much there in case of your extra capsule. Here the difference is because the capsule which prevents it from further external rotating and further shortening, right? Because it is outside the capsule, there is nothing to inhibit this. So that is why it is going into more external rotation and more shortening. So that is the difference. So this is basic level. Now they have gone to advanced level. So asking the treatment. So the treatment depends upon the age. So carefully listen. So whenever you are dealing with IC fracture, so this is called as IC, this is called as IT. Okay, first let me tell you the IT. Very simple. The treatment of IT is either a DHS or a PFN. So why DHS or PFN? Very simple. Because here the problem is only malunion, right? So it might end up in malunion. So you're treating the malunion with fixation. So how are you fixing? You're fixing with DHS or PFN, and this is very important that you maintain the neck shaft angle. So that is the only thing we have to do in case of your IT fracture. We have to do either a DHS or a PFN. That is it. But when it comes to IC fracture, what are we worried about IC fracture? In IC fracture, we are worried about the AVN, because the head is going to damage, because the capsules, because the blood supply is from the neck to the head. So the blood supply is from the neck to the head like this. Okay. So once there is a fracture here like this, so all the blood supply will get disrupted and the head will go into AVN. So now because the head is going into AVN, what we are going to do? We are going to replace the head. So this replacement of the head, what is it called? It is called as your hemiarthroplasty. It is called as your hemiarthroplasty. So replacement of the head. Only one part you are replacing. Hemi means only half part. What is the hip joint? Hip joint is both acetabulum and the head, right? So that is we are replacing only the femoral head, only half. That is hemiarthroplasty. Understood? And what is the next thing what you can do? The next thing what you can do is, you can go for synthesis, that you can put a CC screws. But when are you going to put the CC screws? The CC screws we are going to put whenever it is in the case of your 45 years old patients. Okay. So the two treatments which are responsible is, one is your CC screws which we can put, and the second one what we can do, we can go for replacing the head. So when we replace the head, it is called as the hemiarthroplasty, and when we are putting it, the fixation. So how do we fix it? The fixation is like this. So imagine that this is the head and now there is a fracture. So this fracture we are putting with the screws. So you will apply the screws from here. So these are the screws. So you will reduce the fracture and then you do. So why are you doing in the 45 years old people? Because in this people you can try what is called as osteosynthesis. So the head is still viable and the patient has come to you very early and the fracture is minimally displaced. So you are trying to reduce it and you are going to fix it with the CC screws. So this is for 45 years. If the patient age is more than 60, you have to go for replacement of the head, which is called as the hemiarthroplasty, because the head has high chances of landing up in AVN. Understood? And before 45 to 60, you have to decide based upon the patient's criteria, whether the patient is active individual or whether the patient is old with a lot of comorbidities. So all that you have to consider. But there is one more option. So one more option is whenever there is a patient with acetabulum is also, already degeneration has started in the acetabulum. So then what you can do is you can go for THR, that is total hip replacement. Then you can go for THR, that is total hip replacement. When you will go for THR? When the patient age is more than 60, more than 75 years of age, when you on the x-ray, if you see some acetabular involvement. So acetabulum is also osteoarthritic changes are there in the acetabulum, that is degeneration has started in the acetabulum. So because you can't go for a second surgery further, age is also very high, that is 75 years above, then you can go for a total hip replacement. So there are three things which you have to remember. One is the age for IC fracture. If it is less than 45, go for CC screws. More than 60, hemiarthroplasty. If the patient is more than 75, or if with 60 years, if there is an acetabular changes which is involved, then you can either go for a total hip replacement or a hemiarthroplasty. That depends upon the patient. Okay, is that clear? Any doubts? Yes? Quickly, any doubts? Okay, now what is this? So this is a fracture femur. So here is a femur shaft fracture. So we have done with the proximal femur fractures. There are two, that is IC and IT. Now we are up with the femur shaft fractures. Femur shaft fractures very important. Again, with one thing which we can deal is the fat embolism syndrome. So you have to be very, very careful whenever they ask about the femur fractures. And then they can ask you based upon the age. So if it is in the 5 years old patients, so 5 years old patients, so then you can go for what is called as the TENS. So what is a TENS? TENS are nothing but these are the titanium elastic nailing system. So why we have approached this titanium elastic nailing system? So here we are putting the femur into a growing bone. So we want something which is elastic, so which has to increase along with the bone. So that is why if the patient is above 5 years of age, then you can go for TENS. If the patient is below 2 years, so then you can go for hip spica. So you can go for either traction. If it is less than 2 years, you will go for a traction which is called as the gallows traction. So you know the gallows traction, right? So this is the traction asked in the exam again. So this is the gallows traction, and somewhere between 2 to 5 years you can go for the hip spica. So this is 2 to 5 years. So what is a hip spica? So you going to do casing completely for the limb along with the abdomen. So limb and abdomen, whenever they are involved, it is called as spica. So this is the hip spica for 2 to 5 years of age group. If it is less than 2 years, you go for a gallows traction. So gallows traction is something where the two limbs you put, that you are involving the two limbs and you put traction for the two limbs, right? So you put traction for the two limbs. So this is called as the gallows traction. CC screws, why not preferred in case of your IT fracture? Yes, Sanjay. So whenever imagine this is an IT fracture, it is a highly bearing lot of loads, right? So this high loads cannot be taken up by the CC fractures, right? So CC screws, when you put, they easily break. They break through because they can't withstand such high pressures. And what is the main thing what we have to restore? I told you in case of DHS, it is the neck shaft angle. Okay, so we have to going to restore the neck shaft angle. So that is why something which is involving both the neck and the shaft you have to consider. not only one which is only the neck. For IC fractures it is different. You can consider only CC screws because the main thing you have to reduce it. But here in the case of IT, the neck shaft angle comes into play, and hence you have to take something which is connecting the neck and the shaft. So if you see the DHS and the PFN is one where you put the screw into the head. So there is PFN, you put the screw into head and nail into the shaft. And similarly, when you put the plate here, when you put the screw here and the plate here, it is DHS. Okay. So DHS, you will see a plate. You will see a plate and a screw. The screw is into the head. Whereas PFN, you see a screw into the head plus nail into the shaft. So something which connects with the shaft and the neck is one which we use in case of your IT fracture. So IC fracture is just CC screws. Why? Because we are only maintaining the shape of the head. So that we can do with the CC screws fixation. Okay? Yes. Next. So here we are where we are dealing with the femur fractures, right? So femur fractures, so when depending upon the age, again, if the age is less than 2 years, you go for gallows, 2 to 5 years, you go for hip spica, and more than 5 years, you go for your TENS nailing. And when the patient is, more the adult. So what you do, adult, you go for intramedullary interlocking nail. So you can see what are we talking about the nails, the interlocking, intramedullary interlocking. That means they are inside the medulla and they are locked above and below. So you can see the screws here. So one screw above, one screw below. So this is called locking. If this screw is placed in the head, then it is proximal femoral nail. So screw is placed in the head, it is PFN. Screw is placed in the shaft. So here there are two screws, one proximal screw and one the distal screw. So there is a proximal screw and the distal screw. Okay, these are placed in the shaft. So these are placed in the shaft. So these are intramedullary interlocking nails. Intramedullary interlocking nails. This is the treatment for your femur shaft fracture. Okay. Yes. Now coming to the ankle fracture. So ankle fractures is one more important topic and they will ask you in the question. So there are two important things which you have to remember. One is the bimalleolar fracture and the second one is your trimalleolar fracture. One is bi, second one is tri. Right. So bimalleolar fracture, what you see? You see there are two malleoli. So one is your medial malleolus, the second one is lateral malleolus. Then you have to ask me what is tri? Tri is medial malleolus, lateral malleolus and posterior malleolus. So on the lateral x-ray you will see that there is a fracture on the posterior side. So this is your posterior malleolus. This is medial, this is lateral. So medial malleolus, lateral malleolus. On the lateral x-ray, always on the lateral x-ray you will see the posterior aspect. So the posterior aspect you see the posterior malleolus. And now tell me what would be the investigation of choice. So whenever you want to see the bone, the investigation of choice is always a CT scan. So remember cortex. So you want to see the bone, the cortex. It is C. C for C. And then whenever you want to see the soft tissue structures or the marrow, then it is MRI. M for M. And all your soft tissue like your muscle, your edema, ligaments, tendons, all that you are going for MRI. So the investigation of choice is MRI. So usually they will ask you in the exam, so what is the investigation of choice? Next investigation if you want to diagnose some fracture. So it is usually the CT scan. And you have to remember the Lodge-Hassan classification, which is mainly for your ankle fractures. And in this, one thing what I want to remember is whenever it is a pronation adduction injury, so the limb is going to pronation and adduction, so the fibula will be suprasyndesmotic. So you will see the fracture of the fibula is very above, high above. So that is the important thing which you have to remember, pronation and adduction. So the most common is supination, external rotation. So most common is supination and external rotation. And one more thing what they have asked is vertical split. So the vertical split of malleolus is seen in which condition? So the vertical split is seen in supination and adduction. So that is what you have to remember. 3 questions, most common, supination and external rotation. And vertical split of medial malleolus, this is the vertical split of medial malleolus, this is seen in supination and adduction. And suprasyndesmotic involvement of the fibula. So syndesmosis is near this joint, right? So above the joint, if the fibula is involved, that is seen in pronation adduction injuries. Okay, so that is what you have to remember. Now coming to the spine. So spine is again a important thing, but usually in the trauma you have to remember two important fractures. So the first one is the burst fracture, second one is the chance fracture. So there are two important fractures in the exam point of view. What is a burst? What is a chance? Second one is wedge fracture. So wedge is nothing but it is a compression fracture. So in this compression fracture, what you see, it is most commonly seen in a condition that is called as osteoporosis, right? So in the osteoporosis, most commonly which vertebrae? The dorsal vertebrae is one which is involved, and osteoporosis you see wedge fractures. So how do you identify the chance fractures? So the chance fracture, where you see the chance fracture, you see where there is a horizontal involvement of the fracture. So horizontal fracture, so you see this is the horizontal fracture what I was talking about. So this is the horizontal fracture. And what is the classification which involves the classification? This is called as the Dennis column concept. Dennis column concept, where they have divided the vertebrae and into two parts, right? So you have three parts, that is anterior column, middle column, posterior column. So when you see the chance fracture, that means all the three columns are involved. So all the three columns, so hence it is an unstable fracture. So why you want to learn about the Dennis three column concept? So Dennis three column concept is mainly to tell you whether this is a stable fracture or an unstable fracture. So if you see a burst fracture if it is involving only the anterior and the middle, so hence it is somewhat stable. But if it goes to the posterior, if it is a burst and the fragments are falling on the spinal cord, it becomes unstable, right? So if you see there is a burst fracture, so all complete vertebral body is involved. So that is a burst fracture. What is a chance fracture? It is also called as a seat belt fracture, where there is a flexion and distraction. So there is a flexion and distraction which is involved here, and because of that there will be a horizontal fracture which is involved here, and this is a chance fracture. So this is a chance fracture. So remember, they will ask you about what is a burst, chance or a compression. This is osteoporosis. So IBQ also, the first one here, this is the burst fracture, and whenever you see a horizontal line of fracture in the spine, that is your chance fracture. Okay, and the Dennis three column concept is used to name, you know, which one is stable or unstable. If it is the anterior column is involved, it is usually stable. If it is the posterior column is involved, it is unstable, right? And now these are some of the named fractures which are very, very important, and you're going to go through it. So we have discussed burst, we have discussed chance, and clash overlace fracture is mainly the C7 vertebra. C7 vertebra is clash overlace fracture. And then there are important fractures, C1 fracture. So C1 is C1. So C1 is Jefferson. So F for F. So C1, 1 for 1 is Jefferson C1. So it is nothing but your atlas, right? So C1 is atlas. C2 is axis. C2 is axis. The most common fracture in the axis is odontoid fracture. So odontoid fracture, C2 most common, odontoid, it is called as the dense fracture. Whereas spondylolisthesis of C2 over C3, that is your hangman's fracture. That is your hangman's fracture. This is important. And similarly, they will ask you about a whiplash injury. This is next a soft tissue injury. What is a whiplash? Whiplash is you are driving the car, sudden a jerk has come. So you are going hyperextension and flexion like this. So when I am doing sudden hyperextension and sudden hyperflexion, all the soft tissue injuries are involved, and they will cause you severe pain in the cervical spine, headaches, and it will show as if there is a lot of disturbance has happened in the bone. But the X-ray comes out to be normal. So that time you have to remember there is a concept which is called as a whiplash injury, where there will be severe pain in the neck and the head, but there is involvement only of the soft tissue. So you can go for an MRI and check for the edema of the muscle. So that is your whiplash injuries. And undertakers is usually carrying the body postpartum. So postmortem. So this is the postmortem. So when they are carrying the bodies in the postmortem, they usually try to damage the C6 and C7. Sometimes they might be seen as the fractures. But you have to remember there could be a chance of undertaker's fractures also. So you have to be careful, important with the forensic point of view. Okay, so these are certain spine fractures. But what usually they ask in the exam is this, the prolapse intervertebral disc. The prolapse intervertebral disc is what they usually ask. So what is that? So prolapse intervertebral disc is, so you have to understand there is a disc which has two components. So one is called annulus fibrosus, which is inside is the nucleus pulposus. So this is the nucleus pulposus, this is the annulus fibrosus. So anatomy, annulus fibrosus, they are circumferential fibers like this, right? And whenever there is a damage or tear in this fiber, so tear in this fibers will result in protrusion of the nucleus pulposus outside. So the now nucleus pulposus comes outside. So it will come outside and sit like that? No, it will irritate the nerves. So this irritation of the nerves is nothing but your sciatica. So this irritation of the nerve is nothing but your sciatica, which starts right from the buttocks. So the pain starts right from the buttocks to the great toe. So that is the sciatica. So buttocks to great toe is sciatica, and here there will be pain, radiation. So there will be radiating pain along the posterior aspect of the thigh with the tingling and numbness. So these are all the signs and symptoms. They'll put it in the x-ray, put up in the question, and then there could be a weakness. So all these are symptoms. So pain, which is radiating, you will have tingling and numbness, and sometimes weakness. So how do I identify? Investigation of choice is always MRI. So before that, you can do certain test which is called as SLRT, and this is a passive stretch leg raising test. So you are going to straight leg raising test, which is a passive. Okay, passive ka matlab then the surgeon is doing. So here what are you doing? You can see in the picture that the surgeon is trying to lift the leg completely in straight. So knee in extension, you're going to lift the leg straight. So on the posterior aspect, the sciatic nerve will stretch. So this stretch will result in pain. So whenever there is a pain, SLRT positive, passive, so then you can think about PIVD, that is prolapse intervertebral disc. So the investigation of choice is MRI. On the MRI, you will come to know. And now you can see and now when you want to test it, so you will test for the weakness. So you will test for the weakness, you do the motor and then you do the sensory testing on the limbs. Right, so motor and sensory testing on the limbs. So here what you have to remember is whenever there is an involvement of L4 and L5 disc, so which nerve is involved? So that is the question. So whenever there is an L4, L5 disc, yes, answer. Yes, L4, L5 disc, which nerve gets involved? Is it the L4 nerve or the L5 nerve? L4 nerve or L5 nerve? Which nerve gets involved in the disc prolapse of L4 and L5? So this is the question they ask you. Quick. So there is a question here, the patient will come with the pain. Yes, if it is an L4 and L5 disc, the involvement is the L5 nerve. Similarly, if it is an L5 and S1 disc, which is involved? Which is involved? Yes, S1 is involved. Why? The diagram is the explanation. So here you see this is the L4 and L5 disc, right? So this is the L4 and L5 disc. So now this disc, if it is now coming out, so there is a disc which is coming out here. So what is happening here? So here what happens is already the L4 nerve root has escaped here. So this is already escaped here. So this disc now will damage which nerve? It will damage the L5, which will damage the L5. So L4, L5, the disc which is, the nerve which is involved is L5. Similarly, L5, S1. So imagine this is L5 and S1. So what will happen? The L5 has already escaped. So the nerve which is damaged here is, so here it is a disc prolapse. So always remember, I am talking about the central disc prolapse. Central disc prolapse. In case of central disc prolapse, in the center, if the disc is prolapsing, so here the nerve which is damaged is S1. So this is the S1. So nerve which is exiting through the foramen is called the exiting nerve root. Nerve which is coming down from that to the next level is called the traversing nerve root. So which nerve is involved? They can ask you traversing nerve, not the exiting nerve, the traversing nerve. So sometimes they can ask you which nerve is involved. Instead of L4 and L5, they will ask you is the exiting nerve or traversing nerve. So the traversing nerve is the nerve which goes down to the next level. Exiting nerve is which exits at that level through the foramen. So here the involvement is the traversing nerve root, and in the L4 and L5 it is the L5 nerve root which is involved. So the symptoms what they present with: pain, radiation, tingling and numbness, and weakness. So you will ask for choice, that is MRI you have to ask, and before that test which we do is your SLRT. And now what is this? This has been asked in the exam. Exactly the same thing which has been asked. So the X-ray of the spine, whenever you see, what all you have to look for. So the first you will see the shape of the vertebrae. So if there is a wedging or not. Then you have to look for the disc spaces. Then you will look for the disc spaces. So whether the disc spaces are maintained or not. Then you will look for the alignment. Then you will look for the alignment. So how do we look for the alignment? So you will draw a line along the anterior columns of all the vertebrae and posterior columns of all the vertebrae, right? So now can you see there is a change in this? Okay, you can see that there is a drop in this level. So here you can see this is coming forward, right? So this protrusion, this is called as spondylolisthesis. And now you have to be very specific in naming. Always do with the sacrum. So this is the sacrum. This is the sacrum here. And now you can see that this is the L5, L4. So sacrum, L4 and L5. So there is an L4 disc, L4 spondylolisthesis over L5. So this is L5 over L4, right? So this is L4 spondylolisthesis over L5. Okay. So spondylolisthesis is nothing but the protrusion. And again they have asked this. What is lysis? Break. What is listhesis? It is the protrusion. Right. Okay, lysis and listhesis. Lysis is break. Why listhesis is happening? Listhesis is happening because there is a lysis. Where would be that lysis? That lysis usually we see in pars interarticularis. So usually we see in pars interarticularis. So this is the area between your superior facet and inferior facet. So there is a break in the pars interarticularis which will result in the listhesis. So this is the spondylolisthesis. So this is the spondylolisthesis. Again the patient will have pain, the paresthesias, and then there could be weakness, and most important thing what they will have is the step sign. So whenever you examine, you will see one sign which is called as the step sign. So you are palpating all the transverse processes, all the posterior spinous processes, right? So the spinous processes you are palpating like this, so like this, and one will go inside. So this is called as the step sign. So as you are palpating from above downwards, you will go like this and come like this. So this will you feel it is a step. So this is seen in palpation. So this is seen in palpation. Okay, so this is called as the step sign which we see in case of spondylolisthesis. And what is this? This has been asked in INI-CET again. So lumbar canal stenosis. So what is lumbar canal stenosis? So this is a condition where you see that the spinal canal narrowing. So you know there is a spinal canal in the spinal vertebra. All the vertebra they are having a narrow canal, right? So this canal, whenever it further compromises because of disc, because of ligament calcification, because of fracture, whatever is the cause, narrowing of the spinal canal will result in spinal canal stenosis. So this stenosis whenever will happen, the patient will have very, very severe claudication pain. This claudication pain is neurogenic claudication. Okay, I'll write here. This is neurogenic claudication. So what is neurogenic claudication? That means the patient will have pain whenever they walk, and once they have this pain, they will sit and rest, and after that sitting and resting, they can further walk. So this is called as neurogenic claudication, which is different from your vascular claudication. Sorry. Different from your vascular claudication. So vascular claudication usually starts with the first step, but neurogenic claudication will take few steps and then the patient will complain of pain. And very important, what is this sign called? This is called as shopping cart sign. So what is the shopping cart sign? In the shopping cart sign, what you see? The patient, whenever it flexes the limb, spine. So on flexion, the pain relieves. The pain increases on extension. That means the spinal canal will become more narrow. So the narrowness will increase on extension. That you have to remember. On flexion, there is a relief of pain. So that is why the patient will try to stoop, they try to bend because of relief of the pain. So whenever they do the flexion like this, there is a pain relief. But whenever they stand straight or extend, there will be increase in the pain. So this is called as the shopping cart sign. So this is called as the shopping cart sign, which is seen in your lumbar canal stenosis. This you have to remember. Yes. Yes, now all this you have to answer. Very easy. I have explained everything in detail. Now quickly answer. Yes, what is the first one? A, B, C, D and E. Quick, IBQ. Yes, what is A? Mayur, Omkar. Sanjay, what is answer A? This has been asked in the exam again. What do you think is the answer? These are the types of fixation. So what fixation you call in type A? Yes. Type A is nothing but there is a patella fracture and it has been fixed with the tension band wiring. So whenever you see a fracture of patella, you can fix it with the tension band wiring. What are the other areas? Your greater tuberosity, your greater trochanter, medial malleolus, all this you can use your tension band wiring. Okay, these are the tension band wiring which is used. Okay, and they are done in the figure of 8. So they will ask you what is the treatment of patella fracture. The answer is tension band wiring. And then I have explained you what is this. You are seeing a screw in the head and again a plate on the shaft. Yes, there is a screw in the head and it is fixed with the plate in the shaft and you are treating the IT fracture. So what is this? Yes. Yes, very good. This is DHS. So whenever you see a plate, this is DHS. Whenever you see a nail, screw in the head and a nail and with the nail, this is PFN. Very important. All are your image based questions. So one is your DHS and second one is your PFN, right? So whenever you see a nail, it is PFN. You see a plate, it is DHS. And then this is your IMIL. This we have learned in the any femur or your long bone fractures. You can treat with this intramedullary interlocking nail. And finally, can you tell what is E? 100 on 100. Who tells this answer? I have discussed this. Nothing new. It is not looking like a nail, right? It is not interlocking, but it is inside the medulla. You can see it is in the pediatric bone, in the femur. We have discussed whenever it is after 5 years in the femur shaft fractures of a pediatric bone, what nails we use. Yes, Mayur, where have you gone? Omkar? Omkar left the chat. Sanjay, yes, what is the answer? Okay, you keep thinking. Yes, very good. This is called the tense nailing system. Yes, when the age is more than 5 years and you want to fix the fracture femur, you're going with the tense nailing system. Very good. Right, and then we are going for this. What are this? This is called the prosthesis. This is called the prosthesis. So what is a prosthesis? The part which is replacing. It is a replacing a part. So for example, which part are we replacing? Which are replacing the femoral head. So this is a prosthesis. So usually what we use is the bipolar prosthesis now. But for your image based question, this is your Moore's prosthesis and this is your Thompson's prosthesis. How do you identify? Thompson is with the collar like this and Moore's with the two holes. So just remember, Moore's and Thompson's are two, but most commonly used nowadays is your bipolar prosthesis, right? And now identify what is this. This is a plate. You can see the oval holes in it, and this oval holes, whenever you see a plate with a gap like this, so this is your dynamic compression plate, the DCP. It is your dynamic compression plate. So this is your dynamic compression plate, and now this is used for various fracture fixations. But when it comes to osteoporosis, so osteoporotic bones, if you want to treat or if you want to treat an intra-articular fractures, so you take the help of one more plate which is called as the locking compression plate. So these are identification, all your IBQs here. So one is the LCP, the second one is DCP. So what is a DCP? Dynamic compression plate. What is an LCP? It is a locking compression plate. So this is a locking compression plate, right? So LCP. So how do you identify in the exam? If you see an oval hole like this, just an oval hole, then that is your DCP. You see a combi hole, there is a combination of holes, and then you see something which is there for locking. So you see the threads in it. So you need to see the threads, right? So these threads, when you see, this is called as a locking plate. And similarly, the screws will also have threads, and we are going to put these threads and those threads matching. Okay, so you are going to match the threads. So this is called as a locking thread. Hence, because of this matching, you can use them in the osteoporotic bones. There is no matching system in the DCP. They are used in the regular bones, which are normal bones, but this is called a dynamic compression plate. Got it? Yes. Next, your favorite topic. What is this? This is all IBQs, right? So usually tumors in the exam, they have asked with the help of X-ray. So basically this will be dealt with the radiologist as well. So nothing to worry. We'll just try to see the orthopedic point of view. So the first one, very, very important. It is an extra growth, right? It is an osteochondroma. So this is an osteochondroma. It is also called as exostosis. This is also called as exostosis. So where you see after the growth maturity. So you see the growth is away from the joint. So this is the joint, right? So you see this is the joint, and now the growth is away from the joint. And you can see that there is a cartilage cap which is covering this. So there is a cartilage cap. So that is important. So it is covered by a cartilage cap. So this is osteochondroma. There is a bone which is increasing. It is also called as exostosis, extra growth. It is covered by the cartilage cap. So how will you remove it? You remove it by excision. Right? So that is it. Then this one, this is called as a deformity. This is called as a Shepherd-Crook deformity. So this is nothing but your Shepherd-Crook deformity, and this is seen in your fibrous dysplasia. So you see this in the fibrous dysplasia. What is fibrous dysplasia? Where this is completely the bone is replaced by the fibrous tissue. Hence you can also see as the ground glass appearance. So you also see a ground glass appearance, right? So both fibrous dysplasia, Shepherd-Crook deformity, ground glass appearance. All this you see in this. Next, what is this? This has been asked in the exam. What is the important points of this? You see this in the diaphysis. The first thing what you see is this in the diaphysis, and this is a formation of the bone, but the lesion is less than 2 centimeter. Okay, in the cortical structures. So you'll see in the cortex. less than 2 centimeters is the lesion. Hence, what is the investigation of choice? The investigation of the choice is CT scan, because you want to see the cortex, right? You want to see the cortex. So this is one peculiar thing. What you have to remember about this is, this you can treat it NSAID, night pains. Okay, this is this thing which you do with the for the diagnosis. So patient will come with the night pain, and then with the NSAID the pain gets reduced. So this is because the release of the prostaglandins which are present in the tumor, and now they get reduced by the NSAIDs, and because of this you can confirm that this is an osteoid osteoma. But now what we do radio frequency ablation for the treatment. So now they have asked you what is the treatment for it in the match the following. So that is the radio frequency ablation usually we see for the osteoid osteoma, right? Very good. And next, what is this? Very important, your giant cell tumor, also called as your osteoclastoma, and you all know that this is seen in the epiphysis. So this is seen in the epiphysis of the joint, right? And it usually doesn't cross the line, but sometimes it might cross, and the treatment here is the extended curettage. So the treatment, what you do the extended curettage. Right, extended curettage. And then your enchondroma. Enchondroma is mostly, remember, small hands and feet. So this is very important. And whenever they put an X-ray of small hands and feet, something loosened and something in the metaphysis only. Metaphysis, something loosened, metaphysis, and you can see some amount of, the popcorn calcification, some amount of calcifications in the cavity. Then it is your enchondroma. So this is your enchondroma. Okay, then multiple enchondromatosis. Multiple enchondromatosis. What is this called? This is called as the Olier's disease. This you have to remember. Okay, and this multiple enchondromatosis, when it is seen with your skin lesions, hemangiomas, this is called as Maffucci's syndrome. Okay, yes. What is multiple exhaustosis? So multiple exhaustosis, which is called as diaphyseal achalasia. Okay, and then the most important thing which was asked in the exam, your fibrous dysplasia, yes, with precocious puberty and cafe lid spot. This is asked in the exam. So what is this? Yes, answer. What is this called? This is called as your, yes, you have to answer. This is asked in the exam. Fibrous dysplasia, this is polyostotic fibrous dysplasia with precocious puberty with cafe lid spots. What is this called? Yes. This is a syndrome name which has been asked in the exam. Very important. Yes, I am waiting for your answer. You keep thinking about that syndrome. Now next. So what is this? So here we have seen what is GCT. Similarly, like GCT, you will find one more thing which is called as ABC. But this ABC is usually seen in the metaphysis. So this ABC is seen in the metaphysis. And similarly, this is also aggressive. It is expansile. So you can see that there is an aggression that is coming out of the margin. So this is called aggressive. And on the MRI, the investigation of choice, what you see is multiple fluid levels. So on the MRI, what you see is multiple fluid levels. So this is again a diagnostic for your ABC, that is called as aneurysmal bone cyst. So what is aneurysmal bone cyst? Which is usually seen in case of your metaphysis, similarly like your GCT. But the GCT you see in the epiphysis, this you see in the metaphysis. And when you go for an MRI, you see what is the fluid levels. In the GCT, what you see is the soap bubble appearance. This is important. Now the GCT, what you see? The soap bubble appearance, right? Yes. And then UBC. UBC is nothing but your simple or the unicameral bone cyst. So what is important here? Important here is the trapdoor sign. The trapdoor sign or the fallen leaf sign. The trapdoor or the fallen leaf sign, usually what we see the pathological fractures. So they usually very silent and they come up with the pathological fractures, and this fragment whenever you see in the cavity, this is seen as the fallen leaf sign. So this is called as the fallen leaf sign or the trapdoor sign in case of your unicameral or the simple bone cyst. Okay, have you come up with this syndrome which is seen in the fibrous dysplasia? Okay. Okay, now all the malignant variety. So these are all the malignant variety where you see this, the first one what you see is hair on end appearance. This is also called as hair on end appearance, not to be confused with your sunburst appearance, because you see this is seen in the diaphysis, right? And again to this you have one more periosteal reaction which is called as the onion peel appearance. So this is the onion peel appearance. So now can you tell me what is the diagnosis of the onion peel appearance? Yes, this is the Ewing's sarcoma. This is the Ewing's sarcoma. So not to get confused with the sunburst appearance. So you have to always be careful. This is in the diaphysis. And what is the most important thing of Ewing's sarcoma? The patient will present with fever, raised ESR and CRP also, exactly mimicking your osteomyelitis. So this is very important. Whenever you diagnose the Ewing's sarcoma, you will always see a kid with the osteomyelitis also. So you have to be very sure whether you are dealing with the osteomyelitis or the Ewing's sarcoma. Sometimes this periosteal reaction can be not very specific to Ewing's sarcoma, right? So that is why what is the important thing what you have to do? You have to always go for the biopsy. So biopsy is very, very important. And what you see on the biopsy? So biopsy, you see the round cell tumor. So this is a blue round cell tumor. Okay, on the biopsy we see this. And when you send for the culture, you can see if there is a bacteria present, you will see that there is a culture medium positive. Okay, so this is how you differentiate between your Ewing's sarcoma and your osteomyelitis, but mind you, both will be present in a similar pattern and usually seen in the first decade. So that is the main issue. So usually Ewing's also is seen in 4 to 8 years of group. Okay, and chemotherapy doesn't always we advise in case of Ewing's sarcoma, and radiotherapy. Chemotherapy has no role first of all, and we don't do a radiotherapy because in radiotherapy there is a high risk of again patient landing up in osteosarcoma. Okay, yes. And then what is this? This is called your osteosarcoma. Very, very important. Always asked in the exam. So all your examiner's favorite tumor is your osteosarcoma. And you see two important things. One is your sunburst appearance, which is the formation of the osteoid. So osteosarcoma is osteoid forming tumor. So there is a bone which is forming always. So two important things which you have to note here is, one is a sunburst appearance you see, and the second one is your Codman's triangle. So you can see one is the Codman's triangle, the second one is the sunburst appearance. So these two are the radiological things which we see. Yes, it is the McCune-Albright syndrome. Very good. McCune-Albright syndrome. So this was asked in the exam. Okay, which syndrome does show all this? You know, your fibrous dysplasia, precocious puberty and capillate spots. Okay, so the sunburst appearance, what you see? You see both your Ewing's, you see the Codman's triangle and your Codman's triangle and sunburst appearance. So why sunburst appearance? So sunburst appearance is nothing but your whatever the osteoid is forming, it is forming along the vessels. So this could be osteoid forming along the vessels or your Sharpie's fiber. So both this will result in your sunburst appearance, right? So elevation of the periosteum is your Codman's triangle. So elevation of the periosteum is your Codman's triangle, right? Yes, these two are very, very important, and the treatment here is, first you go for chemotherapy, surgery. So chemotherapy. So this is the very, very important, your osteosarcoma. Next, Yeah, one more important topic not to miss by anyone. This is again a very important topic. So median nerve. So median nerve, ulnar nerve, radial nerve. All these are very, very important. One question is definitely asked from the nerve injuries. So first of all, what you have to remember is the median nerve. So three things. Neuropraxia, I have taught you, axonotemesis and neurotemesis. We have already discussed there is a complete loss of transaction, complete loss. Okay, this is Sedan's classification. Sunderland's classification is type 5, type 1, type 2, type 3, type 4. And how do you know that? So there are three layers: endoneurium, perineurium, epineurium. Right. So endoneurium is damage is type 3 directly, and type 4 is perineurium, and type 5 is epineurium. Right. So what is type 1 and type 2? Type 1 is again neuropraxia for the sedans, and type 2 is damage to the myelin sheath. Okay, so this is about your neurology. And now let us see what is the median nerve palsy. So coming to the median nerve, you all know it supplies the flexors. So flexors, very importantly, all the flexors except the flexor carpi ulnaris and flexor digitorum, except I am writing, please be careful, except flexor digitorum profundus medial half and flexor carpi ulnaris. Okay, and then it supplies your thenar muscles, and then it supplies your first and second lumbricals. Okay, this is very important. All these are important. Okay, and then sensations of first index finger. Okay, all these are supplied by the median nerve, and whenever there is a problem in the median nerve, you will always see that the problem is towards the thumb. So whenever the thumb and the index are involved, it is median nerve. Remember, this is a major thing which you have to remember. So median nerve, coming to median nerve, you see this is the ape thumb deformity. The first one what you see is the ape thumb deformity, and the second one what you see, either a pointing index which has to be done here, or your Ochsner's clasp deformity. This is called the Pope sign or the benediction sign. Okay, Pope sign or the benediction sign. Okay, and one more thing what you see is the pointing index. So this is your pointing index. So this is your pointing index or your Ochsner's clasp deformity. So what is all happening? So here the median nerve, I told you all the flexors are involved. So whenever the flexors are involved, what you have to do? You have to flex the fingers. So now I'm trying to flex all my fingers, but because the index finger is supplied exclusively by the median nerve, the index finger will not completely flex. So there is a retention, there is a lag in the flexion which is called as the pointing index. So this is called as the pointing index. So the finger is not completely flexing. That where I am able to see when I am doing both the hands flexion. But if I do a single hand flexion, what is happening in a single hand? You see these two will flex completely, and the middle finger, because of some involvement of the FDP and FDS, it will come to little flexion, but you can see there is again the index finger is not flexing completely. So this is called as the Pope sign. So this is called as the Pope sign. Usually the popes from the Christianity, they put like this. So this is how they greet, right? So this is called the Pope sign or the benediction sign, right? And then coming to the next one is your Ochsner's clasp deformity, where you do a clasping like this, and then you see the index finger is completely not flexing. So this is called as the pointing index, and whenever there is involvement of the anterior interosseous nerve, you have to remember that there is an OK sign. So this is your OK sign. So the flexion of the index and the thumb pinching at the terminal things like this has to come towards like this. Perfect O. So this is called as O sign or the OK sign, and if it is not perfectly like this, then this is the AIN palsy. So this is the AIN palsy. And now coming next to our ulnar nerve. So when you talk about the ulnar nerve, again the FDP medial half and FCU are supplied by your ulnar nerve, and then you have your hypothenar muscle group, hypothenar, and what is most important, the adductor pollicis. So the adductor pollicis is which is a group of thenar is supplied by your ulnar nerve. So this is very important. So the hypothenar, the adductor pollicis of the thenar group, and third and fourth lumbricals. So all these are supplied by your ulnar nerve. Ulnar nerve is supposed to be called the musician's nerve because of all this intrinsic muscles. Most of the intrinsic muscles are supplied by your ulnar nerve. So there are dorsal interossei and the palmar interossei. So all these are supplied by the ulnar nerve. And what is the deformity you see? The deformity what we see is the claw hand. So claw hand is what? Claw hand is hyperextension of the MCP. So these two are MCPs. So whenever the MCPs are hyperextended, and the flexion of the IP. So flexion of the IP, extension of MCP and flexion of the IP. This is your claw hand. So whenever you see this is called as the claw hand, and usually you see in the ring and the little finger. So this is the claw hand, very specific for your ulnar nerve. And what is this? This is called the card test. So this is called the card test. Again for your adduction. Pad is adduction, right? And then the second one what you see is the book test. So this is your book test. So what you do in the book test? In the book test you are trying to hold the book with the help of your adductor pollicis, but there is a ulnar nerve palsy. Whenever there is an ulnar nerve palsy here, in case of your ulnar nerve palsy, instead of adductor pollicis, what we use? We use the flexor pollicis. Now this is supplied by your median nerve. So hence you see there is a bending of the thumb, flexion of the thumb. So this is very important, and this is called as the Fromen's sign. So this is called as the Fromen's sign. Okay, this is called as the Fromen's sign. So book test, Fromen's sign for ulnar nerve palsy, right? And then what is this? This is called as pen test. Pen test is again for your median nerve. Pen test is for your median. I have told you whenever there is involvement of the thumb, you have to always think about your median nerve. So book test is also your median nerve is active, not palsy. Ulnar nerve is palsy. Okay, and pen test is you are testing the abduction of the pen. So this is the pen test for median nerve, book test for the ulnar nerve, card test for your again your ulnar nerve, and then you have the IGAVA test. IGAVA is testing your dorsal interossei for the abduction. So dorsal interossei is for the abduction. So these are all the nerve tests, very important to exam point of view. And now coming to the radial nerve. So radial nerve, what is there? Radial nerve, we have already seen that then whenever there is a shaft fracture. So in the shaft fracture, humerus shaft fracture, there will be a radial nerve. And one more important thing, your favorite diagnosis, Saturday nerve palsy. So what happens in the Saturday night palsy? So you are all very well what happens in the Saturday night, okay, party life. So the patient goes to the party and then comes next morning with the wrist drop, and you all know the story. So there will be a neuropraxia of the radial nerve, right? In the axilla it gets twisted, it gets because of the position of the hand. So how the way he is sleeping, see, after completely enjoying the party, he sleeps in this position where there is a lot of compression over the radial nerve, which results in the wrist drop. So there are no tests for your radial nerve. The one thing which you have to remember is Saturday nerve palsy and your Holstein-Lewis fracture. Okay, and then we have discussed about the pin, which will tell you about the finger drop, and pin we see in the Monteggia fracture. Clear everybody? Any doubts? Yes. Now what is the treatment? The treatment for your radial nerve palsy. So whenever you see a radial nerve palsy, this is again very important. So radial nerve palsy will result in wrist drop, and the treatment of the wrist drop is your 𝐒𝐿 splint. So treatment is your 𝐒𝐿 splint, and there are two types of 𝐒𝐿 splint. So one is your static 𝐒𝐿 splint, the second one is your dynamic 𝐒𝐿 splint. So whenever it is a static, there is no movement. So dynamic, there is a movement, hence you can see the spring mechanism on the dorsal aspect like this. So you will try to extend the fingers with the help of your spring. So this is called as the dynamic 𝐒𝐿 splint, right? And this is your static 𝐒𝐿 splint. Okay, this is again an IBQ, and they will ask you. And this I have told you that AIN palsy, right? AIN palsy, this is nothing but your OK sign. Okay. and this is your knuckle bender splint. So this is your knuckle bender splint. Knuckle bender splint is for your ulnar nerve palsy. And now you see what is knuckle bender doing here. Knuckle bender is trying to flex, flex your IP and extend, trying to flex your MP, that is your MCP, and extend your IP. So reverse of your claw hand. So there will be flexion of your MCP and extension of your IP. So that is the knuckle bender splint. Again, very important IBQ for the exam point of view. And then we have the palsies, that is CPN palsy. We have already discussed. This has been asked as the diagram format, given on arrow mark if there is a fracture at the fibular head or neck, because the CPN turns over the fibular neck. So there is a CPN which turns over the fibular neck. So the fractures around the fibular head and neck will result in CPN palsies. And how do you treat it? You treat it with the foot drop splint. So you treat it with the foot drop splint, right? And then you have your regimental badge area. This is for your axillary nerve. So whenever you are treating with the axillary nerve, so there will be deltoid palsy. So there is a deltoid palsy and the regimental badge area. So this is your regimental badge area, where you see that there is a anesthetic patch, so that sensations are decreased only in this particular area, which is called as regimental badge area. And then this is your brachial plexus. So brachial plexus, you have two important things, right? So one is your Erb's palsy, the second one is your Ķ-𝐶 palsy. Erb's palsy is upper trunk, Ķ-𝐶 palsy is C8 and T1. Okay, Erb's palsy, you will see there is a formation, that is there is adduction, pronation and internal rotation of this limb. And the treatment is your airplane splint. Okay, the treatment is your airplane splint. So that is about the splint and various palsies. And now you see the entrapment syndrome. This is very important. Carpal tunnel is again your median nerve. So you have your two important tests, which is called as your Durkan's test. This has been asked in the exam, which is very important. Direct direct median nerve compression is your Durkan's test. Guyon's canal, you have your ulnar nerve involvement. So carpal tunnel is median nerve, Durkan's is ulnar nerve. This is your sciatic nerve, right? This is your sciatic nerve. And then you have myalgia paresthetica, which is your lateral cutaneous nerve of thigh. So here the patient will have symptoms only on the lateral side of the thigh, and the symptoms are very severe. Even the touching of the cloth will cause, sensation and tingling, numbness over that particular lateral cutaneous nerve of thigh. And chiralgia paresthetica is your superficial radial nerve. So this is your superficial radial nerve. Okay. Yes, so these are the entrapment syndromes which you have to remember. And pronator syndrome, it is again the median nerve, and cubital tunnel is your ulnar nerve, tarsal tunnel is a posterior tibial nerve. Pronator syndrome is because the median nerve goes between two heads of the pronator teres. This is your pronator syndrome, right? And cubital tunnel is one more tunnel which the ulnar nerve crosses through it. So there is a involvement of the ulnar nerve again in the cubital tunnel. Okay, and these are various splints which are involved. So this is the collar, and these collars are of two types, hard collar and soft collar. So soft collar we usually use for general conditions, and hard collar we usually use for trauma. And you know this is your Thomas splint. So this is your Thomas splint and used for fracture femur. Okay, and then this is your BB splint. And now can you tell me what traction is this? We have discussed about. This is Bowler-Brown splint for your skeletal traction. Okay, and what is this traction which is being seen here in the image? This is your gallows traction. This is your gallows traction. Okay, I have discussed fracture femur in less than 2 years of age. You see this gallows traction. And this splint, your important Milwaukee brace and your Boston's brace. So Milwaukee and Boston's brace. You can see both of them, and where they are used? They are used in scoliosis. And what is the angle? The angle measured here is Cobb's angle. If the angle is 20 to 40 degrees, you treat them with the brace, and this is the brace. So Milwaukee is up to the occiput and mandible, both high level. Okay, this is usually the thoracic level. So thoracic level use the Boston brace, and Milwaukee use where they high, where is the involvement of the occiput and the mandible. And what is this? This is your Taylor's brace. So this is your Taylor's brace, where we use it in the tuberculosis. So tuberculosis, you use the Taylor's brace. And what is this? You have 4-post collar. All the 4 posts you can see, this is your 4-post collar. Okay, and then this is your ASH, anterior spinal hyperextension, and this is your SOMI. Okay, this is your ASH brace and this is your SOMI brace. So these are all used for your cervical problems, and these are your cervical braces which are used. One is your anterior spinal hyperextension brace, and then is your SOMI. Now coming to various other disorders where we have, this is called as the tennis elbow. So what is the test which we use here? This is the Cosen's test, and extensor carpi radialis brevis is the tendon which is involved here, and this is your tennis elbow. Okay, how do you treat it? You again treat it with the rest, and then you give a steroid if you are severe pain, and then you can treat with the band. So tennis elbow band is present, you can treat it with this. So what is Cosen's test? When you extend the wrist, then you will have pain. So extension of the wrist will cause pain in the elbow, which is called as the tennis elbow, the Cosen's test. And what is the test which is involved here? This is what APL and EPB tendons are involved. Though this is your D. curvains. So this is your D. curvains tenosynovitis, and here the tendons which are involved are your APL and EPB, and the test is Finkelstein's test, and the test is your Finkelstein's test. Okay. Yes. This is your Finkelstein's test. So you're doing the thumb closing and then you're extending it. So this is your test which we do for your D. curvains tenosynovitis. And the tendons which are involved in the first compartment tendons, those are your APL and EPB. This you have to remember. And then what is this? This is your Dupuytren's contracture. So Dupuytren's contracture is a condition where there is involvement of the fascia. So whatever the palmar fascia is there, it is being converted because of some idiopathic or liver cirrhosis or alcoholics, you see, and there is a fibrotic cord which is formed. So this fibrotic cord will result in contracture of the finger. So usually the middle and the ring fingers are involved, most commonly seen with alcoholics and liver cirrhosis. So this is your Dupuytren's contracture. And then what is this? This is your trigger finger. So in the trigger finger, what we see, there is a nodule which is formed, and this nodule will not allow the flexor tendons to move freely in the synovial sheath. So that is why what we do, we remove this nodule. So this requires excision. So this is your trigger finger. Why in the name trigger? So suddenly and sudden flexion, the patient will have pain on extending, and sudden extension will result in clicking of the sound. So there will be sound, and then the patient will have sudden extension of the finger. And what is this? This is damage of the ulnar collateral ligament. What is this? Skier's thumb or gamekeeper's thumb. So skier's thumb or gamekeeper's thumb, you have a damage to the ulnar collateral ligament which is damaged, and this ligament, whenever it is damaged, and involvement of your adductor pollicis tendon between the ligament will result in failure of the healing, and this is called as Steiner's lesion. So this is called as the Steiner's lesion. So adductor pollicis tendon will come between the ligaments. So this is the ligament which is being damaged, and when this adductor pollicis is coming in between, this is called as a Steiner's lesion, and otherwise it will heal well. So usually seen in the skiers which do ski, and gamekeepers. Gamekeepers are the ones which will play with the animal's neck. So they will turn the animal's neck, twist the animal's neck. So because of the twisting forces, there will be damage to the ligament. And then what are the signs? So these are the signs again of the carpal tunnel syndrome. So carpal tunnel syndrome, you will see there is a compression test, and then you have the Fallon sign. So Fallon sign is you're putting all this together like this for few minutes, and then the compression happens. So whatever you do the wrist flexion. On wrist flexion, you have all the symptoms. So usually what we have, tingling and numbness in the thumb area. Tingling and numbness in the thumb area, thenar muscle group. So in the thumb thenar muscle group, usually increased in the night time because of sudden flexion of the wrist. And then this is called as your carpal tunnel syndrome, and these are the tests. The direct carpal compression I told you, this is called as the Durkan's test. So this is called as the Durkan's test. And two important finger injuries, one is mallet, second one is jersey. Whenever I say mallet, mallet is the shape, right? So the shape, it is bending down like this. So mallet is whenever there is a rupture of the extensor tendon. So the extensor tendon is lost, so the finger goes into flexion. So finger goes into flexion. So this is called as the mallet finger. What about jersey finger? Jersey finger is whenever there is loss of flexors, loss of flexor tendon. So flexor tendon, because the extensor, that if you normally see is a finger is an extension only, no? So even if there is a loss of flexion also, it is an extension. So that is why it is named as jersey. But if the loss of extension, the finger goes into flexion like this, but the flexion deformity can be easily seen. So this is called as the mallet finger. So mallet is the shape of this. So this is the mallet finger, mallet extensors. So mallet is rupture of the extensors. Mallet is rupture of the extensor. Okay, and jerseys. Jerseys, you hold the jersey like this sometimes in tackling. So because of that, there will be a rupture of the flexors. So flexors, you don't see any deformity because the finger isn't straight like that. So this depends. Sometimes avulsions also can occur, and that might result in avulsion of the extensor tendons or the flexors. And then we have your Achilles tendon. So Achilles tendon, what we have? You have your Thompson's test. So Achilles tendon, we have your Thompson's test, right? The Thompson's test, what you do, you squeeze the calf muscle. So squeezing of the calf muscles will occur, and this will cause the plantar flexion of the foot. So the foot goes into plantar flexion on squeezing of the calf muscles. So this is called as the Thompson's test, not to confuse with the Thomas test, not to confuse with the Thomas test. So Achilles tendon is Thompson's test. Okay, now coming to the metabolic disorders, we have varieties of ways. But the most important thing you have to remember is your osteoarthritis and your rheumatoid arthritis. Okay. So coming to the osteoarthritis, so usually we are going to see, just give me 2 minutes. So this is your osteoarthritis and this is your rheumatoid arthritis. So these are your joint disorders. Okay, osteoarthritis, most commonly it is a degenerative disease. Okay, and then this is because of the forces which are acting on the medial compartment. So you see there is a forces which are acting on the medial compartment, and what you actually see on the x-ray is three important things. One is your joint space narrowing, you see, and then you see the sclerosis and you see the subchondral cyst. So these are all the features of your osteoarthritis. So sclerosis, subchondral cyst and your joint space narrowing. Whereas in the rheumatoid arthritis, so rheumatoid, what you see, this is an inflammatory condition. So usually what we see is joint space narrowing is there obviously, but what you see is lucency, juxta-articular osteopenia. So there will be a lot of, juxta-articular osteopenia. Can you pause it for a minute? Can I continue? 2:30? Okay. For 15 minutes at least? Okay. So juxta-articular osteopenia is the what we see in case of the rheumatoid arthritis, right? So osteoarthritis, if you remember, this is mainly because of the degeneration. So you will see mostly involvement of the medial compartment. So this is the medial compartment, and here you see there is a lot of forces which is acting on it. So there will be degeneration of the meniscus first. So the meniscus is lost first, and then after the meniscus, the bone loss will happen, and this will result in subchondral sclerosis and subchondral cyst. Whereas in rheumatoid, this is mainly because of the inflammation. So you will see bilateral involvement. So the bilateral involvement, so you will see both medial and the lateral compartment which is involved, and this medial and lateral compartment involvement is, you will see the entire area around the joint is also loosened. That is your juxta-articular lucency is that. So you will see osteopenia and the lucency. So that is what, and there is lot of erosions which we see and a lot of destructions in the joint. So erosions and destructions in the joint is mainly because of the inflammatory arthritis. Whereas in a degenerative osteoarthritis, mostly we see this sclerosis. So this is one thing which you have to remember. Can I extend for up to 15 minutes more, guys? Sorry, we are late. Just more 10 minutes more. Is that okay for you all? Okay, in the rheumatoid, in the rheumatoid, what we actually see is various deformities, because there is a lot of destruction which can occur in the ligaments also. This ligament involvement and the joint involvement will result in the deformities, where we have two important. One is called the swan neck deformity and the second one is called the Bottigneus deformity. Okay, one is the swan neck deformity, the second one is Bottigneus deformity. The swan neck deformity, what you have to remember is, it is similarly like the mallet finger, what we have thought. So there is a flexion in the DIP. So this is the FD form, so fixed deposit. So flexion in the DIP. And what is Bottigneus? Bottigneus is flexion in the PIP, extension in the DIP. This you have to remember. Okay, flexion in the DIP and extension in the DIP is the Bottigneus. So what I actually remember is only the swan neck. So swan neck, one thing I remember is FT. So there is a flexion in the DIP. That's it. So whenever there is a flexion in the DIP, the opposite you see in the PIP, that is extension. And similarly, this is the Bottigneus. Bottigneus is flexion in the PIP and extension of the DIP. So remember only one thing, that is your DIP flexion is just seen in the swan neck. So that is your rheumatoid. And what is the other thing what you can see in the rheumatoid? You can see there is the Z deformity also. So the Z deformity and the metacarpals are drifted like this. So the ulnar drift deformity also you can see. So completely they are all these deformities which, because of the lot of inflammatory products which are released in the joints, will result in these deformities. But in case of osteoarthritis, what you see is there are important nodes which you can see. Okay, though these nodes are two types, Herberdens nodes and Boucher's nodes. How do you remember Herberdens nodes and Boucher's nodes? Okay, Herberdens nodes and Boucher's nodes. Here I remember this as HD. HD in PIP. Okay. So FD, HD, FD, HD. This is what I remember. You can do whatever mnemonics you want, but please remember that Herberdens is DIP. So whenever the distal interferential joint is involved with the formation of nodule, in case of your osteoarthritis, that is your Herberdens node. And osteoarthritis also, there is an involvement of the hands mostly. So the most common joint which is involved is your CMC joint. So CMC joint is the most common joint which is most commonly involved in your osteoarthritis. When it comes to rheumatoid arthritis, you will see the involvement of variety of joints, but most commonly what is involved is your MCP joints and your PIP joints. And the question what recently was asked was involvement of cervical spine. So cervical spine, what is most commonly involved? It is your atlantoaxial instability, AAI. Atlantoaxial instability is one which is most commonly seen in case of cervical spine in rheumatoid arthritis. So this is the question which was asked. So what is the patient has come with pain in the cervical spine? What could be the most common thing which we can see in rheumatoid arthritis? So this is your atlantoaxial instability which we can see in rheumatoid arthritis. Okay. Yes, and the next one, these are all the, I've told you, ulnar deviation of the metacarpophalangeal joint, your Z deformity, Bottineus, swan neck, all these deformities are usually seen in your rheumatoid arthritis. Okay, so what is the thing which we usually see? Again, it is most commonly seen in young patient and most commonly seen in female patient, because this is an inflammatory conditions. So young females, bilateral symmetrical involvement. So bilateral involvement and symmetrical involvement you see in case of your rheumatoid arthritis. Okay, then we have, what is this? So this is very important question. This is your dagger sign. So what is your dagger sign? So dagger sign is nothing but which is seen in case of your ankylosing spondylitis. So ankylosing spondylitis is the condition. Again, you are very much familiar what happens in it. It is the involvement of your axial skeleton. So whenever there is an involvement of axial skeleton, and this is also an inflammatory condition, again how will they ask you? Again they will put questions like young male patient, stiffness of the back. This is very important. Stiffness of the back is very important, and morning stiffness. Yes, and again I forgot to tell you, in inflammatory rheumatoid arthritis also morning stiffness. And what is this morning stiffness? Usually it should be of more than 1 hour, and there should be involvement of the hand joints. So this is all important. Euler criteria. So we use the Euler criteria for diagnosing of the rheumatoid arthritis. Okay. Similarly, ankylosing spondylitis also, what you have your young male with stiffness of the back and morning stiffness and enthesitis. So what is enthesitis? Enthesitis is the involvement of all the enthesis. Enthesis is tendon attaching to the bone. So all the tendon areas where it is attached to the bone, especially heel. And then you have your uveitis. Now all these conditions they put in the question. So they will tell young male patient and with the uveitis, with enthesitis and with morning stiffness. And one more important thing is you will see this dagger sign. So there is a calcification of the PLL, calcification of the PLL. So this is the dagger sign. And then what you see, the syndesmophytes. The syndesmophytes you see, and this syndesmophytes will result in what is called as the bamboo spine. So this is your bamboo spine. Okay, and what is this test? This test is your Schober's test. Schober's test is you will test for the flexion of the spine. So you're testing for the flexion of the spine, and the reduction in the flexion is nothing but there is a restriction of the lumbar movement. So restriction of the lumbar movement will result in the Schober's test. And similarly, can you recollect one more test here? That is your Adams test. So what is Adams test? Adams test is for your scoliosis. So similarly, that is also bending. So whenever you bend, the scoliosis disappears. So that is your Adams test. Here you bend and you will measure, and this measuring will result in, you will find out that there is a decrease in the lumbar flexion. So that is your Schober's test. So this is your Adams test, bamboo spine, dagger sign, all this. But what is the most important thing you should never forget to diagnose this? So in MRI, and what do you see? Sacroiliitis. This is very important, and this is asked in the exam. So see, concept based, we know everything about ankylosing spondylitis, young male, HLA-B27, all that you know. But what is most important, the concept, it should involve the sacroiliac joints. How do you identify that? You take the MRI, you see the sacroiliitis involvement with presence of edema. So that is how you confirm this as your ankylosing spondylitis. So what is important here? The important is the MRI sacroiliitis identification. So the sacroiliitis with the involvement of lumbar spine, enthesitis, all this put together will give you the picture of your ankylosing spondylitis. And what is this X-ray? So this X-ray is nothing but pencil in cup appearance, and this is seen where pencil in cup appearance, very important, just a IBQ, it is psoriasis. And one more thing, psoriasis, what we use, the Casper criteria. This is important. And psoriasis, there is an involvement of DIP. So psoriasis, Casper criteria, involvement of DIP. Why DIP? Nothing to mug up here. whenever the nails are involved, that is your psoriasis. So nails are in relation with distal interpharyngeal joints. So remember, nails, distal interpharyngeal joints with Casper criteria is psoriasis, psoriatic criteria. And now in the psoriasis, what is important is it is arthritis mutilans. So psoriasis is arthritis mutilans. So there is a lot of destruction which will happen. Okay, so this is arthritis mutilans. That's it. And then what is this? This is fluorosis. So severe sclerosis, where you see this is nothing but your fluorosis. So here what happens? Calcium fluoride. So what is the normal calcium? Calcium hydroxyapatite, right? Calcium hydroxyapatite. So there is calcium and then there is hydroxyapatite which has to be formed. But here what happens is, here fluoroxyapatite, it forms what? It forms the fluoroxyapatite, and this fluoroxyapatite is not very good with resorption. So there is a decreased resorption which occurs, and this decreased resorption will become sclerotic bone, which is called as fluorosis. And what is the technique? This is asked in the exam. The technique is Nalgonda technique. So this is exam. Nalgonda technique, what we use, you have to be very familiar in the SPM. I think alum. Yes. So Nalgonda technique we use with alum. So that is, this is asked in the exam about fluorosis. So in the point of view from ortho, it is mainly the teeth, yellowing of the teeth, and your ligamentum flavum which is involved. So ligamentum flavum, what will happen? It will go to hypertrophy because of fluorosis, right? And then if you see the bone, it is completely sclerosis because there is a formation of fluoroxyapatite which is not very good with resorption. So there is no resorption happening, hence it is sclerosis which we see. Yes, following. Now this is the metabolic disorders. So metabolic disorders we have are very important: rickets. You know all the cupping, fraying and splaying. Decrease in vitamin D will lead to decrease in the calcium. What is important for rickets? Rickets, you see, what is that? Genu varum. So that is important. You see genu varum in the rickets, or sometimes you can see your wind swept deformity. So what is wind swept deformity? So one leg in varus, one knee in varus, the second knee in valgus. Okay, so this is the rickets. And what is the X-ray finding? Usually they ask a rickets, they usually ask the X-ray. So what is actually rickets? So which zone you see? You see this in the physis. Okay, you have physis, the growth plate. So in the growth plate, you see there is a lot of, cartilage which is formed, but it is not ostia, or it is not converted into bone, no ossification, because there is no vitamin D, no calcium, phosphorus, no deposition. So everything is loosened. So you can see everything is loosened because there is decrease in calcium and phosphorus. This is about the rickets. So what important thing you have to remember is the X-ray findings. So first one here is your cupping. So it is cup-like structure, and then you see some deposition, that is fraying, and these extensions. So these are called splaying. So this is cupping and usually seen in the wrist joints. Usually you take the X-ray of the wrist joints and you see. Okay, so that is about the rickets. Then now coming up to the next thing, that is scurvy. So what happens in the scurvy? Similarly, here there is a decrease in vitamin C. But vitamin C is important for what? It is important for collagen. So collagen is important for cross-linking. So whenever there is decrease of cross-linking, decrease of collagen, what will happen? Osteoid is disturbed. But remember, calcium is normal. So ossification is normal. The collagen is what? The osteoid, right? So that means the main bone is formed with osteoid and minerals. So here the problem is in osteoid. In rickets, the problem is in minerals. So here minerals, that is calcium and phosphorus problem. Okay, here the problem is in osteoid. So the bone is laid, but it is not good. So what will happen? Now the bone is weak again. The bone itself is weak. But because of presence of calcium, everything appears calcified here. So if you see, there is a dense zone of provisional calcification. Wimberger sign. What is Wimberger sign? You can see a line around the epiphysis. So epiphysis is dull because bone is dull. But the calcification is present. So there you see a ring epiphysis. And again you see subperiosteal hemorrhages. So why again? So whenever you see vitamin C deficiency, this is associated with what? Bleeding disorders. So bleeding disorders, why? Because the epithelium, the vessels are also made with vitamin C. So that is why the epithelium is also loose. So this result in subperiosteal hemorrhages. So you have to look for subperiosteal hemorrhages and the provisional calcification. So white line of Frankel is again the provisional zone of calcification, and the Pelkan spurs. Pelkan spur is again the extensions. Extensions are the Pelkan spurs. So if you see the calcification, you can see. But there is some zone which is very lucid. So that is your scorbutic zone where the bone is weak. So the collagen is weak here. Because of the collagen weakness, what happens? The bone tries to bend. Okay. That is the vitamin C. Next. Yes, now coming to the next important thing, that is your sports medicine. So in the sports medicine, you have three important things. First, we'll go with the knee joint. So knee joint you have three. So first is your meniscus, cruciate, collaterals. Right? So whenever I talk about the meniscus, the test is very important. They talk about the McMurray's test, right? The Thessaly's test and the Apley's grinding test. Okay? Then whenever we talk about the cruciates, we talk about the ACL, PCL. ACL anterior drawers test, right? And the pivot shift, and then you have your Latchman's test. Similarly, collaterals, very easy, varus and valgus. So when I talk about valgus stress, we are talking about the MCL. Have you remember? So this is the knee. Imagine that this is the knee and I'm trying to open the knee from the inside. So this is the inside and outside. So trying to open the knee, for example, like this. So this side is inside, I'm talking about, this side is outside. So whenever trying to open the knee, so this is the valgus force I'm giving. So valgus will test the MCL. Right. Similarly, you're pushing the knee like this. So this is the varus stress. So varus stress will do your LCL. So this is important. Okay. And now in prone position, when you're doing this, this is called as your Apley's grinding test. So prone position, again you do external rotation and internal rotation, and this is for your meniscus. This is for your meniscus. Clear? Yes. I'm going a little bit fast. Sorry for the time. So this is your anterior draw. So anterior draws, you put this in 90 degrees and you're pulling it forward. So the tibia, you're pulling it forward. So the cruciates are tested with the anterior draws test. And this is your McMurray's. Again, you're doing this. This is your McMurray's for your meniscus. So remember, there are important tests. So one is your meniscus. So meniscus is between your femur and tibia condyles. So this meniscus can be tested with the McMurray's, Apley's and Thessaly. So three important things. So remember, McMurray's is supine, you sleep and twist. Thessaly, you stand and twist. Right, and then Apley's prone and twist. So three things. So prone position twisting, Apley's. Standing twisting, Thessaly's. Sitting supine and twisting, use your McMurray's. Anterior draws, you know, and Latchman's is supposed to be the sensitive, if you remember. And then we have the most specific, that is your pivot shift test. This is a specific test, is a pivot shift test. Okay? Yes. And now the investigation of choice is always MRI in case of your sports medicine. But remember, the gold standard is always your scopy. So gold standard, we will always go for arthroscopy, that is diagnostic arthroscopy. But investigation of choice is MRI. And in this you can see the ACL. This is the ACL here. Right, and this is your PCL. So anterior tibia, if it is originating from the anterior tibia, ACL. Posterior tibia, PCL. So absence of these two will result in whether it is ACL tear or a PCL tear. Okay, and treatment is ACL or PCL reconstruction. So you have to build that again. Okay. Yes, now this has been asked in the exam, this one. So the question in INI-CET, meniscal tears. So here the meniscus, this is the vascularity, this is the genicular artery, and it divides in the periphery. This is called red, white and red. Why? Because periphery, this is rich in blood supply. So periphery, it is rich in blood. Hence, whenever the tears are in the periphery, tears here in the periphery, you heal. They heal. So what you do? You do meniscal repair. So they heal because you do a meniscal repair. So whenever in the white zone, what you do? You remove. So white zone, they don't heal because there is no vascularity. So this is meniscectomy. This is meniscectomy. So meniscal repair and meniscectomy. Okay, done. Next, these are the tests. So rotator cuff muscles, if you remember, there are 4 in number. The supraspinatus rotator cuff, you remember, it is the empty can test. So this is the empty can test where you do abduction and internal rotation and you try to lift it up. This is the empty cans. This is the lift off test. So whenever I say lift off test, this is because of your subscapularis. So lift off test is for your subscapularis. And then you have belly press test. So belly press test is again for internal rotation, your subscapularis. Okay, 3 important tests: empty can test, belly press test and lift off test. Lift off test is for your subscapularis. And now coming to the pediatric orthopedics, we have the very important what you called as the torus fracture. That is a bend, you see, this is called as the torus fracture. Bend in the cortex is torus. What is most important is your Salter-Harris classification. So when it comes to Salter-Harris classification, it is mainly for the physis. So you will see the involvement of the physis. So that is your Salter-Harris classification. How you remember? With the mnemonic Salter itself. Right. So straight when it's through the zone of hypertrophy, it is type 1. Above when it is involving the metaphysis, it is type 2. Below lower when it is involving the epiphysis, it is type 3. And through, that is through all these 3 is type 4. And crush injury where you can't see in the X-ray, it is type 5. This is Salter-Harris, very important. And then you have your nursemaid's elbow, where there is a subluxation from the annular ligament. So there is a annular ligament, this is radial head, and this radial head is secured inside the annular ligament. So with this maneuver, the daddy moves the child with the limb like this in this position. Subluxation of the radial head will happen from the annular ligament. The patient will cry in pain. Then what you do? You slightly flex it and supinate. So supination is the treatment. So treatment is supination. You reassure and you tightly supinate. That is the treatment. Now coming to the CTEV. So this is nothing but cave. Treatment should be started as soon as possible. So in the cave, what you see? The cavus, the deformities, adduction, varus, equinus. So how do you treat all this? Treat with the Ponseti technique. You treat with the Ponseti technique. And what is Ponseti technique? Again, you treat first cavus, adduction, varus and equinus. You do serial casing. So you do serial casing to the baby. Okay, every week you change it. This is an above knee cast. Right, once it is corrected, you put in the Dennis Brown splint. So this is the Dennis Brown splint. Okay, up to walking age. And these are the CTEV shoes. So you can see the straight inner border, no heel, and the outer border is raised again for not going back into the deformity. So this is the CTEV deformity. And cavus you see in the midfoot because of the arch which is elevated. Adduction in the forefoot you see. Varus in the hind foot where the calcaneum is going into the varus, and then equinus because of the tendoachilles. right? And then DDH, we have two important screening tests. One is called the Barlow and Otterloni. So Barlow is nothing but dislocation. So again you do abduction and external rotation. Otterloni you do, sorry, Barlow is dislocation. So you do adduction and internal rotation. So flexion, adduction and internal rotation. So Otterloni you reduce it. So flexion, abduction and external rotation. So these two are the screening tests which we do, and this is the Pavlik harness which we give for the baby of less than 6 months. So this is the Pavlik harness, the brace which we provide less than 6 months, right? And again you can see this is a Perthes disease. So Perthes disease, this was asked in the exam. This is nothing but your avascular necrosis of the femoral head. Okay, and here what is most important is the Perthes disease is again given as an X-ray, usually seen in 4 to 8 years of group. Remember one important thing I'll tell you, that is your painless limb. So whenever they ask you painless limb in a child of 4 years, that is your Perthes disease. And adolescent group similarly with the pain, but this pain is radiating to the knee. This pain is radiating to the knee, then this is nothing but your SCFE. SCFE is slipped capital femoral epiphysis. This is an example of type 1 Salter Harris, right? And this is seen with patients with endocrinopathies, okay? And obesity. Obesity and endocrinopathies play an important role where there is a slip of the epiphysis which you see, that is the SCFE. And one more line which you see, that is your Kleene line. So this is the Kleene line which we see, and this is called as the Trethove sign. So what is a Kleene line? So Kleene line is you are drawing a lateral line along the femoral neck. And this, if you draw a lateral line normal, you'll see it will cross the epiphysis. Here it is not crossing the epiphysis. This is called as a Trethove sign, and this line is called the Kleene line. And these are all the various things which you can remember for the AVN. They will ask you Kienbock's lunate. So these are all the things which you have to remember. And these are the IBQs. So this is the scapula at a higher level. And the down one is your Klippel-Field syndrome. So already it is given the 3 condition: low hairline, short neck and cervical vertebra, and this is your Springel's deformity. So scapula at the higher levels is the Springel deformity, and your short webbed neck, this is your Klippel-Field syndrome. And coming to the infections, you have various things. The first thing what you see is this sequestrum. So sequestrum is seen mainly in the osteomyelitis, that is chronic, and you see the Brody's abscess. So this is your Brody's abscess, which is a subacute osteomyelitis. But what is important in case of TB is these two. So one is your wandering acetabulum, and second one is mortar and pestle appearance. So these two are important in the TB. All these are IBQs, nothing much to learn about it. So usually there are 4 stages in the TB. So in the 4th stage, the destruction stage you see, and what they have asked recently is what is the diagnostic test for TB, that is your CB-NAT. So this you have to remember, the test for TB is your CB-NAT, right? And this is the triple deformity, is self-explanatory. And various metabolic, again this is the osteomalacia where you see the Looser's zone, right? Osteomalacia is adult rickets. And then you see protrusio acetabuli again in case of your osteomalacia. And then this is your hyperparathyroidism. So hyperparathyroidism is a condition where you see there is an increased PTH. So this increased PTH will cause increase in the calcium. So how the increase the calcium is happening? This is because of increased resorption. So all the things you see about resorption. Okay, so this resorption is mainly seen on the radial side of the phalanx, and you see this as the tumor. Because of this resorption, excessive resorption, the bone is filled with fibrous tissue with hemorrhage, which is called as Brown's tumor, seen in hyperparathyroidism. Right, again the Paget's disease, you see picture frame vertebra, okay, and the ivory vertebra. So what is Paget's? Paget's is there is a problem in the resorption. Okay, so you have 2 important things: Paget's disease, that is ivory vertebra, which is picture frame vertebrae and ivory vertebrae. Okay, and this is rugged jersey spine, you see in spinal osteodystrophy and also in case of hyperparathyroidism. And this is your osteoporosis. Now what they have asked in osteoporosis is about the FRAX. So FRAX is nothing but your identification of the probability of fracture. This is probability test. So that is the FRAX. And then this is full of sclerosis. Again, a example of your Paget's disease. Sorry, this is not Paget's, this is osteopetrosis. This is osteopetrosis. Okay. Osteopetrosis, IBQ again, and this is osteogenesis imperfecta. So you can see that there is a deformity in the bone, which you can see. This deformity is because again there is a loss of collagen called A1 and A2 genes are lost. So this is osteogenesis imperfecta, and this is your bone periosteum elevator. So this is your periosteum elevator. Again, they can ask you a few of the instruments. So you will elevate the periosteum, which is covering of the bone, and these are the bone spikes. So these are the bone spikes, right? So these bone spikes are mainly used for, supporting during the fixation. So you will put the spikes and they will help you for the retraction. So these are the bone spikes, and this is a very important osteotome. So this is the osteotomes, and this is for cutting, break of the bone. So if you want to break, like in malunion we have seen the osteotomies, and then you have your curette for curettage. So for your GCT, you have read that curettage is done. So this is the curette, and then this is the bone holding forceps. So this is the bone holding forceps. So once you are done with the reduction, so once you have elevated the muscle with this bone spike, then you will hold the bone with the help of bone holding forceps, and this is the plate holding forceps. So now these are all the instruments which are useful. So these are the plate holding. You can see that difference in this. So this you see both are rounded. So bone is hold. This you see one is rounded, the other one is like this. So you can see this is a plate holding forceps. And again, the types of amputations are important. Most important at the ankle, you see the cymes at the level of ankle. Torso metatarsal is Lisfranc's. Tarsal bones, mid-tarsal is Chopard's. Okay, torso-metatarsal fracture dislocation is Lisfranc's again. And the two important foot, one is called the Satch foot, solid ankle cushion foot, and then is called the Jaipur foot. Sorry, this is your Jaipur foot and that is your Satch foot. So what is the difference between these two? So Jaipur foot and Satch foot. So I have told you this is a solid ankle. So this has been designed by the Western world, which is not very useful for the Indian setup, whereas Jaipur is mainly for the Indian, where you can do all the movements are possible and you can walk with the barefoot. So barefoot and movements, which are very, very important. So this has been devised by the Jaipur P.K. Sethi. He is the orthopedic surgeon and he has used the vulcanized rubber. So the weight is also reduced. So vulcanized rubber, what is the speciality? They can walk on the uneven surfaces also with the barefoot, and all the movements such as squatting, inversion, eversion, all are possible, which are not possible with the Satch foot, where they have used the wood keel. So because of this, that is not possible. Rest. So that is it for today. I've been little fast, but that's okay. It's a marathon. So hope you all understood. Thank you so much. If any doubts, you can always meet us on Instagram, PW Meded or Dr. 𝐒𝐿𝐴𝐀𝐄𝐝 Ortho. Okay. Yes. All the best for your exams. See you all on the other side. Do well. Bye.
So good afternoon everyone. If I'm visible and audible, please give me a thumbs up. We'll start with the session on anesthesia now. Yeah. Okay. So let me start with the anesthesia. Yes, guys. So I'm not getting messages from you. Yeah, got it. Dr. Sudhanshu, right. Okay, hi. So let's start with without wasting any more time, let's just start. So my name is Dr. Vinesh Srivastav. I'm a faculty in anesthesia, and we'll start with the revision of anesthesia. First thing that we'll start straight away is that you have to know about the types of anesthesia where they ask you. I know all of you are aware, but just revising fast, the types of anesthesia that we need to be aware. Most importantly, the first thing is general anesthesia, which we all know is used for any major surgery or any surgery above the umbilicus, right? Above the umbilicus would mean ophthalm also. Above the umbilicus would mean a dental procedure also, but that is not a common thing which we do, and that is why apart from general anesthesia, remember local and regional become very important. Local is something which is topical, right, which we apply over various surfaces, and then you have infiltration when you take a suture. All right. Apart from that, there is field. Regional is one when region gets anesthetized. For example, for an upper limb, you go for a GA, surgery above the umbilicus. But then using a peripheral nerve block or a brachial plexus block becomes much more easy. Similarly, spinal and epidural are kind of a regional anesthesia. One region gets anesthetized. Spinal is for any surgery below the umbilicus, right? Epidural more commonly is used for analgesia or pain relief. Remember, for labor analgesia or post-operative analgesia, this is a choice. It also helps you to increase anesthesia time. Apart from that, a very important part I'll discuss later, intravenous regional anesthesia. And the last two things you need to know is monitored anesthesia care, where you are just standby, right? And conscious sedation, which all of you have done during internship when you've taken kids for MRI scan. All right. So monitored anesthesia care and conscious sedation are two sides of the same coin. These are the types of anesthesia you need to be aware of. The major part here is that major surgeries all go for general anesthesia or surgery above the umbilicus. Spinal anesthesia is for surgery below the umbilicus. This is the major part. But in case you have a hernia patient, pediatric patient who will not let you give spinal, that is why pediatric patients normally we give general anesthesia. And if someone has a respiratory problem, neuromuscular disorder, remember for that we prefer to give regional anesthesia. So though everything will be okay, the patient is for GA, like someone having epigastric hernia above the umbilicus. But still, if the patient is a respiratory patient or a neuromuscular disorder, we prefer to use regional. These are the types of anesthesia slightly. Okay, guys, let's go about the GA. When we give GA, we intubate someone, right? We put a laryngeal mask airway and you have to give a breath. But what if it becomes difficult? So what are the predictors of difficult intubation when you want to intubate someone? So remember, for that, we can use a short form called LEMONS. LEMONS. I think all of you are aware of that. LEMONS. These are predictors for difficult intubation. Look externally, where we need to look externally at the airway for any abnormality. Okay, for any abnormality. Remember, what would airway mean? Airway would mean anything between the nose to the chest. So remember this point. Any abnormality that you see between the nose to the chest, which can be a teeth or a tooth which is protruding out, presence of a beard, presence of a mass, right? On the nose to chest, anywhere if you see teeth, beard, mass, any past history of surgery, right? Anything else. So that becomes a difficult airway. Look externally. E stands for evaluate distances. Mouth opening should be 3-finger breadth or 5 centimeter, right? More than or equal to. Thyromental distance 6.5 centimeters. Sternomental 12.5. This is considered normal. Anything which is less than this is abnormal. If less, it is abnormal. Okay. If it is less, it is abnormal. Now, Malampatti 3 and 4. M stands for Malampatti 3 and 4. M also would stand for mandible. O stands for obesity. N stands for neck movement and neck circumference. S stands for a snorer or past history of surgery to the face, where you are going to intubate someone. So you can remember it as LEMONS. Now, similarly, we hold a mask on someone's face. So for a difficult mask ventilation, what we can remember it as bones, B-O-N-E-S, right? Presence of a beard on the face, someone who is obese, any problem with the neck, someone who is edentulous, no teeth, means you can't hold the mask on the face, someone who's a snorer or a obese patient. All right. So that is for difficult mask ventilation. Thumbs up, guys. All okay? Yes. All okay, guys? Okay. So let's discuss about Malampatti 3 and 4, which you are discussing. Okay. So Malampatti 3 and 4 are basically said to be difficult intubation. Now, Malampatti itself is an important question by itself. You guys are aware of that. So first thing is, how do you get a Malampatti examination done? You ask the patient to open the mouth, extend the tongue, and do not phonate. Open the mouth, extend the tongue, and do not phonate. Okay, and do not phonate. After that, you need to look at the posterior pharyngeal structures. Posterior pharyngeal structures. Based on that structures that you see, you classify them into Malampatti 1, 2, 3 and 4. Okay, Malampatti class 1, class 2, class 3 and class 4. So remember, in Malampatti class 1, class 2, class 3, class 4, there's only one structure that helps you identify all of them, and that is uvula. If you can see the complete uvula, it is Malampatti 1. If the tip of the uvula is not visible but the rest is visible, it becomes Malampatti 2. If you can just see the base of the uvula, the other uvula is not visible, that's Malampatti 3. And if you don't see the uvula at all, it becomes Malampatti 4. So forget everything else, you just look at the uvula and you know the answer. So therefore, if if the complete uvula is visible, okay, so it becomes Malampatti 1. If the tip of the uvula is obscured, so if the complete uvula is visible along with the torticollis, fauces, soft palate, hard palate, that's Malampatti 1. Malampatti 2, the tip of the uvula is not visible, rest is visible. Okay, so the tip is not visible. Tip of what? Tip of the uvula is not visible, rest all are visible. Malampatti 3, only the base of the uvula is seen. Malampatti 4, remember, only hard palate, so therefore no uvula seen. So that uvula helps you identify. Now they say Malampatti classification basically correlates with the 𝐒𝐿 grading. This Malampatti classification correlates with the 𝐒𝐿 grading, and that is why Malampatti classification is said to tell you the ease of intubation, which is easy and which is difficult. So in 𝐒𝐿 grading, which is called as laryngoscopic grading, again this has been an important question in the exam, right? So when you put a laryngoscope, if you see the vocal cords are seen, that's 𝐒𝐿 1, right? Vocal cords half seen, 𝐒𝐿 2, only the epiglottis seen, 𝐒𝐿 3, and nothing is seen on laryngoscopy, that is 𝐒𝐿 4. So therefore Malampatti 1 and 2 would basically be like 𝐒𝐿 1 and 2 when you put a laryngoscope, so they are easy. Malampatti 3 and 4 is like 𝐒𝐿 3 and 4, this is considered difficult. Therefore Malampatti classification tells you what? It tells us the ease of intubation, which is easy and which is difficult. It tells the ease of intubation. And how did you identify? It was relation of tongue to the position in the oral cavity. Okay, the position of the tongue in relation to the oral cavity. That's how it realized. Position of tongue in relation to the oral cavity and structures. Thumbs up, guys. All okay? So since it's a revision, we are trying to, touch up all the important points one by one. Yes, guys. All okay? Not getting an answer. Yes, everyone. Correct message, thumbs up to kar do. All okay, guys? So let's go to the anesthesia machine. When we speak about the anesthesia machine, guys, remember the anesthesia machine gets classified into three types: based on the pressure of the walls, because the oxygen cylinder normally is at 2000 pound per square inch. The nitrous oxide cylinder is at 750 pound per square inch. It's very high pressure. It cannot be given to a patient directly. That's why we need to reduce the pressure. So to reduce the pressure, okay, Dr. Sai Krishna has given me a thumbs up. Thank you. Okay, at least I know now you guys are able to get things done. So that's the reason why anesthesia machine gets divided into three parts, right? So you have got a pressure reducing valve and these knobs. Based on that, you have the first part, the second part, and the third part of anesthesia machine, and we say as the high pressure system, intermediate, and low pressure system. So without going into too much details, remember this anesthesia machine normally has three parts. Okay, so the three parts of anesthesia machine, one is the high pressure system, the other becomes the intermediate pressure system, and the third part becomes the low pressure system that we just saw. The high pressure system, as you can see, involves the cylinders which you are seeing there, right? That is the pressure on a higher side. So we have cylinders and attachments basically as a part of high pressure system. The intermediate pressure system is basically going to be pipelines and its attachments. Apart from that, the oxygen flush valve, which is for emergency, is an important part of the intermediate pressure system. And the last is the knobs. They are important. These are called flow control valves. The second part, you know, this part, these valves are called flow control. And here these were the pressure reducing, which are a part of high pressure system. And the last is the low pressure system. As you can see, it would contain this flow meter, this vaporizer, and the outlet. That is the low pressure, the third part. Okay. So therefore, the lower pressure system is basically having the flow meter assembly, as we just saw. The vaporizer would be a part of this, and outlet. Right. Now from here, you all know every small, what details are they ask you is basically regarding the cylinders. This is the question which comes in the exam. They ask you regarding pipelines. This becomes an important question. They ask you about oxygen flush, especially in INI-CET, that's important. They ask you about knobs. This is what is important. Here they ask you about vaporizer. These are the points that you need to study, which you all know. When you study cylinders, you study the pin index and the colors of the cylinder. When you study pipeline, you study about the colors. When you see oxygen flush, what is the importance of oxygen flush? So as I said, oxygen flush is used in emergency. We have already mentioned that. Okay. So when it is used in emergency, what is it used for? In case you feel that a patient is hypoxic and not getting oxygen, in that case, we use the oxygen flush valve. It provides in emergency to a patient 35 liters of oxygen, but because from intermediate pressure system, at what pressure? At 60 pound per square inch pressure, which is slightly on a higher side, and therefore an important point is the side effect of this is barotrauma. That's the question which comes from here. Okay, that's barotrauma. That's barotrauma. All right. Now, when we're discussing the knobs, so again, this has already been discussed in detail, but as I said, all these important, so many points you don't need to study. We've just taken one part from the type of anesthesia machine. One important point which is there from the anesthesia machine, we've just taken that. When we speak about the knobs, guys, what are the knobs? These are the knobs. You already know one of the color is, you know, blue, one is white. So what are they signify? White is oxygen and blue is nitrogen. So these are those knobs. All right. So therefore, talking about the knobs, what is important is the color. There are two types of knobs which you have. One is nitrous oxide, which is blue in color. It has got small serrations. The other one is oxygen, which is white in color. It has got broad serrations or broad groups. That's about knobs. All right, and then we have the vaporizer. So let's see the individual colors. So when we speak about the cylinders, here you need to know the colors and pin index, right? Especially because pin index system prevents the wrong attachment of cylinders. So when we speak about the cylinders, you need to know the color and pin index. When we speak of pipelines, here you need to know the color and diametric index safety system. Oxygen flush we've already discussed, knobs we already discussed, and vaporizer you need to know the one which is different based on color also. That's what we'll see. So when we speak about cylinders, guys, so remember these are the colors of cylinder. That's how the cylinder looks like. Okay. So the first cylinder that you should be knowing is the cylinder of air. air has a gray body. So this is the gray color. So this has a gray body with black and white shoulder. It's got a black shoulder as well as a white shoulder. This is the cylinder of air. Then you come to cylinder of oxygen. Oxygen, this is black in color, black body, but it has a white shoulder. When we come to nitrous oxide, okay, so when we are discussing nitrous oxide, it is completely blue. It is completely blue, shoulder as well as the cylinder. When you take Entonox, Entonox is a combination of oxygen and nitrous. So therefore in Entonox, you get the blue color along with the white color, oxygen with nitrous, and there's a blue body which you see. So this is Entonox and this is blue body with blue and white shoulder. Then we have carbon dioxide. Okay, so carbon dioxide is completely gray. You will see the top is also gray as well as the body is gray. And then there is helium or heliox. When you say of helium or heliox, it has a brown body. But when you speak of the shoulder, it may be brown with white. Heliox means it has oxygen. So white in color. So hopefully these points are clear. Right? So these are all the colors of the cylinders that you need to know. So these are the colors. And to prevent the wrong attachment of cylinder, so that I don't interchange them, as in I don't put the oxygen cylinder there and I don't put the nitrous cylinder here. That is why we have the pin index safety system. So this is basically, guys, the pin index safety system. Okay, it prevents the wrong attachment of cylinder. You're aware of that. Okay, so this is the pin index safety system. It prevents the wrong cylinder attachment. It prevents the wrong cylinder attachment. Now, here also you need to know the numbers. Okay, so normally air, as you can see, this has been given the number 1 and 5. Oxygen has the number 2 and 5. Nitrous oxide here is the number 3 and 5. Entonox is 7. Carbon dioxide is 1,6 or it can be 2,6 depending on the percentages of carbon dioxide present. So this is pin index. The next system, the knobs we were discussing, here is what you get, the nitrous oxide knob, which is blue in color, and this is oxygen knob, which is white in color. This is about the intermediate pressure system. Beyond this, this is what is called as the flow meter assembly. Not to go into too much about details of that for exam purposes. But what was important is the vaporizer after the flow meter assembly. So we had seen after the flow meter assembly, the next thing is the vaporizer. So let's go into the vaporizer and look at the colors. So all of you already know, right? Just a revision sort of thing now. Halothane is red in color. All right. Isoflurane is purple in color. So these are the vaporizers we are discussing. These are the vaporizers. All right. So halothane is what is red in color. Isoflurane is what is purple in color. All right. Desflurane is what is blue in color. And sevoflurane is what is yellow in color. Now, as you can look structure wise, it's the blue one which looks different from all of them in terms of structure, because this is electrically heated. It's a special vaporizer. So remember, this has been asked as image based question. Desflurane has a special vaporizer compared to others. All right. And this vaporizer is basically Tech 6 is what they call. This basically gets electrically heated. It has an electrical supply. Right? Because desflurane boils at 23 degree or room temperature. Clear? Now the last part that we'll discuss is pipelines. So here we have discussed pipelines, color and diametric index safety system. So pipelines are something which come and attach at the back of anesthesia machine over here. So you get nitrous and oxygen getting attached over here. Right? So these are the pipelines. So pipelines are part of intermediate pressure system. And again, just like cylinders, if I want to interchange, can I interchange them? Like, you know the colors now. So if I see the colors, remember the white one is always going to be oxygen. Right? The blue one that you see is always going to be nitrous oxide. All right. The black one which you see is always going to be air. And the yellow, which is most commonly used for suctioning. All of you must have used that in the wards also. That is for suction. All right. So if I want to prevent the wrong attachment of cylinders, I don't want to, pipelines, I don't want them to get interchanged between here and here. So that is why what we have? A diametric index safety system. So in pipelines, we have the diametric index safety system. It prevents the wrong pipeline attachment. Thumbs up, guys. Okay till here? Yes, Dr. Smooth Specialist says hi. So hi. But apart from that, all okay till here? Now, beyond the anesthesia machine, what connects to the patient, right? This was the anesthesia machine. Beyond that, what connects to the patient? This is what is called as the breathing circuit. Now, here's another important question from where exam, they ask you questions from breathing circuit. And breathing circuits, normally what you see over here is what is called Mapleson circuit. And these Mapleson circuits are made up of 5 things. What are the 5 things they are made up of? This fresh gas flow coming from the anesthesia machine. Okay, it's made from the fresh gas flow coming from the anesthesia machine. There is a bag from where you can give breath to the patient. Here is the connecting tube which you see. All right. Then you have a expiratory valve, which is also called as a adjustable pressure limiting valve, and then you have a mask. These are the 5 things which basically form the circuits, Mapleson circuits. So the circuits basically get divided into 3 types. Remember, the circuits are of 3 types. When we speak of these breathing circuits, they are of 3 types. One is a open circuit. Other you can call semi-open or semi-closed at your level. Let's discuss it as semi-open. And the last one is the closed circuit. Closed circuit is also called circle system because everything goes round and round. Semi-open circuits are basically the Mapleson circuits. Okay, and open circuits are not used nowadays. This was used in the past. In the old times, they were used for ether and chloroform. Not used now. So do we use in the for anesthesia? No. So you will find open circuits not used in anesthesia, but semi-open are used for anesthesia. Closed circuits are used for anesthesia. Because closed circuits is a circle system, it contains soda lime, right? There is rebreathing. So there is rebreathing of gases over here. You are rebreathing the gases with removal of carbon dioxide. Here, there is no rebreathing. And similarly, open circuits, no rebreathing. Correct? So when we speak of breathing circuits, guys, now speaking of open circuits, they are not used anymore. So let's not discuss about them. This was the first one. The second is semi-open, which is very commonly used, Mapleson circuits. Remember, they are of 6 types: Mapleson A, Mapleson B, Mapleson C, Mapleson D, Mapleson E, and Mapleson F. Out of that, remember, mostly Mapleson B and C, both of them are obsolete. So they will not be asking you. What we are left with is Mapleson A, D, E, and F. So Mapleson A is what is called as a McGill circuit or a lag circuit. Okay, this is more commonly used for a patient who is spontaneously breathing. So this is used for a spontaneously breathing adult. Mapleson A. You know, you just doing it a short procedure where patient is spontaneously breathing and 10 minutes the surgery will get over. We'll prefer to use Mapleson A. In Mapleson A, the lag circuit is said to be coaxial in nature, one tube inside the other. But it is used for a spontaneous breathing patient. Just for an adult. Mapleson D, main circuit use. Now, main circuit is the most common use. This is used for controlled ventilation or IPPV in adult. So remember, D and A are 2 circuits which are used in adults. So now what will you do? E and F become 2 circuits to be used for pediatrics. Okay, so E and F suddenly are the ones which you'll try to use for pediatrics. So Mapleson E is called the Ayer's TPs, and this is basically used for a neonatal ventilation, but it is not very commonly used. It is used in ICU to wean a patient off ventilator. Right, but the most common used in pediatric patient is Jackson-Rees circuit. Right, Jackson-Rees. Remember, Jackson-Rees is JR. JR means pediatric. It's used in pediatric patient, but pediatric patient come in various sizes. Sizes in the various ages. So therefore, it is going to be for a pediatric patient less than 6 years of age and less than 20 kg. And if it is more than, in that case, you have Bain circuit, and that is why Bain circuit is more common, not only for adults, but you can use Bain circuit for pediatric patients also who are more than 6 years of age and more than 20 kg. So this becomes very important. So remember, these are the three things that they'll ask you in exam. Normally what they ask you is only Mapleson A, Mapleson D and Mapleson F. Normally they don't ask you E also, but I think you should be knowing E. Remember, Mapleson C, as they said, used in emergency. So it's like an Ambu bag. Ambu bag is a sort of derivative of Mapleson C, and that is why this was used for CPR and chest physiotherapy. Okay, that is the only use of Mapleson C. It's a derivative of Mapleson C, the Ambu bag. Okay, it looks like an Ambu. Thumbs up, guys. All okay? Let's go to the next one. That is the closed circuit or the circle system. So when we speak of the circle system, it contains soda lime. The closed circuit or the circle system contains soda lime, which is carbon dioxide absorber. So soda lime basically is calcium hydroxide, sodium hydroxide, potassium hydroxide. Apart from that, it also contains indicators and silica. These are the contents. The point is that use of soda lime. So what happens is, what goes inside the patient, the fresh flow gases are oxygen, nitrous and inhalational. What comes out of the patient, this is gone inside the patient, and what comes out of the patient is basically carbon dioxide, nitrous and inhalational. What we do is we absorb this carbon dioxide, and this nitrous and inhalational are sent back inside the patient again, and that is why this is called closed circuit or circle system, where we are reusing these nitrous and inhalational. So I am reusing the anesthesia gases, I'm decreasing the use of anesthesia gases, I'm decreasing the complications and OT pollution and everything. All the advantages are there. All right, I'm reusing anesthesia gases. Why? Because I'm causing rebreathing after removal of carbon dioxide. How come? I've removed the carbon dioxide from here by the presence of soda lime. This soda lime is what removes the carbon dioxide. Whatever is left is sent inside the patient again. So this is what was left, nitrous and inhalational, and this we send inside the patient again, right? And that's why it is called as the circle system, right? Okay, guys. Very thumbs up, everyone. All okay? So I'm reusing the anesthesia gases, I'm decreasing the use of anesthesia gases, I'm decreasing the complications. That is why what I've done is, how can I reuse the anesthesia gases? Because I am removing the carbon dioxide. We remove the carbon dioxide, right, and then use them, and then reuse. All right, and therefore at one point this used soda lime will become saturated. How will I come to know? When soda lime becomes saturated, it becomes full with CO2. How will I come to know? So when soda lime becomes full, that box of soda lime becomes full, it is called saturated. How will I come to know? I will come to know because patients, it will stop absorbing more carbon dioxide. So patients' carbon dioxide will increase. I will come to know from the clinical signs. I will come to know from capnography. Remember, important graph of capnography, rebreathing, step ladder pattern. And because indicators are added, I will get to see a color change. Normally the color change is from pink to white. Okay, so when soda lime becomes full or saturated, that is how I come to know. So I was reusing the gases. So therefore the whole concept of circle system was use of the gases, right? Rebreathing after removal of carbon dioxide. So the whole concept here is rebreathing anesthesia gases after removal of carbon dioxide. Okay. Okay, guys, understood till here? So let's go to the individual drugs then. Are thumbs up, guys? All okay? Any questions and doubts? Please feel free to ask me. Also remember, on our app we have the INI-CET, the GT. So try to give that also. That will be a good revision for you, all of you. Download the app, and you can appear in the GT as well. All right, we have that INI-CET GT there. So what's the harm in just appearing for the GT? Okay, so let's go forward, guys. Inhalational anesthetics. Let's discuss that. Okay. So when we discuss inhalational anesthetics, all right, inhalational anesthetics means all these inhalational drugs which are going, the same inhalational drugs that I'm discussing about, all these inhalational drugs which are going, right? Let's discuss about them. So when we are discussing about these drugs, remember, inhalational anesthetics have 2-3 important points on which questions are asked, and the reason is that because they are not going like a normal IV drug. These drugs basically start from the anesthesia machine, okay, and from the anesthesia machine, what happens is they are going into the breathing circuits, as we just saw, okay. So these drugs, inhalationals, they start from the anesthesia machine. From here, they go into the breathing circuit. From the breathing circuit, they reach the patient's alveoli, from where they reach the bloodstream, and finally they go to the brain where they produce their effect. Alright, that is how the inhalationals work. Now, at every point, there is one important question that they ask in the exam. At the level of alveoli, what is important is the minimum alveolar concentration. At the level of the bloodstream, when the blood gets dissolved, it's called blood gas solubility. So here, what is important is minimum alveolar concentration. At the level of bloodstream, it is that blood gas solubility, and when it reaches the brain, oil gas solubility or lipid solubility. These things are important, which we need to know. So when the drug is working at the brain, what is the mechanism of action? So the inhalational anesthetics mechanism of action normally is to produce general anesthesia, right? So general anesthesia, always remember, is the depression of the brain, and therefore what is it? You want more excitation or inhibition? I would want excitation to decrease and inhibition to increase. So what is an inhibitory neurotransmitter? So I want the inhibition to increase. Inhibitory neurotransmitter is GABA. So therefore GABA increases, and that is the mechanism of most of the drugs. Remember, general anesthesia works on GABA. It increases the GABA. All right. Now, speaking about the next part, minimum alveolar concentration. All of you are already aware, you would be knowing that minimum alveolar concentration is inversely proportional to potency. What is important for us is the sequence. Sequence means which one is more potent, which one is less potent. So remember, we can remember it by a mnemonic. Maharashtra is Delhi? No. Maharashtra is Delhi? No. You can remember it like that. All right. So Maharashtra is Delhi? No. You can remember it like that. So here we have methoxyflurane, most potent. Then you have halothane, isoflurane, sevoflurane, desflurane, and nitrous, where we find that methoxyflurane, okay, so this M is that MF, methoxyflurane, and NO is nitrous oxide. So methoxyflurane is supposed to be the most potent, and nitrous oxide is supposed to be the least potent. This is the most potent, and nitrous oxide is supposed to be the least potent. Okay, clear? The next one I told you we'll discuss about is the blood gas solubility. So this blood gas solubility, all right, what does it do? What does it help us to determine over here? The onset and recovery. Again, it is inversely proportional to onset and recovery. Now, if I want to discuss about the sequence over here, sequence, which one is fast and slow? So again, I can use the same mnemonic, Maharashtra. Remember what was my mnemonic? I remembered the mnemonic as Maharashtra is Delhi? No. That's how I remembered the mnemonic. Maharashtra is Delhi? No. This is how I remembered. I'll just change it slightly. That is, Maharashtra is not Delhi. Why? It's expensive. Okay. It may not be expensive, guys, but there's a mnemonic that we are using. So the mnemonic that we are using is Maharashtra is Delhi? No. And then Maharashtra is not Delhi. Why? It's expensive. So we use the same mnemonic, right? So in the sequence, Maharashtra, which is M and H, Maharashtra is not Delhi. Not means nitrous oxide. Delhi. Why? Because it is expensive. That becomes my mnemonic. All right. So therefore, we have xenon as the fastest acting. Then you have desflurane, nitrous, sevoflurane, right? Isoflurane, halothane, and the last is methoxyflurane. All right. So where we have that methoxyflurane has the slowest onset and recovery. Methoxyflurane, remember it's inversely proportional. It has the slowest onset and recovery compared to xenon, which has the fastest onset and recovery amongst all the agents. In fact, it is said to be the most ideal anesthetic agent. And remember, nitrous and desflurane values are almost similar. I'm not asking you to remember the values, but just remember the sequence becomes very important. Also, one more point, when you speak of minimum alveolar concentration, remember it will have percentages written. For example, let me take one like isoflurane. So if you take isoflurane, it will be written as the value as 1.2%. Okay, halothane will be mentioned as 0.75%. But when you speak of blood gas solubility, there's going to be numbers, right? Numbers. For example, the same halothane would have a number of 2.4, but no percent. That's the point. Okay. Let's not go into too much details. That's not what is needed, but this much is sufficient for us to know. The last point we'll write over here is oil gas solubility. Okay. That oil gas solubility is also called lipid solubility, and this is directly proportional to potency because it is lipid solubility. Okay, so oil gas solubility directly proportional to potency. So we've discussed all these 3 points over here along with the sequences. Let's discuss the individual agents. So when you speak of nitrous oxide, now nitrous oxide, guys, remember, apart from other things, nitrous oxide has 3 important properties. Okay, and that is nitrous oxide has concentration effect, where it increases its own concentration. It has got second gas effect, where it increases others' concentration. A lot of people also call third gas effect, but it is not called third gas effect. It is called Finck effect or diffusion hypoxia. These 3 points are seen only with nitrous. You are aware of this. The first 2 take place during the induction when you put someone to sleep. This takes place during the recovery. So it's opposite of the point number 1 and 2. Okay. So concentration and second gas effect means nitrous increases its own concentration and concentration of co-administered gases. And Finck effect, diffusion hypoxia, is opposite of that during the recovery. And because it is causing hypoxia, so remember, whenever someone says hypoxia, what is the treatment? Treatment is going to be 100% oxygen for 3 to 5 minutes after extubation of the patient. After extubation of patient, right? So these are 3 properties seen only with nitrous, not seen with any other inhalation. Apart from that, what are the other points of nitrous? Remember, nitrous oxide is an agent which causes environmental pollution and it expands closed air spaces, right? Apart from that, nitrous oxide has a problem, and that is it causes nausea, vomiting, maximum. It causes vitamin B12 deficiency. Okay, so it can lead to vitamin B12 deficiency. That's why you get megaloblastic anemia. Okay, there can be peripheral neuropathy. All right, so, and apart from that, it is also teratogenic. So environmental pollution expands closed air spaces, nausea, vomiting. All right, vitamin B12 deficiency and teratogenic. So these become the side effects of nitrous oxide. All right, because it expands closed air spaces. Contraindication: not to be used in pneumothorax, pneumopericardium, right? Neurosurgery in case of an embolism. Also, it is not supposed to be used where? In ear surgery, ophthalmic surgery, especially vitreoretinal surgery. All right. Also, because it can expand closed air spaces, means any body cavity which contains air can be expanded. So therefore, any GIT surgery, laparoscopy, all these places, nitrous oxide remains contraindicated, volvulus and all. Okay. So remember, any GIT surgery, if there is volvulus, intestinal obstruction, anywhere, I'm not going to use nitrous. So remember, these become the contraindications to use of nitrous, where I will not use it. So pneumothorax, pneumomediastinum, neurosurgery, embolism, ear surgery, eye surgery, GIT, laparoscopy. All these become important contraindications where not to use nitrous. Let's go to the next one, halothane. So all of you are aware, if I have to discuss the side effects of halothane, all right, one of the basic problem with halothane is that it is the maximum metabolized drug out of all the inhalationals. Means inhalational would have gone to the respiratory and then out, but it goes to the liver, and because it goes to the liver, what can it cause? Hepatitis. Okay, so this is maximum metabolized drug, and because it also gets so much metabolized, it can cause hepatitis, and that's because of trifluoroacetic acid. It's also known to cause arrhythmias, right? Malignant hyperthermia. So these are the side effects. It is also causing uterine muscle relaxation, and therefore one of the side effects can be postpartum hemorrhage, right? It is a tocolytic agent, but that is one property which also helps it for what? As a drug of choice for manual removal of placenta. That's the only place where we can use halothane, right? If someone will say what is the drug of choice, only one place where you can use halothane, and that is manual removal of placenta. Rest, nowhere we use halothane anymore. It's out. Rest all are side effects. Whether you talk of hepatitis, whether you talk of arrhythmias, you speak of malignant hyperthermia, it causes the maximum malignant hyperthermia out of all the inhalational agents. Maximum out of all the inhalational. It's got the maximum trigger, all right? And uterine muscle relaxation also. That's the only reason why it can be used for manual removal of placenta. But you've got to remember that when you're using it for uterine muscle relaxation, it can cause postpartum hemorrhage. PPH can be caused, right? Apart from that, another good property which halothane had is that it is a sweet odor. So it can be used for pediatric patients, not preferred. It's also a bronchodilator, but not used. Okay, so ideally you will say, yeah, sweet odor, I can use it for a pediatric patient. Bronchodilator I can use for respiratory patient, but not preferred. I can use it, but not preferred to be used. When you speak of isoflurane, guys, remember, it maintains the cardiac output, right? It maintains the cardiac output, and therefore it's one of the best drugs for the cardiac system. So therefore it is supposed to be the drug of choice in CVS. So if someone says what is the drug of choice, so isoflurane is the one which we will use as drug of choice in the CVS ideally. Okay, apart from that, the only other place we can use it is liver transplant, because it maintains the hepatic blood flow. So these are the two places for isoflurane where you can use it, right? Coronary steel, rarely, it doesn't cause so much, but yes, this is the only thing which may be counted as one of the side effects. It can rarely cause coronary steel phenomena, but remember, it's rare. It's there, but it is very, very rare. Apart from that, it's one of the most common drugs used for maintenance of anesthesia, right? It is relatively stable in the CNS also, all right? So it is stable in the CNS and in the liver, because it maintains the blood supply in the liver also, in the CNS also. It causes the least increase in intracranial pressure. You can use it for CNS, but remember, the drug of choice is not going to be isoflurane for the CNS. It's going to be the drug of choice only for CVS. When you speak of desflurane, remember, if I have to discuss desflurane and where it can be used, so desflurane is the drug of choice ideally in a kidney patient, renal, in an obese patient, in an old patient, right? Kidney patient, renal patient, obese, old patient, and it can also be used for daycare surgery. Apart from that, if someone is in shock, okay, and you can remember it as ruse test. Okay, you can remember it as ruse test. Okay, so renal, obese, old, and shock, you can remember it as ruse test. This is the only place where desflurane is used. Now, desflurane is the least metabolized drug, all right, least metabolized drug. It has got no nephrotoxicity, that is why drug of choice in kidney patients. It causes sympathetic stimulation, that's why used in, a patient of shock. And environmental pollution, just like nitrous, is one of the side effects which it has. Okay, desflurane has this side effect of environmental pollution. But where will you use it? Renal, obese, old, and shock. Remember it as ruse test. So the important ones, forget halothane, it was only manual removal of placenta. Isoflurane is CVS and liver transplant. Correct? Desflurane in renal, obese, old, and shock. Remember ruse test. And sevoflurane is everywhere else. Everywhere else that you can now think of, the drug of choice is sevoflurane. So if someone will say where you use sevoflurane, so if someone is undergoing CNS procedure, I will use sevoflurane. Anything hepatic, I will use sevoflurane. Remember, sevoflurane is the best drug for a pediatric patient. It is the best drug for a respiratory patient. It is the best drug if a single agent is to be used, right, for intubation as well as muscle relaxation, right, for induction as well as intubation. So CNS, hepatic, pediatric, respi, everywhere you can use it except for one place. Then that is the side effect that it has. It can produce compound A with soda lime, and this compound A is nephrotoxic, and that is why the only place, right, where ideally we use desflurane is renal patient. Now talking about daycare surgery, where the biggest problem happens. So remember, both desflurane, yes, it can be used in daycare surgery. I am not denying that. Desflurane can be used in daycare surgery, but the best drug to use in daycare ideally becomes sevoflurane. Okay, sevoflurane. Fast onset, fast recovery, works like desflurane only. Now, you will find that this agent has got all the good properties. There is no hepatotoxicity, least increase in cerebral blood flow. It has got the maximum skeletal muscle relaxation. That is why used as a single agent or a sole agent, right? And the good properties is going to be, it is a bronchodilator, all right? It's a very, very sweet smelling drug and bronchodilator. So therefore, yes, that was the reason for a pediatric patient. That was the reason for a respiratory patient for it to be used. All right. Now, the last thing we'll mention over here in terms of these 4 important agents is desflurane. Out of all the agents, remember, the maximum bronchial irritation is seen with desflurane. Maximum bronchial or airway irritation is seen with desflurane out of all the agents, right? And that is why desflurane is not very commonly used for daycare also. Well, someone will say, why ideally books and lots of books have mentioned that desflurane is the drug of choice for daycare. Why am I saying sevo and not des? Because it is maximum bronchial irritant, and they say why to use it, better to use sevoflurane only for daycare. All right. Now, the last agent that you need to see here is xenon. Remember, xenon is said to be the most ideal anesthetic agent. It has no environmental pollution. The only side effect that it has is that it is expensive. It can increase airway resistance. Its properties are similar to nitrous oxide. Remember, its properties are similar to nitrous oxide. Thumbs up, guys. All okay till here? So we've discussed all the inhalationals. I've discussed all the drug of choice, actually, which they ask in exam. So hopefully you'll be able to answer that and with the points also. Yes, guys. Yes. Thumbs up, guys. So let's go forward to the intravenous anesthetics. We'll discuss the IV ones right now. When you speak of intravenous anesthetics, the pathway is different from the inhalationals because these drugs are going IV. So these drugs are given IV at a particular dose. The IV drug goes straight away to the brain. In the brain, it produces general anesthesia, right? The mechanism of action normally is the same thing as GABA, or for ketamine, it can be NMDA. That is only for ketamine, right? Only for ketamine NMDA receptor. Now, once the drug moves out of the brain, remember these drugs stay in the brain for 5 to 10 minutes and they are out of the brain. When they are moving out of the brain, do they go for metabolism, biotransformation, excretion, elimination? What is that? No. Therein comes the important question. Yes, guys, what is that thing called? When it moves out of the brain, what is it that happens? Yes, anyone? That is an important question, especially for INI-CET. They keep on repeating this question again and again. When the drug moves out of the brain, what has happened? Is it metabolism, excretion, elimination, biotransformation? It's none of that. It is redistribution. Redistribution to fat and muscle. Once it gets redistributed, that is the reason. Because of the redistribution, the concentration in the brain decreases. Therefore, the patient may become awake, patient may become aware, and that is why you need maintenance. Clear? That is why we need maintenance, and this means the patient become awake and aware, which means the anesthesia effect is over. Anesthesia effect is over, right? The patient has become awake, and after the redistribution to fat and muscle, yes, then it is going to go to the liver, where it undergoes metabolism. It goes to the kidney, where it undergoes excretion. Finally, there is clearance that takes place, and the drug is out of the body. That is the clearance. Okay, clear everyone? So remember here the important point is regarding the redistribution. So redistribution, remember, is what terminates the anesthesia effect of IV drug. It terminates the anesthesia effect of the intravenous drugs. Okay, and that is the reason why we give maintenance of anesthesia. Okay, that's why we will need to give maintenance, right? So the thing that finishes off the effect is redistribution. Remember. So let's talk about the individual agents. When you speak of thiopentone, so remember thiopentone is a good drug. Thiopentone is a good drug for two things: pentone, neuro and ophthal. Neuro and ophthal. So if you will say thiopentone, it can be a good drug for neuro and ophthal. This is the only place I can use it. But more than that, where thiopentone is used, all right, is basically for the treatment of raised intracranial pressure in the ICU. All right, it is used for what else? It can be used for treatment of status epilepticus and narcoanalysis. These are the basic uses. Actually, this drug was good for the brain, but ideally the point is, since we have propofol, it is not so often used. This drug is good for neuro and ophthal. It is good to be used there, but normally we use it for treatment of raised intracranial pressure in the ICU. It is used for status epilepticus and narcoanalysis. These are the three main reason. The point is, this drug is a very good cerebroprotective drug. It's an anticonvulsant agent. What is going to be the side effect? The side effect is basically pain on injection, right? It can cause thrombophlebitis, skin necrosis, because it has got a very, very high pH. So remember, the pH of this drug is 10.8 to 11, highly basic pH, and also it comes in a powder form. So it has to be reconstituted. So remember, a powder form can always precipitate. So therefore, these are the reasons why thio can precipitate anytime. Remember, it can precipitate anytime. It's a powder, it's got a high pH. So side effect is going to be pain on injection. There can be thrombophlebitis. It's such a high pH, right? Then, in case it goes into the artery, remember, it can form a precipitate. And that intra-arterial, if it's gone intra-arterial, it can cause vasospasm and gangrene. So, there was pain on injection, thrombophlebitis because of the high pH and powder form. The powder form can get precipitated in the artery, leading to vasospasm and gangrene. And in a vein, it can cause venous thrombosis. So therefore, artery we had vasospasm and gangrene, and in a vein, it can cause venous thrombosis. Remember that arterial gangrene is important, that question, that this comes many a times in the exam. The last thing is that it can cause is histamine release. It can also cause histamine release. And because it causes histamine release, guys, remember, it can cause bronchospasm or laryngospasm along with pruritus. Okay, so these are the important properties of thiopentone: bronchospasm, laryngospasm along with pruritus. That's thiopentone. All right, so the only use, remember, can be neuro and ophthal. It is good to be used, but we don't use it. Again, as I said, it's not preferred. It's good for use, but not preferred. Good for use in neuro and ophthal, but not preferred because of propofol being available. All right, propofol is that one magic drug which is used everywhere. Okay, it is one magic drug which is used everywhere. So I'll discuss the uses of propofol later. In like one part, we'll just discuss it out. Okay, so propofol, when you say, is just like thiopentone, as you can see, similar properties. Cerebroprotective, anticonvulsant, all the points are almost similar, right? Antiemetic. The point is, propofol is not a powder. The difference here, Propofol basically comes as an emulsion. Okay? It comes as a milky white emulsion. All of you are aware of that. Okay, it comes as a milky white emulsion. Now, milky white emulsion, it contains egg lecithin, glycerol and soybean oil. Egg lecithin, glycerol and soybean oil, because of which this becomes a good culture medium to grow E. coli and Pseudomonas, and therefore discard a open vial or used vial in how much time? Yes, anyone? In how much time do you discard it? Discard open vial within 6 hours. Okay, discard an open vial within 6 hours. Discard an open vial within 6 hours. All right, done. So this is one of the most important points. Being an emulsion, it is again painful. All right. So if we will say what are the side effects of propofol, it causes a painful injection because it is an emulsion. Apart from that, it can cause myoclonus and hiccups. Because it contains egg lecithin, glycerol, soybean oil, the side effect can be, if you're giving it for a long period of time, it can increase the lipids of a patient, it can increase triglycerides, it can even cause pancreatitis. And especially in a pediatric patient, if you give it for long duration of time, in that case, it can lead to propofol infusion syndrome. Propofol infusion syndrome, because there is so much fat getting involved, which is failure of free fatty acid metabolism. Clear? But this, remember, is seen more commonly in pediatric patients. Pediatric patients in the ICU. Why? Because it is the drug of choice for ICU sedation. It's the drug of choice for day-care surgery. Okay, it's most common used drug for routine induction and sedation. So most common drug. Another good point about propofol is that it gets metabolized 70% from the liver metabolism and 30% from the lungs. So it has got an extra hepatic source of metabolism. It's metabolized 70% from the liver and 30% from the lungs. All right. So it's got a fast and rapid metabolism and therefore used for daycare surgery. Clear? Talking about etomidate, I'll discuss about all the places where propofol is used in just a while. Okay, where all the places where propofol is used. Just give me 2 seconds. Now, talking about etomidate. Remember, etomidate is one of the drugs which is the best drug for a cardiac patient. So if someone says patient is cardiac patient, so in what drug will you use? I will use etomidate. It's a drug of choice for CVS. Also remember, in CVS, it's not alone etomidate. You can also use opioids. Apart from etomidate, remember, opioids are also considered drug of choice for CVS. Right? Many places you will find this, especially with low ejection fraction if there are patients. So here, remember, both opioids and etomidate are considered as drug of choice for CVS. Right? Etomidate is considered the most cardio-stable, but what are the side effects? The biggest side effect that etomidate has is that it causes adrenal suppression, right? Myoclonus and nausea vomiting. It causes maximum myoclonus and maximum nausea vomiting out of all the inhalational agents. Sorry, all the IV agents. Maximum. Okay. Then you have another drug called methohexitone. This methohexitone is just like thiopentone. All right. But as you can see, thiopentone is an anticonvulsant. On the other hand, methohexitone is like thiopentone, the same group, but it is proconvulsant. So this drug is used where this is ideally considered as the drug of choice for ECT in psychiatry. It is considered as a drug of choice for ECT in psychiatry. It also has side effects. Just like etomidate had adrenal suppression, myoclonus and nausea vomiting as the side effects which are there, it can also produce focal seizures that we'll mention. Similarly, methohexitone has a side effect of hypothalamus pituitary adrenal axis suppression. So here are the side effects of methohexitone. Okay, HPA axis suppression and nausea vomiting, just like etomidate. Etomidate has one more side effect, right? and that is this myoclonus, which is seen. You can also call it as focal seizures. So etomidate can produce focal seizures. Okay, so we are done with etomidate as well as methoxytone, both the drug of choice we have done. So till now, thiopentone could have been used for neuro and opthal, but we don't use it, don't prefer, right? It's used for treatment of raised intracranial pressure in the ICU, status epilepticus, and narcoanalysis. Propofol is everywhere, as I said, I'll discuss. Etomidate and opioids for CVS. Methoxytone is ECT. So where do we use ketamine? So when you have to talk about ketamine, so let me discuss now where is ketamine used and where is propofol used. So ketamine is opposite to propofol. Propofol, we said is one drug. So if I have to discuss the pharmacodynamic properties, so pharmacodynamic properties may, if you have to discuss CVS, RS, CNS, and opthal. So if I speak about thiopentone, it causes CVS depression. Yes, it causes RS depression. It is basically considered cerebroprotective, and it is also said to be anticonvulsant. Opthal, basically we will say it decreases intraocular pressure. Propofol is even more than thiopentone. The CVS depression is even more. The respiratory depression is even more. Cerebroprotective and anticonvulsant is similar to thio, and opthal properties are similar to thio, and that is why propofol is used in CVS and opthal patients. All right. Etomidate, on the other hand, is CVS stable. It causes respiratory depression. Here it can cause seizure. Opthal properties not needed. Ketamine is just opposite to all of them. All these drugs that we discussed are the ones which are working on the GABA receptor. Remember? And where does ketamine work? Another question. It's opposite to all of them. Remember, it works at the NMD receptor, and that is ketamine. Opposite. So look at propofol and just turn it upside down. You take propofol and turn it upside down, and that becomes ketamine. Okay. CNS also increase, intraocular pressure also increase. So in the CVS, it increases heart rate and BP. It increases oxygen demand. In respiratory, you can just say that it maintains respiration and it's a good bronchodilator. CNS increases everything. Intraocular pressure increases everything. It can even cause a seizure. Right? That's how you can remember now ketamine. So all the pharmacodynamic properties are basically done in just one small part. Right? So all the pharmacodynamic properties we finished here. All of them. Okay? Just based on this. Now, since what you know about ketamine, where is ketamine going to be used? It increases the CVS, RS, and CNS. So then it's a good bronchodilator. So therefore, if we get a respiratory patient with active bronchospasm, who has a bronchospasm right now, or if I get a patient with status asthmaticus, right? If I get a pediatric patient, if I get a patient in shock, or if I get a patient of shunt, all these places I will use ketamine. Apart from that, if I have to use ketamine, I can also use it for out of OT anesthesia. It maintains the respiration. I can use it for various kind of short procedures as well, because it is the only analgesic drug which we will just see. Okay, so for burn dressings it can be used. It can be used. It maintains the airway reflexes. It can be used for full stomach patients. Right? And ketamine also is very good antidepressant. Last year's INI-CET question. Right? And also uterotonic. Uterotonic property is there. Okay, it has a uterotonic property. So therefore it can be used for cesarean section in case you want to take care of the uterus as well. In LSCS can be used. If you have to use an IV agent, in LSCS it can be used. Right, apart from what we have mentioned, everywhere else it is propofol. Apart from what we have discussed, everywhere else. So if someone says daycare surgery, and if someone says a respiratory patient with no bronchospasm, someone says a liver patient, kidney patient, right? Someone says normal routine intubation, LMA insertion, routine induction, sedation, ICU sedation, right? Malignant hyperthermia, porphyria, anything that you mention, the answer is propofol. Propofol also has antiemetic properties, antipruritic properties, is also antioxidant. Clear? So all the ways you'll find propofol is to be one of the best drugs. Daycare surgery, respiratory patient with no bronchospasm, routine induction, routine sedation, ICU sedation, intubation, LMA insertion, malignant hypothermia, porphyria, you name it, the answer is propofol everywhere. CNS also, ophthal also, everywhere the answer is propofol. Okay, so therefore those are the places where you use ECT, methotrexate, CVS, opioids and etomidate. Respiratory, we've already discussed, divided into two parts between ketamine and propofol. Rest everywhere answer is propofol. So ketamine, remember, we have already discussed the choices, like where it is used, but it is an NMD receptor antagonist. It produces dissociative anesthesia. It is the only analgesic and a good bronchodilator, best bronchodilator out of all the IV agents. Used for active asthma. These are the uses which we discussed. These are the uses. It produces dissociative anesthesia. It divides thalamocortical, dissociation. But that is not considered as a very good effect. Yes, that is its effect. But if someone will say, is it a side effect? Yes, because it is the dissociative anesthesia which leads to the production of hallucinations and emergence delirium, which is not a good effect. So therefore, a lot of people have this confusion that it produces dissociative anesthesia. Then why is that called as a side effect? The dissociative anesthesia is called as a side effect because this emergence delirium that it produces, this emergence delirium and hallucination, the problem with it is that it is because of the dissociative anesthesia, since it produces dissociative anesthesia. And that is why dissociative anesthesia, yes, it's a property, but it can also be counted as a side effect, right? Apart from that, as I said, can be used in shock, right to left shunt, and full stomach patients. You already mentioned that. Also opposite to propofol. You saw this. Propofol was decreasing everything. Ketamine increases everything. So it increases all the pressures and secretions. And therefore, whenever you give ketamine to a patient, remember, because it increases secretions, therefore we always add atropine or glycopyrrolate. Okay, atropine or glycopyrrolate, and because of emergence delirium, therefore we add benzodiazepine to whenever we're giving ketamine. So ketamine is never given alone. Ketamine is combined with benzodiazepine and always with atropine or glycopyrrolate when it is given to the patient. Then we go to midazolam. Midazolam, remember, out of all the IV anesthetic drugs, this is the most common used benzodiazepine out of all the benzodiazepines. It produces anterograde amnesia. It's also anticonvulsant and cerebroprotective, not a painful injection, right? So remember, propofol had that problem of painful injection, right? Thiopentone was also painful. Etomidate is also a painful injection. Remember, this etomidate is also a painful injection. In fact, methotrexate is also said to be a painful injection. Remember, the only analgesic is ketamine. So therefore, when you speak of these drugs, most painful. So if they ask you about the painful injections, remember propofol is the most painful, similar to etomidate. Then you have methotrexate, then you have thiopentone, and finally we have ketamine, right? That's how we can remember it. Alright, so midazolam is the most common used benzodiazepine. It produces anterograde amnesia. Routinely, it's all stable. The only thing you need to remember here is that if you give an overdose, what is the antidote that you can use, right? Antidote, or if you want to reverse the side effects. Remember, for midazolam, that is flumazenil. Flumazenil is a benzodiazepine antagonist, and that is what can be used. Okay, so to reverse the side effects of midazolam, otherwise a safe drug. The last drug here in IV drugs, remember, alpha-2 agonist, clonidine and dexmedetomidine, they are used in anesthesia. Okay, they are used as adjuvant or co-induction agents. You have heard about these drugs as centrally acting antihypertensive drugs, right? So what are the uses in anesthesia? We use them as a pre-medication drug. We use them for ICU sedation, for hypotensive anesthesia, to reduce the blood pressure in OT. Apart from that, you can also use it as an additive to spinal anesthesia. It helps you to decrease the shivering in a patient, right? So therefore, these are the important properties of clonidine and dexmedetomidine, right? Used as a pre-medication, ICU sedation, hypotensive anesthesia, because you already know it as centrally acting antihypertensive drug. Okay, so they are decreasing. So these are all the uses. Now, one more point which was asked last year, and that is, no, not last year, November INI-CET exam, and that is, you must have heard of a drug called haloperidol. Remember, antipsychotics are also used in anesthesia. Antipsychotics. There are two of them which can be used. One is haloperidol and droperidol. Now, haloperidol, guys, normally is used for ICU psychosis. Droperidol, guys, has two uses because of its property. One is it has a good sedative effect, and other thing, it's a good antiemetic. So therefore, it can be used for post-operative nausea, vomiting, and because it produces sedation, I can use it for anesthesia that's called neurolept anesthesia. What was last year's question? Last year's question was, when you use haloperidol, remember, it causes a side effect, right? And that is called neuroleptic malignant syndrome. Neuroleptic malignant, that's not malignant hypothermia. It's almost similar to that, but it is called neuroleptic malignant syndrome, NMS. Okay, it's called NMS, neuroleptic malignant syndrome. And here the treatment, you can also use dantrolene, and that was the question last year. Clear, guys? Thumbs up. I think we thumbs up in there. All okay, everyone? I can see people around, but hopefully. Let's go to the next group of drugs. So remember, this IV drugs was important. Then we straight away go to muscle relaxants. Now, in muscle relaxants, when we are discussing, we are not going to see the mechanism too much in detail, but where the questions are asked and concentrated is what we are seeing. Everyone okay? All right. So when we are discussing the skeletal muscle relaxants, guys, remember, skeletal muscle relaxants are working where? So these drugs, skeletal muscle relaxants, are working at the neuromuscular junction at the nicotinic receptor. They are working at the nicotinic receptor, which are cholinergic, acetylcholine. All right. So they are working over there. These drugs are going to block the neuromuscular junction because they are going to cause muscle paralysis. So skeletal muscle laxants are going to cause skeletal muscle paralysis. All right, they're going to cause skeletal muscle paralysis. They are going to prevent a muscle contraction. They prevent a muscle contraction. All right, and all of you know that contraction takes place at neuromuscular junction. So therefore, these drugs are working at the neuromuscular junction at the nicotinic receptor. Now, we divide them into two types. One is depolarizing and other is non-depolarizing. So remember, depolarizing agents are going to be like acetylcholine. Means they will work like acetylcholine, similar to acetylcholine. So if they work similar to acetylcholine, they are going to cause depolarization, and that is the mechanism of action. So remember, these drugs, depolarizing agents, remember, are going to cause depolarization, and after the depolarization, then muscle paralysis. Right? They are going to work like acetylcholine. On the other hand, so I got one response from Dr. Sandeep. Okay, got it. Thank you. All right. Thank you, guys. Now, speaking about non-depolarizing, as the name suggests, they are competing with acetylcholine for the sites. Okay, so is it working like acetylcholine? No, they are opposite to acetylcholine. So therefore, they cause no depolarization. That means straight away muscle paralysis. That means straight away muscle paralysis. Straight away muscle paralysis. So now, if I have to discuss the properties, then the depolarizing agents, because they work like acetylcholine, they are similar to acetylcholine. So therefore, they are agonist or antagonist at the receptor. As you can see, they are agonist at the receptor. So these drugs that we see, they are agonist at the receptor. They work like acetylcholine, right? These non-depolarizing drugs, they are not like acetylcholine. So they work as antagonist at the receptor, right? The depolarizing agents, because they are similar to acetylcholine, they work like acetylcholine. Are they fighting acetylcholine? No, they are not fighting. Therefore, these become non-competitive in nature. Okay? On the other hand, when you speak of non-depolarizing drugs, they are competitive. They are competitive to acetylcholine. All right, and that's why the only depolarizing drug that we know is just one drug called succinylcholine. It sounds like acetylcholine. On the other hand, every other drug, vecuronium, atracurium, mivacurium, pancuronium, everything is non-depolarizing. Everything else is non-depolarizing. All right, everything else is non-depolarizing. Now, what is the mechanism of action? So these drugs, which are succinylcholine, it works like acetylcholine, but remember what it does is it works like acetylcholine, but it's a partial agonist at the receptor. So it does half the work of acetylcholine. It goes at the receptor, it causes a depolarization, as we can see. And after the depolarization, whenever it causes a depolarization, remember there's going to be muscle movement. Depolarization also always causes a muscle movement, which is called fasciculation. So therefore, you get fasciculation with succinylcholine because here is no depolarization. So there is no muscle movement, and that's why you get no fasciculation with vecuronium. All right. So it causes depolarization. It works as an agonist, non-competitive in nature. It causes depolarization, and after the depolarization, what happens? It leads to a persistent depolarization. It doesn't go away. It stays at the receptor. Because it stays at the receptor, it causes persistent depolarization because it stays at the receptor. That is the mechanism of action. It stays at the receptor and does not go away till the time it is sitting at the acetylcholine goes away immediately. So that's why the receptor becomes empty. But this works half like acetylcholine. It sits at the receptor. It causes persistent depolarization, doesn't go away. Therefore, till the time it is sitting at the receptor, it causes depolarization. Till then, muscles are paralyzed. Till then, muscles remain paralyzed because it is sitting at the receptor. It doesn't go away. It is causing persistent depolarization. And who destroys it? It is plasma cholinesterase that destroys succinylcholine after 5 to 8 minutes. That becomes the duration of action, and hence it is called the shortest acting muscle relaxant. Okay. On the other hand, when we speak, so all the points here are exam questions. It causes depolarization. It causes fasciculation for succinylcholine. It's a partial agonist, non-competitive. It causes persistent depolarization, and plasma cholinesterase destroys succinylcholine. Right. On the other hand, when you speak of vecuronium, vecuronium is competitive. Competitive to what? It is competitive to acetylcholine. Means whosoever is strong gets to sit on the receptor. If vecuronium was strong than acetylcholine, then vecuronium sits at the receptor. If acetylcholine becomes stronger than vecuronium, it will sit at the receptor. That is the meaning of competitive. Non-competitive was it was not fighting. But vecuronium is going to fight with acetylcholine. It's antagonist. So once it sits at the receptor, it is antagonist, no depolarization. So therefore, because there is no depolarization, therefore point number 4, there is straight away paralysis. Once it is there at the receptor, once you give vecuronium at the receptor in a good quantity, straight away it is muscle paralysis. There is no depolarization, hence it is called as non-depolarizing. Right? Until the time it sits at the receptor, there is muscle paralysis. Till the time it's there at the receptor, it causes muscle paralysis. But if you want to take it away, who destroys it? No one. But what will you do? You can increase acetylcholine. Remember, if you want to throw vecuronium away, I can use this property of increasing acetylcholine. If I can increase acetylcholine, then vecuronium will be thrown away. How can you use increase acetylcholine? Remember, it's competitive in nature. So for that, what I can do is I can give the patient neostigmine. What neostigmine does is, neostigmine is an anticholinesterase. It blocks acetylcholinesterase. Acetylcholinesterase is the one which was destroying acetylcholine. So therefore, Because it blocks acetylcholinesterase, it increases acetylcholine, and at one point acetylcholine becomes more than vecuronium. Remember, that is what is called as reversal. Okay, so therefore this is what is called as reversal. When you give neostigmine to a patient, you are increasing acetylcholine, and the acetylcholine becomes more than vecuronium, and it is thrown away. And these are all the points which gets asked in the exam, and these are the difference between them. Thumbs up, guys. All okay? All okay, everyone? So all the points we've discussed. If there's any doubt, please ask me, guys. If there's any doubt that you want me to clear, let me know. Okay, otherwise this is what we had thought of covering up. Okay, no doubts. Hopefully understood all the points over here. Okay, so let's go forward. All right. So talking about succinylcholine. When we speak about succinylcholine, remember succinylcholine is a depolarizing muscle relaxant, right? It's a depolarizing, means it causes depolarization or some muscle movement. So it has some side effects that you can see. Before we go to side effects, remember it is the shortest acting muscle relaxant. It works between 5 to 8 minutes. Not just the shortest acting, it's also the fastest acting muscle relaxant. Okay. So fastest acting means it works within 30 to 60 seconds. All right. I'm discussing more what are going to be the side effects of succinylcholine. The first thing is can be a prolonged block. It can cause a prolonged block. Routinely it is only 5 to 8 minutes. Na? Why 5 to 8 minutes? Because it gets destroyed by plasma cholinesterase in 5 to 8 minutes. That is why it is shortest acting. But what if someone has a deficiency? So therefore you can get a prolonged block, which can happen in plasma cholinesterase deficiency. It can happen with atypical plasma cholinesterase, and it can also happen in case of a high dose of succinylcholine if it is given, high doses, right? And this prolonged block can also be called as a phase 2 block or a dual block. Now there's no other treatment for this condition apart from IPPV. The only treatment of this condition is IPPV. The only treatment of this condition is IPPV. Okay. Now the second thing is, right, second thing, when depolarization takes place, sodium goes inside, potassium goes outside. So when potassium goes outside, there are chances of it causing hyperkalemia. It can increase potassium, and this potassium specifically can be increased a patient who's already got hyperkalemia, right? So in that patient becomes dangerous because it's going to increase potassium. So in a patient of hyperkalemia, it becomes difficult to use succinylcholine. Someone has burns, more potassium, chances are very high that in a patient of renal failure, that is a big problem, right? So all these conditions, burn, renal failure, neuromuscular disorder, a nerve disorder, patient of spine injury, massive trauma, all these are places where we can get high potassium, very high potassium in the patient. So you have to be careful. Hyperkalemia, right? The next thing is it can increase all the pressures, intraocular pressure, intracranial pressure. It also increases intragastric pressure, right? It can cause fasciculations. Those fasciculations can cause myalgia and myoglobinuria. Damage to the muscles, right? So it has increased the potassium, okay? It has caused fasciculation. It has increased the pressures, intraocular, intracranial pressure, right? Intragastric pressure. It can also cause allergic reactions and anaphylaxis. And the last is in the cardiac system, remember, it can cause bradycardia and arrhythmias, leading to arrest, especially in pediatric patient. Especially in pediatric patients. Clear? So that is succinylcholine. These are all the side effects. And it's last point, malignant hyperthermia. And the last point is malignant hyperthermia trigger. So therefore, the same thing would become the side contraindication. A patient of atypical plasma cholinesterase or plasma cholinesterase deficiency side is a contraindication. Correct? All these patients of hyperkalemia, burns, brain, all these become contraindication. Intraocular pressure, intracranial pressure, all this becomes contraindication, right? Malignant hyperthermia is a contraindication. So these are the contraindications of. Hello, sir. Thank you, sir. Thank you. Dr. Prasanna is around. Thank you, sir. Thank you so much. Dr. Prasanna was there. So I just said thanks. Thank you, sir. Okay. So malignant hyperthermia is a contraindication. Okay. Next we go to non-depolarizing agents. So when you speak of non-depolarizing agent, guys, we divide them into two types: aminosteroids and benzyl isoquinoline compound. So aminosteroid compounds, guys, are the ones which have onium written behind them. Always remember this part. And benzyl isoquinoline compounds are the ones which have curium written behind them. Curium. All right. So when we speak of aminosteroid compounds, guys, so remember pancuronium, pipecuronium, vecuronium, and rocuronium. So out of this, pancuronium is basically long acting, and pipecuronium, both of them are long acting. Okay, so I'll just give me a second. I'll write that separately later on. So these are all the onium compounds. Right, pancuronium has one point. It can increase the heart rate, it can increase the blood pressure, it can also cause arrhythmias. Pipecuronium is not needed so much to be known. These are the long acting. These are long acting. Vecuronium and rocuronium, both of them are basically intermediate acting. These two are intermediate acting. So long acting and intermediate acting. So when you speak of vecuronium, guys, remember vecuronium is the most common used. It's the most cardiovascular stable drug. Most cardiovascular stable. Rocuronium, remember, it has the fastest onset of action. It is painful. It is painful and it can increase the heart rate. Right? These are intermediate acting. Then we speak of benzyl isoquinoline compounds, where you have doxycurium, and doxycurium basically it causes maximum histamine release. This is long acting. Okay, this is again long acting. Atracurium and cisatracurium are both counted as intermediate acting, and mivacurium is said to be short acting. Now, atracurium, the biggest point is that 1/3 of atracurium undergoes Hoffman's elimination, which is non-enzymatic Hoffman's elimination, which is non-enzymatic, all right, and non-organ dependent degradation. It melts like ice. You take ice in your hand. What happened? Ice melts because of temperature. That's exactly what is atracurium's Hoffman's elimination. You keep it on as soon as you give it to the patient. Based on temperature and pH, it gets degraded. Temperature and pH based degradation. That is what is called Hoffman's elimination. Okay, it gets destroyed on its own, Hoffman's. The remaining 2/3 undergoes ester hydrolysis, right? And then it can, all these things can lead to formation of a metabolite which is called ludanosine, which can cause seizures, right? Which can cause seizures, and it can also cause histamine release, leading to decrease in blood pressure. And histamine release, which can decrease blood pressure. So therefore, they made a new drug. Atracurium was all good, huh? Very good. Hoffman's elimination means I don't need to give neostigmine. See, the problem with neostigmine is that it is going to increase acetylcholine everywhere in the body. So we don't want to play with acetylcholine so much. That's why they say this is a very good property, that in case we are using Hoffman's elimination, we give atracurium, I don't need to give a reversal to the patient, right? The problem was the production of seizures because of the metabolite and the histamine release leading to hypotension. So they said, let's make cisatracurium. Cisatracurium has the same properties like atra. It is just like atracurium. It is like atracurium, but it has less incidence of seizures, since it decreases the production of the metabolite ludanosine, and it has no histamine release. Therefore, it's a better drug than atracurium. So remember, cisatracurium is said to be a better drug than atracurium. Okay, the last drug here is mivacurium. Remember, it's the shortest acting. Mivacurium is called the shortest acting non-depolarizing muscle relaxant. Remember, here we had doxycurium. So doxycurium was the longest acting, right? The shortest is mivacurium. it gets metabolized by plasma cholinesterase. Remember the same thing which metabolizes succinylcholine, right? Therefore, this will also need no reversal. Only problem here is histamine release. Only problem here is histamine release. All right. So therefore, we don't need a reversal here also. So if I have to see which are the drugs that don't need a reversal, right? So if I have to see which are the drugs that don't need a reversal, no reversal with neostigmine. Okay. So no reversal with neostigmine. So one we will get atracurium, cis-atracurium because of the Hoffman's elimination. Non-enzymatic, non-organ dependent. Okay. So remember, this is non-enzymatic, non-organ dependent, temperature and pH based degradation. Second, succinylcholine and mivacurium. These two get metabolized by plasma cholinesterase. Third one is rocuronium. It has a special reversal agent, and that special reversal agent is called Sugamadex. Okay, Sugamadex. This question has been asked. So Sugamadex is a special reversal agent, chelating agent. It encapsulates, binds it, and takes it away. This is used for a fast reversal. It's like a chelating agent or binding agent. All right. It causes a fast reversal. All right. And remember, Sugamadex can be used for rocuronium. It can also be used for vecuronium and for even pancuronium. Right. So we've discussed atra, cis-atra, succinylcholine, miva, rocuronium. There's another drug which is still under research, and that is gantacurium. This has not been asked in exam, but you need to know. Here also you'll need no reversal. The reversal agent for this is amino acid L-cysteine. Okay. So it needs no reversal. So these are the drugs that don't need a reversal. All right. So atra, cis-atra, succinylcholine, miva, roc, and gantacurium. So I think we have discussed all the points here for all the questions. Any questions and doubts, guys, please ask me. Otherwise, we go to the neuromuscular monitor. All right. So when we are discussing the neuromuscular monitor, I think all of you are already aware this image comes very often in the exam. Right? So most of the drugs we've already finished. Okay. So when you speak of neuromuscular monitor, what you're doing is trying to monitor the neuromuscular junction. I'm monitoring the neuromuscular junction, the neuromuscular transmission, or the neuromuscular function of the patient, right? I'm basically trying to monitor the muscle paralysis. So neuromuscular would mean I'm going to look at one nerve and I'm going to look at one muscle. So there's going to be one nerve and one muscle. Okay. So which is the most common site? So remember, the most common site used is the ulnar nerve and the adductor pollicis muscle. The most common site used is the ulnar nerve and the adductor pollicis muscle. But they say the most ideal is the facial nerve and the orbicularis oculi muscle, right? So this is what you do. The most common mode used is the train of 4. The most common mode used is the train of 4, right? What is the train of 4 mode? We give 4 stimuli, each of 2 hertz in a span of 2 seconds. Okay. Train of 4. So train of 4 mode is basically 1, 2, 3, 4. What we have done is we have given 4 stimuli, each of 2 hertz in a span of 2 seconds. If there is no block and no paralysis, this is what you get, right? When there is a block, partial paralysis with a depolarizing, here you will get same height, decrease amplitude, same height, decrease amplitude. This is in succinylcholine phase 1, right? Non-depolarizing, I get to see fade. Fade means it is going down like this, right? Instead of 1, 2, 3, 4, which would have come, I'm going to get 1, 2, 3, 4. This is what is called fade. It is fading down. It is going down this way. Remember, the same fade is also seen in succinylcholine phase 2 block. The same fade is also seen in succinylcholine phase 2 block. If you remember, this was a phase 2 block we discussed. Prolonged block, dual block in plasma cholinesterase deficiency, atypical plasma cholinesterase. So here what we get is a fade in phase 2 block. So this is what you need to know on the neuromuscular monitor. All right. Apart from that, there are various kinds of stimuli. It's not just this strain of 4. I can give various other stimuli, single stimulus, double burst. Then there is tetany. Tetany is like this, tetany. So this is around 50 hertz, which you give for tetany, and there is post-tetanic count. So various types of stimuli there. Out of that, the most common is strain of 4. Now, all right, let's go to the last part here, and that is reversal agent. When we give neostigmine to a patient, I just said that it blocks acetylcholinesterase enzyme, and the point was normally acetylcholine was going into synaptic vesicle, getting destroyed by this acetylcholinesterase enzyme. So when you give neostigmine and block acetylcholinesterase, you are increasing acetylcholine. The increase of acetylcholine at the nicotinic receptor, it causes the reversal of the muscle block, which we just saw. But it also increases at the muscarinic receptor, which is going to lead to muscarinic side effects. What to do then? Therefore, we add atropine or glycopyrrolate, last year's question. So atropine and glycopyrrolate are added not for the reversal of muscle block. They are added to take care of the muscarinic side effects. Remember this. Okay. Atropine and glycopyrrolate is added to neostigmine to take care of the muscarinic side effects. Okay. Let's go to local anesthetics. When we discuss local anesthesia, guys, remember local anesthetics are basically working where? When you give local anesthesia, these drugs are working at the nerve. So remember, general anesthesia, we said, is working at the brain. We just mentioned that. It's working at that GABA receptors, right? Because it was working at the brain, patient is unconscious. What about local? When you speak of local anesthesia or regional anesthesia, this is working at the nerve. So therefore, general anesthesia is basically working at the central nervous system, and this is working at the peripheral nervous system, right? It works at the nerve, and basically the patient remains conscious. So therefore, mechanism of action. What do? They are working at the nerve. Local anesthetics work at the nerve or the nerve fiber. Local anesthetics are working at the nerve or the nerve fiber. They are working at the peripheral nervous system. Basically, they are going to work, they're going to prevent the conduction of impulse that is taking place. This conduction that was taking place, they're going to prevent that. How come? What happens is, local anesthesia drugs, being lipid soluble, they penetrate the cell, and from the intracellular side they block the sodium channel, which are on the nodes of Ranvier. So therefore, these local anesthetic drugs, basically what they do, they go inside the cell, the mechanism of action. So they bind to the intracellular side of the sodium channel. So they are working on the sodium channel. They are working on the nodes of Ranvier. They are working on the nodes of Ranvier. They penetrate the sodium channel, go to the intracellular slide, and they block it from within. Because they block from within, now sodium can't enter, because of which the sodium can't enter, as you can see, because the sodium can't enter now, and that is the reason why they block the action potential from going forward. They block the nerve conduction. That is the mechanism of action. They are working at the nerve fiber, at the peripheral nervous system, nodes of Ranvier, right? They bind, they go intracellular, go inside and block the sodium channel from within, and they prevent the action potential or the movement of the nerve conduction that is taking place. Now, speaking about the drug properties. So this is the mechanism of action of the local anesthesia drugs. Specifically speaking about the properties. So there are few properties that we need to know. So when you're discussing the properties, the first thing is that these drugs are weak bases. So they'll work in which medium? Weak bases are going to work in which medium? So when we discuss these drug properties, remember, they're going to have a better effect in basic medium. Therefore, we add soda bicarb. Local anesthetic, remember, these drugs are weak bases. These drugs are weak bases, so they are going to have a better effect in basic medium. By addition of soda bicarb, I'm making the drug more basic. So basic drug going in basic medium, you get a better effect, right? It decreases the subcutaneous pain to the patient. It also leads to a faster onset of action. and less subcutaneous pain. So this property is based on the pH, right? The second, what you can do is all these drugs have local vasodilator activity. Therefore, what we can do is we can add vasoconstrictor. We can add phenylephrine, or we can use adrenaline. By addition of phenylephrine and adrenaline, I am going to decrease the systemic absorption of the drug. Therefore, more action takes place at the nerve, and this would lead to better action, longer duration, and also because systemic absorption is less, you get less toxicity, right? And that's why it's better to add adrenaline and phenylephrine, but it can't be used in some places because it is a vasoconstrictor. It's contraindicated in end arteries, which is finger, toes, ear, nose, and penis, right? Not to be used in 4 or 5 places. Rest we can use it everywhere. It's a good drug overall, right? So we can add soda bicarb, we can add phenylephrine. This can be done. Then remember, when you speak of these local anesthesia drugs, there can be various other additives that I can use, okay, apart from soda bicarb and phenylephrine. And that is, sometimes there is preservative present. There is preservative present, methyl paraben. I can also combine it with some anesthesia drugs. The anesthesia drugs that can be present, we can use our opioids, we can use ketamine, we can use midazolam, all right, alpha-2 agonist, as I just said. Dextrose is present for spinal anesthesia. Dextrose is present for spinal anesthesia drugs. It has been added. Plus, for various surface creams, there can be lot of things which can be added. You can add antiviral, antibacterial drugs, antibacterial, antiviral. There can be steroids. 2 local anesthetics can be combined. So in creams, we have a lot of combinations we can do, right? But otherwise, we use soda bicarb, phenylephrine for the injectable drugs, preservative, combination of anesthesia drugs, and dextrose. Okay, so antibacterial, antiviral drugs are used, also antifungal. You get combination of these creams. So not going to details of that, but hopefully the points are okay till here. Okay, so next that we discuss is that regarding the pharmacokinetics. Okay, so when we discuss the pharmacokinetics, absorption takes place in the blood vessel, systemic absorption, right? And this can lead to the side effect also. And this would go for metabolism, and it is also going to the CVS and CNS. So basically what happens, the systemic absorption of the drug goes to the liver, which goes for metabolism, and in the CVS and CNS, which can cause toxicity of the drug, which we just saw, right? So in case you inject a drug directly in the blood vessel, straight away it is going to cause toxicity. So when you speak of local anesthesia systemic toxicity, remember the CNS symptoms take place before the CVS symptoms. Important point. Local anesthesia systemic toxicity, the CNS symptoms take place before the CVS symptoms, right? And what are the CNS symptoms? The common one that you see is a convulsion. Yes, other things are also there, but the commonest thing that we are going to see is a convulsion, right? While in CVS, what we get is arrhythmia. All right, so arrhythmias come after the convulsion. So if you have to see the side effect profile, the initially things that you're getting are all the CNS things, and after that is when you get the CVS. So CNS occurs first, CVS occurs later. So what is the treatment? All right, what is the treatment? Remember, of course, because there are going to be arrhythmias and convulsions, so you're going to use antiarrhythmics. All right, I'm going to use anticonvulsants. I'm going to use oxygen. I have to do CPR, ACLS, all these points are going to be done. But the most important is used of intralipid. Intralipid, guys, is a new thing. It's a new treatment or for the toxicity of local anesthesia drugs. Intralipid is the same one which is used for total parenteral nutrition. We use it because of something called as a lipid sink theory. It's a lipid. See, these drugs, if you just saw a while back, were lipid soluble, right? The local anesthesia drugs are lipid soluble. They're soluble in the lipid. And that's why if you give intralipid and you've caused an overdose of local anesthesia drug, it will absorb it. And that's what is called as a lipid sink theory, since local anesthesia drugs are lipid soluble. Okay, since local anesthesia drugs are lipid soluble, so that lipid sink theory is where it creates a sink where all the lipid drugs are involved. And this is specifically true for bupivacaine toxicity. This intralipid is especially for bupivacaine toxicity. Remember this point. Okay, so this is toxicity of the local anesthesia drugs. Why are we so worried about the arrhythmia part? Because guys, remember, arrhythmias normally are irreversible. See, convulsions in this patient can be reversed. We are not worried. This is reversible. But arrhythmias normally are irreversible. And that is why it's a problem. Okay. Let's talk about the metabolism. So I just discussed with you that when we are giving the drug to the patient and absorption takes place in the blood vessel, it can go to the liver for metabolism and into the CVS and CNS for toxicity. Talking about metabolism. So when we speak of metabolism, so when you speak about this metabolism, it depends on the structure. Okay. So metabolism of the local anesthetic depends on the structure. Depends on the structure. So the structure is that it has the aromatic ring, intermediate chain, and amide part. So if the intermediate chain is ester, so those drugs are called amino ester. Amino ester. If the intermediate chain is amide, the lung drugs are called amino amides. So when you speak of amino esters, all the drugs with single I are amino esters, all the drugs with double I are amino amides. So drugs like cocaine, procaine, chloroprocaine, tetracaine, all these drugs with single I are amino esters. Double I, lignocaine, bupivacaine, ropivacaine, these are amino amides. All the amino esters get metabolized in the plasma by plasma cholinesterase, except for cocaine. Except for cocaine. So remember, cocaine is what gets metabolized in the liver. Cocaine has one more point, that cocaine, remember, all these drugs were vasodilators, right? That's why we added phenylephrine or adrenaline. Cocaine is a vasoconstrictor. Okay, cocaine, remember, is a vasoconstrictor. Rest all are vasodilators, right? So when you're discussing the properties, why was the problem with this? Why did we add epinephrine, adrenaline or phenylephrine? Because local anesthetics are vasodilators, except for cocaine, which is a vasoconstrictor. Okay, so that's the reason. Now, so we've discussed about cocaine, procaine, chloroprocaine, tetracaine. They are all metabolized in the plasma, right? Except for cocaine that gets metabolized in the liver. Okay. What about the other drugs, lignocaine, bupivacaine, and all these drugs which were there? They are getting metabolized in the liver. They get metabolized in the liver by liver enzymes. Therefore, you have to be careful, not avoid it, but you have to decrease the dose in a liver dysfunction. If someone has a poor liver function, remember these amino amide drugs, you are supposed to give a lower dose, but try to avoid them in a poor liver function because they get metabolized in the liver. All right. Clear? So this is about the local anesthesia, metabolism, and the last part is then excretion. Since we're discussing the pharmacodynamics, the excretion takes place from the kidneys. So we discussed the metabolism based on the structure. It gets metabolized in plasma or the liver. Next part, when we classify these local anesthesia drugs, we classify them basically in two types: injectable and surface. Surface local anesthesia drugs are ones which are used for various creams and all. Okay, so here remember, lignocaine, they are divided into two types: soluble, right? We divide them into soluble and insoluble. We divide them into soluble and insoluble. The soluble are cocaine, lignocaine, tetracaine, proparacaine. Remember, this proparacaine has been asked. This proparacaine is what is used in ophthalmic surgery, cataract, right? Proparacaine is used in ophthalmic surgery. It starts to work immediately within 5 to 10 seconds, works for 15 to 20 minutes. All right. Then we have lignocaine. Lignocaine again is very commonly used. It is commonly used for various creams, gels, jelly. All of us have used it for Foley's catheterization. It's a commonly used one. Then you have benzocaine. When you speak of benzocaine, this is used for various oral ulcer gels, oral ulcer cream, right? And you have oxetacane, which is used for antacids. Oxetacane, this is used for antacids or suspension gels. Suspension gel antacids. Antacid gel. Suspension. Okay, so these are surface. They are surface local anesthesia drugs. There's also butylamine benzoate. You just need to know the names and one small point over here. Then we discuss about the injectable ones. When you discuss the injectable ones, we can classify them into three types. That is less potent, short duration, less toxic. Second is intermediate potent and duration, intermediate toxic. Highly potent, long duration, these are highly toxic. So remember, procaine and chloroprocaine are the short acting ones which you see, where you find chloroprocaine is the shortest acting and the fastest acting, right? Lignocaine and prilocaine. So therefore lignocaine, this is the most common used. Remember, the maximum dose of lignocaine which we can use of lignocaine, maximum dose of lignocaine is around 4 to 5 milligram per kg, and that of lignocaine plus adrenaline is up to 7 milligram per kg. All right, so that is lignocaine. It can be used in various concentrations. Remember, you have 0.5%, you have 1% lignocaine, 2%, 2.5%. There is 3% available, 4% available, 5%, 10%, and 15%. You see, right from 0.5 to 15, these are the various concentrations of lignocaine available that is used. 0.5, 1, 2. Remember, injectable ones are between 0.5 to 4% normally. 0.5% to 2% normally are injectable ones. The rest all are surface anesthesia drugs, routinely. Okay, so that's about lignocaine. And remember, lignocaine can also be used IV. What are the IV uses of lignocaine? Yes, lignocaine is local anesthetic but used IV. All of you also know it as antiarrhythmic, class 1B. Antiarrhythmic. It decreases the pain of propofol injection. Intravenous regional anesthesia and decreases intubation response. Clear? That's about lignocaine. Now, prilocaine is used in EMLA cream, which we will just discuss now. Highly potent drugs and long duration. So here we discussed lignocaine, we have discussed chloroprocaine, here we discussed lignocaine, which is same as lidocaine. Talking about bupivacaine and ropivacaine, dibucaine. Remember, dibucaine, this is the longest acting, okay, longest acting local anesthetic. Talking about bupivacaine, remember, bupivacaine is the most cardiotoxic local anesthesia drug, okay, bupivacaine, and therefore it is contraindicated for any IV use. Don't use it IV at all. Bupivacaine is available at 0.5% and 0.25%. 0.25% and 0.5%. So 0.25% provides a sensory block, 0.5 is sensory plus motor both. So if I want to use just for pain relief, I can use this 0.525. If I want motor and sensory both or anesthesia, I will use 0.5. Can you see this? There's a difference between them. A 0.25 is helpful for sensory, 0.5 is helpful for sensory motor both. This is called differential block. All right. Now the point is, being most cardiotoxic, this is the place where you get arrhythmias. Therefore, this is where the treatment of toxicity of bupivacaine is where we use intralipid. Remember that intralipid that I discussed before, that 20% intralipid is used for bupivacaine toxicity. And the second thing that we can also use is small doses of adrenaline. Okay, so that the heart does not stop, because CVS is, if the CVS gets stopped, how will you give any drug there? The heart does not need to be, you have to be careful that the heart does not stop because it becomes irreversible. The serious complications. Okay, so that's about the local anesthetic. Speaking about malignant hyperthermia, one of the most important questions which comes. Okay, so we've discussed the local anesthetic drugs also, all of them. And ropivacaine. One drug we did not discuss is ropivacaine. Let me finish off that. That's what I was thinking. Ropivacaine. Ropivacaine is a S enantiomer of bupivacaine. So it's a mirror image. It's a mirror image of bupivacaine. So you have made it less cardiotoxic. So therefore, slightly potency also goes less. So this has a good sensory block, but compared to bupivacaine, it has little less motor block. Okay, compared to bupivacaine, less motor block. Talking about malignant hyperthermia, important, very, very important question. It's a genetic disorder basically. It's a genetic disorder already present in the gene of sarcoplasmic reticulum. So sarcoplasmic reticulum is present in muscles. So it becomes a disorder of the muscles also, right? And in that muscle, sarcoplasmic reticulum, it has a ryanodine receptor gene abnormality, which is a calcium release channel. So it's a disorder of the calcium channel. Does it happen in everyone? No, it happens only when a patient gets exposed to the inhalational agent. Okay, inhalational agent means if a patient is getting exposed to isoflurane, sevoflurane. Remember, maximum is halothane. Maximum is seen with halothane, but it can happen with all the inhalationals, whether it is isoflurane, sevoflurane, even with succinylcholine as well as lignocaine. So in this case, what happens is if you give these drugs to the patient, when the patient comes in the OT, suddenly a calcium gets released. There is a release of calcium that takes place, and the release of calcium suddenly causes sustained muscle contraction and breakdown of the muscles, for which you get all the side effects. So therefore, what happens is when you give these drugs like halothane, succinylcholine, or even lignocaine, remember, even lignocaine can cause malignant hyperthermia. So when you give these drugs to the patient who has the genetic abnormality, in this patient suddenly there is increased calcium release, right? This increases this causes also the muscles get involved. There is increased calcium release that takes place. This increases the metabolism, right? And the muscles get rigid. So there is muscle rigidity, as we just saw. All the side effects are because of all this. All the problems are because of this. The calcium release can cause arrhythmias because it changes the electrolyte imbalance. The increased metabolism increases the carbon dioxide production. It increases the temperature. And because muscles are getting damaged, it can cause muscle rigidity and myoglobinuria. And this is seen in the patient. All this will lead to acidosis, renal failure, and death of the patient. Treatment, only one thing. There's only one thing. All of you already know it, right? I don't have to say that. All of you are already aware. The only treatment of this condition is dantrolene. Okay. The only treatment of this condition is dantrolene sodium. So dantrolene sodium is the only treatment. And in case this patient comes in for surgery, then dantrolene is not treatment in the dantrolene is a treatment in the OT when it develops in the OT. But if this patient comes for surgery, right, if this patient is planned for surgery and if you have to give general anesthesia, remember propofol, we had mentioned that. And if it was local, you use procaine, because I can't use lignocaine in this patient. Clear? Thumbs up everyone. Then we come to IVRA, intravenous regional anesthesia or Bayer's block. Remember, this is called intravenous regional anesthesia. So I'm injecting the drug intravenously because I'm giving, as the name suggests, in this case, local anesthesia drugs are injected IV. So there are high chances of toxicity of the drug, which we just discussed. And therefore, you have to add a double cuff tourniquet. It is identified by the double cuff tourniquet. So therefore, you have to have a double cuff tourniquet, only then inject the drug. Okay. Double cuff tourniquet is always present. And the kind of drug that we'll use is a less toxic drug. Okay. The drugs which have less toxic or wide margin of safety. And therefore, because the local anesthesia drugs are injected IV, I am going to use only two drugs, either lignocaine or prilocaine, because these drugs are relatively safe compared to bupivacaine, and therefore bupivacaine here is contraindicated, right? And because you have to use a tourniquet, it can be used for only upper limb and lower limb surgery, that too lasting for 1 hour, not more than that. You can't have any other kind of tourniquet, neck tourniquet, head tourniquet, not possible. You can't do anything like that. Okay. So this is intravenous regional anesthesia or Byers block, where local anesthesia is injected IV, but you need to have a double cuff tourniquet so that it does not go into the systemic circulation outside. You don't want that to take place. Speaking about the next one, EMLA cream. EMLA is eutectic mixture. Remember, even the full form has been asked. Eutectic mixture, equal concentration to lower the melting point. So what we are doing is, we are lowering the melting point so that it can be absorbed from the skin. Lowering the melting point. Lowering the melting point of the two local anesthetics, which we are mixing together. What are we mixing? 2.5% lignocaine, 2.5% prilocaine, and this can anesthetize intact skin. So this is called EMLA cream. It's called eutectic mixture of local anesthesia. It is used for dermal analgesia. It's a topical anesthetic. You're lowering the melting point of two local anesthesia drugs so that they can be absorbed from intact skin. Basically, it was made for needle phobia. Pediatric patients, but it can be used for any superficial procedure. It can be used for any superficial procedure, right? And like biopsy, people using even for tattoos here, right? Circumcision, skin grafting, all these places you can use. Now, if it gets spread to a very large surface area, remember there is one side effect that takes place. It can be seen with prilocaine or it can be seen with benzocaine, and that is what we don't expect from anesthesia, which is methemoglobinemia. All right, and methemoglobinemia, remember the treatment of this is going to be IV methylene blue. IV methylene blue. Even oxygen does not work, huh? You just have to give IV methylene blue. Thumbs up, guys. Is that okay? So then we go to regional anesthesia. Yes, everyone. Well, give me thumbs up here. All of you okay? Any questions and doubts till now? So we'll just take about an hour more and then finish off the whole thing. All okay, guys? Okay, so let's start with regional anesthesia. Remember, spinal, epidural, and caudal. These are collectively called as central neuraxial block because they are working on the central nerves of the body. These are basically called as the central neuraxial block. All right. So when you are giving spinal or epidural, what are the structures getting pierced? Okay. What are the structures getting pierced? So therefore, the first structure that gets pierced is the skin. All right. The first structure that you see over here that gets pierced is the skin. After the skin, the next is the subcutaneous tissue or the fat. Subcutaneous tissue or the fat. After that, the next layer that we see, so this was the skin. After the skin was the subcutaneous tissue. Skin, subcutaneous tissue. All right. One second. This is the skin. After the skin, this area that you see next, okay, this yellow color thing, this is the subcutaneous tissue or the fat. After that, we get this ligament covering up the spinous process. It's called supraspinous ligament. It's covering up like this. Then you get a ligament in between the spinous process. It's called interspinous ligament. Supraspinous, interspinous. And after that, you get another ligament over here, the pink colored one. This is ligamentum flavum. So we got 5 structures: skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, and ligamentum flavum. We got 5 structures. Okay, so skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, and ligamentum flavum. As soon as you cross ligamentum flavum, all right, the next layer that we see, as soon as we cross ligamentum flavum, the next layer that we see over here after that is the epidural space. Okay, so this is our epidural space. So epidural space is just after the ligamentum flavum. So remember this point, the last layer to get punctured, okay, before the epidural space is ligamentum flavum. All right, so that's the sixth one. After the epidural space, the next that you get is dura. All right, so this place that you see over here, this is the dura, and immediately next to the dura, if you will see, is this place, and this is what is called as the arachnoid. So this is the arachnoid, and the space in between them then becomes the subdural space. This space in between them then is what is called as the subdural space. All right, so subdural space means after the dura, this is the subdural space. This is the subdural. Okay, this is the subdural space. One second. Okay, this was the arachnoid. I just want to take this out. This is our subdural space. All right, so we get the dura. Along with the dura, we get the arachnoid. Once you cross the arachnoid, then the next layer is where we get the CSF. Okay, this is the place where we get the CSF, and this is your subarachnoid space. Right, this is what contains the spinal cord, and when the spinal cord is over here, there are the nerves going out from here. All right, the various nerves which move out from here, and these are the nerves where the effect takes place of spinal and epidural. So from spinal anesthesia, the effect takes place from within the CSF, and in epidural anesthesia, it takes place from outside. This is the epidural space. The same nerves are getting brought from outside. So the site of action remains the same, but in spinal, they are from within the CSF, and in epidural they are outside the CSF. Okay, so therefore, subarachnoid space is the one where we give spinal anesthesia. Okay, subarachnoid space is the place where we give spinal anesthesia, and the last layer to be punctured before that is the arachnoid. So subarachnoid space is what contains the CSF. This is what contains the CSF. This is where we give spinal anesthesia. Spinal anesthesia is given here in the subarachnoid space. So clear? So we know the layers now. The last layer before epidural is ligament of flavum. The last layer before spinal is arachnoid. Types of needles. This was again last year's question, NEET PG. When we speak of epidural needles, remember the epidural needles are going to be having 1 centimeter marking. They have this 1 centimeter marking so that you know how far you're from the skin, because in epidural you're supposed to puncture the ligament of flavum but not puncture the dura. That's why epidural is much more difficult. The most common used is this 2E needle. The most common used is the curved tip 2E needle. This is the most common used. We don't use the straight tip needle so much. Okay, so these are the epidural needles. These are epidural needle. How do you identify them? Remember 1 centimeter markings. These are much more thick. Okay, they are much more thick, and you have 1 centimeter markings. Compared to that, when we see spinal needles, so these are the ones which are spinal needles. Spinal needles you will find are much more thinner, and they have no markings. They have no markings. All right, there are two types: spinal needle, cutting and pencil tip. The cutting needle is basically dura cutting. Because they cut the dura, they cause more damage to the dura and more incidence of post-dural puncture headache. Pencil tip are dura separating needles, so they are causing less damage and less incidence of PDPH. Okay, so these are called dura separating, or even we call as dura splitting. All right, dura separating, dura splitting needles. Now, the differences between the two: spinal anesthesia, where do you give it? Because you don't want to create problem to the spinal cord, it's always given below L1, L2. Remember, the most common space used is L3, L4. How do we identify that? Remember, we can identify the area by presence of Tuffier's line. Tuffier's line. So Tuffier's lines tells us is the line joining the highest point of iliac crest. It corresponds to the L4, L5 interspace. Okay, books have also mentioned L3, L4, but if both options are given, choose L4 and L5. Okay, So below L1, L2 is where you give spinal. Epidural can be given. Remember, epidural is also called as extradural. Why extradural? Outside the dura. Outside the dura. Subdural means inside the dura. Subarachnoid means inside the arachnoid. Which level will you give it? You can give it at any level. I can give it cervical, I can give it thoracic, I can give it lumbar, or I can give it sacral. Alright. So thoracic is what is used in rib fracture. Lumbar is the most common used, which we know. Sacral is what is called as caudal anesthesia, used for pediatric patients. Okay. So you can give epidural at any level. Where do you inject the spinal anesthesia drug? The spinal anesthesia drug is injected in the subarachnoid space after the puncture of the dura. In epidural, you are injecting the drug in the epidural space. Here, dura is not punctured. Okay, it's between the ligamentum flavum and the dura. That's where you give the drug. How do you identify the subarachnoid space? When the CSF appears, free and clear flow is when we inject. Epidural space is also called peridural. We use the loss of resistance to air or saline. Okay, the drug given in spinal space, it's a small space. Correct. CSF is a small closed space. A less drug is sufficient to cover up all the area and leads to a faster action. So therefore, we give 2.5 to 3.5 ml bupivacaine heavy, and use 15 to 20 ml bupivacaine. Larger amount of drug is needed for epidural. Onset for spinal is fast, small area. Epidural is slow, 15 to 20 minutes. But the point is, spinal anesthesia acts fast, but it causes a more dense block, a better block. Therefore, this is used for anesthesia and surgery. Compared to that, epidural may have less dense block. It is outside the spinal, right, outside the CSF, and therefore it is more commonly used for analgesia, which we discussed before. Correct. And because the spinal works very fast, you are going to get a fast hypotension. Correct. And here it comparatively works slow. You have a catheter and it works. There is slow hypotension. That's the reason. Fast action, fast hypotension, slow action, slow hypotension. Clear? Let's talk about the side effects. When we are discussing the side effects, what may be the intraoperative side effects? So the intraoperative side effects can be a vasovagal syncope, which leads to collapse of the patient immediate. This is the immediate collapse. Immediate collapse of the patient. By mistake, the drug can go intravascular, local anesthesia systemic toxicity. Shivering. There is a sympathetic block which leads to the shivering that is seen in the patient. Nausea, vomiting. That is seen because there is hypotension. Hypotension. This is the most common complication seen. Reason is sympathetic block. Here you get decreased blood pressure and increased heart rate. Body tries to compensate for it. Now, if you want to prevent this hypotension, you need to do co-loading, treatment and prevention. Treatment and prevention. So prevention is co-loading with colloids. Treatment is give IV fluids or colloid. Give vasopressor. You can also use head-low position, and adrenaline can be used. Right? If the level goes further up and involves other systems, it is called high spinal anesthesia, where the involvement of the CVS will lead to hypotension with bradycardia. The treatment is atropine. And further affecting the CNS and all, it will lead to total spinal anesthesia. It can lead to total spinal anesthesia, where the patient becomes unconscious. There may be coma. All right. Patient is unconscious. There may be coma, and there can be respiratory arrest. Okay. Collapse of the patient, which can lead to collapse of the patient. Right. And for that, of course, the treatment is going to be ABC, CPR, and all the other things which we have seen. Oxygen. Clear? Doctor enlightening doctor says, why are you shivering? Oh, I'm not shivering, guys. Oh, I think my table is shivering. Sorry. I got one point said good by Dr. Sandeep. And Dr. Enlightening doctor says, why are you shivering? No. AC भी बंद कर देते हैं, but not shivering. My table is kind of moving, I think. That's the reason why you're feeling that. Okay. Thanks for pointing it out, Dr. Enlightening. Enlightening doctor. Is that okay till here, guys? So we have discussed all the intraoperative complications. Let's go to the post-operative. When you discuss the post-operative complications, post-op. My table was actually, I think, moving, and that is why, it was moving the camera which is kept. Post-operative. So when we discuss the post-operative complications, the most common that you see is urinary retention. Urinary retention. All right. The most common post-operative. And the most common delayed post-operative complication is post-dural puncture headache, which is also called as spinal headache, post-spinal or post-lumbar puncture headache. Post-spinal or post-lumbar puncture headache. All right. Apart from that, post-operative, you can get other complications also, like infections, meningitis, abscess formation, arachnoiditis. There can be damage to the nerves and blood vessels. Damage to the nerve and the blood vessels. Right? Now, so when you speak of post-dural puncture headache, remember, post-dural puncture headache is the most common delayed complication. This takes 2 to 3 days after the spinal and may persist for how many days? About 1 to 2 weeks. It is fronto-occipital in nature, the kind of pain which the patient feels. Along with that, it also has a postural variation, which is most important. There may be associated symptoms, but most important is the postural variation. And the postural variation means it increases on sitting and straining, decreases on lying down. Patient is very comfortable when lying down, otherwise it may increase. All right, on sitting, straining. And now, how will you prevent it? What was the reason for post-dural puncture headache? The reason for post-dural puncture headache was we gave spinal anesthesia, we punctured the dura. Because we punctured the dura of the patient, what happens is CSF keeps on leaking. Because of the loss of CSF, these meninges which are there, they get stretched, and this is what causes the headache. Okay, so the stretch of the meninges is what causes the headache. All right, so therefore, the whole point is the dura puncture that we did, that is the mechanism. We did the dura puncture. That dura puncture, it led to the CSF loss. This loss of CSF stretches the meninges. Along with that, there is also vasodilation that takes place. And this is what causes the headache. So how do you prevent it? Point is less number of punctures on dura. Correct. Use small bore needle. Don't use wide bore needle. Thin bore needle, small or thin bore needles. All right. Also use dura cutting or dura splitting. Use dura splitting needles, which is the pencil tip ones. Always remember pencil tip. Okay. Now, always remember, compared to females, males and old patients have less, right? Females are having it more. So in terms of factors responsible, remember, more PDPH takes place in females, in young patients, and especially pregnant. Okay. So this is about the post-dural puncture headache. Contraindications. So what is the treatment? What is the treatment? Remember, the treatment is going to be basically supportive. You're supposed to give IV fluids or oral fluid, adequate hydration, basically use analgesics, anti-inflammatory. I can give steroids, I can give sumatriptan. It's not too strain, patient has gone home, stool softeners. Caffeine can be given, cerebral vasoconstrictor. And theophylline can be given, cerebral vasoconstrictor. But remember, the last resort is the epidural blood patch. It's not the first thing, but this is the last resort that you will do, not the first one. It's the last resort, but remember, it's the most definite. But the most definite. Okay, it's the last resort, but the most definite. Enlightening doctor says, sir, please ask the team to provide hard copy. Hard copy will put in, but then that will be done by tonight by tomorrow. We'll put in the hard copy of the notes. Don't worry, you can download them. As I was saying, yeah, we have set a good GT also. I know all of you are appearing for the INI-CET. Now try to appear for the GT. You download the app. We have the GT also there. Try to give that GT as well. There's a good number of questions which are there. See, no one can say this question is going to come. No one can ever say that. But the point is about practice and revision. As you can see, what all of us are trying to do is get the whole things revised in a shortest amount of time possible. So if you will see, till now, we started about 2 hours back and we finished almost 70 to 80% of anesthesia. Right? We've discussed every topic till now from anesthesia. Right? Same thing is there with all other subjects. Okay. So give the GT also, guys. Now, next I'm discussing is the contraindications. So absolute contraindications are skin infection at the site of injection. All right. Severe hypovolemia or coagulopathy. Remember, coagulopathy would mean if the platelet count is less than 80,000, don't give spinal epidural. INR more than 1.4, don't give that. And remember, for surgery, the platelet count they say less than 50,000, according to me. But I think you have to confirm it from surgery. According to me, less than 50,000 surgery, you have to be careful and we don't proceed ahead. All right, for surgery, less than 50,000 platelets. Now, apart from that, next talking about spinal, raised intracranial pressure. Okay, lack of consent or patient refusal is an absolute contraindication. Allergy to drugs, severe shock and sepsis, and severe aortic stenosis or mitral stenosis. These are absolute contraindications. Absolute. The rest all others are relative. Okay, but these are the absolute ones. Now, talking about the airway management. When we speak about the airway management, remember laryngoscopy and intubation, LMA insertion. These 3 things where you need to know things. So laryngoscopy, the same image has been asked in exam. When you do a laryngoscopy, okay, when do you want to intubate someone? Right? What are the reasons behind it? So when you want to maintain a patent airway, what are the indications? Indications. When do you want to intubate someone? Indications. The first would be to maintain an open airway or a patent airway. Second is whenever you want to prevent aspiration. Third is whenever we want to give mechanical ventilation for any cause. For any cause. Fourth, whenever you want to do a pulmonary lavage. Pulmonary lavage means whenever you want to remove the secretions, right, which can also be called as pulmonary toilet. And the last one is it can become a route for medications like surfactant, okay, or anesthesia drugs or emergency drugs. So you can give respiratory medicines, anesthesia medicines, all right, and surfactant can be given, emergency drugs can be given. Now, so when you're doing laryngoscopy, the position is called sniffing position, which can also be called as McGill position. Okay, sniffing position or McGill position, sniffing the morning air. So therefore, what you do is in that position, you keep a pillow below the occiput. So you keep 8 to 10 centimeter pillow under the occiput. Remember, nothing is kept under the shoulder. Nothing under the shoulder, because if something goes under the shoulder, that is called rose position, ENT. Okay, so if this image comes in the exam, remember if something is kept below the shoulder, that is what is called as the rose position of ENT for tonsillectomy. All right, here I'm just keeping a 8 to 10 centimeter pillow under the occiput. With that, what is happening is we are causing a head extension. So there is a head extension at the atlanto-occipital joint and we are causing a neck flexion at the cervical spine. So what happens is basically you are getting head extension and neck flexion. And these two, when you do, the 3 axes come in one line, oral, tracheal and pharyngeal. So these axes come in one line. By doing this position, the oral axis, the tracheal and the pharyngeal axis, they basically come in one line. these three axes, they come in one line. All right, it eases the laryngoscopic view. It becomes easy to intubate the patient. Now, this is the normal position. But if someone is obese, so for an obese patient, what is done is this position, which is called as a head elevated laryngoscopic position. Head elevated laryngoscopic position, or you can also use what is called as a ramped position. So this is done for an obese patient, head elevated laryngoscopic position or a ramped position, where you will find that the tragus and the sternum are at the same level. Also remember, many times for a pediatric patient, you need no pillow. For a pediatric patient, no pillow or a thin pillow is needed. Sometimes nothing is needed. All right. So these are the various laryngoscopic positions that you do, in which it eases the laryngoscopic view. So when the three axes come in one line, it eases the laryngoscopic view. Then, talking about laryngoscopes. So remember, the types of laryngoscopes are important. All right. So when we are discussing the types of laryngoscopes, remember Macintosh, or the curved one which you would see, this is used for adults. Okay, Macintosh is used in adults. When you see the Miller or a straight blade, this is used in pediatric patients. Miller or the straight blade. What happens? Why you use a curved blade in adult? So that the epiglottis can be excluded. But in pediatric patient, the epiglottis is included inside, as their epiglottis is very long and floppy. It falls onto the glottis. That is the reason. So for adults, what we use is a Macintosh blade used in adults. All right. And this includes the epiglottis. It excludes the epiglottis. We do not include it inside. And in pediatric patient, because it is long and floppy, we include the epiglottis in a pediatric patient. That's the reason we use a straight blade in pediatric and a curved blade in adult. But in a difficult intubation, especially in anesthesia, what we use is a hinge tip blade. So this is the hinge tip which you see, and here is a lever at the back. So when you press the lever, that hinge joint goes up, and this is something which helps you for difficult intubation. It lifts up, or it elevates the epiglottis. It lifts up the epiglottis. All right. This is a video laryngoscope, where you can see the vocal cords directly on the screen or the monitor. Okay, screen or the monitor, where you can see. Now, where would this be used? Again, this would be basically used for difficult intubation or infectious diseases like COVID. This was very commonly used during the COVID times, infectious diseases, because you can see it directly on the screen or the monitor which is attached to the laryngoscope. So these are the various types of laryngoscope. When you speak of laryngoscope, remember there are some complications of laryngoscope that you need to know. All right, and you are already aware, but remember there can be bleeding, there can be inflammation of any place, because there's a bleeding, so inflammation can take place, which can cause iatrogenic obstruction of the airway. Right, there can be a hemodynamic response where there is increase in the various pressures in the heart rate and BP. It's called the hemodynamic response. Of course, we've seen the trauma to various structures, but remember, even the vertebral column can be damaged. So there can be even trauma to the vertebral column. Right, vertebral column can get damaged. So bleeding, inflammation, trauma, obstruction, hemodynamic changes, and trauma to vertebral column. Others are also there. And when you speak about teeth, the most common teeth to get damaged are the upper incisors during laryngoscopy. Clear? Next, let's go to the endotracheal tube. So when you speak of endotracheal tube, you need to know what are the parts. I think most of you are already aware, and questions have come from there also. So bevel is this end which you see in the patient. This bevel is what is called as the patient end. It goes inside the patient. On the other hand, you get the connector. So this connector or the adapter basically is the machine end or the umbu bag end. This is what goes to the umbu bag. So it is called the machine end or the umbu bag end. Okay, this is what goes to the umbu bag. Now, right above the bevel, you get to see a part which is this area, which is called the Murphy's eye. Murphy's eye is given as an additional port for ventilation. Okay, so we have this Murphy's eye which has been given, and this has been given as an additional port for ventilation. This is an additional port for ventilation. This is a additional port for oxygenation and ventilation. So that is Murphy's eye. Next to the Murphy's eye, what you see is the cuff. Okay, the cuff is what helps to prevent the aspiration, and nowadays the cuff which is used is a high volume, but the pressure gets distributed along the tracheal walls. Okay, so this cuff that you will see, it becomes high volume but low pressure. Okay, so therefore nowadays the cuff which is available is a high volume low pressure cuff. This is what helps to prevent the aspiration. This is what helps to prevent the aspiration when you inflate the cuff. So inflate the cuff with 5 to 10 ml of air or saline. But remember, the cuff pressure is less than 25 to 30 centimeter of water. Okay, it should be less than 25 to 30 centimeter of water. If the cuff pressure is more, it's going to cause damage. And if it is the cuff pressure is less, then it can cause aspiration leakage. Then you have this black line. This black line is basically vocal cord guide, and this vocal cord guide or vocal cord marker, you can also call it vocal cord marker. This is supposed to lie at the vocal cords. It has been given so that this is supposed to lie at the vocal cords, right? Next to that, you find something written as the ID, internal diameter. Okay, internal diameter. So what is internal diameter? Internal diameter is basically what tells you the size of the endotracheal tube. Internal diameter is the size of the endotracheal tube, and also internal diameter is inversely proportional to the resistance. To the resistance of the endotracheal tube. Okay. Then you have this blue colored radio opaque line, radio marker. There's a blue line that you see at the back like this, right? There's a blue line which you see. That's a radio marker. This can be seen on X-ray, right? Next, these numbers which you see, which is 20, 22, 24, all these numbers, these are called depth markers. These are called depth markers to tell you where exactly to fix the tube. These are called depth markers. Depth markers. So in a male patient, we keep 21 to 23 at the teeth. In a female patient, 19 or 21. Right? Size of endotracheal tube, male patient is 8, 8.5, female patient is 7, 7.5. All right. And then you have this pilot balloon. It's the pilot balloon from where you put the air inside, and the air travels through the inflation line, and from here it goes and inflates the cuff, right? What is the best method to confirm? The best method to confirm is basically capnography. Okay, best method to confirm that you place the tube correctly is capnography. All right, even fiber optic. Of course, there are lots of indirect methods, but the best method to confirm is capnography and fiber optic. Other methods are, of course, you guys know, auscultation. Indirect methods, there are loads of them. X-ray. All right. Then, speaking about a full stomach patient. When a full stomach patient comes, we cannot intubate directly. So, in a full stomach patient, what we do is a rapid sequence induction. Rapid sequence induction. This is what is done in a full stomach patient. So in a full stomach patient, what we do is a rapid sequence induction where we are applying cricoid pressure. So not just full stomach patient, basically any patient with the risk of aspiration. Any patient with risk of aspiration where bag mask ventilation is contraindicated. So there we do rapid sequence induction where we pre-oxygenate the patient first for 3 to 5 minutes with 100% oxygen. Lungs become full with air, with oxygen. After that, you give the cricoid pressure. As you can see, cricoid pressure is given 30 Newton, and this shuts off the esophagus. So this cricoid pressure that we are giving to the patient, remember it's given by assistant. Cricoid pressure is given by assistant, and this the person giving cricoid pressure is assistant. It shuts off the esophagus, prevents aspiration. Then you give the induction drug plus the muscle relaxant. After that, you do laryngoscopy, intubate, inflate the cuff, confirm the position, only then remove cricoid pressure. Only then remove cricoid pressure. Dr. Ashutosh Kumar says, sir, lignocaine without preservative is used in arrhythmia. Yes, correct. Without preservative, absolutely correct. That was the whole point about preservative. Correct, Dr. Ashutosh Kumar. Lignocaine without preservative is used in arrhythmia. Is the same used for IV for decreasing pain? Yes. Whatever is given IV is without the preservative. Absolutely correct, Dr. Ashutosh Kumar. Talking about cricoid pressure. So laryngoscopy, intubate the patient, inflate the cuff, confirm the position, and only then remove the cricoid pressure. Only then remove the cricoid pressure. All right. Now, when we speak about a patient who comes for road traffic accident, okay, remember when you get a patient of road traffic accident, cervical spine injury or maxillofacial injury. So what would you do in a patient like this? So always remember, Glasgow coma scale less than 8 or equal to 8, the first thing is intubate the patient. If the patient has to be given an emergency airway management. Emergency airway management means, remember, no pulse, no BP. The first thing here that you will do is no pulse, no BP. You are going to put oral endotracheal tube or surgical cricothyroidotomy. Just save the life. Whatever be it, if there is no pulse and BP, you just have to save the life. But if it is an elective airway management, means here pulse is present, BP is present, it may be less. In this case, if it's a cervical spine injury, you can't move the neck, you will put a nasal endotracheal tube. And if it's a maxillofacial injury, I am going to do a tracheostomy or a facial injury. Okay. So this is what is done in the patient. Talking about LM, laryngeal mask airway. So this is your laryngeal mask airway. So laryngeal mask airway, guys, are basically divided into two types. These laryngeal mask airway are supraglottic devices. So when you speak of LMA, these are supraglottic, outside the glottis, right? The tip lies at the esophagus. All right, supraglottic. The tip lies at the esophagus. All right, they lie in the larynx. All right, they are used in emergency. They are used during CPR. They can be used for difficult airway. And I can also use them in anesthesia. Okay, I can use them in anesthesia. But in anesthesia, depends what generation is available. So they're classified into two types. First generation, which has just one tube. That is, one tube is the airway tube or the ventilating tube. So these are all first generation. One tube, one tube, one tube, one tube, and one tube. So you get classic LMA, which is the most common used. No, not used now, but it was the first one which was developed. Intubating LMA. This helps for intubation. You have the flexible LMA and unique LMA. It's a good thing, LMA, but the LMA does not prevent aspiration. The biggest disadvantage of a laryngeal mask airway is it does not prevent aspiration. It does not prevent aspiration. None of the LMAs directly prevent aspiration. So therefore, they said, why not put a Ryle's tube from the nose, which can suction the stomach? They combined the two together and they made the second generation LMA. All right. So that is what is called as a second generation LMA. It has two tubes now. Second generation LMA has two tubes. You are going to see two tubes in each one of them. Okay. The first tube, the second tube, and then here the first tube, second tube, first tube, second tube, first tube, and second tube. So these are the second generation LMA. So when you speak about the second generation LMA, right? So remember, the second generation LMA has two tubes. First, is the airway tube, which was there before. And along with that, second, we also have a drain tube, which helps for suctioning. Therefore, what is the advantage of the second generation LMA? This decreases the chances of aspiration, does not prevent. It decreases the chances of aspiration. Therefore, in anesthesia, can be used for IPPV. Problem with the first generation was, in anesthesia, it was used only for spontaneously breathing patient, not IPPV. It was contraindicated for IPPV, positive pressure ventilation. That is the difference between the first and the second one. Now, what are the points here? So, ProSeal LMA is the second generation. Supreme LMA, this is used for difficult intubation. Right, iGel is the most common. This is said to be a cuffless LMA. And Ambu Aura Gain, this is again a second generation. Remember, most of the Ambu LMAs are first generation, like Ambu Aura 40, which was asked in the exam. Most of the Ambu LMAs are first generation, only one tube, except for Ambu Aura Gain. Right? Exam, they had asked you Ambu Aura 40. INI-CET only. Okay. Now, let's talk about the other devices now. So these are all non-definite devices. They do not prevent aspiration. So whether you are discussing the LMA, all these devices which we are discussing are non-definite. The first one was the laryngeal mask airway. Apart from the laryngeal mask airway, the next ones are the oropharyngeal airway, the nasopharyngeal airway, bag mask ventilation, or even the Ambu bag. Right? So oropharyngeal and nasopharyngeal airway, both of them prevent the backfall of tongue. So oropharyngeal airway is between the corner of the mouth to angle of mandible. Alright, nasopharyngeal airway from the tip of nose to the tragus of the ear. Now the difference is that oropharyngeal airway is contraindicated in awake patient. It can stimulate the gag reflex, right? And it can lead to so many complications, aspiration, vomiting, alright, laryngospasm. And the advantage of nasopharyngeal, it bypasses the gag reflex. It can be used in awake patient. Bag mask ventilation. It provides the seal for positive pressure ventilation. Alright, the mask provides the seal for positive pressure ventilation. The biggest disadvantage of bag mask ventilation is that it increases dead space. So, what device decreases the dead space? Dead space is decreased by which device? Device that decreases the dead space is tracheostomy and endotracheal intubation. It is decreasing the dead space. Ambu bag. So for Ambu bag, we used to say that there are 3 walls in the front and 2 walls in the back. So basically there are 5 walls present. Right. So last year, they asked you about the pop-off valve. Pop-off valve, at what pressure does it break even? So for an adult patient, it is 30 to 40 centimeter of water. And for a pediatric patient, it goes away at 10 to 20 centimeter of water. This was asked last year in NEET PG. There are 5 valves. Out of them, 1 is a pop-off valve, is what they asked you. Okay, so Ambu bag had 3 valves in the front plus 2 valves at the back. Out of the 3, 1 was this pop-off valve. Correct? Let's go to the oxygen delivery devices. Dr. Ashutosh says, sir, if the patient develops mild hypertension in the OT, dangling should be continued with inhalational. No, you have to stop inhalational. Absolutely stop inhalational. No TIVA, just have to save the life. Forget the anesthesia, forget the surgery. Okay, just give Dantrolene and save the life, otherwise he'll be dead on OT table. Dr. Ashutosh. Okay. Next, discuss the oxygen delivery devices. Oxygen delivery devices are classified into 2 types, low flow and high flow. Low flow devices are the ones which can be used for stable. High flow is basically used for unstable. Maximum flow rate. Nasal cannula, the maximum it gives is 44%. There's a formula to calculate it. 21 plus 4 multiplied by the flow rate. For simple face mask, maximum is 60%. All of you know that. In a simple face mask, if you can attach this reservoir bag, in that case, it becomes 70%. And to this, if you attach a valve, right, this becomes non-rebreathing mask. So it has an oxygen reservoir bag also. It has this valve also. So based on that, it can give 90%. So maximum FiO2 is given by the non-rebreathing mask, which is 90%. So nasal cannula 44%, simple face mask 60%, partial rebreathing 70%, non-rebreathing 90%. So out of all the low flow devices, the maximum is seen with non-rebreathing mask. Correct? Patient becomes unstable. We can use high flow nasal cannula. So high flow nasal cannula can give 100%. Okay. So high flow nasal cannula can give 100%. It is basically providing warm and humidified oxygen to the patient. It decreases the nasopharyngeal dead space. All right. Warm and humidified oxygen is delivered to the patient. It decreases the nasopharyngeal dead space and it can give 100%. It's just like a nasal cannula, which is much more thicker. Then there is Venturi mask, which is again a high flow device. It is based on the Venturi principle or Bernoulli's law. Venturi principle or Bernoulli's law. Remember, the maximum it can give is 60 only. So what is it used for basically? So based on this law, it causes air entrainment. It's got a hole from where air can go inside. Right? Oxygen goes from here and air goes from the side. So therefore, because of this reason, it becomes a fixed output device. It's a fixed output device, right? And you can use it wherever you want to give it a titrated oxygen to a patient. Whenever you want to give a titrated oxygen to the patient, for example, COPD, this is where we use Venturi mask. Okay, the maximum though is 60. Talking about non-invasive ventilation. So when you speak about the non-invasive ventilation, so nasal cannula, simple face mask, partial rebreathing, non-rebreathing, high flow nasal cannula. The next would be non-invasive. So for a non-invasive ventilation, the most common used is CPAP and BiPAP. Okay, so continuous positive airway pressure, which is CPAP, bi-level positive airway pressure, which is BiPAP. Both of them are tight face masks which go on the face and they prevent the alveoli from they keep the alveoli open during expiration. So therefore, because you're using a tight mask, right? They're using a tight mask. So what are the contraindications where not to use it? In case someone has a facial fracture, right, or a facial edema, you cannot put this tight mask. Uncooperative patient, you can't use it. But more important, unconscious or sedated patient, we can't use it, right? Advantages of using a CPAP or a BiPAP: it helps you to increase oxygen, helps to decrease carbon dioxide, can be used before mechanical ventilation. Before you're going to mechanical ventilation, you can use this, and it is also used as a treatment of obstructive sleep apnea. It prevents the alveolar collapse during expiration, right? When you speak about the ventilator, right, mechanical ventilation. So when you speak of mechanical ventilation, we cannot discuss too much into the details of that. But when we're discussing mechanical ventilation, guys, remember, mechanical ventilation, basically you're putting the patient on ventilator to decrease the work of breathing. So initially we'll have to put the patient on a control mode, and when the patient improves, I will try to put the patient on a support mode or a weaning mode. The commonest control mode would be to control the tidal volume, so which is called as the volume control mode, or we may control the pressure, which is called as the pressure control mode. Nowadays, pressure control mode is not used so often, right? The support mode, when the patient is improving, there are two modes which are there: synchronized intermittent mandatory ventilation and pressure support. So these are the support modes. Remember the last thing over here, that is lung protective strategy. Lung protective strategy. The lung protective strategy now is to use a low tidal volume but a high P. This is last year's NEET PG question. Low tidal volume means 4 to 6 ml per kg, and high peak means up to 20. All right. So this is in mechanical ventilation. Speaking about the monitors. So let's discuss the monitors. I think all of you are aware. We'll just finish off them fast. Just towards the end now, almost done. Okay. So when we speak about the monitors, remember capnography. So in the capnography graph, remember capnography is something which monitors the carbon dioxide. All right. So carbon dioxide, whenever the graph detects carbon dioxide, it goes up, means expiration. It goes down, inspiration. Graph goes up, expiration. Graph goes down, inspiration. So remember, there are 5 points. When the graph is going up, it can be like this. So the first point is going to be, this is the baseline or the dead space gas. Baseline or the dead space gas. Baseline or the dead space. This point is A to B. B to C is basically the alveolar gas plus the dead space gas. C to D. C to D is basically the alveolar gas plateau. So these are the various phases of expiration. All right. And point number D is what is called as EtCO2, end tidal carbon dioxide, which is approximately the same as PCO2. That's point number D, maximum CO2. So this represents the maximum carbon dioxide getting released from the alveoli, and then the graph goes down, D to E. This is inspiration, and the whole thing starts again. Okay, so this is important for A to B, B to C, C to D, and D to E. All right. When we speak of capnography, this is what is seen as a normal capnography trace. This is what is seen normal during IPPV or correct intubation. If someone has been intubated correctly, this is the graph that you get. Okay. For a spontaneous breathing, I get a graph like this. This is seen in a spontaneously breathing normal patient like you and I right now. We will get a graph like that. So whenever there is increased CO2, this graph would suggest that CO2 is increasing. So graph may be increasing where malignant hyperthermia, in thyrotoxicosis, sepsis, fever, laparoscopy, right? All these conditions. Rebreathing. This is rebreathing own carbon dioxide. This is seen with that soda lime getting exhausted that we discussed before. Soda lime exhausted. This is called as a step ladder pattern. All right. Then this is what is called as 𝐒𝐿, which means spontaneous breathing has returned. You can call it as return of spontaneous breathing out of muscle relaxant effect. That is why you got a 𝐒𝐿. There was IPPV going on, and suddenly there was a spontaneous breath of the patient. The graph going down means spontaneous breath of the patient, which means patient is out of the muscle relaxant effect. All right. Sudden loss of waveform means the sudden fall of zero. Sudden drop of EtCO2 to zero. This would suggest that patient is in embolism. All right. There is embolism. There may be cardiac arrest. There may be disconnection from the circuit, esophageal intubation, right? All these would suggest, okay, accidental extubation also, sudden drop to zero, right? Shark fin appearance is airway obstruction. So this is basically called shark fin appearance. There is airway obstruction, which is seen in COPD, bronchial asthma. Cardiac oscillations are seen during inspiration, especially with pediatric patients and those with a thin chest wall, right? During CPR, when you're doing CPR, you get a graph like this. This means CPR going on, small ones, and this means patient is revived after CPR. Okay. The next is bispectral index. All of you know this is called as the depth of anesthesia monitor. It is based on electroencephalogram. It is based on EEG. Based on that, you get a value. 100 means patient is awake. 0 means patient is in coma, no electrical activity. Remember, a value of 40 to 60 or 45 to 65 is for GA and 65 to 85 is for sedation. So therefore, It helps me to titrate anesthesia drugs better. It helps to prevent overdose and underdose. It helps us to prevent overdose and underdose. It prevents recall or patient being awake. Patient awake or aware. All right. It also leads to faster emergence from anesthesia. These are advantages. Pulse oximeter. Pulse oximeter is based on the Beer-Lambert's law. So what does it tell you? A pulse oximeter tells us the SpO2. It tells us the pulse rate. It tells about the peripheral perfusion, if it's happening or not. And it can tell the volume status. Peripheral perfusion, if it is taking place or not. And the graph tells us about the volume status. It cannot detect abnormal hemoglobin. So these are the limitations, like methemoglobinemia, right? Methemoglobinemia or carboxyhemoglobin. All right. You will get a wrong reading in shivering, hypothermia, vasoconstriction, shock. Okay. Hypotension, nail polish, and hyperpigmentation. Wrong reading. Temperature monitoring. All right. The most common site is, the best site actually is pulmonary artery, but the most common use is distal esophagus. Remember, apart from distal esophagus, nasopharynx is very important for brain temperature and even tympanic membrane. Tympanic membrane. This is important for brain temperature. Also, rectum and bladder are close to core temperature, but they are not core temperature. The best site for core temperature is always pulmonary artery. Best, but most common is distal esophagus. Talking about CPR. Remember, when we do CPR, the first step is always verify the scene safety and always check for response, the second step. Remember, in a triage, unresponsive patient is attended first. Unresponsive patient is attended first. Okay, check for response. If there is no response, third step is call for help. All right. The fourth step is look for breath and pulse. So you are checking breath and pulse simultaneously within 10 seconds. If both pulse and breath are present, keep the patient in the recovery position. If pulse is present and breath is absent, what is missing is the breath. In that case, give a breath to the patient, right? And give 10 breaths per minute. That's important. And check pulse every 2 minutes. The third is that both are absent, no pulse, no breath. That is my fifth step. Start the CPR. Okay. And you will be doing cycles of 30:2. Keep on doing that. Sixth step is you get AED. When you get AED, check for the rhythm, a shockable rhythm, give a shock. After the shock, no pulse check. Remember that. Then immediately resume CPR and go back and check rhythm again if there is no pulse. Right? If it's a non-shockable rhythm, straight away, no shock, resume CPR, and after that, if there is no pulse, go back again. This is the whole cycle of CPR that you do. When you are giving breath to a patient, when you are giving chest compression, remember it is lower 1/3 of the sternum. The rate is 100 chest compressions when we are giving. This is lower 1/3 of the sternum. The chest compressions are 100 to 120 per minute. The depth is 5 to 6 centimeter, all right, or 2 to 2.4 inches, and allow the chest recoil. All right. When you do the maneuvers for airway, that was for chest compression. When you do airway maneuver, so always remember there is this head tilt, chin lift, jaw thrust that we do, and once after the airway is done, then you give the breathing. So therefore, this is what we do in the patient. Chest compression, then comes airway, where you open the airway, and then you give the breath to the patient. Okay. Then, how is an advanced life support different from a basic life support? So in an advanced life support, what we have done, you remember you called people to help you out. You called for help at step number 3. So those people have come with the help. So now what has happened is, you have to give a high quality CPR. So these are the points for a high quality CPR. So in a high quality CPR, you need to push hard. We have mentioned push fast, okay, minimize interruptions, allow chest recoil, avoid excessive ventilation. You have got help. Put endotracheal tube or supraglottic airway, and remember capnography best method to confirm. Use biphasic shock 120 to 200 joules, monophasic is 360 joules when you're giving a shock to the patient. Drugs that can be used: adrenaline, amiodarone, lignocaine, and magnesium. Now you've got drugs also. People have come to help you, right? How will you monitor the CPR? Monitor the CPR with pulse and BP. Look at EtCO2 and intra-arterial monitoring, right? And in between, keep on thinking about the 5H and 5T. What must happen to the patient so that you can take care of those things. Chain of survival. This is the 2025 new chain of survival, both for adults and pediatrics. What are the sequence of events need to be done to save the life? These are the sequence of events that will help you to save the life of a patient. The first is recognize it's a cardiac arrest, emergency, activate, call people for help, give a high quality CPR, do a defibrillation when you get a defibrillator. Fourth is advanced resuscitation, advanced life support. Fifth is post cardiac arrest care, means when you revive the person. And sixth is recovery and survivorship. So when you have revived the person, remember, maintain the heart rate, maintain the blood pressure, maintain the respiratory rate, maintain the ventilator settings basically, because this patient is just revived. Temperature between 32 to 36 degrees, all right? And here you can do a neurological consult to see. We can do a neurological consult, okay, to see if there is no brain death, all right? And you can take the patient to a cardiac cath, right? In case there's an arrest, you will have to see what else is to be done. Cardiac cath. All right, we come to ASA grading. Remember, ASA grading is a normal healthy patient, ASA 1. Mild systemic disorder, which is controlled, is ASA 2. Severe systemic disorder, uncontrolled, ASA 3. All right, severe systemic disorder, threat to life, ASA 4. Moribund patient not expected to survive without surgery, ASA 5. Brain dead is ASA 6. Remember, only ASA 1 and 2, they go for daycare surgery. Sometimes ASA 3 for daycare. Otherwise, ASA 4, 5 are gone. You don't do daycare. Fasting guidelines: clear liquids is 2 hours. Breast milk is 4 hours. Light meal, light breakfast is for 6 hours or any other type of milk. Heavy meal, 8 hours. What drugs that need to be stopped before surgery? All right. Remember, smoking is always stopped before surgery for 4 to 6 weeks to decrease the respiratory complication. Nowadays, aspirin is not stopped. Previously, it used to be stopped. But in case you need to stop for chances of bleeding, you stop it for 3 to 5 days. In case, but routinely it is not stopped. Warfarin, 4 to 5 days. Clopidogrel, 5 to 7 days. OC pills with high estrogen, 4 to 6 weeks. Herbal medication, 4 to 6 weeks. Angiotensin receptor blockers, ACE inhibitors, diuretics, 1 day. OHA, insulin, NSAIDs, all of them omit the NSAIDs. Basically stop them 1 hour, 1 day prior and omit the morning dose for all of them. So OHA is stopped 1 day prior, NSAIDs 1 day prior, insulin, omit the morning dose and adjust the dose. All right. Goals of pre-medication. Why you want to give pre-medication to a patient? To decrease anxiety, or sedation, to decrease secretion. To decrease secretion, drug of choice is glycopyrrolate. For aspiration prophylaxis, the drug of choice is metoclopramide. Prevent infection. Anyways, doctor, again we'll be discussing in detail. Dr. Siraj sir will be just joining 2 minutes more and he will be discussing all this in detail. According to me, you can confirm that from him. According to me, the best drug that is used to prevent infection here is cefazolin. Sir will tell you much better. All right, this is the drug which we use. So glycopyrrolate to decrease secretions, aspiration prophylaxis metoclopramide, and infection cefazolin. These drugs are given 10 minutes to 1 hour prior. So post-op nausea, vomiting, to take care, the drug of choice is ondansetron. For post-op analgesia, we can give blocks, epidural, local. We use various drugs which are analgesics like PCM, NSAIDs, COX-2 inhibitors, weak opioids, moderate opioids, and strong opioids. Okay, guys. Any questions and doubts, please ask me. Otherwise, Dr. Siraj sir will be just joining, right? And thank you everyone for all the messages. Hopefully you've understood. We tried to finish off complete anesthesia also in this much time. and try to cover each and every topic. Any questions and doubts? Otherwise, I'll just move away. Dr. Siraj sir will be waiting now. Yes. So I've already will be sharing the notes. It will be available. All right. Hopefully, it will be okay. Any questions and doubts, guys? You can join us on Instagram. You can follow me on Instagram also. Any questions, you can ask me directly. I'll share my number with you. If there's any doubt, you can give me a WhatsApp message also. So 99. So that's my number. Okay. Any questions and doubts, you can ask me. So anyways, no other questions, I think. So all the best, guys. Do well. And when you get your seat, do let us know. And all of you should attempt the INI-CET GT that we have, the grand test which we have. Okay. So Dr. Ashutosh says, you mentioned head low for bradycardia in spinal. Isn't it head up? Correct, Dr. Ashutosh. Good question. Dr. Ashutosh said he head low for spinal bradycardia. No, it's not for bradycardia. Head low for spinal, basically, let me tell you this. So when you give spinal anesthesia, because we are using dextrose, where is spinal? Okay. So we mentioned head low because what has happened is the sympathetic block is causing peripheral pooling of blood. So they say in the books that, you know, if there is peripheral pooling of blood, you can do a head low position which will counteract that. But if you do head low, the chances is that you are going to cause high spinal anesthesia. And that is the side effect, and that is why this is normally not done. But yes, books have mentioned it. Good question, Dr. Ashutosh. Clear? But yes, it has been mentioned you do a head low position so that you can increase the venous return to the heart because it is because of the peripheral pooling of the blood. Okay, Dr. Ashutosh? Head up is done basically when it is going for a high spinal anesthesia. A routine normal anesthesia would not be needed for high spinal. But yes, when you do a head low, as Dr. Ashutosh says, the level may go up and lead to the problem. Okay, Dr. Ashutosh? ठीक है, और तो क्वेश्चन नहीं किसी को? Hopefully we are done. Sorry to keep Dr. Siraj waiting. I think no other question then. Chalo, let me just hand up. You have my number, guys. You have my thank you, Dr. Ashutosh. You have my Instagram. You can follow me and my number. Bye bye, guys. All the best. Do well and let us know. Appear for the GT. Thank you so much. Thank you, guys, for joining.
All right, hi guys, very good evening to all of you. Welcome to our today's INI-CET marathon, and now we are going to start pharmacology, and it will be taking roughly around, let's say, 3.5 to 4 hours. थोड़ा बहुत ऊपर नीचे हो जाता है. Let's say half an hour up and down, more or less around in 4 hours straight. We'll try to quickly revise the pharmacology for all of you guys. For all my students, those who are live right now, please give me a quick confirmation if I'm clearly audible and visible. अगर audio video सब ठीक है, अगर आपको मेरी आवाज़ आ रही है तो जल्दी से कंफर्मेशन दे दीजिए. यस सर, एवरीथिंग इज फाइन एंड लेट्स गेट स्टार्टेड विद द रिवीजन ऑफ फार्माकोलॉजी. हाय डियर स्टूडेंट्स, क्विक कंफर्मेशन प्लीज. All right, great. Thank you very much. So this session of 4 hours that we are going to conduct today is actually scheduled according, or planned, I would say, according to the topics that are frequently being asked in the examination. Because you also understand that in 4 hours, even if we try to cover, let's say, 50% of pharmacology high-yield topics, that's not possible. So ये किस बेसिस पे प्लान किया गया है कि 4 आवर्स में आपका हाई यील्ड टॉपिक रिवाइज हो जाए. दैट इज मेनली ऑन द बेसिस ऑफ द प्रीवियस ईयर टॉपिक्स दैट आर यूजुअली बीइंग आस्क्ड इन द एग्जामिनेशन, राइट. सो द फर्स्ट एंड फॉरमोस्ट टॉपिक दैट आई एम गोइंग टू कवर इज गोइंग टू बी योर ऑटोकॉइड्स एंड इम्यूनोमॉड्यूलेटर्स. वन ऑफ द टॉपिक जहां से ऑलमोस्ट एवरी एग्जामिनेशन में क्वेश्चन रहते हैं। ऑटाकॉइड्स एंड इम्यूनोमॉड्यूलेटर से बहुत सारे क्वेश्चन आते हैं। तो सबसे पहले हम इसी की बात करेंगे, ऑटाकॉइड्स में हिस्टामिन, सेरोटोनिन एंड देन इम्यूनोमॉड्यूलेटर ड्रग्स एंड सम ऑफ द इंपॉर्टेंट मोनोक्लोनल एंटीबॉडीज ऑल्सो आई विल बी डिस्कसिंग फॉर ऑल ऑफ यू गाइस, राइट, बिकॉज आई नो कि ये चीज़ें होते होते काफ़ी एंड हो जाता है। आई मीन वी ट्राई टू कवर ऑल दिस टॉपिक्स इन द वेरी एंड ऑफ आवर प्रिपरेशन और वेरी एंड ऑफ studying pharmacology, and we often end up missing this topic, so we call them sometime orphan topics. So orphan topics से आजकल question ज़्यादा आ रहे हैं, lot of questions are being asked, so we'll first cover this one. First and foremost, I'll be talking about histamine and serotonin, and you also know for the fact that all the histamine receptor, they are mainly going to act via G protein coupled receptor, GPCR. All of them, they are going to act via GPCR, that is G protein coupled receptor. Now what is the meaning of all the histamine receptor? We are having H1, then we are having H2, right, H3, H4, H1, H2, then we have something called your H3, and we have something called your H4. Histamine 1, they are mainly going to act via GQ. So again, there is autocoids with general pharmacology. H2 is the only histamine receptor that is acting by GS, and H3 and 4. H3 and 4, these are the receptors that are mainly acting by GI. Remember, GI के through काम करते हैं. They are auto-inhibitory in nature. They are actually present, especially H3 that we know, it is mainly present in the CNS, and in the CNS they are going to decrease the histamine level. In the CNS, they are going to decrease the histamine level. H4, on the other hand, it is mainly present at the WBC. They are mainly involved in the chemotaxis. We do not have drug for H4, right? H1, H2, H3, and H4, majority of the drugs that we have, that is targeting H1. So whenever we say that we are going to give antihistaminic drug, we actually mean that we are giving our patient something called your H1 blocker. Antihistaminic means H1 blocker we are all going to give, right? So where is H1 located? Remember, H1 is the one that is located in all the allergies pathway. Histamine के H1 receptor की बात करेंगे, allergies में involve हैं. H1 it is also present in the CNS, and in the CNS they are actually going to maintain wakefulness. That explains the fact that if they are going to maintain the wakefulness, if you are awake right now, possibly in your reticular activating system, there is going to be the definite role of H1. So H1 in the brain, it is involved in the maintaining wakefulness, and that explains the fact that if you take antihistaminic drug H1 blocker, whenever you give H1 blocker, one important side effect that you always get is going to be sedation. So drug like your cetirizine, chlorpheniramine, these are all antihistaminic drugs. They can always call what? Sedation as a side effect. In addition to that, remember, these are also associated with other actions, like for example flushing, right? They are also associated with this other actions like flushing. Then we know H2 is mainly present at where? H2 is mainly present at the gastric parietal cell in the stomach, gastric parietal cell, and they are mainly associated with, H2 is mainly associated with increasing the acid secretion. Think and tell me, अगर H2 acid secretion के साथ associated है, तो what kind of drug should I be using? The answer is pretty simple. I will be using mainly something called your H2 blocker. You know the drug H2 blocker, like your drugs like your ranitidine, tidine, जितने भी ड्रग हैं सबके नाम में tidine आता है, right? Ranitidine, right? Nizatidine. Then we have cimetidine. They are all going to be tidine. They are all going to be tidine. These are mainly going to be utilized in the treatment of peptic ulcer disease. They are mainly going to utilize in the treatment of peptic ulcer disease, right? Remember H3 that we know, H3, it is mainly present at where? H3 is mainly present at the CNS. And as I told you, they are autoreceptor. They are acting by GI. They are acting by GI autoreceptor. So they decrease the level of histamine, right? So H3 in the CNS, they are actually decreasing the level of histamine in the brain. Now, can you tell me what was the role of histamine in the brain? What was the role of histamine in the brain? The role of histamine in the brain was to maintain wakefulness. See, H1 that is working by GQ, the role is to maintain wakefulness. अगर ये post synaptic पे काम कर रहे हैं, so the role is to maintain wakefulness. But if there is someone who is decreasing histamine, they are going to cause what? Sedation. So they themselves will be causing what? Sedation. That explains the fact that अगर हमने H3 का inverse agonist दिया, if I am going to give H3 का inverse agonist, then what will happen? Inverse agonist, ulta action, right? H3 itself is causing sedation. So see nature how it is maintaining the balance. One is maintaining wakefulness, so at the same time there is H3 also that is going to maintain the wakefulness, I mean sedation. So there should be a balance. There should be a balance. Otherwise एक बहुत ज़्यादा wakefulness करेगा और एक बहुत ज़्यादा sedation करेगा, right? So H3 का inverse agonist is available for all of us, right? That is called your tiprolicin, pitolisant. Now who can tell me that H3 का inverse agonist, what will it do? Pitolisant, tiprolicant. Right, antagonist of H3, 3 का antagonist, tiprolicant and pitolisant. What will they do? If H3 itself is causing sedation, H3 का inverse agonist sedation का उल्टा काम करेगा, inverse है, inverse agonist उल्टा काम करेगा, so they will maintain the wakefulness. So where can we use this? They are mainly going to utilize for the management of the narcolepsy. We can utilize it for the management of the narcolepsy. इसको हम narcolepsy में manage कर सकते हैं, use कर सकते हैं. We can utilize them in the management of the narcolepsy, right? So we have different receptor. We have H2, we have H3, and we have H1. So whenever we say antihistaminic, we are actually talking about treatment of allergy के लिए first, I mean H1 antagonist. Now these antihistaminic drug that we know, H1 antagonist that is mentioned here, remember these are known as your first generation antihistaminic, first generation H1 blocker. Down here is known as your second generation H1 antagonist. What is the difference between first generation and second generation? The first generation antihistaminic drug, they relatively having short T half-life, short to intermediate T half-life, short to intermediate acting, short to intermediate acting, right? They crosses blood-brain barrier as well. They cross the blood-brain barrier. Therefore, excess sedation will be very important problem. Excess sedation, plus they also possess excess of anticholinergic property. They also possess as excess of anticholinergic property. More anticholinergic property they have. किसकी बात कर रहा हूँ? First generation की बात कर रहा हूँ. First generation is having more anticholinergic property. Compared to this, if I am going to look at the second generation one, they will have relatively longer acting, long T half-life, longer T half-life, right? They will have less blood-brain barrier crossing capacity. So all the antihistaminic, all the allergic pathways, mainly will be preferring what? The second generation, less blood-brain barrier crossing, right? In addition to that, they will have less to no sedating property, less to non-sedative in nature, or less to non-sedative. Why? Because they have less blood-brain barrier crossing capacity, plus they will also have lesser anticholinergic property. They have lesser anticholinergic action. Lesser anticholinergic action is going to be seen with the second generation antihistaminic drug. So we have first generation, we have second generation antihistaminic drug. Among these second generation, we have drugs like your olopatadine, alcaftadine, आंखों पे काम करने वाला, loratadine, cetirizine. Cetirizine, actually, remember, boys and girls, is actually an isomer of cetirizine that you see here. It's an isomer of the first generation. Therefore, being a second generation, which one is also having a more sedating property, that is cetirizine. So cetirizine actually is isomer. It is derived from first generation. Isomer of first generation antihistaminic drugs, right? Isomer of the first generation. Therefore, it will be having also sedating property. And what we have currently, we have levocetirizine. Levocetirizine, it is actually going to be a derivative of cetirizine. Levocetirizine is derivative of cetirizine, so this will have relatively less sedative property, less sedative property to non-sedative property. Then we have estamizole terfenadine. Remember, estamizole terfenadine तो आजकल clinically use करते ही नहीं है. Estamizole terfenadine, they are actually associated with QT prolongation. QT prolongation. Therefore, estamizole terfenadine has been banned. These two drugs, estamizole, terfenadine, they are banned. और terfenadine का एक isomer available है. One of the isomer of the terfenadine that we know is called your fexofenadine. So fexofenadine के साथ एक important MCQ is that this is going to be overall least to non-sedative in nature. Overall least to non-sedative in nature. Therefore, examiner asks, which antihistaminic drug is going to be preferred in truck drivers, pilots, right? So history of truck driver will be there, pilots will be there, because truck driver, they are mostly taking their heavy vehicle in the night, and if they sleep on the road after taking your drug, then I don't know how many more people will sleep on the road, right? So we have truck drivers, pilots, again pilot, they need to be awake, conscious, and also heavy machinery operator. So in a factory, if there is a heavy machine operator, right, and he is feeling sleepy while operating the machine, imagine what outcome it can cause, right? So we have fexofenadine. This is the overall least to non-sedative in nature. Wherever we talk about allergic management, we always use the antihistaminic drug, and antihistaminic may we use second generation more commonly. Among the first generation, we have chlorpheniramine, pheniramine. This is the less sedative among the first generation, less sedative among फर्स्ट जनरेशन, एमंग फर्स्ट जनरेशन में कोई थोड़ा कम सीडेटिव, छोटा एक्टिंग क्लोरफेनिरामिन, देन वी हैव फेनिरामिन. डॉक्सिलामीन इज वन ऑफ द ड्रग इज रेडिली अवेलेबल. इट्स अ ड्रग ऑफ चॉइस फॉर मॉर्निंग सिकनेस. डॉक्सिनेट के नाम से आता है, ड्रग ऑफ चॉइस फॉर मॉर्निंग सिकनेस. अ ड्रग दैट इज मैंडेटरली एडेड विद डॉक्सिलामीन इज गोइंग टू विटामिन B6. दे इंटरफेयर विद द B6 एब्जॉर्प्शन एंड B6 की कमी कराते हैं, पाइरोक्सिन की कमी कराते हैं, राइट. डाइफेनाइट्रामीन, प्रोमेथाजिन. प्रोमेथाजिन इज वन ऑफ द ड्रग दैट इज हैविंग ओवरऑल maximum antihistaminic property with maximum anticholinergic property. Promethazine, maximum antihistaminic and maximum anticholinergic property. Maximum antihistaminic and maximum anticholinergic property is noted with the promethazine. So it's very I would say very pro in its action, है ना, बहुत ही ज़्यादा pro है, बहुत ही ज़्यादा proactive है, right? So promethazine can also be utilized in the management of, it can also be utilized in the management of the motion sickness, right? Motion sickness, because of its again anticholinergic property. Buclizine, cyclizine as a drug, we can utilize them in motion sickness, but they are more preferred also for the vertigo, for the seasickness, right? For all this condition, we can actually utilize buclizine, cyclizine, right? Buclizine, cyclizine. So these are the ऊपर वाले जितने भी हैं, they are all considered the first generation, and नीचे वाले second generation antihistaminic. So whenever we talk about antihistaminic, we are always talking about these first, H1 antagonist. So first generation वाले, second generation वाले. Always to remember one question that can be expected, that all the good part is there with the second generation, like longer T half-life, lesser blood-brain barrier crossing capacity, less to non-sedative, lesser anticholinergic property. Everything is good with the second generation. One negative point with the second generation is that examiner asks which of the following is associated with cardiac side effect, right? So remember, it is the second generation, especially drugs like estamizole, terfenadine, they are the one that is associated with cardiotoxic event, associated with the cardiotoxicity. Some of them are banned as well. So second generation is the one that is mainly associated with the cardiotoxicity, right? So this is everything about your antihistaminic, or I would say H1 antagonist, right? तो ये होगा हमारा ऑटोकॉइड्स में हिस्टामिन के बारे में हमने डिस्कस कर लिया. Quickly I will also be talking about your serotonin. How many receptor of serotonin do we have? See, all the histamine receptor quickly recap करते हैं एक 60 सेकेंड में. We had 4 histamine receptor, and all the 4 histamine receptor, they were acting via G protein coupled receptor. All the histamine receptor, they were acting via what? G protein coupled receptor. The only one that is acting by GS is called H2, right? The only one that is acting by GS is called H2. Then H1 is GQ. All the one is mostly with the GQ only. Okay? Then H3 and H4 is going to be acting by GI. S3 and S4 इनका activity होता है GI के through, right? Whenever we talk about antihistaminic drug, we are giving first generation, second generation, they are all going to be your H1 antagonist. H1 antagonist always shorter acting, more sedative, more anticholinergic side effect, right? Second generation will have lesser. Overall least sedative is going to be your fexofenadine. आप बड़ा फेमस ड्रग है मॉन्टेयर FX के नाम से आपने देखा होगा, है ना, जिसमें मॉन्टेल्यूकास्टोस फेक्सोफेनाडिन होता है, right? We use them for the treatment of allergies, hives, right? Where whatever allergies that we want to treat, we can utilize the antihistaminic drug, right? So we have olopatadine, L-caftadine. Drug like olopatadine, L-caftadine, अगर मैं बोलूँ, we have drugs like your olopatadine, है ना, L-caftadine. These are ocular और आँखों के लिए, so they are available as eye drop for allergic conjunctivitis. तो स्प्रिंग कटार या एलर्जिक कंजंक्टिवाइटिस जो है वहाँ पे इसको यूटिलाइज कर सकते हैं, ओलोपैटाडिन एंड एल्केफ्टाडिन. हिस्टामिन के बाद बात करते हैं सेरोटोनिन के, वी हैव अगेन 4 receptor for which we have drug. We have 5-HT1, 5-HT2, 5-HT3, 5-HT4. The first question that is going to be asked, out of all the serotonin receptor which does not act by G protein, let me tell you, 5-HT3 is the one. It is 5-HT3. They are the one that is not acting by G protein couple receptor. 5-HT3 not acting by G protein couple receptor. They are the one that is acting by ion channel or ligand gated receptor. Ion channel or ligand gated receptor. 5-HT3 mainly located at the chemoreceptor trigger zone, causing nausea and vomiting. Therefore, we always give 5-HT3 ka antagonist. What do we give? 5-HT3 ka antagonist. The name of the drug under 5-HT3 antagonists are going to be drugs like your ondansetron, granisetron. All these are going to be setron. Ondansetron, granisetron, palanosetron is very, very potent. Palanosetron is very, very potent. Right? It's very, very potent. They are all going to be 5-HT3 antagonists. They are the drug of choice for any case of nausea and vomiting, and these are also considered the drug of choice for chemotherapy induced nausea and vomiting. CANV is chemotherapy induced nausea and vomiting. So prevention के लिए भी also we can give. Even during infusion, if there is a nausea and vomiting, we can also utilize them, right? Any case of nausea and vomiting, we can use ondansetron, granisetron, or any of the cetrons. 5-HT4, if you are going to pay attention, 5-HT4, this is called 5-HT4. 5-HT4, they are the one that is the only serotonin receptor whose action is mediated by GS. So GS mediated, that means they are stimulatory in nature. They are present at the GIT and they increase the GI motility. 5-HT4 is increasing the GI motility. One 5-HT4 agonist that we are going to use is called prucalopride. I want you to read the name again. The name is called prucalopride, right? Prucalopride. So if they are going to increase the GI motility, we can use it for the treatment of constipation. We can use it where? For the treatment of constipation, right? Constipation that is occurring mainly due to, let's say, irritable bowel syndrome, diabetic gastroparesis, because they are increasing the GI motility, right? Irritable bowel syndrome, diabetic gastroparesis, diabetic mellitus induced constipation, या diabetic gastroparesis, या opioid induced constipation. Opioid induced constipation. In any case of constipation, we can utilize constipation due to irritable bowel syndrome. We have two types of irritable bowel syndrome: diarrhea dominant and constipation dominant, right? Other drugs that we have like cisapride, mosapride, tigacerot. Cisapride, mosapride, remember these drugs are mainly associated with the QT prolongation and we are not using them clinically. And the risk of QT prolongation, risk is further increased with enzyme inhibitor. Risk further increase with the enzyme inhibitors. Enzyme inhibitors. With the enzyme inhibitors, the risks are further going to be increased. Remember that. 5-HT3, 5-HT4. Then we have 5-HT2. Remember, they are mainly utilized in the treatment of psychosis. We have 5-HT2, a blocker usually utilized as antipsychotic, or I would say atypical antipsychotics. There are many drugs that you know about from this group. I can write a few that are coming from the antipsychotic group. For example, drugs like your olanzapine. We have drugs like your olanzapine, right? Other drugs that we have is clozapine, olanzapine, clozapine, right? Quetiapine, right? Quetiapine. So all these are the important 5-HT2 blocker. They are the typical antipsychotics drug. And other drugs that we have like catanserin, ritanserin, they are considered the 5-HT2A 2C blocker. Earlier we use it for the peripheral vascular disease and also in hypertension, right? Third line drug in hypertension also we can utilize. Cyproheptadine, it's one of the antihistaminic drug with, they have antihistaminic property, antihistaminic drug with 5-HT2 blocking property. That means anti-serotonergic property as well. They are the drug of choice for serotonin syndrome. Drug of choice for serotonin syndrome. So who will be the candidate of serotonin syndrome, especially if the patient is on SSRIs, right? Methiserzide, again clinically not used. They are also one of the 5-HT2 blocker. They were earlier they were used in past for the prophylaxis of migraine, methiserzide, but now remember it's clinically not used because they are associated with pleuropulmonary fibrosis. So this question will be asked to you, which of the following does not cause fibrotic reaction? So pleuropulmonary fibrosis is caused by methiserzide. Remember that. You can always take it out that yes, they are the drug that is associated with pleuropulmonary fibrosis, or I would say fibrotic reaction. Pleuropulmonary fibrosis or fibrotic reaction, methiserzide. इसको clinically use नहीं करते. Now see, there is a rule in serotonin that I would always ask you to remember by rule of 5. What does rule of 5 says? In the top here, I have given here the name rule of 5. What does rule of 5 says? Rule of 5 clearly says that for receptor number 1 and receptor number 4, you are supposed to use agonist. You are supposed to use agonist for receptor number 1 and 4. For 2 and 3, you are supposed to use antagonist. As simple as that. So see, 2 and 3, we are going to use antagonist. So 5:2, 5:2 a blocker, we used what? Antagonist, the atypical antipsychotic. But there is an exception to the rule. An exception to the rule is going to be lorcaserin. Lorcaserin is one of the drug, boys and girls, remember, this is going to be one of the 5:2C agonist. राइट, दे आर गोइंग टू बी द एगोनिस्ट. लोड को कम कर देता है, आपके बॉडी को लोड को कम कर देता है. दे आर मेनली यूटिलाइज इन द ट्रीटमेंट ऑफ ओबेसिटी. दे आर यूटिलाइज इन द ट्रीटमेंट ऑफ ओबेसिटी. तो दे आर वन ऑफ द एंटी ओबेसिटी ड्रग, लोरकार्सेरिन. तो ये एक्सेप्शन टू द रूल है, इसलिए डॉटेड लाइन के नीचे है. द नेम ऑफ द ड्रग इज कॉल्ड लोरकार्सेरिन. लोड कम कर देता है. दे आर गोइंग टू बी योर treatment drug utilized for the treatment of obesity. Others are mainly going to be the antagonist. So 1 and 4 ka agonist, 2 and 3 ka antagonist. So this question has also been asked in the past that whether you are using agonist or antagonist. Agonist और antagonist क्या यूज कर रहे हैं. अब आप मुझे बताइए 5:1 का मैंने क्या 5:1 का मैंने क्या बताया था. 1 का क्या यूज करेंगे 1 and 4. व्हाट डज रूल ऑफ 5 सेज 1 and 4 का क्या यूज करना है एगोनिस्ट. तो वी हैव 5:1A, राइट. तो वी हैव 5:1A, ना पार्शियल एगोनिस्ट ऑफ द 5:1A दैट इज अगेन एक्टिंग बाय GI. रिमेंबर दे आर एक्टिंग बाय GI. वी हैव ड्रग लाइक योर ब्यूस्पिरोन. रोने वालों को देते हैं. रोता कौन है? जो एंग्जाइटी में होता है. जेपीरॉन, ब्यूस्पिरोन, जेपीरॉन रोने वालों को देता है. रोता कौन है? जो एंग्जाइटी में होता है. तो वी हैव 5:1A एगोनिस्ट. दे आर मेनली गोइंग टू यूटिलाइज फॉर द ट्रीटमेंट ऑफ एंग्जाइटी. दे आर मेनली गोइंग टू यूटिलाइज फॉर द ट्रीटमेंट ऑफ एंग्जाइटी. ये एंग्जाइटी के लिए यूज किया था 5:1A एगोनिस्ट, ब्यूस्पिरोन, जेपीरॉन. देन वी हैव 5:1B/D एगोनिस्ट. 5:1B/D एगोनिस्ट. Which drug we use for 5:1B/D agonist? Remember, 5:1B/D agonist, the drug that we are going to use are called drug like your sumatriptan, rizatriptan. They are all going to be the triptans. 5:1B/D agonist, they are going to be the triptans. They are the drug of choice for migraine. Simply, drug of choice for migraine. But अगर ये भी पूछे what is the drug of choice for acute severe migraine? Again, the answer remains the same. Acute severe migraine. The answer is again going to be your triptans. They are 5:1B/D agonist. Now, what does the B/D agonist means? If you're going to look at the nerve ending, let's say quickly summarize. There is a nerve ending here that is, let's say, a cranial nerve 5 का nerve ending, trigeminal nerve की nerve ending. And here we have a peptide that is called CGRP. Whenever they are released, they will be causing neurovascular bundle का inflammation, especially cranial nerve 5 nerve ending का, or all the areas that are being innervated by this area, there will be innervation. Therefore, the patient will have pain, headache, and there will be aura as well. Some visual symptom will also be there, nausea and vomiting. Other symptom will also be seen. So do remember this CGRP के लिए we have on the presynaptic neuron something called your 5-HT1, 5-HT1D. And recently we found out one more receptor that we have that is called 5-HT1F. So both are autoreceptor. That means whenever these are going to get stimulated, whenever they will be getting stimulated, they are going to inhibit the release of CGRP. They will send always a inhibitory feedback. They are always going to send what? A inhibitory feedback, inhibitory signal that yes, no need to go. There is excess of CGRP. Whenever CGRP work, they are going to cause neurovascular bundle ka inflammation. Now, one of the variant of this 5-HT1D, which is known as 5-HT1B, they are present also on the blood vessel. Now, try to understand, whenever you give 5-HT1B/D agonist, there is a variant of the same that is available, that is called 5-HT1B. It is present on the blood vessel, and whenever this blood vessel is going to get stimulated, they are going to cause vasoconstriction. What are they going to cause? Vasoconstriction. So always do remember, they are causing what? Vasoconstriction. They are causing what? Vasoconstriction. So when you use 5-HT1B/D agonist, what is one problem? That this migraine wali drug, they can cause vasoconstriction. So this migraine wali drug, this all the triptans, these are going to be associated with precipitation of MI. They are going to be associated with precipitation of MI, they can actually precipitate what? MI. ये MI को precipitate कर सकते हैं. They can precipitate MI, right? So there is always going to be a question that, okay, there is a patient having this problem and he's having history of MI. Which migraine drug should be given with precaution? Students usually go for, you know, little other drugs. यार migraine है तो triptan तो देंगे ही, but always remember triptan should be, you should be avoiding this. Rather than that, triptans, which is 5-HT1B by agonist, because it will be acting here and here. Rather than that, you can give something called your 5-HT1F agonist, because 1F clearly says that 1F, I will not give the F. ये F जो है किसको नहीं देगा? ब्लड वेसल को नहीं देगा. It will not give the F to the blood vessel. It will not give the F to the blood vessel. So we have a new drug that is called 5-HT1F agonist. We have a new drug that is called 5-HT1F agonist. The name of the drug is called lasmiditan. The name of the drug is called lasmiditan. तो इसके नाम में देखिए सब कुछ लिखा हुआ है. लेस MI देता है, lasmiditan. So can we also use it in acute severe migraine without precipitating MI? Yes. 5-HT1F agonist. It does not give the F innervation to the blood vessel. Blood vessel पे नहीं जाता है. Therefore, it can also be utilized in the migraine. Yes, that's absolutely correct. Right? And remember, they do not precipitate MI or any cardiac event. They do not precipitate MI or any cardiac event. Lasmiditan. All right. So ये हो गया आपके 4 important histaminic एंड सेरोटोनर्जिक रिसेप्टर. देखो सेरोटोनिन के एक बार क्विकली रिकैप करेंगे फॉर ऑल माय स्टूडेंट दोज आर लिसनिंग टू मी. देखिए पढ़ना तो पढ़ चुके हो, रिवाइज भी कर चुके हो, लेकिन एक बार फिर से रिवाइज कर लेते हैं रिवाइज में भी. राइट? हाउ मेनी सेरोटोनिन रिसेप्टर डिड आई टेल यू? ऑल ऑफ यू प्लीज गेट एक्टिवेटेड. हाउ मेनी सेरोटोनिन रिसेप्टर डिड आई टेल यू? 4 receptor, 1 2 3 4. Out of these, which serotonin receptor does not act by G protein? That is 5-HT3. 5-HT3 वाले drug 5-HT3 का antagonist, that is cetron, non-cetron, granicetron, pranacetron. Remember I told you there is a rule called rule of 5. This is just a mnemonic purpose only. 1 and 4 का we are going to use agonist, 2 and 3 का we use antagonist. 5-HT4 is mediated by GS, and we have drug like prucalopride. That is the only one. Only problem with the prucalopride recently that we have noted, I would just write here in note that remember prucalopride as a drug that is utilized for prokinetic property and a diabetic gastroparesis and any other condition. Prucalopride is one of the drug. They are mainly associated with increase in the suicide ideation. They are actually associated with increase in the suicide ideation. तो suicidal tendency, suicide ideation को ये बढ़ा देते हैं. तो whenever a person is on prucalopride, they should always be given this important instruction. दवा लेने के बाद कुछ समय बाद अगर आपको ऐसी फीलिंग आती है, ऐसी सोच आती है, तो प्लीज रिफर बैक टू योर डॉक्टर. है ना? ऐसा हो सकता है कि ये दवा का साइड इफेक्ट हो. सो विच सेरोटोनिन वाले ड्रग कैन बी एसोसिएटेड विद सुसाइड आइडिएशन? दैट इज गोइंग टू बी 5-HT4 agonist. क्लियर है? 5-HT2 atypical antipsychotics, all the clozapine, olanzapine, and 5-HT1, 1A and B by D. 1A, A for anxiety, we use it for the treatment of anxiety, and 1B by D, this is going to be 5-HT1B by D. 5-HT1B by D, they are triptans that are utilized in the migraine. Right. तो ये हो गया आपके इंपॉर्टेंट क्वेश्चन. नाउ देखते हैं सारे क्वेश्चन ये कौन कौन इसी से रिलेटेड क्वेश्चन है. इनवर्स एगोनिस्ट ऑफ H3 that is used for the narcolepsy. H3 is acting by GI. Inverse agonist is going to be drugs like your tiprolisant and other one is called pitolisant. तो फटाफट अब ये सारे क्वेश्चन आपके निकल जाएंगे. Which antihistaminic drug is having maximum antihistaminic and anticholinergic property? एक बड़ा ही प्रोएक्टिव ड्रग है, अपने आप को बहुत ही एक्टिव मानता है, उसको बोलते हैं प्रोमेथाजीन. Promethazine is also utilized in motion sickness, right? Promethazine. Least sedative antihistaminic. Overall, least sedative antihistaminic drug. Overall, it is actually going to be your fexofenadine. Overall, it is going to be fexofenadine. Overall, least sedative antihistaminic drug is going to be fexofenadine. They are the one that is preferred in truck drivers and pilots. Estemizole terfenadine is because of the QT prolongation. For allergic conjunctivitis, ocular या आँखों के लिए, right? So we have olopatadine, and we have 𝐿-ceftadine. Olopatadine and we have 𝐿-ceftadine आँखों के लिए, that is going to utilize for allergic conjunctivitis. Which 5-HT2C agonist utilized for obesity? 5-HT2. Remember what is the rule of 5 says? The rule of 5 says 1 and 4 का use agonist, 2 and 3 का you use antagonist. तो 5-HT2 का usually antagonist, लेकिन exception to the rule is lower carcerine, जो लोड को कम कर देता है, that is going to be your lower carcerine. Triptans act on which receptor? That is going to be 5-HT1B/D agonist. Drug of choice for chemotherapy induced vomiting, that is going to be 5-HT3 antagonist. We have drugs like your ondansetron, granisetron, pelanosetron. किसी के नाम में सेट्रॉन आएगा, इसके नाम में सेट्रॉन आएगा. ondansetron, granisetron, pelanosetron, right? They are all going to be setrons. Methotrexate, क्या मैंने बताया था? They are causing what? Pleuropulmonary fibrosis. They are going to cause pleuropulmonary fibrosis. Prostaglandins का precursor. Okay. So ये थोड़ा सा पैथोलॉजी भी हो जाएगा. Prostaglandin का precursor क्या होगा? What is the precursor of prostaglandin? So you see, we have phospholipid that is getting converted to phospholipase A2, and with the help of different enzyme, they are going to get converted to either a prostaglandin or either your leukotriene, prostaglandin or either leukotriene. Are you guys following me here? Right? So we have phospholipid that is getting converted to arachidonic acid with the help of phospholipase A2. So phospholipase A2 is the mediator. इससे क्या बनता है? Arachidonic acid, and with the help of enzyme like COX and with the help of LOX, they are going to get converted to leukotriene. तो अगर क्वेश्चन पूछा what is the precursor of prostaglandin, so immediate precursor is always going to be arachidonic acid. Immediate precursor is going to be arachidonic acid. And अगर मैं पूछूं which drug inhibit the prostaglandin synthesis, so it's going to be COX inhibitor, right? So COX inhibitor, they are actually going to be all the NSAIDs, non-steroidal anti-inflammatory drugs. They are going to act as an inhibitor of the prostaglandin synthesis. Effect of prostaglandin in fetus. So fetus में they maintain the ductus arteriosus patency. They are going to do what? Maintain the ductus arteriosus patency. Maintain the ductus arteriosus patency. To maintain the patency of ductus arteriosus. Which prostaglandin analog used for cervical ripening? So we can utilize misoprostol. We can utilize misoprostol and mifepristone. They are the highly effective drug utilized for the MTP, medical termination of pregnancy, first trimester, right? जितने भी फर्स्ट ट्राइमेस्टर मेडिकल टर्मिनेशन प्रेगनेंसी होते हैं, मोस्ट प्रेफर्ड इज गोइंग टू बी मीफेप्रिस्टोन एंड मिसोप्रोस्टोल. मिसोप्रोस्टोल एंड मीफेप्रिस्टोन. मीफेप्रिस्टोन का एक्सपेरिमेंटल नेम वाज RU486. समटाइम वी आल्सो यूज दैट. Which prostaglandin analog used for IBS with constipation? IBS with constipation के लिए the drug that we are going to use is called lubiprostone. ये lubricate कर देता है, lubiprostone. So they are one of the prostaglandin E1 analog. They open the luminal chloride channel. They are acting by opening the luminal chloride channel. They are going to act by opening the luminal chloride channel. Luminal मतलब lumen, intestine के lumen की तरफ जो chloride channel होता है, they will be opening by luminal chloride channel that is leading to chloride influx. They will be leading to chloride influx. Once the chloride goes inside, right, they will be causing passive drive of water. Right, chloride goes inside, they will be causing passive drive of water. Right, so these are the important serotonin and these are the important histamine that we have covered. Now immunomodulators quickly हम देख लेते हैं and कुछ other disease related to the COX and LOX. One of which will be gout and rheumatoid arthritis. So a quick summary on the drugs that are used for the treatment of the gouty arthritis. See, whenever the patient comes to you in the acute scenario of gouty arthritis, the main problem is pain and inflammation. So the drug of choice for acute gout, our main focus is the pain. Our main focus is the inflammation which is ongoing. So we do not, we are not targeting uric acid level right now. Although the main problem is because of uric acid, still we are not targeting uric acid right now. The drug of choice is going to be NSAIDs because patient is there in pain due to inflammation. NSAIDs are going to be non-steroidal anti-inflammatory drug. They are going to be the COX inhibitor. They are going to be what? The COX inhibitors. So they are the main drug. I mean, in the acute scenario, exception to the rule, except your aspirin. Aspirin inhibit the uric acid excretion. Aspirin की वजह से uric acid का level उल्टा और बढ़ जाता है, right? So NSAIDs are the important drug that can be utilized. If it is non-responsive to NSAID, then we can actually add what? Steroids. then we can add what? Steroids can be added. And अगर इससे भी काम नहीं चला, NR means non-responsive, this NR is always going to be for non-responsive. अगर इससे भी काम नहीं चला, then we can add colchicine. It's a very specific drug. Colchicine is a very specific drug for, it's a very specific drug for, you know, gout. It's a very specific drug for gout. C for colchicine, remember, they are going to be the chemotaxis inhibitor. They are going to be what? Chemotaxis inhibitor. C for colchicine, C for chemotaxis inhibitor, right? Colchicine is not commonly utilized. What is the reason? Because this colchicine as an agent, they are associated with bone marrow suppression. They are associated with problems like Stevens-Johnson syndrome, bone marrow suppression, Stevens-Johnson syndrome, right? And they can also lead to other problems like hypersensitivity reaction, abdominal pain, GI side effect like nausea, vomiting, diarrhea, abdominal pain. So they are having all these side effects. So because of hypersensitivity reaction, GI side effect, we do not prefer colchicine in the acute scenario, right? So remember, acute gouty arthritis में हमारा main समस्या इसमें है पेन एंड इन्फ्लेमेशन विच इज ऑनगोइंग, हमें उसको टारगेट करना है. इन ए क्रोनिक गाउट नाउ वी वांट टू टैकल द लेवल ऑफ यूरिक एसिड. सो वी कैन डिक्रीज द यूरिक एसिड लेवल बाय मल्टीपल मोडालिटी. वन इज यू आर सपोज टू डिक्रीज द यूरिक एसिड लेवल by decreasing the uric acid ka synthesis, and that can be done by giving your patient something called your xanthine oxidase inhibitor. Xanthine oxidase is the rate limiting enzyme. Xanthine oxidase inhibitor, we have drugs like your febuxostat. कौन कौन से ड्रग होते हैं? There is a very famous drug that is called your febuxostat, xanthine oxidase inhibitor. So they are mainly, अगर मैं बोलूँ एक्यूट के लिए कौन सा होगा, सो दैट इज गोइंग टू योर एनसेट, है ना. एनसेट लाइक आइबुप्रोफेन दैट वी नो, है ना. एनसेट्स और भी जितने भी एनसेट्स दैट डाइक्लोफेनाक एनसेट है ना, उनको हम यूज़ कर सकते हैं. You can decrease by giving xanthine oxidase inhibitor. You can decrease by giving xanthine oxidase inhibitor. You can also decrease the uric acid का level by increasing the uric acid का excretion. So you can increase the uric acid का excretion, and when you increase the uric acid का excretion, we call such drug as uricosuric drug. हम इस drug को क्या बोलेंगे? Uricosuric. We are going to increase the uric acid का excretion, uricosuric drug. So these drugs are going to be drugs like your probenecid. ये कौन से drug होंगे? Probenecid, right? Probenecid, lesinurad, benzbromarone, right? Probenecid, lesinurad, benzbromarone, sulfinpyrazone. So these are all going to be the uricosuric drug, right? Uricosuric drug. Or you can also decrease the uric acid level by increasing the uric acid ka metabolism, right? Increasing the uric acid ka metabolism. So which drug can increase the uric acid ka metabolism? We are going to call this drug as a recombinant uricase. They will cause mainly breakdown of uric acid. ये uric acid का जो breakdown है, इसको तोड़ेंगे. Uric acid का breakdown into water soluble metabolite that is called allantoin. Allantoin is one of the water soluble metabolites that can easily get excreted, right? They are easily going to get excreted. Okay, they are easily going to get excreted. So what are the recombinant uricase drug that we know? What are the recombinant uricase? That is going to be, right, recombinant uricase, RAS buricase, pegloticase. We have drug like your RAS buricase, and other one is called your pegloticase. I want you to go through this all again, right? RAS buricase and pegloticase are the name of the drug. RAS buricase and pegloticase. Okay. So we have drugs that are going to be chronic gout के लिए febuxostat, allopurinol. These are the important drugs, है ना, decreasing the uric acid का synthesis. We have febuxostat, allopurinol भी होता है. एक और ड्रग लिख लीजिए इसमें, allopurinol. Allopurinol, febuxostat, they are the drug of choice in chronic gout. They are the drug of choice in chronic gout. Additionally, you can also increase, the therapy by increasing the excretion. For increasing the excretion, you can use uricosuric drug, probenecid, lesinurad, sulfenparazone, right? Benzbromarone, and increase the uric acid excretion by giving rasburicase pegloticase acid. Remember, rasburicase pegloticase acid, they are very fast acting drug, right? So therefore they can also be utilized in tumor lysis syndrome. Rapid reduction in uric acid level and rapid reduction in uric acid in tumor lysis syndrome in done by. So again, this can also be utilized in tumor lysis syndrome also. And in tumor lysis syndrome also we can utilize these important drugs. I hope it is making sense to all of you. Okay. Now, if we are going to talk about the drug that is called your rheumatoid arthritis. So again, remember rheumatoid arthritis में we can use NSAIDs, but ध्यान रखिएगा ये एक immune mediated condition, autoimmune condition है, तो we will be using two important drugs. One is called methotrexate and other immunomodulators that we have. Methotrexate को हम दो वजह से यूज करते हैं. One of the very important reason why we are using methotrexate is going to be your dihydrofolate reductase inhibitor. Please remember that in rheumatoid arthritis, the patient is going to have early morning joint stiffness, pain, है ना, small joints को involve करते हैं, पेन, स्टिफनेस. और आपको ऑर्थोपेडिक्स में अभी थोड़ी देर पहले ही ऑर्थोपेडिक्स हुआ है, जिसमें आपको पढ़ाया गया होगा स्वान नेक डिफॉर्मिटी, बॉटनिया डिफॉर्मिटी, है ना, पढ़ाया गया होगा. So methotrexate, again, they are going to decrease the purine and pyrimidine synthesis because they will not allow the folic acid formation. Second reason why we are using is another reason why we are using methotrexate because of this anti-inflammatory action, because of its anti-inflammatory action. So how will they cause anti-inflammatory action? This anti-inflammatory action is going to be seen mainly anti-inflammatory action is mainly going to be seen due to inhibition of AICRT inhibition of AICRT, they will have anti-inflammatory role, anti-inflammatory action. Now let me go a little deep in this one because many times students will be messaging me, sir anti-inflammatory वाला एक बार जल्दी से बता दीजिए. तो मैं चाहता हूँ कि आप यही बता दे रहा हूँ, आप इसको जितनी बार चाहें उतनी बार रोक के समझ सकते हैं. फर्स्ट एंड फॉरमोस्ट रिमेंबर व्हाट इज AICRT. AICRT का मतलब क्या हुआ? इट इज गोइंग टू बी अमाइनो. It is going to be AICRT, amino. I stand for imidazole, amino imidazole, carboxamide, right? Amino imidazole, carboxamide, ribonucleotide, right? Ribonucleotide, right? Transformylase, ribonucleotide transformylase, right? T stand for transformylase. Now I want you to understand that what is the purpose of this AICRT. AICRT का काम क्या है, राइट? उसको समझने के लिए एंटी इन्फ्लेमेटरी को थोड़ा सा जाते हैं कि कैसे एंटी इन्फ्लेमेटरी एक्शन हो रहा है, राइट? एंटी इन्फ्लेमेटरी एक्शन कराने के लिए आई वुड जस्ट से फॉर यू टू कॉज द एंटी इन्फ्लेमेटरी एक्शन, you have to first understand कि in our body there is something called adenosine. It is the role of adenosine. पहले समझ लीजिए फिर लिख लीजिएगा. It is the adenosine which is having this anti-inflammatory action. Adenosine usually have anti-inflammatory property. And what kind of anti-inflammatory property it is going to do? It is going to inhibit the chemotaxis. Okay, agreed, very good. Chemotaxis is one of the anti-inflammatory property, right? Other क्या कर सकते हैं? Inhibit the cytokine release plus inhibiting the neutrophils. They inhibit the neutrophils as well, right? Inhibit the neutrophils and inhibit the macrophages. The problem is ये सारे के सारे anti-inflammatory action of adenosine is very much favorable for us, but the problem is ये problem ये है इनके साथ that they are going to get metabolized. They are going to get what? Metabolized. So anti-inflammatory action तो बहुत अच्छा था, but these are actually going to get metabolized. ये usually metabolize हो जाते हैं with the help of an enzyme. With the help of an enzyme, adenosine deaminase. So there is an enzyme here by the name of ADA, adenosine deaminase. Adenosine deaminase, they are going to get metabolized. Adenosine deaminase की मदद से क्या हो जाते हैं, ये मेटाबोलाइज हो जाएंगे. अब AICR की कहानी देखते हैं. हमारी बॉडी में वी हैव AICR. व्हाट इज AICR? मैं इसको फिर से बता दे रहा हूँ. अमाइनो इमिडाजोल कार्बोक्सामाइड राइबोन्यूक्लियोटाइड, AICR. AICR अगेन बैलेंस करके रखता है. कैसे AICR कैसे बैलेंस करके रखता है? AICR इज एक्चुअली हैविंग इनहिबिटरी एक्शन एट एडिनोसिन डीएमिनेज. ये क्या करता है? AICR इज एक्चुअली हैविंग इनहिबिटरी एक्शन एट द ADA एडिनोसिन डीएमिनेज. ये तो बहुत अच्छी बात है. तो AICR अगर ये इनहिबिट करता है तो सबसे अच्छी बात तो है ना कि एडिनोसिन का लेवल बढ़ा के रखेगा और एंटी इन्फ्लेमेटरी एक्शन आएगा, लेकिन ये लंबा नहीं चल पाता है. इट डज नॉट एक्ट लॉन्गर. वाई? बिकॉज अगेन AICR it rapidly get metabolized. It is the AICR that is having rapid metabolism with the help of an enzyme that is called AICRT. AICART. Amino imidazole carboxamide ribonucleotide transformylase is the enzyme that is not allowing the longevity of AICR. AICR को जीने नहीं दे रहा है. कौन नहीं जीने दे रहा है? AICRT. Because if AICR would live longer, then adenosine ka level would always be high, and this adenosine is going to produce the anti-inflammatory action. Adenosine would produce what? Anti-inflammatory action. I want you to understand that when I gave methotrexate ने यही काम किया था. It is the methotrexate that inhibited the AICRT. Methotrexate inhibited the AICRT. अब सोच के बताइएगा, अगर AICRT को methotrexate बढ़ा दे, अमाइनो इमिडाजोल कार्बोक्सामाइड राइबोन्यूक्लियोटाइड ट्रांसफॉर्माइलेज, then the level of AICR would increase. और जो इनहिबिटरी एक्शन ऑफ द एडिनोसिन डीएमिनेज था वो कंटिन्यू होता रहेगा, एंड देयरफॉर देयर विल बी इंक्रीज इन द लेवल ऑफ एडिनोसिन. देयर विल बी इंक्रीज इन द लेवल ऑफ एडिनोसिन दैट विल हैव एंटी इन्फ्लेमेटरी प्रॉपर्टी. देयर विल हैव anti-inflammatory property. Are you guys following me here? So the anti-inflammatory action is mainly inhibition of cytokine release, neutrophils, macrophages, all these noted with the methotrexate because of the AICRT inhibiting property. I hope all of you guys have got this one. एक लाइन में बोलूँगा, due to inhibition of AICRT, there will be increase in the level of AICR, that is amino imidazole carboxamide ribonucleotide, which inhibit the ADA enzyme, and adenosine level will be increased. That will continue to have anti-inflammatory property. Other drug that we can use will be sulfasalazine, D-penicillamine. Leflunomide is a very fast acting, and other one is called azathioprine, which is among the second line drug, right? So इनको बोलते हैं, currently we call them SARDs. SARDs, that is going to be slow acting anti-rheumatoid drugs. SARDs का मतलब क्या हो? Slow acting anti-rheumatoid drug. Slow acting anti-rheumatoid drug, SARDs. ठीक है. पहले इसी को हम DMRs बोलते थे. Same drug was earlier known as DMRs, that is disease modifying anti-rheumatoid drugs. इसको हम पहले DMRs बोलते थे. Now we call them SARDs. ठीक है. Other immunomodulators that we can use will be your calcineurin inhibitor that inhibit the activation of interleukin 2. They inhibit the interleukin 2 ka activation. This calcineurin 2 inhibitor that can also be utilized, and but question here is which calcineurin inhibitor is causing gum hypertrophy and hirsutism. So the calcineurin inhibitor that is causing gum hypertrophy specifically अगर ये पूछ रहा है, so this will be none other than your cyclosporine. Because when you look at the calcineurin inhibitor, there are two types of calcineurin inhibitor. One is called your cyclosporine, tacrolimus. Cyclosporine and tacrolimus. They are the calcineurin inhibitor. Then we have other mTOR inhibitor, right? That is going to be sirolimus, everolimus, mammalian transcription rapamycin, sirolimus and everolimus. They inhibit again activation of the pro-inflammatory cells. TNF alpha, again anti-inflammatory drug, TNF alpha. So I say TNF alpha drugs are remembered with the simple mnemonic of ICE and AG. ICE and AG, that is going to be ICE, infliximab, certolizumab, etanercept, adalimumab, and other one is called golimumab. Other one is called golimumab. So we have ICE and ARG. They are the TNF alpha inhibitor. They have multiple uses. One of the uses are also going to be rheumatoid arthritis. Interleukin 1 A is the first letter. So one inhibitor will be anakinra. So A interleukin A is the first letter जो कि rheumatoid arthritis में use करते हैं. They are known as your anakinra. Interleukin 1 inhibitor will be anakinra. Then we have interleukin 2 inhibitor. 2 से याद रखना second letter, that is going to be B basiliximab, and we have daclizumab. Basiliximab and D से daclizumab. So we have B basiliximab, D से 2 होता है, daclizumab. They are the interleukin 2 inhibitor. Now there are two questions. Question number 1: which inhibit the interleukin 2 inhibitor, that is daclizumab, basiliximab, right? Which inhibit the interleukin 2 activation, that is going to be cyclosporine and tacrolimus. They are going to be the calcineurin inhibitor. This calcineurin inhibitor, they are going to inhibit the interleukin 2 ka activation. Remember, out of them, which one is causing gum hypertrophy and hirsutism, that is going to be cyclosporine. Interleukin 6 inhibitor, so I always say very fondly, my student, remember interleukin 6, not as interleukin 6. They say the name of the drug will be tocilizumab, and they say this tocilizumab is actually not a tocilizumab. ये tocilizumab को tocilizumab नहीं बोलते हैं. They say tocilizumab as tocilizumab. What do they say? Tocilizumab. Please tell me and read it out with me. It is called tocilizumab. There is a 6 here. Tocilizumab. It is called tocilizumab. There is another one from the same, that is S for 6. It is called sarilumab. Interleukin S6. Tocilizumab and sarilumab. Co-stimulation inhibitor that inhibit the T cell activation. They inhibit the T cell activation. Abatacept and belatacept, they inhibit the T cell ka activation. Abatacept, belatacept, right? That is coming between CD28 and CD80, right? So we have two important drugs here that I want you to remember at any given time. One is TNF alpha inhibitor. They are going to be ICE and ARG. Simple question will be asked, which of the following the TNF alpha inhibitor, that is going to be ICE, and अगला होगा ARG, infliximab, satolizumab, etanercept. ARG will be adalimumab, golimumab. Interleukin 1A is the first letter, anakinra. 2 B is the second letter and D से होता है 2. Interleukin 6 will be tocilizumab and S से 6 होता है sarilumab. Abatacept, belatacept, they are the drug that are going to act as a co-stimulation inhibitor. एक और drug है जो इसमें हम यूज कर सकते हैं, that is going to be your anti-CD20 monoclonal antibody is called your rituximab, rituximab, and other one is called your ofatumumab, rituximab and ofatumumab. So ध्यान रखिएगा, there is someone by the name of रितु. ये रितु जो है वफा नहीं करती है. रितु वफा इसलिए नहीं करती है बिकॉज उसको पता ही नहीं है वफा क्या होता है. रितु इज वेरी यंग. रितु डज नॉट नो व्हाट इज वफा. दिस यंग रितु डज नॉट नो वफा. तो किसी ने पूछा व्हाट वाज द एज ऑफ रितु, तो आपको पता ना कि 20 ईयर की रितु है. रितु को वफा नहीं आता है. रितु डज नॉट नो वफा, राइट? रिटुक्सिमाब, ओफाटुमुमैब, they are the two important drugs that are coming under your anti-CD20 monoclonal antibodies. Okay. इंपॉर्टेंट इम्यूनोमोडुलेटर्स क्वेश्चन बार बार आपके एग्जाम में रहते ही रहते हैं. सॉर्टेड है. नाउ नेक्स्ट क्वेश्चन जो मैं आपके साथ नेक्स्ट टॉपिक जो डिस्कस करने वाला हूँ, अगेन एक हाई यील्ड टॉपिक है, दैट इज गोइंग टू बी पॉइजनिंग्स एंड मैनेजमेंट. आप देखोगे कि हम लोग यूजुअल टॉपिक जैसे मान लीजिए फार्मा स्टार्ट होता है तो हम आगे से शुरू करते हैं ना. आगे से मतलब जनरल फार्मा करते हैं, एएनएस करते हैं. वी विल डू दैट ऑल्सो, वो भी हम करेंगे. लेकिन जो आगे से शुरुआत होता है जनरल फार्मा, ऑटोनॉमिक नर्वस सिस्टम और ये सब कार्डियो, सीएनएस, हम वहाँ से नहीं कर रहे हैं. हम कर रहे हैं एकदम जहाँ से क्वेश्चन आते हैं ना, ऑटोकॉइड्स, इम्यूनोमोडुलेटर्स, हिस्टामिन, सेरोटोनिन, माइग्रेन में कौन सा ऐसा मेडिसिन है जो कि एमआई प्रेसिपिटेट करेगा, है ना. देन आई हैव आल्सो 25HT1F एगोनिस्ट लेस मिरिटेंट. तो ये सारे चीज़ें हैं. देन पॉइजनिंग्स एंड मैनेजमेंट. अलग अलग पॉइजनिंग के अलग अलग प्रेजेंटेशन होते हैं और डिफरेंट टाइप के ड्रग्स हमारे पास अवेलेबल है. तो यूजुअली आपके पास पेशेंट आएगा और फार्मर की हिस्ट्री होगी. बोलेगा फार्मर फ्रॉम द फील्ड. तो इट कुड बी मोस्टली अ केस ऑफ ऑर्गेनोफॉस्फेट एंड कार्बामेट पॉइजनिंग. फॉर द ऑर्गेनोफॉस्फेट एंड कार्बामेट पॉइजनिंग आई वांट यू टू अंडरस्टैंड दैट दिस ऑर्गेनोफॉस्फेट कार्बामेट, दे आर द irreversible acetylcholine esterase inhibitor and there will be increase in the level of acetylcholine. So acetylcholine का level बहुत ज़्यादा बढ़ जाता है. The level of acetylcholine is very very high and because of this high level of acetylcholine patient will usually have cholinergic symptom. Now there are lot of symptoms that we used to teach in the usual classes जिसको हम बोलते हैं, याद करिए, sludge pneumonic से salivation, lacrimation, urination, diarrhea, GI distress, all those. लेकिन अभी रिवीजन के लिए मैं इतना पढ़ने के लिए नहीं बोलूँगा, मैं बोलूँगा कि बड़े स्पेसिफिक तरीके से आपको ध्यान रखना है कि whenever the patient comes you have to look first in the eyes, right? उनकी आंखों में देखिए, right? Look in the eyes because eyes never lies. आंखें कभी झूठ नहीं बोलती है, मेरी बात को ध्यान सुनिएगा, right? सबसे पहले आंखों में देखेंगे बिकॉज ऑफ द एक्सेस acetylcholine there is going to be meiosis, there is going to be excessive meiosis and sometimes this excessive meiosis is also given the name as a pin पॉइंट प्यूपिल. तो एक फार्मर का हिस्ट्री होगा पिन पॉइंट प्यूपिल, बिकॉज अगर एक ड्रग एडिक्ट पिन पॉइंट प्यूपिल के साथ आता है तो कहानी पूरी चेंज होगी. दिस विल बी हिस्ट्री ऑफ अ फार्मर, ऑलवेज रिमेंबर गाइस, देयर विल बी हिस्ट्री ऑफ अ फार्मर. फार्मर की हिस्ट्री पिन पॉइंट प्यूपिल. सबसे पहले देखा आपने आंखों में, राइट? देन यू विल लुक एट द अदर सिक्रीशन. सो बॉडी के अदर सिक्रीशंस भी बढ़े होंगे बिकॉज ऑफ द एस्टाइलकोलिन. सिक्रीशन वुड एक्चुअली बी increase, right? Secretion increase and because of this excessive secretion, अगर मैं body की secretion की बात करूँ तो body की secretion is increased and because of the excessive secretion of the body which is increased, the body temperature would actually be lesser. Body temperature would be either normal or lesser, कम होगा बिकॉज अगेन ज़्यादा सिक्रीशन होगा तो सिक्रीशन से बॉडी टेम्परेचर कम होता है, ये बात आपको पता है, राइट? सो वी हैव सिक्रीशन. देन यू लुक एट द हार्ट रेट. Then you look at the heart rate. इसमें because of the excessive acetylcholine, heart rate will also be lesser. Decreased heart rate, that would be known as your bradycardia. Again, मैंने क्या बोला कि you have to look first in the eyes. Eyes never lies. आँखें हमेशा सच बताती हैं. तो there will be pinpoint people. Okay, secretion बढ़ा होगा जिसकी वजह से body temperature कम हो सकता है, heart rate भी कम होगा. तो organophosphate carbamate, they are the irreversible acetylcholine esterase inhibitor. The level of acetylcholine is high. Therefore, अगर पूछता है examiner आपसे how will you manage? So the specific antidote for this one is called your atropine. Specific antidote for this one is called atropine. In organophosphate, after this, in organophosphate we can also add oximes. Please remember, oximes को काम करने के लिए एक anionic site available होना चाहिए, which is only present in the organophosphate. Carbamate में available नहीं होता है. Carbamate occupied both anionic and acidic site, which you have read also in your general pharma, right? Atropine, organophosphate, right? Atropine is the antidote. This is known as the antidote. Atropine is the specific antidote. उसके बाद से after that next is in organophosphate we can add oximes like your pralidoxime, obidoxime. These are all going to be the oximes. Pralidoxime, obidoxime, इनके नाम में oxime आता है, pralidoxime, obidoxime, right? देन एट्रोपिन पॉइजनिंग या इसी का एक और आएगा दतूरा पॉइजनिंग, बिकॉज दतूरा का भी एक्टिव कंपोनेंट एट्रोपिन ही होता है. दोनों का प्रेजेंटेशन सेम होगा. एट्रोपिन और दतूरा पॉइजनिंग, इसका प्रेजेंटेशन भी सेम होगा. दे आर द नॉन सेलेक्टिव मस्करनिक एंटागनिस्ट. They are acting as a non-selective muscarinic antagonist. Think and tell me, because of the non-selective muscarinic antagonist property, because of this non-selective muscarinic antagonist property, patient का क्या क्या symptom आएंगे? मैंने बोला कहाँ से देखना शुरू करेंगे? Eyes, because eyes never lies. आंखों में देखिए. If you are going to look at the person, इसमें आएगा history of a person consumed some fruit product, all right, some fruit from a plant, है ना? There will be history of consumption of a fruit. अभी रिसेंटली मैं देख रहा था कि समवन सेड कि किसी इन्फ्लुएंसर ने, है ना, सोशल मीडिया किसी इन्फ्लुएंसर ने कुछ बता दिया कि ये पत्ते देख रहे हो, ये पत्ते देखो आपके घर के आसपास होगा या आपके कहीं होगा, उससे लेकर के आप खाने में मिला के और खा लो, डिटॉक्स हो जाएगा बॉडी आपका, है ना. तो देयर वाज अ ग्रुप ऑफ पीपल, आई थिंक दे कंज्यूम्ड दतूरा का बेसिकली प्लांट प्रोडक्ट था वो. दे पुट दैट इन देयर इन देयर दाल, है ना, और अपने दाल में उसको डाल के खाया एंड देन दे एंड अप विद द एट्रोपिन पॉइजनिंग, दतूरा पॉइजनिंग. तो ध्यान रखिएगा, ये सोशल मीडिया जो इन्फ्लुएंसर्स होते हैं उनसे इन्फ्लुएंस नहीं होना. उनका नाम है इन्फ्लुएंसर, उनका काम ही है इन्फ्लुएंस करना आपको, लेकिन आपको इन्फ्लुएंस नहीं होना है, स्पेशली एज एट ए लेवल ऑफ डॉक्टर्स. नो, आपको तो बिल्कुल ही नहीं होना है. एनीवेज, सो नॉन सेलेक्टिव मस्करनिक एंटागोनिस्ट आंखों में देखोगे तो अगेन एंटीकोलिनर्जिक एक्टिविटी की वजह से नाउ आंखें हो जाएंगी बड़ी बड़ी, माइड्रियासिस, है ना, माइड्रियासिस. देन you are going to look at the body secretion. अगर बॉडी का सिक्रीशन देखोगे तो वो कम हो जाएगा, जिसकी वजह से व्हाट विल हैपन टू द बॉडी टेम्परेचर, बॉडी टेम्परेचर बढ़ जाएगा ना, एट्रोपिन फीवर। तो इसमें हर चीज़ देखिए बड़ा बड़ा, आंखों का साइज भी बड़ा बड़ा, बॉडी टेम्परेचर भी बड़ा बड़ा, एंटीकोलिनर्जिक प्रॉपर्टी की वजह से हार्ट रेट भी देखेंगे तो हार्ट रेट भी होगा बड़ा बड़ा। एट्रोपिन में देखिए क्या क्या है बड़ा बड़ा, आंखें हैं बड़ी बड़ी, बॉडी टेम्परेचर बड़ा बड़ा, हार्ट रेट भी बड़ा बड़ा, है ना। तो एट्रोपिन दतुरा ऐसे प्रेजेंट करेंगे। तो मैं बोलता हूँ कि मेरे स्टूडेंट इसको एट्रोपिन मत बोलो, इसको बड़े प्यार से आप एटोपिन बोलो ना। हर चीज़ इसमें टॉप पे है, चाहे आंखों की साइज हो या बॉडी टेम्परेचर हो या हार्ट रेट हो। The antidote that we know for the management antidote is called your physostigmine. This was a question that was also asked. You will expect all these questions. Physostigmine is the antidote. Then there is next going to be history of a drug addict. तो आएगा कि एक पेशेंट को नाले से उठा के लेकर आया, या दिस क्वेश्चन हैज बीन आस्क्ड, द वर्ड दैट आई एम यूजिंग, है ना, गटर से के पास से ले आया, या दे विल गिव द क्वेश्चन कि पेशेंट को रेलवे ट्रैक से लेकर आया, स्ट्रीट से उठा के लेकर आया, ऐसे करके क्वेश्चन रहेगा, राइट। सो ओपियोइड में यूजुअली ध्यान रखिएगा, देयर विल बी हिस्ट्री ऑफ अ ड्रग एडिक्ट। तो ये आपको क्लिनिकल लाइन्स ऐसे मिलेंगे, हिस्ट्री ऑफ अ ड्रग एडिक्ट। ओपियोइड पॉइजनिंग की अगर मैं बात करूँ, हिस्ट्री ऑफ अ ड्रग एडिक्ट में अगेन आंखों में देखना है, मैंने बताया था आइज नेवर लाइज। सो व्हेन यू लुक एट द हार्ट रेट, opioid usually in the high dose they will have cardiac depression property, so heart rate will be lesser, decrease in the heart rate, and BP will also be lesser। तो cardiac depression property की वजह से BP और heart rate दोनों ही कम होगा, cardiac depression property की वजह से BP और heart rate both will be lesser। Then I want you to look at the eyes, है ना, सबसे पहले तो आंखों को देखना है ना, हार्ट रेट तो लेसर होगा, अग्रीड। आई वांट टू लुक इन द आई, सबसे पहले आंखें देखेंगे। Opioid usually in the high dose, it can also cause pinpoint pupil. They will usually act via Edinger-Westphal nucleus, है ना, via Edinger-Westphal nucleus they will stimulate cranial of 3 activity, and the cranial of 3 activity they can cause, you know, meiosis। So excess meiosis will cause pinpoint pupil, heart rate will be lesser, plus opioid है, इनके साथ कुछ सिम्टम स्पेसिफिक आएंगे, जैसे कि देयर विल बी फीचर ऑफ कॉन्स्टिपेशन, मान लीजिए रहेगा, कॉन्स्टिपेशन की हिस्ट्री दे सकता है कि पेशेंट को एक ड्रग ले रहा है, हो सकता है ड्रग एडिक्ट का हिस्ट्री हो, या पेशेंट कंज्यूम सम ड्रग, नाउ ही इज हैविंग कॉन्स्टिपेशन, व्हाट इज द ड्रग दैट इज पॉसिबली टेकिंग, है। तो ओपियोइड यूजुअली इज एन एनाल्जेसिक ड्रग, विच एनाल्जेसिक कैन कॉज कॉन्स्टिपेशन, ऐसे करके आपके क्वेश्चन आ सकते हैं, ठीक है। इसको मैनेज करने के लिए हाउ विल यू मैनेज, द एंटीडोट फॉर दिस वन इज एक्चुअली गोइंग टू बी नैलोक्सोन। नैलोक्सोन इज ओपियोइड रिसेप्टर एंटागनिस्ट। कोकेन पॉइजनिंग में अगर आप देखते हैं, कोकेन what it is gonna do, cocaine, remember guys, they are the net inhibitor that is going to increase the level of norepinephrine. They are the net inhibitor, they are going to increase the level of, right, cocaine net inhibitor, norepinephrine transporter inhibitor, ठीक है, they will increase the level of norepinephrine। So if you are going to look in the eye, sympathetic tone of the eye will be high, and therefore now there will be mydriasis। now आप देखिए कितना आसानी से मैंने आपको बताया कि पिन पॉइंट पिपिल अगर फार्मर में है, सो दैट विल बी ऑर्गेनोफॉस्फेट कार्बामेट, अगर ड्रग एडिक्ट में है तो पॉसिबली ओपियोइड। कोकेन ड्रग एडिक्ट में अगर पिन पॉइंट पिपिल आता है तो पॉसिबली इट्स कोकेन, राइट। हार्ट रेट विल एक्चुअली बी हाई, हार्ट रेट इज एक्चुअली गोइंग टू बी हाई, बीपी विल बी हाई, टैकीकार्डिया, पैल्पिटेशन, ये सब हो सकता है। इसके अलावा कुछ स्पेसिफिक सिम्टम जो इनके होते हैं, जैसे कि ब्लैक टंग, है ना, ब्लैक टंग, कोकेन बग्स का फीचर आएगा, जिसको विच इज अ टाइप ऑफ टैक्टाइल हेलुसिनेशन, है ना, स्क्रैच मार्क्स ऑन द बॉडी, राइट। सो दीज आर द फीचर्स। इसमें कोई स्पेसिफिक एंटीडोट नहीं है, यू जस्ट मैनेज सिम्टोमेटिकली, है ना, यू मैनेज सिम्टोमेटिकली टू द पेशेंट, जो भी सिम्टम के साथ आ रहा है यू आर सपोज टू डू द हाइड्रेशन एंड मैनेज सिम्टोमेटिकली, कोई ऐसा एंटीडोट नहीं है। अगर जैसे मान लीजिए पेशेंट को टैकीकार्डिया हो रहा है तो उसको बीटा ब्लॉकर दीजिए, लाइक दैट, ऑलराइट। इन चारों में से कोई एक ना एक आता ही है। इसके अलावा मैं बताऊं और भी जो आपके पॉइजनिंग्स आते हैं उनके इंपॉर्टेंट समरी यहाँ पे लिखे हुए हैं। एसिडिक ड्रग पॉइजनिंग लाइक एस्पिरिन, बार्बिट्रेट, और द कंडीशन इज इफ एंटीडोट इज नॉट अवेलेबल। एसिडिक ड्रग पॉइजनिंग, if antidote is not available, in that case scenario we are going to manage it by forced alkaline diuresis, forced alkaline diuresis using what? Forced alkaline diuresis using soda bicarbonate or carbonic anhydrous inhibitor. Okay, acidic drug poison like aspirin, barbiturate, chlorpromide, TCS. You can manage by forced alkaline diuresis. So likewise, basic drug poisoning also, if there is no drug, no antidote available. If antidote is not available, basic drug को कैसे पहचानेंगे? The name end with the ene, like quinidine, स्ट्राइचिनिन. देखिए मॉर्फिन का तो एंटीडोट अवेलेबल है नैलोक्सोन, एट्रोपिन का एंटीडोट अवेलेबल है लाइक फाइसोस्टिग्मीन, राइट? But basic drug poisoning, if antidote is not available, in that case scenario, what are you gonna do? If antidote is not available, then in that case scenario, what are you gonna do? Then we are going to treat it by forced acidic diuresis. अब यूरिन के pH को और acidic करोगे so that drug do not get reabsorbed and only get excreted. Forced acidic diuresis using ammonium chloride NH4Cl. अगर कुछ नहीं है तो सिंपल ascorbic acid, विटामिन सी का सिंपल इंजेक्शन भी काम करेगा, राइट? नेक्स्ट इज गोइंग टू बी पैरासीटामोल पॉइजनिंग. पैरासीटामोल पॉइजनिंग के लिए वी विल गिव एनास्टाइलसिस्टिन. ध्यान रखिएगा, एनास्टाइलसिस्टिन हैज ऑर्फन ड्रग स्टेटस इन पैरासीटामोल पॉइजनिंग एंड दे आर मेनली गोइंग टू एक्ट बाय रिप्लेनिश द ग्लूटाथायोन स्टोर. दे रिप्लेनिश द ग्लूटाथायोन स्टोर. ये भी क्वेश्चन पूछा है एक एग्जाम में कि कैसे काम कर रहा है, तो दे आर रिप्लेनिशिंग द ग्लूटाथायोन स्टोर. डिजॉक्सिन के लिए वी आर गोइंग टू यूटिलाइज द एंटीडोट, स्पेसिफिक एंटीडोट डिजिबाइंड. बेंजोडायजेपिन के लिए व्हाट वी कैन यूज? Benzodiazepine के लिए we can use flumazenil, right? Flumazenil. Beta blocker, again they will cause severe bradycardia. So to maintain the heart rate, we will be giving glucagon that maintains the heart rate. Methanol poisoning, or sometimes they can give you patient bought alcohol from a local liquor shop. है ना, alcohol from a local liquor shop, same as methanol, or the word will be ethylene glycol. So methanol or ethylene glycol actually is going to be a car coolant. दो तरह का एथिलीन ग्लाइकन होता है, इंडस्ट्रियल ग्रेड एंड फार्मास्यूटिकल ग्रेड. अगर आपको याद होगा तो मध्य प्रदेश की जो न्यूज़ है कफ सिरप वाली, जिसमें एथिलीन ग्लाइकोल की मात्रा बहुत ज़्यादा थी एंड मेनी किड्स दे लॉस्ट देयर लाइफ. तो एथिलीन ग्लाइकोल मेनली एक्टिंग सेम एज मेथनॉल, दे आर ऑल्सो गिविंग मेटाबोलाइज द सेम एंजाइम. तो इन दोनों की पॉइजनिंग में the antidote that we are going to use is called your fomepizole. एग्जाम में पूछा कैसे काम करेगा फॉर्मेपिजोल, तो दे आर वन ऑफ द अल्कोहल डिहाइड्रोजिनेज इनहिबिटर. very important. Fomepizole, they have already asked this question because it's a very fresh topic. INI-CET is known to ask these fresh topics. आयरन पॉइजनिंग में क्या देंगे? अगर इमरजेंसी में पेशेंट आपके पास आता है तो यू विल बी गिविंग इंजेक्टेबल चीलेटर दैट इज कॉल्ड डेफेरोक्सामीन. injectable that you are going to use is called deferoxamine, right? And अगर मैं बोलूँ oral iron chelator कौन सा है? Oral iron chelator is going to be deferipron. Oral iron chelator is going to be deferipron, and other one is called your deferasirox. Deferipron and other one is called deferasirox. We have deferipron and we have deferasirox. They are the oral iron chelator, mainly given to whom? Someone who is on prolonged let's say drug therapy that increases the risk of iron poisoning, or someone is having prolonged, let's say, blood transfusion, because excess blood transfusion can also increase the risk of iron poisoning, right? So in that case scenario we can use oral iron chelator. So they are the iron chelator, that is deferipron, deferasirox. Copper के लिए we have D-penicillamine. D-penicillamine is the copper chelating agent, right? Alternatively, अगर ये नहीं है तो we can also use triantine. The only thing with triantine is little expensive. Lead poison के लिए we can use EDTA or British anti-Lewisite, BAL. Heparin के लिए we can use the antidote that is called protamine sulfate. Heparin के लिए what we can use will be protamine sulfate. Warfarin के लिए what we can use will be vitamin K1. Warfarin के लिए क्या यूज कर सकते हैं? Vitamin K1 is for the warfarin. बट अगर ब्लीडिंग प्रेजेंट है, रिमेंबर, इफ ब्लीडिंग इज प्रेजेंट, then for that case scenario we will be using prothrombin complex concentrate, PCC, prothrombin complex concentrate. Rivaroxaban is going to be treated by giving andexanet alpha, that is going to be 10 ACO neutralize करने वाला ड्रग andexanet alpha. Dabigatran, that is going to be thrombin antagonist. Dabigatran, directly acting thrombin antagonist. Dabigatran is the directly acting thrombin antagonist. Dabigatran. इसके लिए हम यूज करते हैं एंटीडोट दैट इज कॉल्ड इदारुसिजुमाब। तो ये कुछ हिमेटोलॉजी के भी एंटीडोट एक जगह समराइज हो गए। स्ट्रेप्टोकाइनेस के लिए वी विल बी यूजिंग एप्सिलॉन अमाइनो कैप्रोइक एसिड। Alternatively, we can also give tranexamic acid. Alternatively, we can also use what? Tranexamic acid. So these are some of the high-yield topics from pharmacology, especially with respect to your antidotes that are very commonly asked. हेपेरिन के लिए सभी को पता है ना, प्रोटामिन सल्फेट, ये सभी को पता है। वारफरिन के लिए विटामिन K1, रिवारोक्साबैन 10A पे बैन लगाता है, तो इसको याद करने का तरीका 10A को न्यूट्रलाइज करने वाला एंडिक्सेनेट अल्फा। डैबिगेट्रन दबा दिया, दबा के दारू, डैबिगेट्रन दबा के दारू, इदारुसिजुमाब। स्ट्रेप्टोकाइनेज एप्सिलॉन अमाइनो कैप्रोइक एसिड, राइट। EDTN बाल इज फॉर लेड। देन एक और क्वेश्चन अभी रिसेंटली पूछा था, ब्रिटिश एंटी लुइसाइड इज गोइंग टू बी कॉन्ट्राइंडिकेटेड इन। तो मैं बोलता हूँ बाल इज हेयर, है ना, ब्रिटिश एंटी लुइसाइड बाल इज हेयर। तो अगर मान लीजिए आप एक बिजनेस करने जाते हो और उस बिजनेस से आपका कैफे में, तो कैफे में बाल रहेगा तो कैफे नहीं चलेगा। तो मैं बोलता हूँ कैफे से बाल को निकालो, राइट। यू शुड क्लीन द कैफे, कैफे से बाल को निकालो, राइट। कैफे दैट इज विल बी कैडमियम, आयरन एंड सेलेनियम। तो इनके टॉक्सिसिटी में अगर आपने बाल दे दिया, सो दे विल फॉर्म अ नेफ्रोटॉक्सिक कॉम्प्लेक्स। बाल फॉर्म्स अ नेफ्रोटॉक्सिक कॉम्प्लेक्स। तो इसलिए इनके कभी भी, है ना, पॉइजनिंग में आप ये नेफ्रोटॉक्सिक कॉम्प्लेक्स नहीं दोगे, नहीं बनने दोगे, राइट। तो वी हैव कैफे से कैडमियम, फेरिक या फेरस जिसको हम आयरन बोलते हैं, Fe से आयरन एंड से सेलेनियम। तो अगर इनके साथ बाल दे दिया गया तो बाल विल फॉर्म अ नेफ्रोटॉक्सिक कॉम्प्लेक्स विद कैफे से, राइट। सो दिस इज अबाउट इंपॉर्टेंट एंटीडोट्स, राइट। एक बार क्लियर रिकैप कर लीजिए। अगेन एसिडिक ड्रग पॉइजनिंग, वी हैव टू चेंज द यूरिन pH टू मोर अल्कलाइन। बेसिक है तो मोर एसिडिक सो दैट वी कैन कॉज डायूरेसिस। पैरासिटामोल पॉइजनिंग, N-acetylcysteine replenishing the glutathione store, digoxin glicidamine, beta blocker glucagon, and benzodiazepine flumazenil, methanol या ethylene glycol के लिए fomepizole which is one of the alcohol dehydrogenase inhibitor। आयरन पॉइजनिंग में अगर इमीडिएटली मान लीजिए हिस्ट्री आता है, अ बेबी वॉज प्लेइंग एंड ही कंज्यूम सब टैबलेट, वेयर ही वॉज प्लेइंग दे फाउंड द एम्प्टी बॉटल ऑफ हिज मदर्स और फादर्स आयरन टैबलेट। तो एम्प्टी बॉटल ऑफ आयरन मिला मतलब आयरन टैबलेट खा लिया तो इमरजेंसी हो गया। तो इन दैट केस सिनेरियो डेफेरॉक्सामिन, oral iron chelator. For example, someone is a case of thalassemia and prolonged or very recurrent blood transfusion. So again, in that case scenario, हमें chronic iron chelator दे के रखना होता है, डेफेरिप्रोन, डेफेरासेरोक्स and copper में D-penicillamine. Alternatively, we can use triantine also. EDTA बाल is for lead, है ना। हेपेरिन ये सब हेमाटोलॉजी वाले हैं। प्रोटामिन सल्फेट हम दे सकते हैं इसमें। वारफरिन के लिए विटामिन K1। अगर ब्लीडिंग प्रेजेंट है तो प्रोथ्रोम्बिन कॉम्प्लेक्स कंसंट्रेट हम देंगे, विल नॉट बी वेटिंग ऑन ओनली ऑन विटामिन K1। रिवारोक्साबैन एंड डिक्सेनेट अल्फा। देन वी हैव डैबिगेट्रान, दबा के दारू, इदारुसिजुमाब, स्ट्रेप्टोकाइनेस, EACA एंड बाल, ब्रिटिश एंटी लुइसाइड, रिमेंबर दे आर कॉन्ट्राइंडिकेटेड इन कैफे से बाल को हटाओ, ठीक है। तो ये हो गया आपका ओवरऑल ऑटोकॉइड इम्यूनोमॉड्यूलेटर, जिसमें मैंने बाकी सारे भी करा दी। अब हम बात करेंगे इंपॉर्टेंट पॉइंट्स इन जनरल फार्मा। जनरल फार्मा एंड ऑटोनॉमिक नर्वस सिस्टम के कुछ इंपॉर्टेंट पॉइंट है जो आपको जानने चाहिए। वन इज कॉल्ड एंजाइम इंड्यूसर, एंजाइम इनहिबिटर। अगर आप मुझसे पूछते हैं सर आप एक बात बता दो कि आप इतने दिन से फार्मा पढ़ा रहे हो, एक टॉपिक बता दो मुझे जनरल फार्मा में जहाँ से डेफिनेट क्वेश्चन आपके एग्जाम में पूछते हैं, तो मैं बोलूँगा देखो बच्चे, इस कंडीशन में तो मैं आपको एक ही टॉपिक बता सकता हूँ कि एक टॉपिक और पढ़ के जाना है जिससे क्वेश्चन डेफिनेट आए, वह ड्रग इंटरेक्शन। ड्रग इंटरेक्शन कैन बी सीन ड्यू टू एंजाइम इंड्यूसर इनहिबिटर। और इससे इतने क्लिनिकल क्वेश्चन बनते हैं कि एग्जामिनर पूछता है। सो दे विल ऑलवेज आस्क द क्वेश्चन, राइट। They will always ask the question from this. So we have enzyme inducer like glycofulvin, phenytoin, rifampicin, smoking of St. John's wort, plant product, carbamazepine, phenobarbital, barbiturate and DDT, राइट। सो GPRS सेलफोन यूज करने से बैटरी डेड हो जाता है, इंड्यूस हो जाता है, खर्च हो जाता है। सो एंजाइम इंड्यूसर से आपको याद ये रखना है, इंड्यूसर विल इंड्यूस एंड दिस इंड्यूसर दे आर गोइंग टू स्पीड अप द मेटाबॉलिज्म, दे आर गोइंग टू इंक्रीज the rapid metabolism. So a drug that is supposed to get metabolized in 10 hours, they rapidly get metabolized. Metabolism मतलब inactivation. They rapidly get metabolized or inactivated, let's say in 2 hours, in 3 hours. So the drug is not able to last as it is supposed to last. So inducer will induce. They are going to speed up the metabolism. For example, you are doing your work at a normal speed and someone is coming to interfere with your speed. Someone is coming and saying, okay, you have to work faster because others are working very fast, something like that. So they are inducers. Someone who is coming and saying work very fast, they are the inducers. Rapid metabolism would always and always lead to an outcome that is called your treatment failure. They would always lead to an outcome that is called your treatment failure. Enzyme inducers. A very good example that is given in your textbook as well. A patient on oral contraceptive pill and she consumed rifampicin, one of the anti-tubercular drug. What is the outcome? So rifampicin is going to speed up the metabolism of OCP and they can actually end up causing contraceptive failure. ये क्या कर सकते हैं? They can end up causing contraceptive failure. OCP and rifampicin can cause contraceptive failure. So in that scenario, what is the advice we are going to give? जो एडवाइस मैं इस पेशेंट को दे सकता हूँ वो कौन सा एडवाइस हो सकता है? सोच के बताइए क्या एडवाइस दे सकता हूँ मैं? I will give the advice that you have to decrease the best advice is actually do not use a drug that is having enzyme inducing and enzyme inhibiting property. But you see, do not use two drugs together. ये तो बहुत ही simple सा सवाल है ना. ये तो even a non-medicus also understand. What kind of advice you will give as a practitioner? The best is, again I told you, don't give two drugs together. For example, rifampicin, OCP का failure rate further बढ़ जाएगा. So you are going to give an advice, use an alternative method of contraception. Possibly let's say a barrier method. Okay, then we have some enzyme inhibitors. We have enzyme inhibitor like HIV protease inhibitor, all the navir like indinavir, ritonavir, erythromycin, clarithromycin, they are the macrolides. एमियोड्रॉन, सिप्रोफ्लॉक्सासिन, ओमेप्राजोल, सिमेटिरिन, कीटोकोनाजोल एंड वाल्प्रोवेट. मैं बड़े प्यार से इनको बोलता हूँ कि ये है पीकॉक वाला, और मेरे साथ आप राइमिंग कर लीजिए पीकॉक वाला, और मेरे साथ बोलिए कि पीकॉक वाला आएगा इनहिबिट करके जाएगा. कौन आएगा? पीकॉक वाला आएगा इनहिबिट करके जाएगा, है ना. मोर वाला, पीकॉक वाला आएगा inhibit करके जाएगा. PEACOCK. So we have HIV protease inhibitor, erythromycin, clarithromycin, amiodarone, ciprofloxacin, omeprazole, सिमेटिरिन, कीटोकोनाजोल एंड वाल्प्रोवेट. एक एंजाइम इनहिबिटर अमॉन्ग एंटी एपिलेप्टिक ड्रग जो कि बड़ा फेमस है वो है वाल्प्रोवेट. बिकॉज अदर ड्रग्स इफ यू आर गोइंग टू लुक एट in the list of inducer, we have phenytoin, we have St. John's wort that is also having anti-epileptic property, carbamazepine, phenobarbital, barbiturate. इतने सारे हैं एंटी एपिलेप्टिक ड्रग, इन सभी का इंड्यूसिंग प्रॉपर्टी है, लेकिन इकलौता वाल्प्रोवेट ऐसा है अमॉन्ग इनहिबिटिंग एंड एंटी एपिलेप्टिक ड्रग. इनहिबिटर में एक इकलौता एंटी एपिलेप्टिक है, उसका नाम है वाल्प्रोवेट, इसीलिए ये इंपॉर्टेंट है. तो मैं बोलता हूँ पीकॉक वाला आएगा इनहिबिट करके जाएगा, है ना. पीकॉक वाला मेरे साथ अभी याद कर लीजिए आप, इज वेरी वेरी इंपॉर्टेंट ड्रग. अब इसमें मैं एक एग्जांपल अगर दे दूं, अगेन inhibitor, are they going to slow down the metabolism? Yes. So there will be slowed metabolism, and because of the slowed metabolism, metabolism बहुत ही slow होने की वजह से, metabolism बहुत ही slow होने की वजह से, right, there will be drug will be there in the body, and you keep on taking the next dose, there will be increase in the risk of toxicity. There will be increase in the risk of what? Toxicity. Due to slowed metabolism, increase in the risk of toxicity. Okay, so we have enzyme inhibitor, slowed metabolism, increasing the risk of toxicity. Okay, so अगर इसका मैं example दे दूं, for example we have a drug like your warfarin, and साथ में आपने एक पेशेंट को क्लेरिथ्रोमाइसिन खाते हुए देख लिया, या किसी ने प्रेस्क्राइब कर दिया, और ही सेल्फ मेडिकेटेड ऑन द क्लेरिथ्रोमाइसिन. सो व्हाट विल दिस क्लेरिथ्रोमाइसिन डू? दे विल स्लो डाउन द मेटाबॉलिज्म ऑफ वारफरिन का मेटाबॉलिज्म स्लो हो जाएगा. सो वारफरिन विल बी देयर इन द बॉडी फॉर मोर लॉन्गर पीरियड, राइट. सो बिकॉज ऑफ दिस देयर विल बी इंक्रीज इन द रिस्क ऑफ व्हाट? इंक्रीज इन द रिस्क ऑफ ब्लीडिंग. तो वारफरिन बॉडी में बढ़ता चला जाएगा, उसका कंसंट्रेशन बॉडी में क्या होगा? बढ़ता चला जाएगा. सो देयर विल बी इंक्रीज concentration of warfarin in the body, excess concentration of warfarin in the body. Okay, that will increase the risk of bleeding. It is going to increase the risk of what? Bleeding. Therefore, what is the advice you would like to give to this patient? ऐसे patient को आप advice क्या दोगे? क्या advice दोगे आप? Warfarin plus clarithromycin, they will increase the risk of bleeding. ऐसे patient को advice आप ये दोगे कि either don't give two drugs that is causing this problem. The best advice is that only, but again that is very common. So what kind of dose adjustment would you like to do? So you will decrease the dose of warfarin. आप warfarin की dose को क्या करोगे, कम करोगे. You are going to decrease the dose of warfarin, and that is very very important. Yes. तो ये आपके ड्रग इंटरेक्शन वाले टॉपिक हो गए हैं. कौन सा ड्रग है, कैसे इंटरफेयर करेगा और क्या एक्शन होगा, ये आपका बहुत इंपॉर्टेंट है, राइट. तो वी हैव GPRS सेलफोन यूज करने से बैटरी बिकम डेड, इंड्यूस हो जाता है. ग्लिसोफोल्विन एंटी फंगल ड्रग, विच एंटी फंगल ड्रग इज हैविंग एंजाइम इनहिबिटिंग प्रॉपर्टी, दैट इज गोइंग टू बी कीटाकोनाजोल, राइट. विच एंटी एपिलेप्टिक ड्रग इज हैविंग एंजाइम इनहिबिटिंग प्रॉपर्टी, दैट इज गोइंग टू बी वैल्प्रोएट. वेरी वेरी इंपॉर्टेंट. ठीक है. दी आर द लिस्ट ऑफ इंपॉर्टेंट माइक्रोसोमल एंजाइम. ध्यान रखिएगा कि मेजॉरिटी ऑफ द ड्रग्स आर बीइंग मेटाबोलाइज्ड बाय CYP3A4. नियरली 50% ऑफ द ड्रग इज मेटाबोलाइज्ड बाय CYP3A4, राइट. CYP3A4 they have less genetic polymorphism. That means मेरी बॉडी में जो CYP3A4 है और आपकी बॉडी में जो CYP3A4 है, that is going to be almost same, right, taking care of majority of the drugs का metabolism. So what does the CYP3A4 stands for? So when we say CYP3A4, इनका nomenclature कैसे दिया गया है? The meaning of CYP is cytochrome P450. 3 is the name of the family. A is the name of the subfamily. And last number 4 is called your gene number. Last number 4 is called your gene number. So अगर मैं बोलूँ कि in CYP2D6 what is the gene number? In CYP2D6 what is the gene number? So the gene number is going to be 6. In CYP2C19 what is the gene number? The gene number is going to be 19. In CYP2C8 or 9 the gene number is 8 and 9, right? 8 है. So this is CYP2C8 separate, CYP2C9 separate, CYP1A1, 1A2. So they are the other drug. Other microsomal enzyme. Majority 50% of the drug metabolism is by CYP3A4. Remember that. Other very important topic from this one, if you are asking, I would say remember the CYP2C19. CYP2C19 is a very important microsomal enzyme that is activating your clopidogrel. So clopidogrel is what? A prodrug. What is clopidogrel? It's a prodrug, and this clopidogrel will always get activated. Clopidogrel, it's an antiplatelet drug, it's a prodrug, it's an antiplatelet drug, and prodrug का मतलब they are inactive compound. After metabolism only they will get active. This is going to be by CYP2C19, right? CYP2C19. Clopidogrel is actually going to get activated by CYP2C19. All right. Now ध्यान रखिएगा, अगर एक ऐसा ड्रग है which is someone like your omeprazole. So this omeprazole is having inhibitory property at the CYP2C19. So omeprazole is having inhibiting property at the CYP2C19, and therefore you have to remember a very very important thing, that this CYP2C19 once inhibited, clopidogrel will not get activated. So these two drugs are always given contraindicated together. They are not given together. Clopidogrel, omeprazole, they are going to be contraindicated together. Reason being, omeprazole is the enzyme inhibitor. I just told you above as well that omeprazole is having enzyme inhibiting property, right? So they are the enzyme inhibitor, and therefore clopidogrel will not be given with the omeprazole. Another question that was asked: if there is a genetic polymorphism in CYP2C19, which drug will not get activated? Clopidogrel. This was a USMLE question. Genetic polymorphism in clopidogrel. Remember, genetic polymorphism in CYP2C19, clopidogrel will not be working. Okay. Then we have some important receptors and their important location. Like we have intracellular receptor and extracellular receptor. Quickly, we'll revise this one. I always say that ligand-gated receptor are considered as the fastest acting receptor. They are the fastest acting. इनका दूसरा नाम होता है ion channel receptor, ion channel या ionotropic receptor, ion channel या ionotropic receptor. So इनके नाम को मैं बोलता हूँ put their name in the Guinness Book of World Record. इनके नाम को कहाँ डाल दो? Guinness Book of World Record में डाल दो. GABA, A and C, NMDA, nicotinic and 5-HT3. Put their name where? In the Guinness Book of World Record. These are goddamn fastest acting receptor. ये सब के सब बड़े fast acting receptor हैं. Guinness, GABA, A and C, NMDA, nicotinic. We have nicotinic at the nerve junction, nicotinic at the neuromuscular junction, and 5-HT3 ये वही वाला है जो nausea vomiting वाला है, right? So they are the fastest acting receptor. Ionotropic and ligand-gated receptors. Next, we have the enzymatic receptor. The most common enzyme in the enzymatic receptors will be tyrosine kinase. And I want you to remember that tyrosine kinase का एक variant another है जिसका नाम है Janus kinase. So what are the important important receptor that is acting by the enzymatic receptor. So we have insulin act by enzymatic receptor, insulin या insulin like growth factor, other growth factor like vascular endothelial growth factor, HER2 इसका दूसरा नाम होता है new HER2 new receptor, they are also acting by the enzymatic receptor. INI-CET का favorite question है 2025 में, they gave the match the following, और बोला कि इसको बताइए राइट एंड लेफ्ट साइड में मैच करना था, बस आप मैच द फॉलोइंग 2025 का INI क्वेश्चन है ये, राइट. सो यू जस्ट हैव टू डू द मैचिंग, कौन सा एग्जांपल है किस रिसेप्टर का. इंट्रासेलुलर रिसेप्टर, देन वी हैव द जी प्रोटीन. इंट्रासेलुलर रिसेप्टर पहले समझ लेते हैं. इंट्रासेलुलर रिसेप्टर का दूसरा नाम होता है न्यूक्लियर रिसेप्टर, बिकॉज ऑल द इंट्रासेलुलर रिसेप्टर दे आर गोइंग टू एक्ट बाय न्यूक्लियर ट्रांसक्रिप्शन, and these nuclear receptors are mainly going to present in the nucleus or they are present in the cytoplasm. So the one that is present in the cytoplasm, they are present in the cytoplasm. कौन कौन से जो cytoplasm present है, जितने भी steroids हैं like glucocorticoids, mineralocorticoids, तो जितने भी steroids हैं, mineralocorticoids like aldosterone, glucocorticoid, mineralocorticoid, sex steroids, right? Sex steroids, they are all acting by the cytoplasmic receptor. अल्टीमेटली सारे के सारे न्यूक्लियर से ही काम करते हैं, लेकिन ये न्यूक्लियर रिसेप्टर जो होते हैं ये साइटोप्लाज्म में भी प्रेजेंट हो सकते हैं एंड दे आर प्रेजेंट इन द न्यूक्लियस ऑल्सो. सेक्स स्टेरॉइड लाइक योर एस्ट्रोजन, प्रोजेस्टेरॉन, राइट, टेस्टोस्टेरॉन, राइट, ऑल दिस acting by the nuclear receptor present in the cytoplasm. Some of the nuclear receptor which are directly present in the nucleus, कुछ ऐसे होते हैं जो न्यूक्लियस में ही डायरेक्टली प्रेजेंट होते हैं, तो मैं बोलता हूँ ये बड़े अंदर होते हैं, बड़े डीपर होते हैं. एंड समवन व्हिच इज वेरी डीपली अवेलेबल, डीपली प्रेजेंट, तो इसमें बोलता हूँ दे फील देमसेल्फ ट्रैप्ड, TRAPE, they say we are trapped. So this is going to be your thyroxine, retinoic acid receptor, retinoic acid is a receptor for vitamin A. Then we also have aryl hydrocarbon receptor. Example is proton pump inhibitor, they are going to act by aryl hydrocarbon receptor. We have PPAR, alpha and gamma, peroxisome proliferator activator receptor, and E stands for estrogen. So estrogen is also one of the nuclear receptors, they can be present in the nucleus also. So they feel themselves trapped inside. ये कहाँ पे अपने आप को पाते हैं, ये अपने आप को ट्रैप पाते हैं बहुत ही अंदर, कहाँ पे, न्यूक्लियस में, राइट. जितने भी स्टेरॉइड्स हैं वो कहाँ पाए जाते हैं, साइटोप्लाज्म में, राइट. इंट्रासेलुलर रिसेप्टर, दिस इंट्रासेलुलर रिसेप्टर इज कंसिडर्ड एज द स्लोवेस्ट एक्टिंग रिसेप्टर. इंट्रासेलुलर रिसेप्टर क्या बोलते हैं, they are the slowest acting receptor because entering into the cell and binding with the receptor, then there is another step that there is going to cause dissociation of heat shock protein from the receptor, entering into the nucleus, causing nuclear transcription. This is all going to take some time. So this is going to be known as slowest acting receptor. Fastest acting is ligand gated. Next that we have is G protein coupled receptor. G protein coupled receptor के 3 variants होते हैं, GS, GI and GQ. GS, GI and GQ. S से we have BDSH, all the beta receptor, dopamine 1, serotonin, right. सेरोटोनिन का मेनली ध्यान रखिएगा 4 नंबर वाला 5:4, हिस्टामिन का 2 that I have already told you, serotonin का 4, procalyprate that I have also told you in autocoids, हिस्टामिन का 2 like ranitidine and all I have told you, and ADH or vasopressin 2 receptor, right. So I always say GS stimulant is going to be B, इसको मैं बोलता हूँ बीटा, राइट, बादशाह, BDSHA, बादशाह, है ना, ऑल द बादशाह वाले GS, ठीक है. देन वी हैव GI, मोस्ट ऑफ देम आर हैविंग 2 in their name, alpha 2, dopamine 2, opioid M2. देन वी हैव 5-HT1 and S3H4. प्लीज रिमेंबर S3H4 भी मैंने आपको पढ़ा रखा है. शुरुआत ही हमारी यहीं से हुई थी, हिस्टामिन से ही हुई थी, राइट. हिस्टामिन से ही शुरुआत हमारा हुआ था. H3 and H4 दे आर मेनली एक्टिंग बाई ऑटो रिसेप्टर. 5:1 अगेन ऑटो इनहिबिटरी इन नेचर. सो वी हैव GI. ADOMS इज द वेरी सिंपल नेमोनिक. ADOMS, ADOMSH, ADOMS. वी हैव alpha 2, dopamine 2, opioid M2, M4, 5:1 and S3H4. ADOMS is a very simple, right. Then we have GQ. GQ mediated is going to be Q, है ना. तो मैं बोलता हूँ मैथ्स इज द सिंपल नेमोनिक. मैथ्स M1, M3, M5, ऑल द ऑड नंबर ऑफ मस्करिन. 2 and 4 किसके साथ था, GI के साथ था. देन वी हैव एंजियोटेंसिन 1, alpha 1, TSH, Then we have H1 and 5-HT2. Okay, H1 and 5-HT2. So these are the important receptors that are acting by your G protein coupled receptor. एक और मैं बता दूं कि आपका जो GQ है, ये जो TSH है, ये आपके GS के थ्रू भी होता है, GS एंड GQ दोनों के थ्रू होता है, ठीक है. So we have H1 and we have 5-HT2. So Badshah Adams का math questionable. Very simple mnemonic that I say that we have a बादशाह उनका नाम है एडम्स. बादशाह एडम्स का मैथ इज क्वेश्चनेबल. मैथ क्वेश्चनेबल इसलिए बिकॉज मैथ वाले सारे क्यू के थ्रू काम कर रहे हैं. मैथ क्वेश्चनेबल इसलिए बिकॉज मैथ वाले सारे क्यू के थ्रू काम कर रहे हैं, ठीक है. सो मैथ्स द कॉलम क्वेश्चन आया हुआ था 2025 में. नेक्स्ट क्वेश्चन इज गोइंग टू बी वासोमोटर रिवर्सल ऑफ डेल इज कॉज्ड बाय या डेल्स रिवर्सल फिनोमेना. इसका दूसरा नाम होता है डेल्स रिवर्सल फिनोमेना. सो इट इज एक्चुअली गोइंग टू बी कॉज्ड बाय अल्फा ब्लॉकर के प्रेजेंस में इफ यू आर गोइंग टू गिव एपिनेफ्रिन, right? So there is going to be only and only fall in the blood pressure, only and only fall in the blood pressure. Vasomotor reversal of Dale कैसे कॉज होगा? तो ऑप्शन में मल्टीपल रहेगा, अल्फा ब्लॉकर देन बीटा ब्लॉकर, एपिनेफ्रिन देन नॉरएपिनेफ्रिन, मल्टीपल ऑप्शन होगा, बट यू हैव टू हंट डाउन द ऑप्शन अल्फा ब्लॉकर के प्रेजेंस में यू आर गोइंग टू गिव एपिनेफ्रिन. Normally if I am going to discuss with all of you guys vasomotor reversal of Dale without let's say this concept, अगर मैं बोलूँ कि अगर नॉर्मली एक पेशेंट को मैं एपिनेफ्रिन देता हूँ, so this epinephrine, it is acting on every receptor, alpha 1, alpha 2, beta 1 and beta 2, all receptor of the sympathetic nervous system. And whenever epinephrine is given, remember the most important receptor on which it is going to work is the alpha 1 because they are more in number. So as soon as you are going to expose your patient on the epinephrine, the BP is going to shoot up. Because of the vasoconstriction, the BP will shoot up. So this BP which was at 120, now it will shoot up to let's say 160, 170. Epinephrine, whenever you are going to expose in a normal experimental setup or in a you and me, let's say, so epinephrine will first act at the 1/6, right? Epinephrine will first act at the alpha 1. Why alpha 1? Because alpha 1 is more in number. तो BP क्या करेगा? शूट करेगा. Now once the effect of the epinephrine comes down at the lesser plasma concentration, beta 2 will work because beta 2 is considered as a sensitive receptor. Sensitive receptor का मतलब क्या हो? Anyone who is showing action at the lesser dose. So at the lesser plasma concentration, the beta 2 will get activated and BP will further fall down. And once the drug is completely out, remember, once the drug is completely out, they will go back again to the normal. So BP देखिए normal से 160 पे गया and it also came down to 90 because of the beta 2 receptor. Alpha 1 को वैसे BP बढ़ा, beta 2 को वैसे fall down हुआ because vasodilatation. Always remember, whenever we give epinephrine, it does not only increase the blood pressure, rather epinephrine produce biphasic response. It produce what? Biphasic response. But whenever I am going to give epinephrine in presence of alpha blocker, then the story will change. In presence of alpha blocker, if I am going to give epinephrine, then let's say this was the time when patient को alpha blocker दे दिया गया. Let's say this is the patient of hypertension. शुरुआत में ही alpha blocker you have given. And at this point of time, if you are going to expose epinephrine, ideally you just read that epinephrine would increase the BP, then decrease the blood pressure, then go back to the normal. Right? You just read that it will be having biphasic response, right? Since alpha 1 is more in number, it will act on the alpha, then it will beta 2 is more sensitive, then it will act on the beta 2. So it is going to show biphasic response. ये आपने बोला normally. But alpha तो already block हो चुका है, so it will not be acting on the alpha. All the epinephrine will actually be acting on the beta 2, and therefore the drug will further fall. The BP will further fall down. So only and only biphasic response will be seen, right? So it may go further down, let's say to 80, right? So there will be only and only fall in the blood pressure. Uniphasic response is called only fall in the blood pressure, or we say uniphasic response. Only fall in the blood pressure, or we say uniphasic response. So this is called your vasomotor reversal of Dale, where epinephrine is given in presence of alpha blocker, only fall in the blood pressure is noted. Epinephrine is given in presence of alpha blocker. Drug of choice for cheese reaction. Cheese reaction होता कैसे? When you are going to give MAO inhibitor in presence of right tyramine rich food, right? Tyramine rich food, right? Patient on MAO inhibitor, if there is a patient on MAO inhibitor और उसको आपने tyramine rich food दे दिया, then there will be cheese reaction, there will be increase in the tyramine mediated activity that is going to cause sympathetic activity. So cheese reaction का जो drug of choice है, what is the drug of choice? That is going to be phentolamine. Phentolamine, boys and girls, is a non-selective alpha blocker. Phentolamine is a non-selective alpha blocker. Drug of choice of BPH, benign prostatic hypertrophy. BPH की drug of choice that is going to be your tamsulosin, right? Tamsulosin. Another one is called weaker analog, that is called cilodosine, that is actually going to be 5 alpha 1A blocker. The good news is that tamsulosin, cilodosine, what is the advantage of using this alpha 1A blocker? This alpha 1A blocker, it do not cause postural hypertension. It do not cause postural hypertension. Sudden fall in blood pressure will be seen with the prazosin. Other drugs for BPH could be, let's say prazosin. Prazosin is another drug that we can use for BPH. Then we have, this is going to be alpha 1 blocker. This will be causing fall in blood pressure, right? Then we have drugs like finasteride, dutasteride, dutasteride. They are going to be 5-alpha reductase inhibitor, right? 5-alpha reductase inhibitor, finasteride, dutasteride. They are going to inhibit the activation of testosterone to dihydrotestosterone, right? A beta blocker that is having antioxidant property. These are some autonomic nervous system important PYQs. So one of the beta blocker that is having antioxidant property is going to be carvedilol, a third generation beta blocker. Carvedilol, and other one is called nebivolol. So they are the one that is having antioxidant property. Carvedilol, it's actually one of the beta blocker that is having beta blocker with alpha blocking property, right? Nebivolol is a beta blocker. It's a beta blocker with increasing the nitric oxide property. NO is nitric oxide. Which beta blocker is preferred for? Most preferred beta blocker in asthmatic patient. Beta blocker preferred for open angle glaucoma. Okay, so this is called open angle glaucoma in asthmatic patient. यूजुअली ग्लोकोमा में हम यूज करते हैं टीमोलॉल. तो मैं बोलता हूँ टिमटिमाते हुए आंखों के लिए टीमोलॉल. बट इफ यू गिव दिस टिमटिमाता हुआ आंखों के लिए टीमोलॉल in asthmatic patient, the patient will also become timtimata hua tara, है ना, because of the precipitation of asthma. So in that case scenario, you are supposed to utilize eye drop by the name of betaxolol. Labetalol, guys, remember it's a beta blocker with alpha blocking property, third generation beta blocker. It's one of the third generation beta blocker. As a matter of fact, it's the drug of choice for hypertension and hypertensive emergency in pregnancy. Benztropine, benzhexol, they are the one that is causing centrally acting anticholinergic property. They are anticholinergic drug, और मैं एक ब्रेन बना दे रहा हूँ छोटू सा, just to tell you they are the centrally acting anticholinergic drug. So they can cause centrally and peripheral both kind of side effect, right? So centrally acting anticholinergic drug, benztropine, benzhexol, they can cause side effect like, let's say, constipation. They can cause side effect like blurring of vision, blurred vision, constipation, like urine retention, right? LD50 and ED50, LD50 and ED50, they are actually, the component of your therapeutic index, right? They are component of therapeutic index, because therapeutic index is equal to a dose that is producing lethality in 50% divided by effect in 50% of the experimental population, right? So therapeutic index is actually considered a measure of what? Safety. Always remember, if the therapeutic index is narrow, तो they are going to be unsafe kind of drug. अगर it wide है तो then only you will be giving them, they are the safe kind of drug. ठीक है. Side effect of ritodrine, isoxaprine, they are the beta 2 agonist, right? They are the beta 2 agonist. ritodrine, इसको हम एज ए टोकोलिटिक यूज करते हैं. टोकोलिटिक का मतलब क्या हुआ? एनी पेशेंट where there is premature labor is there, if you want to slow down the progression of labor, हम यूज करेंगे this tocolytic agent, ritodrine isoxaprine, है ना. So this beta 2 agonist, what kind of side effect is expected? Beta 2, they will also be having their action on the beta 1 of the heart, and they can increase the heart rate, they can cause palpitation. Beta 2 on the muscle will cause side effect like your tremor, right? Then they can also lead to gluconeogenesis, glycogenolysis of the liver, and that will increase the level of glucose, so they can cause hyperglycemia. Beta 2 of the vessel would cause fall in the blood pressure, and they would also lead to capillary tone reduction. That will also lead to sometime pulmonary edema, especially if you're going to give them by the systemic route, ठीक है। आशुतोष पूछ रहे हैं ड्रग ऑफ चॉइस और कीमो इंड्यूस नोशिया वोमिटिंग एप्रिपिटेंट। नहीं, कीमो इंड्यूस नोशिया वोमिटिंग का एप्रिपिटेंट इट डिलेड केसेस, डिलेड नोशिया वोमिटिंग का। जब मैं कीमोथेरेपी भी पढ़ाऊंगा तो उसमें वो आएगा कि डिफरेंट टाइप ऑफ पेशेंट आते हैं। इन ऑल अदर केसेस विल बी यूजिंग ओंडेनसेट्रॉन, एंड कीमोथेरेपी इंड्यूस नोशिया वोमिटिंग के लिए विल बी यूजिंग एप्रिपिटेंट, यस, है ना, डिलेड नोशिया वोमिटिंग के लिए, डिलेड, है ना। जैसे मान लीजिए 24 to 48 आवर्स आफ्टर इन्फ्यूजन इफ देयर इज intractable vomiting, unstoppable vomiting, then we will be using aprepitant. Okay, so side effect is going to be tachycardia, palpitation, tremors. Hyperglycemia is very, very important side effect. They will also decrease the blood pressure, can cause pulmonary edema. Pulmonary edema, beta 2 agonists, especially with the systemic intake, and this beta 2 agonists, they will also increase the activity of sodium, potassium ATPase, and therefore they could lead to hypokalemia. They could lead to what? Hypokalemia. Dopamine affect low dose dopamine. They can cause vasodilatation, and they can cause vasodilatation less than 2 microgram per kg per minute. They can cause vasodilatation. अगर मैं बोलूँ कि 2 to 10 पे क्या करेगा, 2 to 10 microgram per kg per minute पे क्या करेगा, so they will have beta 1 agonistic property, and more than 10 microgram per kg per minute पे they will have alpha 1 agonistic property. So dopamine always have dose dependent activity, है ना। तो quickly हमने revise कर लिया कि in the lesser dose they will mainly be stimulating the D1 receptor, D1, that will be causing vasodilatation. So dopamine का जो action होता है dose dependent आता है, that is going to be like D1 beta 1 alpha 1, that is going to be dabba, D1 beta 1 alpha 1, that is going to be dabba, D1 beta 1 and alpha 1 dabba, less than 2, 2 to 10, more than 10. Which sympathomimetic drug causing reflex bradycardia? इतनी बार ये क्वेश्चन पूछा गया, पूछिए नहीं, right? The name of the drug is called norepinephrine, and therefore remember this will not be causing reflex bradycardia in cardiac transplant patient. Please remember, in cardiac transplant patient, right? In cardiac transplant patient, norepinephrine, अगर मैं बोलूँ norepinephrine in cardiac transplant patient, so there will be no reflex bradycardia. In cardiac transplant patient, there will be only and only direct action. So only there will be increasing the blood pressure and increasing the heart rate. There will be no reflex action. There will be no reflex action. कहाँ पे? Cardiac transplant patient में reflex action नहीं आएगा, ठीक है। Then a graph they used to give something like this, and then they ask which one is the potent and which one is the efficacious. So log dose, and on the y-axis you have the response. So you have A, B, C, D, four drugs here, and from left to right, if you move, the dose is increasing. The dose is increasing at a different dose. Different action is actually noted as you're moving from left to right. As you're moving from left to right, the dose is increasing, right? So अगर पूछता है potency, right? Potency is going to be lowest dose that could produce an action. Lowest dose that can produce an action is called your potency. P for potency, P for power. P for potency, P for power. So potency का order in this case scenario is going to be A followed by B followed by C followed by D. It will always go from left to right. It always go from left to right. Next it's going to be efficacy. Next is going to be efficacy. Efficacy is going to be maximal response regardless of the dose. कितने डोज पे है मतलब नहीं है, मैक्सिमल रिस्पॉन्स रिगार्डलेस ऑफ द डोज, कितने डोज पे मतलब नहीं है। एंड एफिकेसी इट इज दिस वन, दिस एफिकेसी इज द वन विच इज क्लिनिकली मोर इम्पॉर्टेंट. It is clinically more important. What is clinically more important? It is the efficacy which is clinically more important. So if you are going to look at the efficacy order of the efficacy in this graph here, then I would say efficacy looks like a spelling efficacy का Eiffel Tower के जैसा है. और आईफिल टावर क्यों फेमस है? आईफिल टावर फेमस है बिकॉज ऑफ इट्स हाइट. आईफिल टावर क्यों फेमस है? बिकॉज ऑफ इट्स हाइट. तो एफिकेसी में जो हाइट वाले होंगे वो सबसे ज़्यादा एफिकेशियस होंगे. तो बी एंड सी का हाइट देखोगे तो ऑलमोस्ट सेम है. तो बी इज इक्वी एफिकेशियस टू सी. देन देयर इज गोइंग टू बी लेस विल बी ए, एंड लीस्ट एफिकेशियस इज गोइंग टू बी डी. So the order goes in this order in efficacy. कभी भी अगर एग्जाम में आप भूल जाओ तो यू कैन ऑलवेज गेट हेल्प फ्रॉम द हेल्प निमोनिक. हेल्प मैं बताता हूँ कैसे. हाइट एफिकेसी को बताता है, लेफ्ट वाला विल बी टेलिंग अबाउट द पोटेंसी. Left wala will be telling about potency. So as you move from left to right, the potency keeps on decreasing. As you move from left to right, the potency keeps on decreasing. Clear? और जितना हाइट बढ़ता जाएगा एफिकेसी, आईफिल टावर है ना, एफिकेसी आईफिल टावर, जितना हाइट बढ़ता जाएगा एफिकेसी, हाइट एफिकेसी को बताएगा, है ना. स्नेक बाइट, देखिए आप इसमें यूज करते हैं एक तो पॉलीवैलेंट एंटी स्नेक वेनम, उसके बाद से आप देते हैं नियोस्टिग्मीन. नियोस्टिग्मीन के साथ वी ऑल्सो ऐड एट्रोपिन टू मास्क द मस्करिनिक साइड इफेक्ट. वी ऐड एट्रोपिन. एग्जाम में पूछा वाई आर यू एडिंग एट्रोपिन, तो यू आर मेनली एडिंग एट्रोपिन टू मास्क द मस्करिनिक साइड इफेक्ट, टू मास्क द मस्करिनिक और पैरासिम्पैथेटिक साइड इफेक्ट, राइट, टू मास्क द मस्करिनिक साइड इफेक्ट. आपको फॉरेंसिक मेडिसिन वाले पढ़ाएंगे डू इट राइट अप्रोच, है ना, राइट, रीएश्योर, फॉरेंसिक में पढ़ाया जाता है ना, इमोबिलाइज, रीएश्योर, इमोबिलाइज, देन GSO का गो टू हॉस्पिटल, टेक द पेशेंट टू हॉस्पिटल, एंड T से होता है टेल द डॉक्टर. टेल द डॉक्टर क्या, स्नेक कैसा था, काटा तो कैसा लगा, अच्छा लगा, बुरा लगा, ब्लीडिंग हुई, पेन हुआ, है ना. डू इट राइट अप्रोच, राइट. तो एक क्वेश्चन ऐसा आया कि एक पेशेंट है, उसको हॉस्पिटल में लाया गया है और पॉसिबल स्नेक बाइट है, अब क्या करोगे. तो ध्यान रखिएगा, रीएश्योर, इमोबिलाइज, गो टू हॉस्पिटल, ये सारी स्टेप हो चुकी हैं, राइट. अगर मान लीजिए हॉस्पिटल में आया और अभी भी इमोबिलाइजेशन नहीं है, तो सबसे पहले आप इमोबिलाइज करोगे, है ना. उससे पहले क्या, रीएश्योर करोगे, भाई इट्स ओके, सारे के सारे, है ना, स्नेक पॉइजन्स नहीं होते हैं, है ना. जैसे हर लोग खराब नहीं होते हैं, हर इंसान खराब नहीं होता है, वैसे ही सारे स्नेक पॉइजन्स नहीं होते हैं ना. जरूरी नहीं है कि आपको पॉइजन्स वाला ही काटा हो, बिकॉज कई बार इतना ज़्यादा सिंपैथेटिक ड्राइव होता है कि पेशेंट को सिंपैथेटिक ड्राइव से ज़्यादा कॉम्प्लिकेशन बढ़ जाता है कई बार, है ना. एंग्जाइटी, सिंपैथेटिक ड्राइव. स्कॉर्पियन बाइट में वी विल बी यूजिंग द ड्रग दैट इज कॉल्ड प्राजोसिन, वेरनिक्लीन and bupropion. Varenicline and bupropion, they both are actually considered the anti-smoking drug. Bupropion, it is mainly going to be the preferred anti-smoking in depressed patient. अगर कोई depressed patient है उसमें ज़्यादा prefer करेंगे. Alpha blocker like drugs like your prazosin, terazosin, alfuzosin, they are also seen. They can cause side effect that is called postural hypertension. One of the very important side effect is postural hypertension that I mentioned. अगर आपने BPH में ये दे दिया तो पोस्टल हाइपोटेंशन विल बी प्रॉब्लम. सो इसको काउंटर करने के लिए हम क्या देते हैं, टैमसुलोसिन. टैमसुलोसिन का एडवांटेज मैंने बताया भी था अभी आपको कि वन ऑफ द वेरी इंपॉर्टेंट एडवांटेज ऑफ टैमसुलोसिन दैट दिस टैमसुलोसिन इट डू नॉट कॉज पोस्टल हाइपोटेंशन. इज वेरी इंपॉर्टेंट क्वेश्चन हियर, इज वेरी इंपॉर्टेंट. ठीक है, पोस्टल हाइपोटेंशन, अदर साइड इफेक्ट विल बी योर retrograde ejaculation due to alteration in the seminal vesicle tone, है ना. retrograde ejaculation, postural hypotension, they are the important side effect of alpha blocker. Postural hypotension, retrograde ejaculation, eyes में they can cause meiosis. Some important shocks like for example anaphylactic shock, you are going to use adrenaline 1:1000, 1 gram in 1000 ml, और इसको कितना इंजेक्ट करेंगे, IM 0.5 ml will be injected. Septic shock is the only type of shock जहाँ पे heart rate बढ़ा होगा, तो we can use norepinephrine. Cardiogenic shock. Now cardiogenic shock with compromise or let's say fall in the blood pressure, उस कंडीशन में कार्डियोजेनिक शॉक में हम नॉरेपिनेफ्रिन यूज कर सकते हैं. तो इसमें दो है, अगर बीपी नॉर्मल है तो वी कैन इवन गिव डोब्यूटामीन, बीटा 1 एगोनिस्ट, और नॉरेपिनेफ्रिन इन कॉम्प्रोमाइज्ड कार्डियक कंडीशन. ठीक है, न्यूरोजेनिक शॉक में भी हम यूज कर सकते हैं नॉरेपिनेफ्रिन. वेसोवेगल शॉक में वेगल वर्ड आ गया तो हम देंगे एट्रोपिन. वेगल वर्ड आ गया तो एट्रोपिन. वेसोवेगल शॉक वी आर गोइंग टू यूज व्हाट, एट्रोपिन. फिर एक क्वेश्चन आता है शॉक विथ ओलिगुरिया. शॉक विथ ओलिगुरिया, then here the drug of choice is going to be dopamine. However, shock without oliguria अगर पूछ ले, shock without oliguria के लिए again the drug of choice will be dobutamine. Shock without oliguria के लिए drug of choice will be dobutamine. With oliguria के लिए dopamine, higher dose will be utilized. Okay. Selective beta blocker, they are always going to be, remember guys, safe in bronchial asthma patients. They are safe in bronchial asthma patient. And A2, B2 loves Seaman. Again, just you can remember atenolol, betaxolol, acebutolol. Landiolol is very short T half-life, 4 to 5 minutes. Esmolol is also going to be very short T half-life, lasting for 8 to 10 minutes. अब इन दोनों में क्वेश्चन आ जाए which one is the shortest acting, तो you have your answer landiolol, celiprolol, metoprolol, nebivolol. Nebivolol is considered the most cardioselective. Most cardioselective beta blocker is nebivolol. Okay. So these are some of the important cardioselective beta blocker that is safer in the asthmatic patient. Atenolol, acebutolol, betaxolol, landiolol and esmolol, they are shorter acting. एक एग्जाम में क्वेश्चन पूछा why are they shorter acting? So these landiolol and esmolol, these are rapidly metabolized by RBC esterases. Rapidly metabolized by RBC esterases. इसलिए they are shorter acting. Okay, they are rapidly metabolized by RBC esterases. That is why they are shorter acting ones. ठीक है. Some recent MCQs, like for example, if I ask you drug of choice on mountain sickness, तो कुछ questions ऐसे हैं जो ये sickness वाले थे, mountain sickness के लिए, तो you'll be using carbonic anhydrase inhibitor. The site of action is going to be PCT. PCT is the site of action, and ये किस लिए बता रहा हूँ, बिकॉज एक एग्जाम में ट्यूब्यूल बना दिया, पूछा कि एक पेशेंट लद्दाख में गया और वहाँ पे जाकर के उसको ये सिम्टम्स आ रहे हैं, ऑन विच साइट ऑफ द ट्यूब्यूल दे विल बी वर्किंग. कार्बोनिक एनहाइड्रेज इनहिबिटर लाइक एसिटाजोलामाइड, डोरजोलामाइड, drug of choice in mountain sickness. Motion sickness, we are going to use hyoscine scopolamine. Alternative to this, we are also having drug like promethazine. Morning sickness, doxylamine. Morning sickness like doxylamine. Penicillin mediated hypersensitivity, that is going to be adrenaline, again 1:1000, 0.5 ml intramuscular will be given. Mydriatic and cycloplegic preferred in pediatric patient. Pediatrics में mydriatic cycloplegic is going to be atropine, 1% ointment. Please remember, in pediatrics we'll be using more stronger anticholinergic drug. Atropine is more potent and longer acting. Atropine का ointment देंगे, eye drop will not be given because eye drop will have high risk of atropine fever. All right. Then we have the important seizures and important drug of choices. For example, ethosuximide is a drug of choice for absent seizure. Ethosuximide is the drug of choice for absent seizure. It's going to be T-type calcium channel blocker. Myotonic, myoclonic, atonic, Lennox-Gastaut syndrome, Dravet syndrome, सभी के लिए the drug of choice is going to be sodium valproate. The drug of choice is going to be sodium valproate. Partial or focal seizure के लिए we will be using carbamazepine. Generalized tonic-clonic seizure के लिए we can utilize the drug like lamotrigine, and alternatively we can also give valproate. Febrile seizure, fever-induced seizure, febrile seizure के लिए what we can use, right? Intranasal midazolam. अगर ये नहीं है तो we can use per rectal diazepam also. Per rectal diazepam. Status epilepticus, IV lorazepam. Status epilepticus, IV lorazepam. Infantile spasm, the drug of choice will be ACTH. Infantile spasm plus tuberous sclerosis, इसके लिए the drug of choice is going to be vigabatrin. Which anti-epileptic can be utilized during pregnancy? Safest anti-epileptic drug is going to be levetiracetam. अगर रिसेंटली आप इंस्टा पे फॉलो करते हैं तो ये MCQ भी देखे होंगे. लेवेटिरासेटाम का मैकेनिज्म ऑफ एक्शन पूछा गया था. SV2A ब्लॉकर होते हैं. एक्लेम्प्टिक सीजर में विल बी यूजिंग द ड्रग ऑफ चॉइस दैट इज कॉल्ड मैग्नीशियम सल्फेट. तो यू विल हैव टू आइडेंटिफाई कि पेशेंट क्या पूछ रहा है, बिकॉज इसके ड्रग्स भी पूछे गए हैं. एंड अनदर वेरी फेमस क्वेश्चन नाउ इट इज गोइंग टू बी, व्हाट इज द नॉन एपिलेप्टिक यूज ऑफ द एंटी एपिलेप्टिक ड्रग? नॉन एपिलेप्टिक यूज ऑफ द एंटी एपिलेप्टिक। तो नॉन एपिलेप्टिक यूज जैसे कि मैं बोलूँ वैल्प्रोएट का नॉन एपिलेप्टिक यूज क्या है? व्हाट इज द नॉन एपिलेप्टिक यूज ऑफ वैल्प्रोएट? नॉन एपिलेप्टिक यूज ऑफ वैल्प्रोएट, इफ आई से नॉन एपिलेप्टिक use of valproate, it is utilized for the prophylaxis of migraine. It is also utilized as a drug of choice for rapid cycler in bipolar disorder. Rapid cycler in bipolar disorder. नॉन एपिलेप्टिक यूज, देखिए एपिलेप्सी में तो यूज हो रहा है। नॉन एपिलेप्टिक यूज इज द फेमस मोर हॉट क्वेश्चन। प्रोफिलैक्सिस ऑफ द माइग्रेन रैपिड साइक्लर में दे आर गोइंग टू यूटिलाइज, है ना। Lamotrigine can also utilize in bipolar disorder. Phenytoin also utilized as anti-arrhythmic drug. Anti-arrhythmic drug class 1B anti-arrhythmic drug, plus it is also known to cause wound healing because of its collagenase inhibiting property, wound healing। और ये collagenase inhibiting property की वजह से ही कोलाजन का डिपोजिशन हो जाता है एंड दे कैन कॉज गम हाइपरट्रॉफी आल्सो, वेरी कॉमन साइड इफेक्ट ऑफ फेनेटोइन। Carbamazepine is the drug of choice for trigeminal neuralgia and glossopharyngeal neuralgia. Carbamazepine is the drug of choice for trigeminal neuralgia. So they are non-epileptic use. Trigeminal neuralgia, glossopharyngeal neuralgia, carbamazepine. Where else can we use them? Where else can we use them? We can also use them in bipolar disorder. Carbamazepine. टोपीरामेड टोपी पहनता है, टोपी पहन के सारे अच्छे काम करने वाले ड्रग, तो दे आर यूज्ड इन एंटी एपिलेप्टिक ड्रग, ओके अग्रीड, बट पूछ रहा है नॉन एपिलेप्टिक यूज, सो दे कैन आल्सो बी यूज्ड इन द प्रोफिलैक्सिस ऑफ migraine, right? They can also be utilized in the treatment of obesity, right? We can also use them in bipolar disorder, and they also decrease the craving of alcohol. They also decrease the craving of alcohol. तो देखिए ये टोपी पहनने वाला ड्रग है, बड़ी होलिस्टिक ड्रग है। टोपी पहनने वाला ड्रग हेडेक भी नहीं होने देता है, अपना फेवरेट खाना खाओ, वेट भी नहीं बढ़ने देगा, बाइपोलर डिसऑर्डर, एंड ऑल्सो दे डिक्रीज द alcohol craving. Zonisamide, they are known to cause weight loss, but that is statistically non-significant. मतलब इसको ओबेसिटी में यूज नहीं करते हैं, they can cause weight loss. एक और पॉइंट मैं बता दूं यहाँ पे, टोपीरामेड एंड जोनिसामाइड, they share some common side effect. The common side effect is that weight loss and renal stone, and ये जो आपका टोपीरामेड है, टोपीरामेड they can also lead to your precipitation of angle closure glaucoma. Topiramate can also be associated with the angle closure glaucoma. ये जो दोनों साइड इफेक्ट हैं, they are associated with both topiramate and zonisamide. Angle closure glaucoma can also be caused by your topiramate. ठीक है। एंटीसाइकोटिक्स के जो क्वेश्चन आते हैं मोस्टली इनके साइड इफेक्ट पे आते हैं, बार बार आते हैं। टिपिकल एंटीसाइकोटिक्स एंड एटिपिकल एंटीसाइकोटिक्स। टिपिकल एंटीसाइकोटिक्स कौन से होते हैं? दे आर ऑल मेनली गोइंग टू बी योर D2 ब्लॉकर। दे आर ऑल मेनली गोइंग टू बी व्हाट? D2 ब्लॉकर। D2 blocker mainly typical, or atypical are mainly going to be your 5-HT2A blocker. They have some other property as well, like for example alpha blocking property, D-dopamine blocking property, histamine blocking property. They are all properties as well. Typical like haloperidol, droperidol, flupentixol, zuclopentixol, chlorpromazine, thiazidine. Thiazidine को clinically आजकल यूज करते भी नहीं है. This chlorpromazine, thiazidine, they both are considered as a low potency drug. They are low potency drugs. So this low potency drug will always be required in the low potency drug that you know, it is always going to be required in high doses, right? And haloperidol and all, they are all high potency drug. Atypical mein, we have drugs like your risperidone, quetiapine, right? Aripiprazole, brexpiprazole, clozapine, olanzapine, ziprasidone, zotapine, acinapine. Acinapine is available by the sublingual route. Lurasidone, sertindol. Most potent atypical, risperidone. तो मैं बोलता हूँ it's a very very risky drug. And why it's so risky? Because it is the risperidone that is also associated with, right? Also associated with side effect of typicals. What was the side effect of typical? That I will tell you subsequently. Typicals are mostly going to be associated with side effect. Typicals are mostly going to be associated with side effect, that is hyperprolactinemia and extrapyramidal symptom. Extrapyramidal symptom is mainly going to be seen due to blockade of dopamine in nigrostriatal pathway. ठीक है, हाइपर प्रोलैक्टिनीमिया एंड एक्स्ट्रा पिरामिडल सिम्टम. Risperidone are mostly going to be associated with metabolic syndrome as a side effect. Metabolic syndrome as a side effect, like weight gain, dyslipidemia, dysglycemia, right? All these side effects. Risperidone, quetiapine, aripiprazole, brexpiprazole, clozapine, olanzapine, ziprasidone, acinapine, lurasidone. They are all the atypical or 5-HT2A blocker drugs. Now, very risky, risperidone. If you don't want to remember all of them, at least remember clozapine, olanzapine drug, quetiapine drug. They are the drugs coming under the atypical one. Now, maximum risk of extrapyramidal symptom, of course it is going to be the typical one. And typical में भी कौन ज़्यादा होगा, typical में भी कौन सा सबसे ज़्यादा होगा? तो among typical also the one that is having maximum risk of extrapyramidal symptom, it is going to be drug like your haloperidol. Drug like your haloperidol. Least risk overall, it is going to be clozapine, right? मैक्सिमम रिस्क ऑफ एक्स्ट्रापिरामिडल सिम्टम टिपिकल में अगर बात करें तो इट विल बी दिस ड्रग. लेकिन अगर पूछे ए टिपिकल में कौन है जो मैक्सिमम रिस्क कर सकता है, तो मैंने बताया था ए टिपिकल में भी एक रिस्की ड्रग है जो है तो ए टिपिकल ग्रुप में, लेकिन ये भी करा सकता है. तो अमॉन्ग ए टिपिकल देयर इज अ रिस्की ड्रग. द नेम ऑफ द रिस्की ड्रग इज कॉल्ड योर risperidone. The name of the risky drug is called your risperidone. Atypical, that can cause cardiac arrhythmias. So we have drug like your quetiapine, ठीक है, quetiapine, sertindol, zotapine, ziprasidone होता है, राइट. साइड इफेक्ट ऑफ क्लोजापिन, तो क्लोजापिन भी तो एक एटिपिकल ही है, इट्स ऑल्सो एन एटिपिकल ड्रग. दे आर द वन दैट इज हैविंग लीस्ट एसोसिएटेड विद एक्स्ट्रापिरामिडल सिम्टम, and they are considered the first anti-suicidal drug. इसके important side effect क्या क्या होंगे? Apart from the metabolic syndrome, वो तो है ही है, वो तो सारे atypical करेंगे. Metabolic syndrome like weight gain, dyslipidemia and all, they are also associated with side effect like your agranulocytosis. Now this agranulocytosis, it's a very very dangerous side effect. Agranulocytosis is very very dangerous side effect. Agranulocytosis, sialuria, right? Sialuria is excessive salivation, है ना. और salivation usually क्या होता है, due to effect of the drug, salivation is lesser. Due to anticholinergic effect, the salivation will be lesser. But in the night time, once the effect of the drug goes down, excess salivation will be there. तो इसको कई बार बोला था कि सुबह जब पेशेंट उठा तो पिलो वेट था, तो इसको हम बोलते हैं वेट पिलो सिंड्रोम. साइलोरिया, sedation, seizure, and they can even lead to myocarditis. So these are the other side effects. Apart from metabolic syndrome, they have agranulocytosis, that is very dangerous side effect. Sialuria, wet pillow syndrome, sedation, seizure, and myocarditis are the other important side effect. Extrapyramidal symptom earliest जो होता है उसको हम बोलते हैं dystonia. Tone has been altered, and dystonia is mainly treated with a centrally acting anticholinergic drug like benzohexol, benztropine, all these drugs. Centrally acting anticholinergic drug. Most common is going to be your akathisia, motor restlessness without anxiety, akathisia, and they are mostly treated with the propranolol, right? Propranolol. A dangerous extrapyramidal symptom is called neuroleptic malignant syndrome. Death can also be reported. Neuroleptic malignant syndrome treated usually with the bromocriptine. पहले सिर्फ और सिर्फ हम इसमें देते थे dantrolene, but now dantrolene के साथ a specific agent that is added is called your bromocriptine. Although dantrolene is the drug of choice of malignant hyperthermia, which you just read in anesthesia, that dantrolene is the drug of choice in malignant hyperthermia. Remember a very very important point here, right? The presentation of malignant hyperthermia and neuroleptic malignant syndrome is actually going to be almost same, लेकिन underlying cause दोनों का अलग है. In malignant hyperthermia, it is the RYR receptor of the sarcoplasmic reticulum and more calcium availability. Here it is excess of dopamine blockade. Atypical, that will be causing least weight gain. See, atypical will all cause weight gain. Least weight gain will be caused by a drug like aripiprazole, and other one is called ziprasidone. Aripiprazole and other one is called ziprasidone. तो मैंने बोला यार ये एरिपिप्राजोल जिप्रासिडोन वेट गेन तो नहीं कर रहे हैं, तो इसको देखिए, अरे शिप्रा को देखो, शिप्रा का वेट नहीं बढ़ रहा है, अरे शिप्रा तुम्हारा वेट नहीं बढ़ रहा है. There is a miscellaneous group of drug that is causing weight loss. We call them molindone. मैक्सिमम रिस्क ऑफ हाइपरप्रोलैक्टिनिमिया अमंग एटिपिकल। तो मैंने बताया था एटिपिकल में एक घुसपैठिया बैठा हुआ है। घुसपैठिया क्यों? क्योंकि है एटिपिकल में साइड इफेक्ट करता है एटिपिकल वाला, तो घुसपैठिया आर वेरी रिस्की, तो वी कॉल देम रिस्क पेरिडोन। कॉर्नियल ओपेसिटी एंड रेटिनल पिगमेंटेशन दोनों अगर बात करें तो इट विल बी क्लोरप्रोमाजिन, थायोरिडाजिन। इट कैन ऑल्सो कॉज retinal pigmentation, brownish retinal pigmentation, है ना, brownish retinal pigmentation, उसको वर्ड दिया गया browning of visits. Every time the drug reach to the retinal level, they will leave some of the pigment, leave some of the part that turn out to be brownish. So browning of visits. Which antipsychotic that is causing cataract? So we have in our story a queen who was blind. So मैं बोलता हूँ अंधी रानी, है ना। कैटरैक्ट कौन कराता है? क्यूटियापिन अंधी रानी, क्वीन कैटरैक्ट, ठीक है, क्वीन कैटरैक्ट। ड्रग्स that are showing disulfiram like reaction. Disulfiram like reaction will be caused by certain drug like anti-amoebic drug metronidazole, all time favorite question. Antifungal drug is going to be griseofulvine. These are some of the important cephalosporin, right? Procarbazine is anti-cancer drug. Chlorpropamide is one of the first generation sulfonylurea. This is mainly going to be seen due to inhibition of aldehyde dehydrogenase inhibiting property. Because of that, there will be increase in the level of acetaldehyde. This acetaldehyde cause nausea, vomiting, flushing, fall in the blood pressure, headache. All these problems will be noted, right? Abdominal pain, all this problem will be noted. तो बोलेगा एक पेशेंट है जिसको एंटीएमिबिक पे रखा गया है and he went to a party and consumed alcohol. Which antiemic drug is possibly responsible? So that is going to be metronidazole. Then अगले एग्जाम में क्वेश्चन पूछेगा कि कौन सा एंजाइम बॉडी में इनहिबिट हो गया, तो ड्यू टू एल्डिहाइड डिहाइड्रोजनेज इनहिबिटिंग प्रॉपर्टी. सो ड्रग्स दैट आर शोइंग डाइसल्फिराम लाइक रिएक्शन विल बी गवर्नमेंट मेडिकल कॉलेज. मैं बोलता हूँ बड़े प्यार से गवर्नमेंट मेडिकल कॉलेज ऑफ मध्य प्रदेश एंड छत्तीसगढ़. यहाँ पे अल्कोहल वाले साइड इफेक्ट मिलते हैं. गवर्नमेंट मेडिकल कॉलेज ऑफ मध्य प्रदेश एंड CHLU छत्तीसगढ़. कॉलेज में C4T10 एंड सिफोपेराजोन दे आर ऑल सेफेलोस्पोरिन ओनली. तो एक ही साथ आ जाएगा C4T10 सिफोपेराजोन, दे आर द सेफेलोस्पोरिन. गवर्नमेंट मेडिकल कॉलेज ऑफ मध्य प्रदेश एंड छत्तीसगढ़, दे आर द mnemonic to remember drugs that are showing disulfiram like reaction. Methadone is actually going to be a very long acting opioid. Methadone is going to be very long acting opioid and mainly utilized in opioid de-addiction therapy. It is mainly utilized in opioid de-addiction therapy. We call this opioid de-addiction therapy as MST, that is going to be methadone substitution therapy. Methadone substitution therapy, MST, methadone substitution therapy. ठीक है. Whenever an opioid addict comes, we do not suddenly stop, rather we give an alternative opioid, and one of the most preferred alternative opioid that we can utilize here is known as your methadone. One of the alternative that we can use will be your methadone. Okay. Tramadol and tapentadol क्या है? What is tramadol? Tramadol is one of the opioid, right? Opioid that is going to be mu receptor agonist with SNARI. What is SNARI? Serotonin noradrenaline reuptake inhibitor. What is SNARI? That is going to be serotonin noradrenaline reuptake inhibitor. What is SNARI? That is going to be serotonin noradrenaline reuptake inhibitor. So this is your tramadol or any other opioid. Remember guys, we do not use them in the management of, हम इनको अवॉइड करते हैं यूजुअली इन द मैनेजमेंट ऑफ. कोई कोलिकी एब्डोमिनल पेन अगर होता है ना तो उसमें इनको अवॉइड किया जाता है. वी डू नॉट यूज देम इन द मैनेजमेंट ऑफ द कोलिकी एब्डोमिनल पेन, बी इट अ केस ऑफ ट्रामाडोल और बी इट अ केस ऑफ टापेंटाडोल. ट्रामाडोल एंड टापेंटाडोल. ट्रापेंटाडोल का मैकेनिज्म ऑफ एक्शन थोड़ा सा अलग है. कैसे? बिकॉज इट इज एक्चुअली गोइंग टू बी म्यू रिसेप्टर एगोनिस्ट विथ नारी noradrenaline reuptake inhibitor. So this will increase the level of serotonin and increase the level of noradrenaline. This will increase the level of mainly noradrenaline only. So again, examiner question पूछा, which of the following drug is acting by opioid and non-opioid पाथवे। ओपियोइड और नॉन ओपियोइड दोनों एक्टिविटी किसका है जी? तो ओपियोइड एंड नॉन एक्टिविटी, अगर एग्जामिनर ऐसा सवाल पूछता है कि किसका जो दोनों एक्टिविटी आ रहा है, ओपियोइड एंड नॉन ओपियोइड, देन द आंसर टू दिस क्वेश्चन विल बी ट्रामाडोल। ट्रामाडोल पूछा जा चुका है, तो अगला पोटेंशियल एमसीक्यू हो सकता है आपका कौन सा? टापेंटाडोल। टापेंटाडोल विच इज अ म्योपियोइड एगोनिस्ट with the NARI. NARI stand for noradrenaline reuptake inhibitor. Noradrenaline reuptake inhibitor. Okay. Tramadol, it is utilized for any mild to moderate pain, post-operative pain, right? Most potent opioid is going to be sufentanil. Sufentanil is potency compared to morphine will be around 1000 times more potent. ठीक है. Loperamide, diphenokylate. Loperamide is considered as a drug of choice for chemotherapy-induced diarrhea. Chemotherapy-induced diarrhea. It's also an opioid. Chemotherapy-induced diarrhea. It's also an opioid. Naloxone is considered as the antidote for opioid poisoning. Antidote for opioid poisoning या opioid overdose. Naloxone. Naltrexone and nalmefene. Naltrexone, it is mainly utilized in the de-addiction therapy. De-addiction after MST. MST क्या है? Methadone substitution therapy. We are mainly adding naltrexone to prevent the relapse. Nalmefene, it is also used in opioid overdose. In opioid overdose, we can also utilize nalmefene. Right? We can also utilize nalmefene. So they are all three of them, naloxone, nalmefene, and all three of them, they are considered as the opioid antagonist. They are all considered as the opioid antagonist. These are also opioid antagonists, or albumin and nalmefene. They are utilized for opioid-induced constipation. Opioid-induced constipation. The good news is that they are mainly peripherally acting. Are they opioid antagonist? Yes. So they are also opioid antagonist. लेकिन ये albumin nalmefene, they are opioid antagonist. Agreed. They are opioid antagonist. Agreed. And these are actually the peripherally acting opioid antagonist. Peripherally acting opioid antagonist. Okay. First choice of drug in OCD, panic disorder, right? That will be your SSRI, selective serotonin reuptake inhibitor, PTSD, eating disorder. In सभी के लिए we can actually utilize, right? In सभी के लिए we can actually utilize SSRI, selective serotonin reuptake inhibitor. Selective serotonin reuptake inhibitor. Okay. Date rape drug among benzodiazepines. Among benzodiazepines, the date rape drug is going to be फ्लूनाइट्राजिपाम. तो मैं बोलता हूँ डेट रेप ड्रग. कोई मल्टीपल अटेम्प्ट ऑफ रेप हैव बीन डन अंडर इन्फ्लुएंस ऑफ दिस ड्रग. दिस फ्लूनाइट्राजिपाम इज गोइंग टू बी ऑर्डरलेस एंड टेस्टलेस बेंजोडाइजेपिन. ऑर्डरलेस एंड टेस्टलेस बेंजोडाइजेपिन. तो कोई डेट पे आया, अटेम्प्ट किया रेप का, बिकॉज दे विल मिक्स दिस इन द फूड एंड ड्रिंक्स, और वो फ्लू कर गया नाइट्रोजन की स्पीड से, मतलब भाग गया. डेट रेप ड्रग है ना, डेट रेप ड्रग. Inverse agonist of benzodiazepine is going to be beta carbolin. They are the inverse agonist of benzodiazepine. For the prevention and arrest, मतलब prophylactically भी काम करेगा और acute में भी यूज करेंगे. That is going to be none other than your diazepam. Treatment for acute alcohol withdrawal. देखिए acute alcohol withdrawal में अगर आ रहा है patient, तो you can utilize the drug like benzodiazepine, like lorazepam. साथ में will be adding vitamin B1 as well. Right? Which anti-emetic drug is showing disulfiram-like reaction? Disulfiram-like reaction is mainly caused by metronidazole, which we have covered already. Which enzyme is inhibited? That is aldehyde dehydrogenase. That also we have covered. Opioid poisoning, it's a repeat. That is going to be naloxone. Metoclopramide and domperidone. Drug like your metoclopramide, it actually cross. They both are D2 blocker actually. They both are D2 blocker. But drug like metoclopramide, it actually crosses blood-brain barrier. Metoclopramide will be crossing blood-brain barrier and they will be associated with hyperprolactinemia and they can also cause extrapyramidal symptom. Extrapyramidal symptom like dystonia. कई बार एक word आता है abnormal posture is caused by which of the following drug? Antiemetic drug, metoclopramide. Domperidone do not cross the blood-brain barrier. It is only and only metoclopramide that cross the blood-brain barrier. Mania का drug of choice will be lithium. Lithium is one of the IMPase inhibitor. They reduce the secondary messenger IP3DAG. Lithium even at the therapeutic dose also can important side effect. What are the important side effects? So lithium side effect will be leukocytosis. Leukocytosis insipidus मतलब diabetes insipidus. Insipidus मतलब diabetes insipidus. Then we have tremors. Initially there will be fine tremor, right? Initially there will be fine tremors. In toxic dose there will be coarse tremor. Toxic dose आते आते this will turn out to be coarse tremor. Fine tremor followed by coarse tremor. There will be teratogenic drug as well. They can cause teratogenicity. They can cause Epstein anomaly. Right? Epstein anomaly, and they can also lead to hypothyroidism. They can also lead to what? Hypothyroidism. आवाज धीरे, आवाज कम आ रही है क्या किसी को? मेरे तरफ से आवाज तो प्रीटी क्लियर है और मैं अपने सिस्टम में भी सुन पा रहा हूँ अगर तो। आवाज तो प्रीटी क्लियर है। मैं लाइव पूरा वीडियो को मतलब देख रहा हूँ आपके कमेंट के लिए। अगर किसी की आवाज कम आ रही है तो प्लीज ट्राई टू चेक योर ओन सिस्टम। आवाज एब्सोल्युटली फाइन है और काफ़ी अच्छा ऑडियो सिस्टम है कि इसमें आवाज़ बिल्कुल भी कम नहीं है। अगर आपको लग रहा है तो एक बार सिस्टम चेक करिए, या बाकी लोगों को भी लग रहा है तो वी कैन गेट आवर सिस्टम चेक्ड। क्योंकि अगर सेम उसी स्ट्रीम से मैं भी देख रहा हूँ, उसी यूट्यूब से मैं भी देख रहा हूँ, अगर आप लोग को आवाज़ कम लग रही है तो प्लीज़ अदर स्टूडेंट्स ऑल्सो प्लीज़ कमेंट ऑन दिस वन कि आवाज़ कम है क्या। अगर तो लिथियम ओवरडोज में व्हाट इज द ट्रीटमेंट? तो वी कैन यूज हीमोडायलिसिस। हीमोडायलिसिस समथिंग दैट विल बी यूटिलाइज्ड इन लिथियम ओवरडोज। डिप्रेशन में है पेशेंट और स्मोकिंग डिपेंडेंस क्या आ रहा है तो बेस्ट ड्रग फॉर दैट इज गोइंग टू बी योर ब्यूप्रोपियोन। ब्यूप्रोपियोन डिप्रेस्ड पेशेंट विद स्मोकिंग, तो भाई साहब पियो नहीं, भाई साहब पियो नहीं, भाई साहब पियो नहीं, ठीक है। दैट इज गोइंग टू बी योर ब्यूप्रोपियोन। एंटी डिप्रेशन और उसके इंपॉर्टेंट साइड इफेक्ट, सबसे पहले दो क्वेश्चन इसमें आते हैं। एक, कौन सा SSRI, SNRI, TC है और इसके इंपॉर्टेंट साइड इफेक्ट क्या है, ठीक है। तो वी फर्स्ट टॉक अबाउट SSRI, SNRI एंड देन वी टॉक अबाउट द TCA, ठीक है। SSRI में वी हैव शेफ ड्रग, सिटालोप्राम, एसिटालोप्राम, फ्लुओक्सेटिन, फ्लुओक्सामिन, पैरोक्सेटिन, सर्टालिन। वी हैव शेफ, रिपीट विद मी, रिपीट, शेफ, सिटालोप्राम, एसिटालोप्राम, फ्लुओक्सेटिन, फ्लुओक्सामिन, पैरोक्सेटिन, सर्टालिन, शेफ ड्रग। SNRI they are going to also inhibit the reuptake of serotonin, but in addition के साथ noradrenaline भी है, तो we have serotonin noradrenaline reuptake inhibitor। तो we have two important neurotransmitter जिसका लेवल बढ़ रहा है, one of which will be serotonin and they will also increase the level of noradrenaline. The name of the drug is going to be venlafaxine and desvenlafaxine, duloxetine, milnacipran and levomilnacipran. Because there are two neurotransmitters increasing, I always say that learn this one with the help of a very simple story of famous ice cream flavor. By looking at the venlafaxine, can you think of a very famous ice cream flavor that I say? Vanilla. So we have vanilla duals my love. Repeat with me, vanilla duals my love. What is vanilla duals my love stand for? Venlafaxine, duals, duloxetine, my love, milnacipran, levomilnacipran. Vanilla duals my love. Venlafaxine, desvenlafaxine, the D isomer of the venlafaxine only. Duloxetine, milnacipran, levomilnacipran, right? SSRI, chef drug, citalopram, escitalopram, fluoxetine, fluoxamine, paroxetine and sertraline. The important side effect is also very easy to remember because इनके side effect भी आप याद कर सकते हैं with a simple mnemonic of SSRI. Side effect of SSRI will be SSRI. One S stand for your serotonin syndrome. Serotonin syndrome where the patient will have nausea, vomiting, diarrhea. Patient may be agitated, so there will be agitation, एंग्जाइटी, विविड ड्रीम्स, रंगीन सपने भी आ रहे होंगे, विविड ड्रीम्स, राइट, nausea, vomiting, diarrhea, agitation, anxiety, vivid dreams, serotonin. Then there will be sexual dysfunction. अभी sexual dysfunction जो है ना, there are two types of sexual dysfunction. One is, let's say, happy, other one is unhappy. So they can lead to unhappy, that is going to be anorgasmia, lack of orgasm, anorgasmia, decrease in the libido. But there is something called happy side effect, that is called delayed ejaculation. Because of the delayed ejaculation as one of the important side effect, remember it's one of the FDA approved drug for premature ejaculation. It's one of the FDA approved drug for premature ejaculation. Next is going to be restlessness. Next is going to be restlessness, and other one is called your insomnia. I stand for insomnia. I stand for restlessness, and I stand for insomnia. So we have SSRI ka side effect, that is going to be SSRI. SSRI ka side effect SSRI, and the same side effect is also noted with the SNRI, right? So TCA वाला जो side effect होता है, that is mostly related to their pharmacokinetic property as well. What are the TCA that we have? We have imipramine, trimipramine, desipramine, clomipramine, amitriptyline, and nortriptyline. So what are the drugs that we know? imipramine, trimipramine, desipramine, clomipramine, amitriptyline, and nortriptyline. So we have drugs, and I want you to remember by this that we have someone who is saying कि I will try, right? TCA, tricyclic, I will try. क्या बोला? I will try. So we have I try a desi club for my two friends Amy and Nora. I try a desi club for Amy and Nora. So what are the components that we have? I, and I'm trying for two more, so we become three, right? हम तीन हो गए, तो tricyclic antidepressant. I try desi club for Amy and Nora. The important side effect is related to their pharmacokinetic property. So they have alpha blocking property. Because of that, there will be fall in the blood pressure. This fall in the blood pressure, they would lead to, please remember, SNRI ka side effect is going to be same as SSRI. Fall in the blood pressure for TCA, that would also lead to reflex tachycardia. ये TCA का side effect है सारा का सारा, okay? Alpha blocker, they have anticholinergic property. Because of that, there will be blurring of vision. There will be dryness of mouth, constipation. Constipation is a very common side effect. Constipation, urine retention. All the anticholinergic side effect will be noted. Here. Anticholinergic side effect. Okay. Alpha blocking property, antihistaminic property. Because of that, they will also be causing sedation. They have some sedating property as well. They can also cause metabolic acidosis, not alkalosis, acidosis. And this metabolic acidosis can also induce arrhythmia. And for countering this, if there is arrhythmia that is there, you are supposed to treat this patient by giving soda bicarbonate, right? Soda bicarbonate, because metabolic acidosis है तो forced alkaline diuresis करेंगे. So the important side effect is actually related to its pharmacokinetic property, that this drug are actually having some anticholinergic, alpha blocking property, antihistaminic property, and metabolic acidosis. तो उसी से इनके साइड इफेक्ट को भी आप आसानी से याद कर सकते हैं. ठीक है? All clear? So these are the important antidepressant and their important side effect: SSRI, SNRI, TCA. TCA मतलब tricyclic antidepressant. SNRI, serotonin noradrenaline reuptake inhibitor. SSRI, selective serotonin reuptake inhibitor. Alright. अब क्विकली हम बात कर लेते हैं कार्डियोवास्कुलर सिस्टम के लिए. कार्डियोवास्कुलर सिस्टम, सो फार व्हाट ऑल वी हैव कवर्ड ऑटोकॉइड्स, इम्यूनोमोडुलेटर्स, है ना, जिसमें हमने रूमेटॉइड आर्थराइटिस, गाउट, वो सबको कवर कर लिया था. माइग्रेन को भी क्विकली देख लिया था. देन उसके बाद से हमने इंपॉर्टेंट पॉइजनिंग, एंटीडोट्स, वो सारे देख लिए. जनरल फार्मा, ANS देख लिया, और सेंट्रल नर्वस सिस्टम भी देख लिया, राइट. कार्डियोवास्कुलर सिस्टम में एंटी हाइपरटेंसिव ड्रग दैट इज कॉजिंग कुम्स पॉजिटिव, इट्स एक्चुअली गोइंग टू बी अल्फा मिथाइल डोपा. Is actually alpha methyl dopa. It's an old question of NEET PG, that is one of the alpha 2 agonist. Renin release and renin inhibitor, two separate question. A renin release inhibitor is actually going to be beta blocker. But if the question will be like renin inhibitor देन द आंसर वुड बी एलिस्किरेन। तो आपको ध्यान से पढ़ना है क्वेश्चन में क्या पूछ रहा है, रेनिन रिलीज इनहिबिटर पूछ रहा है या रेनिन इनहिबिटर पूछ रहा है, राइट? क्या पूछ रहा है ये आपको क्वेश्चन में देखना है, यू हैव टू सी दिस। मोस्ट कॉमन साइड इफेक्ट ऑफ एस इनहिबिटर, रिमेंबर एस इनहिबिटर का जो साइड इफेक्ट होता है मोस्ट कॉमन, इट्स एक्चुअली गोइंग टू बी ड्राई कफ, इट्स एक्चुअली गोइंग टू बी ड्राई कफ। इट्स मेनली सीन ड्यू टू द ब्रेडिकाइनिन, ब्रेडिकाइनिन की वजह से ड्राई कफ इज वेरी वेरी इंपॉर्टेंट साइड इफेक्ट। The usual side effect ACE inhibitor, I say at least remember ACE का side effect ACE. One is called angioedema, right? Angioedema, right? Angioedema. Then there is going to be cough, right? Angioedema, cough, and there is going to be elevated potassium. Angioedema, cough, and then there is going to be elevated potassium. ACE. ACE का side effect क्या होगा? ACE, right? ये जो ऊपर वाले हैं they are mainly again due to the bradykinin. They are actually going to be again due to the bradykinin. Again due to bradykinin. Okay. Again due to bradykinin. Angioedema, right? Angioedema, dry cough, and elevated potassium. Which ARB is having anti-aggregant property? So again anti-aggregant, that is because of the thromboxane A2 inhibiting property. अगर पूछे यूरिकोस्यूरिक प्रॉपर्टी, यूरिक एसिड को एक्सक्रीशन करेगा, तो ये सारे ARB का जो जवाब होता है दैट इज गोइंग टू बी लोसार्टान। द नेम ऑफ द एजेंट इज लोसार्टान। लो कर देता है यूरिक एसिड को, लो कर देता है बीपी को, लो कर देता है प्लेटलेट की एक्टिविटी को। The antiarrhythmic drug that is causing QT prolongation. See, QT prolongation can be caused by any drug that is having potassium blocking property. QT prolongation is noted with class 1A antiarrhythmic drug. A 1A antiarrhythmic drug is going to be quinidine, procainamide, and other one is called disopyramide. Quinidine, procainamide, and disopyramide, they can cause class 1A, and other one is going to be class 3 antiarrhythmic drug that can also cause. A very important class 3 antiarrhythmic drug is going to be amiodarone. There are so many other drugs like amiodarone, ibutyllite, sotalol, and ibutylite. All these are important. All these are important class 3 antiarrhythmic drug. Actually में class 3 itself is a potassium channel blocker, and 1A के साथ issue ये है that 1A is a sodium blocker with potassium blocking property. Sodium blocker with potassium blocking property. What is the side effect of amiodarone? The side effect of amiodarone, क्या side effect करेगा amiodarone? Amiodarone side effect multiple side effect करेगा, right? For example, they will be causing one of the side effect that is causing QT prolongation. They are also highly hepatotoxic drugs, so they will be causing liver toxicity, QT prolongation, liver toxicity, right? They can also lead to thyroid abnormality, endocrine side effect like thyroid abnormality. अब उसमें most common जो होता है that is going to be hypothyroidism. Hypothyroidism is more common compared to hyper, right? It can cause hyper as well, but hypo और hyper दोनों करा सकता है thyroid abnormality में, ठीक है? Then a very serious side effect that it can cause, will be known as your pulmonary fibrosis. A very serious side effect is called your pulmonary fibrosis. Okay, pulmonary fibrosis is a very very serious side effect. They can also do corneal microdeposits. एक और है corneal microdeposits, that is cornea verticillata, right? Corneal microdeposit, that is cornea verticillata, that can also be caused by amiodarone. So amiodarone is one of the class 3 antiarrhythmic drug, mainly potassium channel blocker. ठीक है? Levosimendan act by levosimendan. They are one of the phosphodiesterase 3 inhibitor. These are also given the name as the inodilator. That means they are having inotropic property and vasodilating property, mainly utilized in the angina. They are mainly going to utilize in the treatment of angina. Levosimendan. We have other drugs under same like ambrinon, milrinon, that is going to be inodilator. Ambrinon, milrinon, है ना? They are the phosphodiesterase 3 inhibitor. इन्हीं का दूसरा नाम होता है inodilator. एंजाइना में यूज कर सकते हैं. Digoxin is mainly acting by sodium potassium ATPase blocking. They are mainly acting by blocking sodium potassium ATPase. They are mainly acting by blocking sodium potassium ATPase. And the most common side effect is going to be nausea and vomiting of digoxin. But अगर एग्जाम में क्वेश्चन पूछे स्पेसिफिक साइड इफेक्ट क्या होगा, तो स्पेसिफिक साइड इफेक्ट इज कॉल्ड xanthopsia. Xanthopsia means yellow vision. Xanthopsia means yellow vision. Xanthopsia is yellow vision. Okay. So digoxin is one of the very important drug that is going to be preferred for atrial fibrillation in congestive heart failure, right? इसका एंजाइना नहीं, इसका कंजेस्टिव हार्ट फेलियर लिखा, आयन डायलेटर ना, तो यू विल बी राइटिंग CHF, कंजेस्टिव हार्ट फेलियर. ओके, कंजेस्टिव हार्ट फेलियर लिखिएगा. डिजॉक्सिन ऑल्सो इन कंजेस्टिव हार्ट फेलियर विद एट्रियल फिब्रिलेशन. Trimetazidine, ranolazine, tri-running, they are the fatty acid oxidation inhibitor. They are mainly going to utilize in the angina. Currently, ranolazine is one of the drug. Trimetazidine, ranolazine. Ranolazine का main mechanism of action when they ask, main mechanism of action of ranolazine, main mechanism of action of ranolazine is going to be late sodium influx inhibitor, right? फासुदिल, इट्स वन ऑफ द रो काइनेज इनहिबिटर. फासुदिल, मैं बोलता हूँ फासुदिल साउंड्स लाइक फंसा हुआ दिल जो रोता रहता है. रो काइनेज इनहिबिटर, फासुदिल, फंसा हुआ दिल. A fibrate that is having uricosuric property is called phenofibrate. Always do remember, guys, all these fibrate are going to be PPAR alpha agonist. PPAR alpha, PPAR, peroxisome proliferator activator receptor alpha. The anti-dyslipidemic drug of choice in child and pregnancy. So we'll be using colesevelam, cholestiramine, right? Colesevelam, colesevelam. They are the anti-dyslipidemic drug of choice for child and pregnancy. Okay, they are the bile acid sequestrant, mainly working in the intestine. Which is the drug of choice for low GFR, or I would say resistant hypertension? We'll be using spironolactone. That is going to be potassium sparing diuretic. Renoprotection diabetic patient, always remember ACE inhibitor. And severe hypocalcemic technique, calcium gluconate infusion. Antihypertensives in pregnancy is another very, very important question. Two questions are asked here. One is, what is safe antihypertensive drug in pregnancy? I always say safe is Lady Harding Medical College. Safe is Lady Harding Medical College. Lady Harding Medical College. They are the safer antihypertensive drug in pregnancy. That is going to be drugs like your labetalol. Labetalol is the third generation beta blocker. They are the drug of choice. Harding will be hydralazine, a potassium channel opener. Another very, very important question that is very, very frequently asked. Med will be alpha methyl dopa and clonidine. They are the alpha 2 agonist. And college will be calcium channel blocker, and C say cardio selective beta blocker. Calcium channel blocker, and please remember any beta blocker that is ending with the dipine like amlodipine, nifedipine, they are the one that will be utilized. So Lady Harding Medical College is considered the safer antihypertensive drug in pregnancy. Now the next question that arises that what is unsafe then? तो मैं बोलूँगा लेडी हार्डिंग मेडिकल कॉलेज तो सेफ है, वहाँ चले जाइए जी. लेकिन कहाँ मत जाइए? अवॉइड द DNB कॉलेजेस. वेयर विल यू अवॉइड? Avoid the DNB. Avoid DNB. That is going to be all the ACE inhibitor, that is all the prils, all the ARB, all the sartans. Pril and sartan is always contraindicated. Then we have diuretics are always avoided, can lead to oligohydramnios. And non-DHPs like verapamil, DHPs use कर सकते हैं, non-DHPs should be avoided. And beta blocker should also be avoided. कौन सा beta blocker? Non-selective beta blocker should not be selected. Non-selective beta blocker should not be selected. Okay. So these are some of the important antihypertensives in the pregnancy. A quick summary of those antihypertensives in pregnancies and all-time favorite question of the examiner as well. बार बार पूछा जाता है, ठीक है. नेक्स्ट इज गोइंग टू बी डायरेटिक्स. क्विकली हम रिवाइज कर लेते हैं डायरेटिक्स को. डायरेटिक्स, कुछ डायरेटिक्स हैं, फॉर एग्जांपल एसिटाजोलामाइड, डोरजोलामाइड. वेयर दे आर वर्किंग मेनली एट द PCT, proximal convoluted tubule. We are going to see they are acting by inhibiting carbonic anhydrase inhibitor. Furosemide, torsemide, they are working mainly at the level of thick ascending limb of loop of Henle by blocking NaK2Cl cotransporter, sodium potassium 2 chloride cotransporter, hydrochlorothiazide, indapamide. They are going to work at the level of early part of DCT, and the early part of DCT working at the NaCl blocking, right? NaCl, hydrochlorothiazide, sodium chloride cotransporter inhibitor. Spironolactone, eplerenone, they are working at the collecting duct. कलेक्टिंग डक्ट में जो ऊपर वाले हैं दे आर एक्चुअली गिवन द नेम ऑफ द पोटेशियम स्पेयरिंग डायरेटिक, इनका नाम दिया गया पोटेशियम स्पेयरिंग डायरेटिक्स. Spironolactone, eplerenone, they are considered as the aldosterone receptor blocker, and triamterene, there is a wrong here, I want you to correct this one. Triamterene and other one is called amyloride. Triamterene and other one is called amyloride, SETA. Triamterene and other one is called amyloride. So they are actually considered the epithelial sodium channel blocker, INI-CET blocker. Epithelial sodium channel blocker, they are known as your INI-CET blocker. All right. So we have different sites. तो कई बार ना ये ट्यूब्यूल दे देता है और उस ट्यूब्यूल में पूछता है कि कहाँ पे काम करेगा. कार्बोनिक एनहाइड्रेज इनहिबिटर, एस्टाजोलामाइड, डोरजोलामाइड, ब्रिंजोलामाइड, मिथाजोलामाइड, and thick ascending limb of loop of Henle, we have furosemide, torsemide, hydrochlorothiazide, indapamide, bumetanide, they are the NaCl inhibitor. Spironolactone, eplerenone, that is going to be spironolactone, eplerenone, SE, triamterene, amyloride, TA. SETA, SETA is a very simple mnemonic to remember, potassium sparing diuretics. Side effect को लिखने के लिए I will just quickly tell you that if you are going to use systemic carbonic anhydrase inhibitor, the most common side effect for them, the most common side effect is going to be hypokalemic, hyperchloremic, metabolic acidosis, because they will be causing loss of bicarbonate leading to metabolic acidosis, right? They can also lead to other side effect that is called paresthesias of upper limb, lower limb, increasing the renal stone risk बढ़ा देंगे, bone marrow suppression because of the sulfa drug component that they have. Sulfa drug is always associated with the bone marrow suppression. Okay. So most common side effect for this one is going to be hypokalemic. Among all the diuretics that is causing hypokalemia, carbonic anhydrase maximally causing hypokalemia. Carbonic anhydrase inhibitor is maximally associated with hypokalemia, right? Next it is going to be your thick ascending limb of loop of Henle, जिसको हम बोलते हैं loop diuretics. इसका नाम रखा गया loop diuretics, furosemide, torsemide, ये bumetanide यहाँ पे भी नहीं होगा, furosemide, torsemide, bumetanide, they are the loop diuretics. They can actually cause the usual side effect, like for example hyponatremia, hypokalemia. Please remember, loop actually causes loss of calcium. Loop diuretic causes loss of calcium, and therefore they can also lead to hypocalcemia. And metabolic alkalosis is the one important side effect reported with them. An important point to be noted here, that because they are causing loss of calcium, remember these are going to be avoided. They are going to be avoided in patient with history of renal stone, avoided in patient with history of renal stone, avoided in patient with history of renal stone, right? And hypocalcemia. अगर किसी को hypocalcemic history है तो we will not be using loop diuretics because they themselves are causing hypocalcemia. They're very fast diuretics. Hydrochlorothiazide, indapamide, metolazone, these are actually known as your thiazide diuretics. इनको हम thiazide का नाम देते हैं, thiazide diuretics. They can have similar kind of side effects, same as your loop diuretics. For example, they can also lead to hyponatremia, hypokalemia, metabolic alkalosis, लेकिन they actually increase the calcium का reabsorption. and therefore they can increase the calcium level, hypercalcemia, and that is why these are going to be the preferred diuretic in renal stone history, renal stone जो कि अभी 2025 का क्वेश्चन है, and also if there is a hypocalcemia का history, if there is a hypocalcemia history, if there is a renal stone history, the preferred diuretic is going to be your thiazide diuretics. Important side effect that is noted with the potassium sparing, they all can cause hyperkalemia. They all can cause hyperkalemia. Spironolactone specifically is also associated with spironolactone specifically is also associated with gift of gynecomastia. Gynecomastia, right? Gift of gynecomastia, decreasing the libido, right? That is spironolactone. So these are the important diuretics. उनके कहाँ पे काम कर रहे हैं, क्या important side effect है? At one place only we have summarized the entire one. Then there is going to be mortality reducing drug in chronic congestive heart failure. In chronic congestive heart failure, there are certain drugs that decrease the mortality. Mortality reducing drug in patient with the chronic congestive heart failure. So one is called your ARNI. ARNI stands for a combination of ARB, angiotensin receptor blocker, that is valsartan, plus neprilysin inhibitor. Neprilysin inhibitor is a new drug that is called sacubitril. So we have a combination of these two. इसको बोलते हैं ARB plus neprilysin inhibitor. ARNI is overall the best. Next is going to be your ACE inhibitor, all the pril वाले drug. Next is going to be ARB, all the sartan वाले drug. Then we have aldosterone receptor blocker, like spironolactone. They have mortality reducing property. Beta blocker, please remember, beta blocker always started in a low dose, never started at the optimal dose. Low dose beta blocker will be given. The preferred one is going to be BMC, that is going to be betaxolol, metoprolol, and carvedilol. They have shown to have mortality reducing property. And SGLT2 inhibitor. I mean पिछले अगर मैं 10 एग्जाम को ले लूँ सबको मिला के INI-CET नीट PG FMG, तो SGLT2 inhibitor एंड कंजेस्टिव हार्ट फेलियर में कम से कम 10 एग्जाम को मैं अगर मिला लूँ तो कम से कम 6 बार ये क्वेश्चन पूछा गया SGLT2 वाला. डायबिटिक पेशेंट विद CHF प्रिफर्ड SGLT2, है ना, या कार्डियक एबनॉर्मेलिटी हो रहा है, इजेक्शन फ्रैक्शन कम है, कौन सा प्रीफर करेंगे, है ना, SGLT2 inhibitor. So SGLT2 inhibitor is also having mortality reducing property in a patient with chronic congestive heart failure. So in a patient with chronic congestive heart failure, the drug that is decreasing mortality is going to be A, lots of A, and B and Fs, BNS. So we have ABS, lots of A, BNS, ABS, A, lots of A, BNS, ABS, right, ABS. तो अगर इंडियन पैटर्न ओबेसिटी देखा जाए तो वी हैव सिंगल पैटर्न एब्स, सिंगल पैक एब्स, लेकिन अगर आपको मोर्टेलिटी रिड्यूस करना है तो 4 पैक वाला ऐप चाहिए, 4, राइट. आर्नी, एस इनहिबिटर, ARB, एल्डोस्टेरॉन, बी से बीटा ब्लॉकर एंड एस से SGLT2 इनहिबिटर. ऑलराइट. सो रीनल एंड कार्डियो क्विकली वी हैव कवर्ड इंपॉर्टेंट एरियाज जो उनके PYQs हैं. Next, we are going to see the anti-diabetic drugs. So alpha glucosidase inhibitor, the site of action is mainly in the intestine. Remember the drugs like acarbose, voglibose, miglitol. The side effect usually is going to be, flatulence, malabsorption. These are the important side effects. Flatulence, malabsorption are the important side effect of acarbose, voglibose, and miglitol. And they can also lead to diarrhea, that is going to be secretory diarrhea. Secretory diarrhea क्यों होगा? Why? Because they are not allowing the absorption of complex sugar, right? So the site of action is mainly in the intestine. And therefore you have to remember this is the only this is the one drug that can be utilized. It can be used in type 1 diabetic mellitus and also in the type 2 diabetic mellitus. दोनों भी यूज कर सकते हैं. Flatulence, malabsorption, diarrhea, patient will be bloated. So ज़्यादातर GI वाले साइड इफेक्ट इसके साथ आ रहे हैं. कौन साइड इफेक्ट आ रहे हैं? GI वाले. GLP-1 एनालॉग, एक्जिनाटाइड, लीराग्लुटाइड, लिक्सिसिनाटाइड, दे आर ऑल GLP-1 एनालॉग. एक्जिनाटाइड, लीराग्लुटाइड. एक और है इसमें बोलते हैं सीमाग्लुटाइड. सीमाग्लुटाइड इज ओरली अवेलेबल, ठीक है, ओरली ऑल्सो अवेलेबल. ऑल दीज आइड वाले ड्रग, पेप्टाइड वाले ड्रग आर गिवन विद द सबक्यूटेनियस, लाइक GLP-1 एनालॉग सबक्यूटेनियस. और जितने भी ड्रग के नाम के साथ पेप्टाइड वाला आइड आता है दे कैन कॉज हाइपोग्लाइसीमिया. So one of the important side effect will be hypoglycemia. Please remember ऊपर वाले में मैंने hypoglycemia नहीं लिखा है. They do not cause hypoglycemia. That is alpha glucosidase. Hypoglycemia. They can also cause weight loss, pancreatitis, and increase the risk of MCT, medullary carcinoma of thyroid. MCT, medullary carcinoma of thyroid. All right. Weight loss is maximally noted with the liraglutide and semaglutide. These are the ones that are also got approval for obesity. They are also got approval for obesity. Obesity. Obesity में injectable वाला ही देते हैं. Okay. DPP-4 inhibitor all the gliptins, like for example we have sitagliptin, right? We have saxagliptin, sitagliptin, saxagliptin, alogliptin, vildagliptin, सबके नाम में gliptin आएगा. टेनेलिग्लिप्टिन, राइट. एंड एक और है इसको बोलते हैं लीनाग्लिप्टिन. Why linagliptin is very famous here? Reason being, linagliptin is the only one that is excreted via hepatic route. And therefore they are safe in renal failure. So lina कहाँ से excrete होता है? लिवर से. They are safe in renal failure. You do not require dose adjustment in renal failure. The important side effect of this DPP-4 inhibitor is going to be nasopharyngitis. INI-CET में इसको nasopharyngitis को ज़्यादा प्रेफर करते हैं compared to the word URTA, upper respiratory tract infection, and they can also cause headache. They are not very much associated with hypoglycemia or weight loss. Okay. Amylin analog like pramlintide. They can also IDE आ गया तो they can also cause hypoglycemia. Mind the fact, if any drug is having IDE, peptide wala IDE, they can cause hypoglycemia. Peptide wala IDE, they can cause hypoglycemia. Okay. Weight loss and pancreatitis. Right? Pancreatitis. Hypoglycemia, weight loss and pancreatitis. SGLT2 inhibitor, canagliflozin, dapagliflozin, empagliflozin. This is going to be gliflozin, canagliflozin, dapagliflozin, empagliflozin. This is going to be gliflozin. They are associated with the side effect. The most common side effect is going to be UTI और PGI. चंडीगढ़ वाले लोग या INI-CET वाले वर्ड लोग यूज करते हैं वर्ड यूरोसेप्सिस. UTI और यूरोसेप्सिस, right? Other side effect will be weight loss, Fournier's gangrene, है ना. Older studies के according to the older studies, they say that drug like your canagliflozin, it is increasing the fracture risk, but this is not a preferred, study. अगर old study की बात करेंगे, so they have show कि they increase the fracture risk. Newer study do not justify this, do not support this. Sulfonylurea, the first generation we have chloropropamide, tolbutamide. Tolbutamide ये वही है which is following zero order kinetics. It is the same which follows zero order kinetics. Chloropropamide, it is associated with DLR. DLR is disulfiram-like reaction. Chloropropamide associated with the disulfiram-like reaction. Chloropropamide, disulfiram-like reaction, it is also associated with SIADH. ठीक है. तो फर्स्ट जनरेशन को ज़्यादा कॉमनली यूज नहीं करते हैं, तो वी मेनली प्रीफर द सेकेंड जनरेशन वन. एंड सेकेंड जनरेशन वेरी इजी टू रिमेंबर, देयर नेम स्टार्टिंग विद ग्लाइब्यूराइड, ग्लाइक्लाजाइड, ग्लाइमीपैराइड, ग्लाइबिनक्लामाइड, राइट. ऑल दी सेकेंड जनरेशन वन. सबके नाम में देखेंगे तो आइड आ रहा है, पेप्टाइड वाला आइड. सो द इंपॉर्टेंट साइड इफेक्ट, द मोस्ट कॉमन साइड इफेक्ट इज गोइंग टू बी एक्चुअली hypoglycemia. The most common side effect is going to be what? Hypoglycemia. Peptide wala IDE causing hypoglycemia. Other side effect that it can cause will be weight gain, because they are insulin secretagogue, and insulin always have fat sparing property. Insulin always have what? Fat sparing property. They can cause hypoglycemia, weight gain, hypoglycemia, weight gain, bone marrow suppression, agranulocytosis. So these are some of the important side effects, and they are also causing hepatotoxicity. टॉक्सिसिटी, इंपॉर्टेंट साइड इफेक्ट दैट इज रिपोर्टेड विद सल्फोनाइलूरिया. इनका नाम होता है इंसुलिन सिक्रेटाकोक. सो द अदर नेम फॉर देम इज कॉल्ड योर इंसुलिन सिक्रेटाकोक. Biguanides like metformin, fenformin, they are the biguanides. Metformin, fenformin, तो they are associated with lactic acidosis. Fenformin is associated with lactic acidosis. इसको क्लिनिकली ज़्यादा यूज़ करते नहीं है. Fenformin को भी don't use clinically. So the only one that is left will be metformin. Metformin is associated with the important side effect. What is the side effect of metformin? What is the side effect of metformin, guys? Right? What is the side effect of metformin? Anyone? They actually reduce, okay? They actually reduce the vitamin B12 absorption. They're actually going to decrease the vitamin B12 absorption, and because of decrement in the vitamin B12 absorption, they can cause megaloblastic anemia. They can cause megaloblastic anemia. Megaloblastic anemia is something that they can cause. Apart from that, they can also cause peripheral neuropathy. They can also cause side effect called lactic acidosis. Okay, lactic acidosis. Okay, yes, B12 deficiency is the one that is causing your megaloblastic anemia and peripheral neuropathy. Usual nausea, vomiting, diarrhea hai, but unexplained diarrhea, yes, that's a very known side effect. PPR gamma agonist, gamma से ग्लूकोज याद रखना है, gamma से ग्लूकोज, पायोग्लिटाजोन. The name of the drug in this one is going to be pioglitazone. They can cause sodium and water retention. Sodium and water retention. That is one side effect that can also lead to weight gain and increasing the bladder cancer risk. तो डायबिटीज में दो कैंसर के लिए जाना जाता है, एक ब्लैडर कैंसर पायोग्लिटाजोन. तो मैं बोलता हूँ एनीथिंग दैट यू पियो इट विल गो टू द ब्लैडर. कुछ भी पियोगे तो कहाँ जाएगा? ब्लैडर में जाएगा. तो एक ब्लैडर कैंसर. एक हो गया आपका मेडुलरी कार्सिनोमा ऑफ थायराइड कैंसर, दैट इज गोइंग टू बी लीराग्लूटाइड, लिक्सिसिनाटाइड, है ना, सीमाग्लूटाइड, ऑल दोस. Now, because they are causing sodium and water retention and weight gain, remember एक और क्वेश्चन पूछा कि the PPR gamma agonists, they are contraindicated in which scenario? They are going to be contraindicated in congestive heart failure and also contraindicated in patient with the CME, cystoid macular edema, because this sodium and water retention, they can also lead to another side effect that is called macular edema. Macular edema will be another side effect. ओके, मिक्सड इमा कोमा के लिए हम IV-T4 देंगे. IV-T4 100 माइक्रोग्राम स्टैट फॉलोड बाय 25 माइक्रोग्राम every 6 hours, Q6 hours. There is a bile acid sequestrant that is approved as an anti-diabetic drug. The name of the drug is called colesevelam. Dopamine agonist bromocriptine has been approved to be utilized in diabetes as well. They thought and they have given the hypothesis that deficiency of the dopamine is possible cause of the insulin resistance. So dopamine ka agonist they started given, you know. Then we have DPP-4 inhibitor in renal failures. कौन सा safe है? That is going to be लीना. ये मैं आपको already बता चुका हूँ. लीनाग्लिप्तीन. All the gliptins are DPP-4 inhibitor. ड्रग ऑफ चॉइस फॉर हाइपरथायरॉइडिज्म इन फर्स्ट ट्राइमेस्टर, दैट इज गोइंग टू बी प्रोपिलथायोरेसिन फर्स्ट ट्राइमेस्टर में. अगर आपने फर्स्ट ट्राइमेस्टर में मेथिमाजोल कार्बाजोल दे दिया तो दे कैन लीड टू योर कंडीशन दैट इज कॉल्ड एप्लेशिया एक्यूटिस. ड्रग ऑफ चॉइस फॉर हाइपरथायरॉइडिज्म सेकंड थर्ड ट्राइमेस्टर, इट इज गोइंग टू बी ड्रग लाइक योर मेथिमाजोल और कार्बाजोल. इमरजेंसी कॉन्ट्रासेप्शन का एक क्वेश्चन आपके एग्जाम में रहता ही है. वन क्वेश्चन ऑफ इमरजेंसी कॉन्ट्रासेप्शन. इफ देयर इज इमरजेंसी कॉन्ट्रासेप्शन नीडेड विद इन 72 आवर्स, the best one is going to be levonorgestrel 1.5 milligram stat or 0.75 का 2 dose at 12 hours interval. Within 5 days अगर पूछता है तो best is going to be IUCD. The most effective is going to be IUCD, intrauterine contraceptive device is most effective. Lanreotide, pasireotide, right? Lanreotide, pasireotide, they are actually somatostatin analog. सोमैटोस्टैटिन एनालॉग. तो कहाँ पे यूज होंगे सोमैटोस्टैटिन एनालॉग? इट कैन बी यूटिलाइज फॉर द ट्रीटमेंट ऑफ एक्रोमेगली, जाइगेंटिज्म, राइट, लैंड्रियोटाइड, पैसीरियोटाइड, है ना. लैंड्रियोटाइड का तो डिपोट भी अवेलेबल है. acromegaly, gigantism. उसके अलावा we can also utilize them in esophageal variceal bleed, right? And also can be utilized in secretory diarrhea. Also can be utilized in secretory diarrhea. In all these conditions, we can utilize. H. pylori therapy. H. pylori is a very common, H. pylori is very common organism that is causing chronic or chronic peptic ulcer disease. So इसमें multiple therapy that we have, triple therapy, quadruple therapy, है ना? So triple therapy is going to have three important drugs, two antibiotics that we know is out of CAM, and साथ में we'll be adding PPI, two antibiotics साथ में we are going to add PPI, that is going to be proton pump inhibitor. What are the three antibiotics? The three antibiotics is going to be clarithromycin, amoxicillin, 1 gram amoxicillin, high dose में amoxicillin, clarithromycin and metronidazole. So out of three, any two antibiotics will be taken. So I say collectively CAMP, they are the three important drugs. तीन एंटीबायोटिक्स में से कोई भी दो ले लेंगे, क्लेरिथ्रो, एमोक्सिसिलिन, मेट्रोनिडाजोल, एंड साथ में पीपीआई विल बी एडेड. क्वाड्रुपल में देयर विल बी फोर ड्रग्स में दिस इज गोइंग टू बी अ टेट्रासाइक्लिन बेस्ड थेरेपी. सो आई से TMC, that is going to be tetracycline, M से minocycline and C से CBS, that is one of the bismuth compound, colloidal bismuth subsalicylate. ठीक है, and साथ में we'll also add PPI will definitely be added. Okay, PPI is going to be definitely added here. H. pylori therapy. In INI-CET, they can also ask one more question, that's called the sequential therapy. So I want you to add sequential therapy also in your note. Sequential therapy may, if you are going to look at the quadruple therapy and triple therapy, they are given for 10 to 14 day. Quadruple therapy 10 to 14 day also. Sequential 10 day. So they are saying you use the antibiotic, it's okay, whatever antibiotic that you have used in triple therapy, it's okay you use, but don't give all the antibiotics together. Why don't you use them in sequence? Because the organism is developing resistance. So from day 1 to day 5, they are advising PPI plus a high dose of amoxicillin, 1 gram twice daily amoxicillin, PPI plus amoxicillin, day 1 to day 5. Okay, PPI plus amoxicillin. Then they are saying day 6 to day 10 you give the antibiotic in sequence. मतलब अब यहाँ पे आप देंगे क्लेरिथ्रोमाइसिन और either metronidazole or tinidazole, right? If metronidazole is not effective, then you can give your patient tinidazole, और PPI तो साथ में चलता रहेगा. PPI is always going to be a part. As a matter of fact, you are advised to continue PPI, right? Continue PPI at least for 4 to 6 weeks even after the therapy. मतलब triple therapy, quadruple therapy, sequential therapy आपने कर लिया, उसके बाद भी you are supposed to use the PPI proton pump inhibitor. The order of the therapy, it always goes in the same order. Like first we will be giving triple, then we are going to give quadruple से नहीं माना, then we are going to give sequential therapy. ठीक है. All right. Then we have the PCABs, potassium competitive acid blocker, a new drug. PCABs is potassium competitive acid blockers. PCABs. We have vonoprazan. तो PPI में क्या था? प्रजोल. ये होगा प्रजान, टीगो प्रजान, वोनोप्रजान. ये प्रजान वाले हैं. ये क्या है? प्रजान वाले ड्रग हैं. They are vonoprazan, tigoprazan, कीवर्प्रजान. Right? Now, what is the advantage of these PCABs? PCABs, they actually competes. They are actually going to compete. PCABs, they are mainly going to compete. They actually competes at the potassium binding site. they compete at the potassium binding site. ठीक है, these are not prodrugs. मतलब omeprazole and all, they are prodrugs. They were getting activated to sulfonamide. They are not prodrugs. You were supposed to give them early morning before breakfast, the PPIs. The dosing around meal is not necessary. Dosing around meal is not important. मतलब कभी भी दे दो, right? They are more potent. They are more potent, right? They have no interaction with the clopidogrel also. No interaction with clopidogrel. मतलब इनका enzyme inhibiting property भी नहीं है, right? So everything is good with the vonoprazan, tigaprazan. I mean, as per the study, they are saying they are quite superior as compared to what we have by the name of your PPI. प्रोटॉन पंप इनहिबिटर से काफ़ी बेहतर पाए गए हैं. कॉस्ट भी इतना ज़्यादा नहीं है. इंडिया में रेड्डीज लैबोरेटरी करके जो फार्मास्यूटिकल कंपनी है, दे हैव बीन मार्केटिंग दिस ड्रग. ऑलराइट. एंटीप्लेटलेट एंटी कोआगुलेंट, जल्दी से इसको समराइज कर लेते हैं. एस्पिरिन क्या है? एस्पिरिन इज वन ऑफ द COX-1 इनहिबिटर. Low dose aspirin will be having antiplatelet property. Low dose aspirin will always and always show your antiplatelet property. Antiplatelet property, remember that. They are the irreversible COX-1 inhibitor. Then we have the ticlopidine, clopidogrel, prasugrel. They are known as your P2Y12 inhibitor. P2Y12 inhibitor will be further divided into irreversible P2Y12 inhibitor, and another one will be reversible P2Y12 inhibitor. That is going to be Cangrelor. ग्रेल के जैसा है लेकिन रिवर्सिबल है. टीका ग्रेलोर भी ग्रेल के जैसा लेकिन रिवर्सिबल है. अब इसमें पूछा कि कौन सा आईवी देंगे, कौन सा ओरल देंगे, तो ध्यान रखिएगा. कैनुला से कैंग्रेलोर. टीका साउंड्स लाइक योर फेवरेट डिनर दैट इज गोइंग टू बी टुनाइट, दैट इज चिकन टिक्का और पनीर टिक्का. तो टीका ओरली लेते हैं ना. सो दे आर द रिवर्सिबल इनहिबिटर, टीका ग्रेलोर, कैंग्रेलोर. रिमेंबर this ticagrelor cangrelor, it can be continued till a day before surgery. Ticlopidine, clopidogrel is the one that is commonly utilized. You are supposed to stop a week prior to surgery because they are the irreversible inhibitor. ठीक है. Abciximab, tirofiban, aptifibatide. Abciximab, tirofiban, aptifibatide, they are going to be your GP2B3A inhibitor. They are the strongest antiplatelet drug, and they inhibit the platelet cross-linking. Abciximab, tirofiban, and aptifibatide. Etopaxar, vorapaxar, they are going to be protease activated receptor inhibitor, also given the name as a thrombin inhibitor. PAR inhibitor, also given the name as a thrombin inhibitor. Warfarin, it's one of the competitive inhibitor of vitamin K dependent factors, or I would say they inhibit the gamma carboxylation, right? They inhibit the gamma carboxylation because it is the gamma carboxylation that is actually involved in the activation of vitamin K. तो ये जो inactive form vitamin K है, it is mainly getting activated, reduced or activated form with the help of your enzyme vitamin K epoxide reductase, right? Vitamin K epoxide reductase inhibit the gamma carboxylation of vitamin K epoxide reductase enzyme. So whenever we give vitamin K dependent clotting factor inhibitor, it is going to be warfarin, which is going to be the oral and orally effective anticoagulant. Always remember, अगर इसका overdose हो जाए तो ये भी क्वेश्चन आता है. Overdose हो जाए तो you will be monitoring by PT-INR. Overdose में the monitoring will be done by PT-INR, and the treatment will be vitamin K1. And if the bleeding is present, अगर bleeding का evidence available है, then in that case scenario you can give prothrombin complex concentrate. अगर ये नहीं है, then we can give the fresh frozen plasma. Earlier we were preferring fresh frozen plasma, लेकिन उससे volume overload बहुत ज़्यादा हो जा रहा था, तो now we are giving PCC prothrombin complex concentrate. Okay. Heparin is considered as the indirect thrombin inhibitor. They are the indirect 2A inhibitor. How do they work? They increase the antithrombin 3 activity. They are going to increase the antithrombin 3 activity 1000 times. And this antithrombin 3, it actually binds or it inhibit factor 2A and factor 10A. 2A and 10A को inhibit करते हैं. Heparin is one of the indirect thrombin inhibitor, indirect factor 2A inhibitor. If ever there is overdose of heparin, the monitoring will be done by APTT. An antidote for this one, which I have already told you in the very beginning today, is known as your protamine sulfate. Protamine sulfate. Remember, another important problem with the heparin, that heparin हफ्ते भर बाद, warfarin within 5 days. Warfarin within 5 days, it is often associated with purple toe syndrome. Within 5 days associated with purple toe syndrome. This is very, very important. Warfarin within 5 days. Warfarin within 5 days. And heparin हफ्ते भर बाद, मतलब after a week therapy, they are associated with something called your HIT syndrome. After a week therapy, they are associated with something called your HIT syndrome. किसकी बात कर रहा हूँ? हेपेरिन की बात कर रहा हूँ. Enoxaparin, dalteparin, tenzaparin, they are the low molecular weight heparin. They also increase the antithrombin 3 activity, but they bind 10A more efficiently as compared to 2A. Fondaparinux is also one of the low molecular weight heparin, and they target 10A only. 10A only. Fondaparinux like heparin, but target only X. Idraparinux like heparin, but target only X. So they are ultra low molecular weight heparin. Rather than saying low molecular, we should call them ultra low molecular weight heparin. Okay, ultra low molecular weight heparin. Hirudine, lepirudine, they are the direct thrombin inhibitor. Please remember, वारफरिन के बाद से जितने भी हेपेरिन हैं, लो मोलिकुलर वेट हेपेरिन हैं, अल्ट्रा लो मोलिकुलर वेट हेपेरिन, they are all given with the subcutaneous route. Even direct thrombin inhibitor also given with the subcutaneous route. But dabigatran is one of them that is orally also effective. Orally also available. Dabigatran orally also available. Remember that. Dabigatran orally also available. ठीक है? Dabigatran orally also available. So we have drugs like your direct thrombin inhibitor, hirudine, lepirudine, right? Bivalirudine, argatroban, melagatran, and dabigatran, right? Dabigatran. Dabigatran is also utilized in overdose of. It is also utilized in overdose of dabigatran. In overdose of dabigatran, if overdose of dabigatran, then the management के लिए we can utilize idarucizumab. इदारुसीजुमैब. ओवरडोज में हम क्या यूज कर सकते हैं? इदारुसीजुमैब. ओके, इदारुसीजुमैब. ऑलराइट. So these are the important hematology वाले drug. We have antiplatelet drug. Then we have anticoagulants. Anticoagulants में direct thrombin inhibitor, indirect thrombin inhibitor, right? Direct and indirect thrombin inhibitor. Direct thrombin inhibitor will be hirudine, lepirudine, bivalirudine, and ergatroban, that is thrombin antagonist, melagatran thrombin antagonist. ये सब के सब इंजेक्टेबल है. एक orally also available है जिसका नाम है, right? Orally is also available, that is known as dabigatran. ठीक है, dabigatran. ओके, चले आगे. एंटीकोगुलेंट ड्रग ऑफ चॉइस इन प्रेगनेंसी. नाउ डिपेंड करता है कि प्रेगनेंसी में पेशेंट कब आपके पास आ रही है. इफ द पेशेंट इज कमिंग, लेट्स से 1 to 12 वीक, 1 to 12 वीक में यू विल बी गिविंग लो मोलिकुलर वेट हेपरिन. Then 13 to 35 week you are supposed to give warfarin, because heparin alone will not be effective. We will be giving warfarin. Warfarin is more stronger anticoagulant. And in the 36th week you are supposed to switch back again स्विच बैक अगेन टू लो मोलिकुलर वेट हेपेरिन, अगेन लो मोलिकुलर वेट हेपेरिन पे स्विच कर लीजिए। डुअल एंटीप्लेटलेट थेरेपी का मतलब हुआ 2 एंटीप्लेटलेट ड्रग अलग अलग, थ्रोम्बोक्सिन A2 इनहिबिटर प्लस P2Y12 इनहिबिटर। थ्रोम्बोक्सिन A2 इनहिबिटर कौन होगा? एस्पिरिन प्लस P2Y12 इनहिबिटर, दैट इज गोइंग टू बी क्लोपिडोग्रेल, राइट, क्लोपिडोग्रेल। सो दे आर नोन एज डुअल एंटीप्लेटलेट थेरेपी। डुअल एंटीप्लेटलेट का मतलब 2 एंटीप्लेटलेट ड्रग जाते हैं, अलग अलग एंटीप्लेटलेट ड्रग। नेक्स्ट इज गोइंग टू बी साइड इफेक्ट ऑफ एंटी-TB ड्रग। So important anti-TB drug, the first generation like HRZD, isoniazid, rifampicin, pyrazinamide, ethambutol. Isoniazid is causing peripheral neuropathy. Obvious reason ये है कि isoniazid, INH as a drug, they are going to increase the vitamin B6 का excretion. That is one reason. And INH also inhibit the vitamin B6 का activation to pyridoxal phosphate, वो भी नहीं होने देगा, तो therefore they will be causing peripheral neuropathy. Now this problem is very common with our population, that means with the Indian population this problem is very common, right? So because of that reason in our population we always add vitamin B6, and xerostomia psychosis is also a side effect, and they can also lead to the gift of gynecomastia. Rifampicin, red orange urine discoloration, flu like symptom, and they can also cause hepatotoxicity that is caused by rifampicin. Pyrazinamide, pyrazinamide, मैं बोलता हूँ maximum toxicity, hepatotoxicity is by pyrazinamide. And hyperuricemia, if there is hyperuricemia, they can also precipitate gout. If there is hyperuricemia, they can actually precipitate what? Gout. Ethambutol, optic neuritis leading to red-green color blindness. Streptomycin is going to be ototoxic and nephrotoxic event. Ethionamide is going to cause neuropsychiatric side effect and hypothyroidism. So we have ethionamide causing hypothyroidism. Hypothyroidism is caused by ethionamide, and hypothyroidism is also caused by PAS. Two important drugs that is causing hypothyroidism is going to be ethionamide and PAS. ठीक है, cycloserine is causing neuropsychiatric side effect. Remember, psychiatric कर देता है cycloserine. PAS you can remember by the very famous stain in pathology. PAS stain आपने सुना होगा नाम ना? PAS stain, red body secretion discoloration, eye and skin discoloration. तो पास स्टेन जैसे पैथो में पास एक स्टेन है, वैसे ये ड्रग पैरामाइनोसैलिसिलिक एसिड ये भी एक स्टेन के जैसा काम करेगा, मतलब एक साइड इफेक्ट निमोनिक ओनली है, पैरामाइनोसैलिसिलिक एसिड, ठीक है। Linezolid causing bone marrow suppression, peripheral neuropathy. In the bone marrow suppression, the more common will be thrombocytopenia, decrease in the platelet count. Bedaquiline, delamanid is causing QT prolongation and hepatotoxicity. QT prolongation and hepatotoxicity. Okay. So in the anti-TB drug, you have to remember the important side effect of these anti-TB drug. Bedaquiline, Q से QT prolongation, very important. Linezolid, bone marrow suppression, peripheral neuropathy. Bone marrow suppression में सबसे common जो होता है thrombocytopenia, decrease in the platelet count. In malaria, the question itself is saying chloroquine sensitive, so we can use chloroquine. But chloroquine resistant में we give artemisinin combination therapy. अब वो डिपेंड करता है कि पेशेंट कहाँ से आ रहा है. If the patient is coming from the northeast state, then we give artemether plus lumefantrine. If the patient is coming from the rest part of India, then we give artesunate plus sulfadoxine pyrimethamine. और इन दोनों के साथ we give primaquine 45 milligram on day 2. A single dose of primaquine will also be added. वाइवैक्स में वी कैन गिव क्लोरोक्वीन विथ प्राइमाक्वीन. अब यहाँ पे प्राइमाक्वीन अलग ये है दैट प्राइमाक्वीन हियर विल बी 15 मिलीग्राम इनटू 2 वीक्स. अगर ये नहीं रिस्पॉन्ड करता है, मान लीजिए वाइवैक्स मलेरिया में इफ दिस इज नॉन रेस्पॉन्सिव, क्लोरोक्वीन इज नॉन रेस्पॉन्सिव, इफ इट इज एन आर नॉन रेस्पॉन्सिव, देन वी कैन अगेन शिफ्ट आवर पेशेंट टू ACT, आर्टेमिसिन कॉम्बिनेशन थेरेपी. आर्टेमिसिन कॉम्बिनेशन थेरेपी. सीवियर मलेरिया और सेरेब्रल मलेरिया, उन दोनों के लिए ड्रग ऑफ चॉइस जो होगा IV आर्टिसोनेट. Pregnancy first trimester. Now this is according to National Vector-Borne Disease Control Program. हमारे कंट्री का जो प्रोग्राम होता है वो नेशनल वेक्टर बॉर्न डिजीज कंट्रोल प्रोग्राम. क्विनीन विथ क्लिंडा इफ देयर इज प्रेगनेंसी इन द फर्स्ट ट्राइमेस्टर, सेकंड थर्ड ट्राइमेस्टर में ACT, आर्टेमिसिन कॉम्बिनेशन थेरेपी. However, according to WHO, in any trimester, first to third trimester, any trimester, right, any trimester patient is coming, they are recommending artemisinin combination therapy more preferably. तो अगेन वो WHO के अकॉर्डिंग. प्रेगनेंसी में वाइवैक्स मलेरिया विल बी गिविंग वीकली क्लोरोक्वीन विल बी गिवन. प्राइमाक्वीन इज ऑलवेज कॉन्ट्राइंडिकेटेड. प्रोफिलैक्सिस इफ इट इज शॉर्टर ड्यूरेशन का जर्नी, तो डॉक्सीसाइक्लिन विल बी स्टार्टेड 2 days prior to journey. and should be given till 6 weeks after. मेफ्लोक्वीन फॉर लॉन्गर, अगर कोई महीनों के लिए जा रहा है, कुछ दिनों के लिए जा रहा है तो डॉक्सी, कुछ महीनों के लिए जा रहा है मेफ्लोक्वीन, सो विल बी गिविंग 2 वीक प्रायर टू द जर्नी एंड इट शुड बी गिवन टिल 6 वीक आफ्टर, मतलब आने के बाद दोनों कंडीशन में आने के बाद 6 वीक आफ्टर तक कंटिन्यू करेंगे, सॉरी 4 वीक आफ्टर, 4 वीक आफ्टर, नॉट 6 वीक, 2 and 4 टोटल नंबर 6 आता है इसमें, 2 day prior to 4 week after and 2 week prior to 4 week after in prophylaxis for the longer term. ठीक है. Chloroquine usually be causing some of the important side effect. The most common will always and always be GI side effect like gastritis, nausea, vomiting. ये जितने भी मलेरिया के इन वाले ड्रग हैं, बेसिक ड्रग हैं, they are highly associated with the GI related side effect. Then they can also cause other side effect like rash. Then oculotoxicity. In oculotoxicity, they will be causing bull's eye maculopathy. Bull's eye maculopathy. Bull's eye maculopathy. They can even lead to hemolysis, especially in G6PD, QT prolongation. These are the important side effects that is noted. Sulfonamide is going to be folic acid synthase enzyme inhibitor. Sulfonamide, folic acid synthase enzyme inhibitor. Alone, whenever we give, they are going to have static property. Cotrimoxazole, it's a combination of trimethoprim. It's a combination of trimethoprim. It's a combination of trimethoprim. And other one is called sulfamethoxazole. Trimethoprim, other one is called sulfamethoxazole. Right? So एक टैबलेट की अगर मैं बात करूं, कोट्राइमोक्साजोल, कॉम्बिनेशन ऑफ ट्राइमेथोप्रिन एंड सल्फामेथोक्साजोल, सो इसमें जो रेशियो होता है दैट इज गोइंग टू बी 1:5 का रेशियो इज 1:5. ट्राइमेथोप्रिन एंड सल्फामेथोक्साजोल 1:5 का रेशियो होता है, राइट, 1:5 का रेशियो ट्राइमेथोप्रिन एंड सल्फामेथोक्साजोल, एंड व्हेन वी गिव देम टुगेदर दे आर हाईली साइडल ड्रग. ठीक है, दिस इज वन ऑफ द डाइहाइड्रोफोलेट रिडक्टेज ट्राइमेथोप्रिन. कोट्राइमोक्साजोल कैन कॉज मल्टीपल साइड इफेक्ट, like for example, they can lead to side effect like kernicterus if it is given in the newborn, crystalluria and renal toxicity, right, kernicterus in newborn, crystalluria and renal toxicity, anemia, especially hemolytic anemia in G6PD, Steven-Johnson syndrome that is presenting with a rash being the most common side effect. ठीक है, rash being the most common side effect. Penicillinase और beta lactamase penicillin, एक होता है बीटा लैक्टामेज इनहिबिटर, एक होता है पेनिसिलिनेज रेजिस्टेंट. So this is going to be your methicillin, the most resistant. Methicillin, cloxacillin, oxacillin, nafcillin and dicloxacillin. These are the important penicillinase resistant penicillin, which you can remember. मेडिकल कॉलेजेस ऑफ न्यू दिल्ली में पेनिसिलिन रेजिस्टेंट पेनिसिलिन, आई मीन इन ड्रग्स को हम बोलते हैं पेनिसिलिन रेजिस्टेंट पेनिसिलिन और बीटा लैक्टमेज रेजिस्टेंट पेनिसिलिन. लिस्टीरिया के लिए ड्रग ऑफ चॉइस इज गोइंग टू बी एम्पिसिलिन. ड्रग ऑफ चॉइस फॉर एमआरएसए के लिए ड्रग ऑफ चॉइस इज गोइंग टू बी वैंकोमाइसिन. वीआरएसए द ड्रग ऑफ चॉइस गोइंग टू बी लाइनेजोलिन. अगर नहीं है तो डेप्टोमाइसिन कैन ऑल्सो बी वन ऑफ द वेरी इफेक्टिव ऑल्टरनेटिव. Cephalosporin for Pseudomonas. Now there are many cephalosporin for Pseudomonas. The drug of choice will be ceftazidime, one of the third generation cephalosporin. Ceftriaxone is the drug of choice in condition called meningitis, like Listeria meningitis. गोनोकोकल इन्फेक्शन, गोनोरिया में ड्रग ऑफ चॉइस है. शैंक्रोइड, इकोलाई, उसमें भी ड्रग ऑफ चॉइस है. कम्युनिटी एक्वायर्ड निमोनिया एंड टाइफॉइड फीवर. इसको एंटेरिक फीवर भी नाम देते हैं। इन सभी में सेफ्ट्रैक्सोन इज कंसिडर्ड एज द ड्रग ऑफ चॉइस। इट्स अ थर्ड जनरेशन सेफलोस्पोरिन। Ceftriaxone is a third generation cephalosporin. Among the protein synthesis inhibitor, aminoglycosides and tetracycline, they are the two important protein synthesis inhibitor. Aminoglycosides are the one that is sidal one, and tetracycline is the one that is static one. Rest all other protein synthesis inhibitor are 50S inhibitor, like for example linezolid, macrolides like erythromycin, clarithromycin, clindamycin. Then we have a combination of two drugs, that is quinprestin, dalfopristin. इनको कलेक्टिवली ही देते हैं, क्विनप्रिस्टिन, डाल्फोप्रिस्टिन को कलेक्टिवली देते हैं. Chloramphenicol, these are the important 50S inhibitor. So we have 30S inhibitor and we also have 50S inhibitor. See, most of the protein synthesis inhibitor are static until unless it's mentioned otherwise. Like for example, aminoglycoside has sidal property. Plague, tularemia, brucellosis के लिए we can use the drug that is streptomycin. साथ में the drug that will be adding will also be doxycycline, one of the tetracycline. एंथ्रैक्स का ड्रग ऑफ चॉइस एंड एंथ्रैक्स के प्रोफिलैक्सिस का ड्रग ऑफ चॉइस दोनों अलग है. ड्रग ऑफ चॉइस फॉर एंथ्रैक्स इज गोइंग टू बी पेनिसिलिन जी, बट अगर पूछे ड्रग ऑफ चॉइस फॉर प्रोफिलैक्सिस ऑफ एंथ्रैक्स, ड्रग ऑफ चॉइस फॉर प्रोफिलैक्सिस ऑफ एंथ्रैक्स, ड्रग ऑफ चॉइस फॉर प्रोफिलैक्सिस ऑफ एंथ्रैक्स, देन उसका जो ड्रग ऑफ चॉइस आपका होगा दैट विल बी सिप्रोफ्लॉक्सासिन. ट्राइकोमोनियासिस इट्स गोइंग टू बी मेट्रोनिडाजोल. बार बार ये क्वेश्चन आता रहता है. Cystic hydrated disease like echinococcus granulosus will be albendazole. Silver sulfadiazine is mainly utilized for the burn. It's mainly utilized for what? Burn. CMV retinitis will be the drug of choice called ganciclovir. इसका एक प्रो ड्रग भी अवेलेबल है. देखिए ये हमेशा इंजेक्टेबल होते हैं, लेकिन इसका एक प्रो ड्रग आया है जिसका नाम है वेलगैनसाइक्लोवीर. The good news is that valganciclovir orally भी available है. Valganciclovir is also available orally. CMV retinitis है ना. You will be getting always a patient with history of HIV है ना. कुछ ऑफ्थल्मोलॉजी के साथ इंटीग्रेशन करके देगा इसमें, ठीक है. बैक्टीरियल वेजिनोसिस, अगेन द ड्रग ऑफ चॉइस इज गोइंग टू बी मेट्रोनिडाजोल. Type 2 lepra reaction is which type of hypersensitivity? So that is going to be type 3 hypersensitivity reaction. Drug of choice for Legionnaires disease, azithromycin. Mucormycosis. Mucormycosis के लिए we have amphotericin B, black fungus जिसका नाम से जानते हैं. Seizure में imipenem should be avoided because they have shown to decrease the seizure threshold. They can cause, they are epileptogenic in nature. Throughout contraindicated in pregnancy is going to be aminoglycoside like streptomycin, capreomycin, kanamycin. They are the one that is always contraindicated. Bacterial vaginosis हो चुका है metronidazole. This is a repeat question. Cryptococcal meningitis के लिए we can utilize amphotericin B और साथ में we will be giving 5-flucytosine. Very very important question, multiple number repeated question. 5-flucytosine is one of the DNA and RNA inhibitor. 5-flucytosine is one of the DNA and RNA inhibitor. Right? Some important anti-cancer drug को जल्दी से समराइज कर लेंगे. राइट, लाइक फॉर एग्जांपल कीमोथेरेपी इंड्यूस नोशिया एंड वोमिटिंग के लिए ड्रग ऑफ चॉइस अगर है तो ऑलरेडी मैं बता चुका हूँ, लेकिन जल्दी से रिवाइज कर लेते हैं. वी विल बी यूजिंग 5-HT3 का एंटागनिस्ट. 5-HT3 एंटागनिस्ट, द नेम ऑफ द ड्रग इज कॉल्ड ओंडेनसेट्रॉन, ग्रेनिसेट्रॉन, प्लानोसेट्रॉन. अगर आता है डिलेड कीमोथेरेपी इंड्यूस नोशिया एंड वोमिटिंग, डिलेड CINV, then we can utilize NK1 antagonist. There is going to be aprepitant, rolapitant, netupitant. सबके नाम में pitant आएगा. P का एंटागनिस्ट aprepitant, rolapitant और netupitant. ये क्वेश्चन भी आ चुका है कि P का एंटागनिस्ट कौन सा है. राइट, तो अगर इससे नहीं काम चलता तो ये कर सकते हैं. एड ऑन ड्रग के फॉर्म में हम यूज कर सकते हैं डोमपेरिडोन को. Domperidone we can use. and we can also utilize dexamethasone, that is the steroids. Dexamethasone, they have also have alleviating effect on the nausea and vomiting. देन अगर आता है एनीमिया, कीमो इंड्यूस एनीमिया, तो एनीमिया के लिए हम क्या यूज कर सकते हैं? ईपोइटीन, ईपोइटीन, डार्बीपोइटीन, ईपोइटीन, डार्बीपोइटीन, एनीमिया, कीमो इंड्यूस नोजिया. न्यूट्रोपीनिया के लिए यू कैन यूज फिलग्रास्टिम. Filgrastim is one of the granulocyte colony stimulating factor, or we can use other, that is regramostim, malgramostim, right? So we can utilize, they are the granulocyte monocyte colony stimulating factor, right? Look at the name, granulocyte monocyte stimulant, granulocyte monocyte stimulant. तो कोई भी न्यूट्रोपीनिया हो, न्यूट्रोपीनिया ड्यू टू कीमोथेरेपी, congenital neutropenia, neutropenia due to some chronic disease, कहीं भी यूज कर सकते हैं. थ्रोम्बोसाइटोपिनिया में भी कैन यूटिलाइज इंटरल्यूकिन 11 का एगोनिस्ट. ध्यान रखिएगा, द नेम ऑफ द कंपाउंड इज कॉल्ड ओपरेलवेकिन. ओपरेलवेकिन, one tyrosine kinase inhibitor that we can use fostamatinib. Fostamatinib, we can also use them in ITP, or thrombopoietin receptor agonist. Thrombopoietin agonist, that is going to be L-Trombopag. इसके नाम में देखिए ना, L-Trombopag, L-Trombopag. तो देखिए थ्रोम्बोपोइटीन का एगोनिस्ट L-Trombopag, Ava-Trombopag, Lushu-Trombopag, they are all going to be Trombopag, L-Trombopag, Ava-Trombopag and Lushu-Trombopag. ठीक है, so they are the thrombopoietin receptor agonist that can be utilized for the thrombocytopenia. Tamoxifen का important side effect is going to be endometrial proliferation or endometrial carcinoma, because now in the postmenopausal women, remember, जब भी हम यूज करते हैं tamoxifen, then एस्ट्रोजन वहाँ पे ऐसे एगोनिस्ट काम करने लगता है, बिकॉज एस्ट्रोजन की लेवल हमेशा वहाँ पे क्या होता है, कम होता है postmenopausal women में, so they can cause endometrial receptor का proliferation. The most cardiotoxic will be your anthracycline group of drug, anthracyclines. There is going to be drugs like your doxorubicin, daunorubicin, right? Which anti-cancer drug require bladder function monitoring? That is going to be your cyclophosphamide, cyclophosphamide and ifosfamide. Actually इनका एक मेटाबोलाइट होता है, right? The metabolite is called acrolein, that is highly toxic to the bladder. Drug used to prevent pulmonary fibrosis, that is going to be perfenidone. Pulmonary fibrosis will be perfenidone, right? Perfenidone, nintedanib, they are the one that is utilized for preventing pulmonary fibrosis caused by chemotherapeutics. Mechanism of action of flutamide, remember flutamide, nilutamide, apalutamide, they are anti-androgenic drug. Anti-androgenic, we can utilize them in prostatic cancer, right? Nilutamide, bicalutamide, apalutamide, all those. So perfenidone, it will slow down the progression of pulmonary fibrosis. Which one can cause pulmonary fibrosis? That is busulfan bleomycin, that I will tell you subsequently. Some important mechanism of rituximab, I think मैं आपको बता चुका हूँ ये बात. ऋतु वफा नहीं करेगी, ofatumumab. So this is going to be anti-CD20. पूछा गया ऋतु, व्हाट्स योर एज, शी सेड 20. तो समझ में आया कि अच्छा ऋतु वफा इसलिए नहीं करेगी बिकॉज शी डोंट नो व्हाट इज वफा, शी इज टू यंग, शी इज टू यंग टू अंडरस्टैंड वफा. सो ऋतु वफा नहीं करेगी, दिस इज जस्ट निमोनिक टू रिमेंबर. तो ऋतु किसी को हमेशा याद करती रहती थी, राइट? जब पास जाके देखा गया तो वो याद करती थी कृष्णा को, बोलती थी माई कृष्णा, माई कृष्णा, वो हमेशा कृष्णा को याद करती थी. माई कृष्णा विल बी मायस्थीनिया ग्रेविस, CLL, rheumatoid arthritis, ITP, idiopathic thrombocytopenic purpura, inflammatory bowel diseases, SLE, non-Hodgkin's lymphoma and autoimmune hemolytic anemia. So this is a very, very important one. Rituximab is considered the overall most commonly utilized monoclonal antibody. Overall most commonly used monoclonal antibody. MAB सबसे ज़्यादा जो commonly होता है rituximab. It has lot of cancerous and non-cancerous uses. Cervix cancer, और एनी अदर यूरोजेनिटल कैंसर, चाहे ब्लैडर हो जाए, सब हो जाए, सभी का ड्रग ऑफ चॉइस इज एक्चुअली गोइंग टू बी योर सिस्प्लाटिन, वन ऑफ द प्लेटिनम कंपाउंड। ठीक है। इंपॉर्टेंट साइड इफेक्ट ऑफ सिस्प्लाटिन, वन ऑफ द प्लेटिनम कंपाउंड इज गोइंग टू बी नेफ्रोटॉक्सिसिटी. Nephrotoxicity is one of the very important side effect of this one, and to prevent this nephrotoxicity you have to add amifostine, या alternatively we can also add N-acetylcysteine. ये वही N-acetylcysteine है जो पैरासिटामोल पॉइजनिंग में यूज कर रहे थे, इसको म्यूकोलिटिक में भी यूज कर सकते हैं, एंड दे हैव नेफ्रोप्रोटेक्टिव प्रॉपर्टी एज वेल. नेफ्रोटॉक्सिक इज द इंपॉर्टेंट साइड इफेक्ट. अदर साइड इफेक्ट विल आल्सो बी ऑटोटॉक्सिटी. अब जितने भी इंपॉर्टेंट साइड इफेक्ट हैं एंटी कैंसर ड्रग के, उनको मैं क्विकली समराइज कर दूंगा इस कीमोमैन में, विच विल बी द लास्ट थिंग. आफ्टर दैट everything else will be done. This is the last thing that I'm going to discuss, and we always get 1 to 2 question. Sit back, relax, try to finish this in the next 2 to 3 minutes, and ज़्यादा से ज़्यादा 5 minutes, and then we'll be done for the day. So we have a very famous superman in the pharmacology whose name is chemoman. Now what does this chemoman do? This chemoman is mainly involved and utilized for summarizing the important side effects. So how will I make chemoman? So I'll be making by 1 circle, 1 rectangle and 4 triangle. So ये बना हुआ है, अगर आप चाहें तो बना लीजिए फटाफट. Right, 1 circle, 1 rectangle and 4 triangles. That's it. Chemoman. I'll be starting first with the smile of the chemoman. If you see, the chemoman is smiling, listening to you and listening to all your queries, right, and making sure nothing get flushed out. So kidney, all these are actually representative of letter C, and letter C stands for cisplatin, that is causing nausea and vomiting. An important side effect is called nephrotoxicity, and to prevent this nephrotoxic event we are going to utilize amifostine or N-acetylcysteine. क्या यूज करेंगे हम यूज करेंगे amifostine, या we'll be using amifostine और amifostine यूज कर सकते हैं, या हम यूज करेंगे N-acetylcysteine, amifostine या N-acetylcysteine यूज करेंगे. ठीक है. So this is going to be your important drug that is called cisplatin. Next is going to be your bleomycin busulfan. तो 2 lungs हैं क्यूमेन के, ध्यान दीजिएगा. क्यूमेन के 2 lungs हैं, ये देखिए B and B. That is going to be bleomycin busulfan. That is going to cause pulmonary fibrosis. It is going to cause fibrosis, and to slow down this fibrosis, we will be using pirfenidone or nintedanib. Okay. This is about your bleomycin and busulfan, that is causing B for lungs की जगह पे fibrosis. Then we have D. Look at the D. D here is going to be doxorubicin, donrubicin, और ये दिल है जो सब पे ट्रस्ट कर लेता है. दिल है जो सब पे क्या करता है, ट्रस्ट करता है. तो we have doxorubicin, donrubicin, and इधर trastuzumab, another monoclonal antibody, trastuzumab, ER positive breast cancer, HER2 positive breast cancer में यूज करते हैं इसको. So they are causing cardiotoxicity, that is dilated cardiomyopathy, and to prevent this we'll be using dexrazoxane. क्या यूज करेंगे, dexrazoxane. We are going to use what, dexrazoxane. So DD, doxorubicin, donrubicin, and इनके टॉक्सिसिटी को प्रिवेंट करने के लिए we are using dexrazoxane. Actually dexrazoxane is one of the iron chelated drugs. Then around that I want you to see there is a bladder here, and the bladder C and this Y, this will be cyclophosphamide, ifosfamide, and C and Y बीच में है एक I, C and Y बीच में है एक I. So cyclophosphamide and ifosfamide, they are going to be hemorrhagic cystitis, and to prevent this we will be giving IV mesna. To prevent this one we are going to give what, IV mesna. Cyclophosphamide, ifosfamide, highly toxic to the bladder. I want you to see the liver. Liver looks like कि किसी ने पीछे से धक्का मार दिया, तो this is going to be letter 6. And liver is handling all the toxicities. So 6 mercaptopurine, 6 thioguanine, and toxicity or metabolism, methotrexate, they are causing hepatotoxicity. Another side effect of methotrexate that you know is bone marrow suppression, megaloblastic anemia. And to prevent this one we are going to utilize folinic acid or leucovorin. हम क्या यूज करेंगे, folinic acid or leucovorin. That's very important. M, look at the M. M is the long bones, methotrexate, bone marrow suppression. Then all the limbs of the human, upper limb, lower limb, सारे limbs देखिए कैसे ना लेटर V के फॉर्म में बने ना, V, letter V, that is going to be vincristine, vinblastine. They are causing peripheral neuropathy, and to prevent this one we will be giving vitamin B6 and vitamin B12. Right, vitamin B6 and vitamin B12 will be added here. So vincristine, vinblastine, they are highly associated with the peripheral neuropathy. The patient with the tingling sensation after chemotherapeutic agent. देन लिम्स में देखिए यहाँ पे बड़ा प्यारा सा हाथ है क्यूमैन का जिसमें 5 फिंगर्स हैं, आराम से काउंट कर सकते हैं, राइट. तो वी हैव 5 फ्लोरोयूरासिल एंड कैपेसिटामिन पेमेट्रexate. They are causing hand and foot syndrome, and to prevent this one we'll be adding vitamin B6, that is going to be pyridoxine. Vitamin B6, that is going to be pyridoxine. So we have 5 fluorouracil and pemetrexate and capecitabine, right? Capecitabine, that will be again causing hand and foot syndrome. Painful erythematous palm and sole, है ना, hand foot syndrome, painful erythematous palm and sole, 5, right? And pemetrexate is the prodrug of 5 fluorouracil only. Capecitabine is the prodrug of 5 fluorouracil. Pemetrexate is a derivative of methotrexate. So pemetrexate 5 and 5 fluorouracil and capecitabine are same, है ना, they are the pyrimidine analogs. एक लास्ट ड्रॉ कर दे रहे हैं, क्यूमैन की टोपी. तो क्यूमैन इज बाल्ड बिकॉज एनी एंटी कैंसर ड्रग दे कैन कॉज दिस वन. तो वी हैव विनक्रिस्टीन, हेड वाला साइड इफेक्ट, इट कैन ऑल्सो कॉज SIADH, सिंड्रोम ऑफ इनअप्रोप्रिएट ADH सिक्रीशन, दैट कैन ऑल्सो बी कॉज बाई SIADH. तो ये आपका क्विकली हो गया इंपॉर्टेंट क्यूमैन. और इस वाले से एक क्वेश्चन आपके एग्जाम में आता ही आता है, बीट एनी एग्जामिनेशन, राइट. सो दिस विल बी एवरीथिंग. इसके अलावा अगर मैं बोलूँ कि जितने भी मोनोक्लोनल एंटीबॉडीज हैं इनके सबके समरी मैंने यहाँ पे दे दिया. जैसे कि पालिविजुमाब वायरस के लिए, रेस्पिरेटरी सिंसिशियल वायरस, इक्यूलिजुमाब अगेन C5 के लिए है, E इज द 5th लेटर, कॉम्प्लीमेंट 5 इनहिबिटर. इक्यूलिजुमाब PNH के लिए हम यूज़ कर सकते हैं. ओमालिजुमाब, मेपोलिजुमाब, रेस्टलिजुमाब, ब्रोंकियल आस्थमा एंड COPD के लिए वी कैन यूटिलाइज. ऑल इज गिवन. ओमालिजुमाब is the IgE inhibitor, Mepoli and Reslizumab, they are the interleukin 5 inhibitor. Then we have one more that is called benralizumab. Benralizumab. That is going to be interleukin 5 receptor antagonist that can be utilized. And we have one more that is called tralokinumab. ये सब ब्रोंकियल आस्थमा एंड COPD में है. tralokinumab, right? Tralokinumab 13. So they are going to be interleukin 13 inhibitor. Okay. Cetuximab, rituximab मैं बता चुका हूँ already. Rituximab anti-CD20. ठीक है. Some important hormonal anti-cancer drug. These are also summarized here. You can go through that. And some newer drugs like aducanumab, lecanemab. They are the monoclonal antibody against beta amyloid utilized in Alzheimer's disease. है ना, aducanumab, lecanemab. एक और न्यू आया है अभी रिसेंटली, donanemab. Donanemab is another new one that is utilized for Alzheimer's disease. It is also for Alzheimer's disease. तो इसको मैं बहुत बड़े प्यार से देखिए, ALD Alzheimer's disease के लिए, aducanumab AD, नाम में Alzheimer's disease AL, lecanemab D, donanemab ALD. ठीक है, ये भी बता चुका हूँ. lasmiditan, that is going to be 5:1 agonist. Migraine prophylaxis के लिए we can use migraine treatment. They do not cause prophylaxis, they do not cause precipitation of MI. And terzepatide, they are going to be GLP-1 and GIP analog. बड़ा फेमस ड्रग है, मुंजारो के नाम से आजकल अवेलेबल है ये ना. Dostarlimab. These are the other drugs. There are some newer drugs that we know. If you can go through that. Denosumab is one of the rank ligand inhibitor utilized in the treatment of osteoporosis. Afrezza is the inhalational insulin. Remember that Afrezza is the inhalational insulin, right? Rest all others are just good to know. Important monoclonal antibody. And these INI-CET में ये जो नए क्वेश्चन है ना, जैसे प्रोटियाजोम इनहिबिटर यूटिलाइज इन मल्टीपल माइलोमा, कैसे याद करेंगे मैं बता रहा हूँ. प्रोटियाजोम प्रोटीन, जोम्बी खाते हैं प्रोटीन, जोम्बी है ना, बोर्टेजोमिब, कार्फिलजोमिब, है ना. ओलापेरिब, पॉली ADP राइबोस पॉलीमरेज इनहिबिटर, BRCA म्यूटेड ओवेरियन कैंसर. CDK, right, that is going to be palbociclib. It's not mentioned here, CDK inhibitor. मैं यहाँ लिख दे रहा हूँ. The name of the drug, cyclin dependent kinase, is palbociclib, ribociclib, सबके नाम में cyclib आएगा, abemaciclib, right? They are all cyclib. All the cyclibs are mainly CDK inhibitor, inhibit cyclin dependent kinase 4 and 6. All the tyrosine kinase inhibitor, NIB, है ना, like imatinib for breast cancer, imatinib for CML and GIST. Okay. Lapatinib, lovely breast cancer. Sorafenib, hepatocellular carcinoma, renal cell carcinoma. Sunitinib can also be used in renal cell carcinoma. Vandetanib, Van, cabozantinib, Van and Cab, medullary carcinoma of thyroid. And so these are some of the important monoclonal antibody. जब मैंने MCQ सेशन कराया NICT के लिए, उसमें भी ये नए वाले जितने भी हैं ये tyrosine kinase inhibitor ये सब भी करा रखा है. So these are some of the newer drug. I want you to go through this one, and with this the important common ones जितने भी हैं, we have covered this entire general pharma, ANS, CNS, cardio, renal, GIT, hematology, है ना, ऑटोकॉइड्स, इम्यूनोमॉड्यूलेटर, एंटी कैंसर, एंटी माइक्रोबियल, जितने भी इंपॉर्टेंट हैं, पॉइजनिंग्स एंड एंटीडोट्स, उस सब को हमने कवर किया इन द गिवन टाइम. तो जैसा कि मैंने बोला था कि अराउंड हमने 5:30 स्टार्ट किया था और 9:30, तो 4 घंटे के अंदर मैंने बोला था कि 10-15 मिनट ऊपर नीचे में हमने कर लिया. तो विद इन 4 hours वी हैव कवर्ड दिस एंटायर session for all of you guys. So I hope you guys have enjoyed this one. Do the revision once, and I'm pretty sure you'll be getting a good amount of topics from the topic that we have covered on the basis of the PYQs and PYTs. Okay, thank you very much to all of you guys. Bye bye.